Ira,
Yeah.
it's live.
Yeah, so it's 3, 2, 1. We are live to the attendees platform. We can start this meeting. Over to you, sir.
Good morning and namaste. Welcome from the beautiful city of Goa, India, to India's first Metabolic Health Conference, Low Carb across the globe. I'm sure most of you have watched the first session yesterday, and all of them were amazing. You were already introduced to Shashi and Anup, and we'd have the first session with Dr. Marcus Hawkins from New Zealand. But before that, let us do a small recap of how interesting the first day was. To begin with, there were no glitches thanks to our hosting partners. And maybe Shashi would like to say a word or two on what and how yesterday went.
I think yesterday was really smooth, and big thanks to Imagika for making it possible, plus our backend team who is constantly monitoring and supporting. And the biggest heartening thing is in the live YouTube channel, there were more than 2,400 views and more than 1,000 views in our front end, in Imagika's front end. So everything went well, and I think we had beautiful sessions yesterday. And I think Anup can now take over. Just a few words, and we'll start with Dr. Marcus.
Yeah, just to add to what you said, it was a great effort by the backend staff and the hosting partners. So it was basically glitch-free, no glitches at all. First experience, first conference, and it's a learning experience for us. But yes, it was very excellent and very good. Thank you.
I think 12 hours went by in a flash for us, is what I.
Mainly, the sessions were so interesting. We got so many feedbacks on our phones, on our social media messages, and people especially loved, the session with Dr. Sean Baker, Ken Berry. All of them were amazing. There was not one guest, I don't have high praises for. For everybody, we received very, very good reviews. So I think it was an amazing day yesterday. We hope to, recreate that thing today as well. So we'll start by the second day, the first session of the second day. Are we ready?
Thank you.
Thank you, Shashi. Thank you, Anup. Okay, so our first guest in the very first session of day 2 is Dr. Marcus Hawkins from New Zealand. And I'm your host, Ira Sahai, or Ira, as a lot of people call me. I'm a metabolic health coach based out of Mumbai, India. Brief introduction about my very special guest today. Dr. Marcus Hawkins is from New Zealand, mainly from Auckland. He has been a general practitioner for 25 years and is currently working as a solo GP in Auckland. Nearly 5 years ago, Dr. Marcus discovered the world of low carbohydrate, healthy fat, which is LCHF eating, and learned about the many benefits of changing the way people eat or can eat. Since then, he's been very passionate about forwarding the message to anybody who would listen. Dr. Marcus now administers a Facebook group for several years now, actually, which is called the Low Carb Doctor New Zealand, with members from all walks of life. It provides general information, discussion, and answers questions on LCHF issues. Dr. Marcus has worked with patients dealing with obesity, helping them reverse pre-diabetes, remit type 2 diabetes, improve or reverse hypertension, and reverse non-alcoholic fatty liver disease, polycystic ovarian syndrome, and improve migraine. Dr. Marcus has been a lone warrior so far, but is now preparing an army of health coaches in New Zealand for further implementation and improving patient care through LCHF. Let me welcome Dr. Marcus Hawkins from Auckland, New Zealand. Welcome, Doctor.
Namaste and kia ora, Ira. Thank you so much for inviting me to take part in your wonderful event. I'm very, very impressed that India is addressing the carbohydrate reduction that needs to take place to reverse and remit disease and make people healthier rather than sicker with the trajectory they're actually on as advised by some national guidelines.
Yeah.
So I'm here in little old New Zealand, population of just over 5 million, the bottom of the South Pacific, in a country that drastically needs to make some changes to our obesity and insulin resistance crisis. So thank you for having me.
Thank you for coming.
I look forward to answering your questions.
First off, Dr. Marcus, the logical question is, you are a mainstream doctor. How and why did you come into low carb?
I went to dinner with my wife at a friend's house, and he handed out some snacks. And the snacks consisted of salami, cheese, and even more cheese, and a few olives. And I just remarked, because I was in the mainstream way of thinking, I said, gosh, what, he told me that it was his way of eating nowadays. I said, well, what's happened to your cholesterol? He said, well, my cholesterol's better than it's ever been, which made me think. And we went home, started to research on the internet, saw a video called The Magic Pill, which is essentially about how we came to be in the low fat, high carb dietary way of eating, how the world's got fatter and sicker, and how we can reverse that by going low carb. That was followed, well, I mean, that was on the background of me being a medical student and then a doctor for 35 years, not having any nutrition education whatsoever.
Yeah.
But following the guidelines from 1977. Then I did a couple of nutrition network courses and then started to offer the low carb way to my patients. And the results were there within days or weeks at times. And I was just so impressed, I could not turn back.
Okay, give us a general view, Dr. Marcus, of the metabolic health scenario of New Zealand, and what conditions plague New Zealand as a country? What are the highest metabolic syndrome number of patients who come to you?
Okay, so we're essentially the same as most other Western societies. We have to deal with obesity and the effects of insulin resistance. So what we're dealing with is obesity per se, and then the consequences such as pre-diabetes and type 2 diabetes, high blood pressure, non-alcoholic fatty liver disease, and polycystic ovarian syndrome. They'll be the commonest things that we would see. And we have to acknowledge the fact that the indigenous people of New Zealand, the Maori, the tangata whenua, the people of the land, have significant obesity and obesity-related diseases. We also have a significant Polynesian population in Auckland, New Zealand, in general, and they are also affected in a similar way.
Okay. So who are the ideal ones that you would immediately want to put on a low carb diet or LCHF diet, and what is the kind of response that you get from the local population there for the LCHF?
Okay. Well, generally anyone who's interested in following this way of eating, and anyone who has the morbidities that I mentioned beforehand, if they're motivated and want to explore it, I'm there for them. They would be the ideal ones, people who are interested and motivated. The response in general is very positive. People will actually sit and listen to me when I ask them if they want to hear about a different way of eating to try and improve their particular health condition or conditions. And they usually sit and hear me out, and I give them a chance to go away and think about things. And generally people fall into two groups. There are those who don't want medication, or they want to lose weight and they want to go down this line. And there's a few, probably about 30%, who say, no, just give me the drugs, it's much easier that way. So essentially they just, they go down the traditional route. I see people both in the practice who are enrolled with me, and I see people coming from outside the practice who have an interest in low carb or want to try and reverse some of these conditions, and they come and seek information and get advice.
What is the general belief surrounding, the diet that local people in New Zealand eat? For example, in India, we have a plate which is carb heavy. So rice or roti, as you said, it's part of the meal, maybe 60 to 70% is carbohydrates. How are people in New Zealand eating? What is the tendency to eat high protein and low carb in general? How is the population eating there?
Generally speaking, it's the SAD diet, the standard American diet. In other words, low saturated fat, cook with polyunsaturated fats or seed oils, generally a high carbohydrate burden with grains, legumes, and fruit, following the traditional food pyramid. So a typical plate, as per sort of national guidelines, would include 25% of protein, 25% of carbohydrates, and the remainder is vegetables, remembering to take the fat off the meat if you're eating meat, or fatty meat. So we start from the point of view also that doctors here and across the world probably never have any education on nutrition. And even if they did, it probably would be the wrong kind of education, in my opinion, following the standard American diet. But that's something that we don't get educated on, which is, I think, quite incredible.
Okay, Dr. Marcus, it's amazing that New Zealand produces dairy and dairy products on industrial scale. In fact, it's, if I'm not wrong, it's the 8th largest milk and milk products exported in the world, which is a good source of protein. Dairy is a good source of protein. Why is it that a country like New Zealand is plagued with obesity and diabetes? New Zealand is now the 3rd most obese country in the world in the OECD, and 1 in 3 children in New Zealand are obese. Why is that?
It's because we're following the standard American diet again. You know, since 1977, you can see, if you, from the ministry itself, Ministry of Health has a graph whereby in 1977, 10% of the population were obese adults, and in 2012, I think it was, over 30% are obese. And it's really because of the dietary advice we've been given, the same as in the UK, in America, South Africa, and European countries. We're getting fatter and sicker because we're eating more carbohydrates, because we're supposedly not, well, we're supposed not to eat too much fat, or any fat, essentially. So we've basically got epidemic proportions across the world in this way. Now, we produce milk and protein, but are advised to drink low-fat milk, which obviously has more sugar in it, because we're following the low-fat, high-carbohydrate diet. We have a lot of sugary drinks. We have a lot of relatively poor people who can only afford sugary drinks. At the same time, on high-carb diets, and also lots of fast food restaurants. You know, the poorest areas in Auckland have fast food restaurants galore. Every top name is there, and they're buying cheap, high-carbohydrate foods because that's all they can afford. So we're not seeing any benefit from having good protein for sale. That's just not doable.
I think New Zealand also has a lot of meat-eating population, if I'm not wrong. 93% of the population are meat eaters, with, again, good quality of dairy available. But I think it's the carbs or the cheap sources of energy and carbs more on the plate that are doing the damage. Is it so?
I'd totally agree with that. Yes, I think the reasons why the meat eating is dropping is principally for 2 reasons. The first being that we're told that red meat is dangerous. You know, it causes bowel cancer. Yes, New Zealand has some of the highest rates of bowel cancer in the world, but I don't believe it's due to the red meat consumption. When they looked into epidemiological studies of bowel cancer and red meat, they also had people who are significantly overweight and were smokers, among other things. So you cannot just say it's going to be the red meat in isolation. Yes, we grill a lot of food on the barbecue. Maybe there's something in that. I don't know. But at this stage, I would not regard red meat as the problem. Secondly, we grow lots of high quality meat, as you say, but the best meat is exported, and the meat that remains is expensive. So again, I don't believe meat or fat is the cause of obesity. It's due to carbohydrates. And you can see that, as I say, graphing over time, both in America and Europe and in New Zealand, people get fatter over the last 50 years or so, because of reduced fat and more carbohydrates. And of course, glucose, the carbohydrate breakdown product, is converted to fat via insulin, the fat storage hormone. Plus, we have a high consumption, as I say, of fast foods and highly processed foods, and all that will aggravate and lead to obesity and counter any products that might be deemed as good.
Okay. In your practice, Dr. Marcus, how many Indian patients on an average do you see, and what are the commonest syndromes that they come to you with, and the challenges that you may be facing with regards to putting them on LCHF? Please discuss about that.
Yeah, I've got just under 5% of Indian and Fijian Indian patients, and I see some of those are overweight and have the complications of diabetes and heart disease. There's also a significant number who are slim but still have type 2 diabetes and assume it's due to insulin resistance. We always acknowledge the fact that anyone from the Indian subcontinent has a significant risk of diabetes and cardiovascular disease that comes earlier and more severe. It is a factor. Now, is this due to carb exposure? Is this due to obesity? Is it due to epigenetics? And some will argue that India's had a number of significant major famines over the years, and that might have altered the DNA. I think it's a combination of things. It's not straightforward, but either way, we still have the problem of carb exposure and obesity. I have a few patients on low carb, healthy fat regimes, but compliance is difficult, as stated before. Rice and rotis are very part of your diet, not your diet, but of Indians' diets. And it's very hard for people to change quite often. And we're looking at behavior change as part of this whole process. I have been able to find a local supplier of low carb foods, an Indian lady actually, and she does some very nice curries with cauliflower rice. And so, we can try and push things towards her with our Indian patients. But I think a lot of people like to cook their own food, and they're very proud of the food they cook. Now, I think you asked a question about vegetarians as well. I haven't had any Indian vegetarian patients come to me for low carb advice. And finally, I'd say most find it too hard, but I keep trying, and I'm always looking for ways to try and improve that. And talking to Anup a short time ago, we're probably going to touch base again and get some hints from people who have done this for themselves and can share the advice.
Yeah. So usually the tendency, I think you must be encountering people, I know for sure, who would, maybe want to give up wheat, but would want to start up on millets instead. What would you tell those people, because they're trying to replace wheat or rice with millets? How good or bad is that?
I don't honestly know the carb content with millet, I must be honest. It's not something that we have over here as a rule. But I mean, again, you're not wanting to substitute one carbohydrate for another, especially if they're equivalent in carb content. You really want to sort of steer away from carbohydrates as best you can by increasing the fat content in food and protein content in food. But it's about making change. It's not about being absolute and totally totally strict on things. It's about making change and gradual change and improving things as you go. So yeah, I'm sorry, I can't answer that question about millet per se.
And what are your views on saturated fat, Dr. Marcus? The general views on saturated fat and eggs, and especially eggs to be eaten without yolk, as the common messaging goes, or red meat, as you said, is bad. So I would like you to make a detailed maybe commentary on what the myths are with regards to seed oils or saturated fats, eggs.
Well, saturated fats are very tasty. Eggs are very tasty. That's the first thing. And in my postgraduate study, it's clear that saturated fats, animal fats, coconut oil are healthy and safe. We know that the low-fat diet that was put forward in 1977 and then reviewed later on was not based on validated science. It was more expediency and financial incentive by companies. So, you have people eating a saturated fat diet, you have them eating coconut oil, animal fats, etc., and you see the numbers improve. The weight comes off, the diabetes improve, the cholesterol profile improves in most people. So, it just bears out the fact that what we've been taught over the last 50 years is not necessarily correct. And I have no issue with any unprocessed meat of any type. When it comes down to meat in general and red meat, I mean, Nina Teicholz does a YouTube presentation called Red Meat and Health, and just shows how there's no real foundation in red meat being carcinogenic. And as I mentioned before, the red meat issue, when they looked at the studies, they had a number of confounding variables such as being overweight and smoking. For me, quantity is not an issue. I don't get people to measure their food or proportion out the amount of food they have. I just get them to reduce carbohydrates as much as possible. I want to keep it simple to make it doable and have people eating to satiety and then no more after that. And bearing in mind, there's only a finite amount of protein that you can eat at any one sitting. As I say, I don't ordinarily monitor protein and fat unless someone's trying to lose weight and they're not able to lose weight. Then I might suggest they reduce their fat intake and increase their protein, which is sometimes the way to go. So yeah, saturated fats are good. Eggs, you can eat as many eggs as you like. It's not an issue in terms of cholesterol lipid profile. You eat the whole egg. The yolk is the best part of the egg, the most nutritious part. Eggs are a whole meal essentially. And so You're not going to adversely affect your cholesterol. You're not going to get sick. It's really a great food to eat, and almost a complete food to eat. And I have no issue with eggs in general.
So these views stand in contradiction to the guidelines given by, say, the various health associations across the world that ask you to, eat less eggs and less red meat and all of that. What do you think is wrong with these dietary guidelines? And should people follow them, not follow them?
Well, I think the dietary guidelines as put forward, say, in 1977 and the food pyramid are incorrect. And I think the food pyramid is actually upside down. When you look at how it all came about, the way we were encouraged or told to eat low fat and essentially therefore high carbohydrate food was really due to an unsubstantiated theory and a corrupt study, in other words, a 7-country study from Ansel Keys, which really doesn't stand up to scrutiny. And then you look at the political expediency of the McGovern Committee. And, when Senator John McGovern was challenged by a scientist to say, well, we don't have the evidence to put forward these guidelines, he said, well, we don't have the time to wait for the science. So the whole thing was just pushed forward for political expediency. And it's just taken hold, and countries have run with it. But there's no evidence really that this was valid, as has been shown in some research papers and PhD presentations. So it's corrupt. And of course, what happens now is that you have big pharma and big food working together. Essentially, big food makes us fat and sick. Big pharma gives us drugs to help the fat and sickness continue, and then you get more from big food, and big pharma comes in again. And it's just so wrong. And what makes me so angry after 35 years in medicine is that you don't actually need to give people drugs. You can take drugs away by changing their diet. And I feel really deceived. And that's something that is, other people don't register, other doctors don't register a lot of the time. It's much easier to prescribe a drug than to try and change what you do. And there's various reasons for that, sometimes valid. We're stressed, overworked, and burned out quite often. So you can understand why people just want to follow the easiest route. But this is all part of a corrupt process, and I can't live with that.
Okay, and Dr. Marcus, do you think now you have a number of years experience of the LCHF LCHF diet? Do you think it is the way out of the current epidemic of cardio-diabesity that the world is facing? And what is the message that you would want to give to people who are metabolically healthy and who don't probably realize the impact that those conditions are creating in their body? So what is the message? And please tell us.
Carbohydrate reduction, or LCHF, is absolutely the way out. Really, it is doable. It is the most natural way. It is the way we were designed to eat and take in food. We had done that for hundreds of thousands of years until things changed of late. It's not for everybody, though, and it's not my job to tell people what to do. It's clear. My job is to advise people, and if people don't want to do that, that's up to them. But you're coming from the point of view of that you have the knowledge and you want to impart that knowledge to people, and if they don't want to accept that, we have to respect that. But I think education comes into this as well as governments, in that, if you educate people, just as we've educated people that low fat was healthy, we can do the same with low carb. And, I do that on an individual basis, but governments need to do that. And if they did come in and start advising people as national guidelines, then I'm sure we would see results. It's just we're caught up in this whole maelstrom of let's say big food and big pharma, political persuasion, and it sounds like a conspiracy theory, but it's not. It's just what's happened. So the way out is, absolutely to look at reducing carbs, but whether or not that'll happen, I think it has to happen one person at a time, one doctor at a time. With people who are metabolically healthy, who want remission, look, we are here to help. We're here to help from a medical perspective. So you're looking at giving medical advice, because sometimes you have to be quite specific about reducing insulin or diabetes medication, blood pressure medication. And then you're also looking at behavior change. And so as a doctor, I've done this on my own. I have had no no one working with me. It's taking a long time with patients, but you are looking at behavior change as well. But as I was saying before, you really need health coaches who are experts in behavior change to help people go from the whole mindset of however long they've been alive, that you have 3 meals a day and you eat, in the Western culture, you eat your meal, and if you don't finish your meal, you don't get your pudding. I mean, how unhealthy is that? You should eat till you're full and then stop.
Yes.
So we're talking about lifelong behavior that needs to be changed. And it is about being, supportive, not directive. That's never going to work. But when people see change, and they see change in their weight, or their periods start returning from the polycystic ovaries, it's quite incredible. They then realize just the effect of food on their bodies. People's irritable bowel improves. They say, well, if I have bread now, I get tummy ache and diarrhea. And so you're looking at change that's evident, as well as behavior change working on the mind. And that's something that I enjoy and need help with. And therefore, from now on, it won't just be me. It will be me and a health coach, hopefully, as soon as I can get one.
Yeah. I had a line from you, and over our discussion in the past few days, I just want to read that. The message of low carb often falls on deaf ears in terms of health professionals, including here in New Zealand, as overworked, stressed, and burned out individuals would rather continue with the easiest route of management than adopt a new way of thinking, even when they're shown the clear benefits. Belief is still very strong in the teachings of the last 50 years. It is easier to prescribe a drug than it is to advise a new dietary approach. The public, as well as the health professionals, continue to be misled and misfed. I guess most of us practice with one eye over a shoulder, looking out for big food, big pharma, as well as the regulatory authorities. I cannot sit back and not do what I believe to be the right thing. That's remarkable, Dr. Marcus, and I think that sums up your entire journey. However, I would want to ask you, have you faced any kind of harassment or, not so much of encouragement from your peers, from your local medical authorities when you're practicing LCHF, being a mainstream doctor?
Well, in my local community, what we call primary health organization, which is the management structure for practices, they know how I think, and they're happy to indulge me. When I go to meetings, they actually prepare a low carb meal for me, which is really sweet. But in terms of others, I mean, I get together with a group of doctors in what we call a peer review group once a month. They know what I do, what I think, but they're not really asking questions. How have you remitted this person's diabetes? How can I learn from that? They're not really engaging, and I guess it's because we are tired, burned out, and overworked, and that, as I say, is a negative effect on good practice, because you don't want to do anything extra because it takes time, and that time is tiring. Nina Teicholz, again, she went to a conference some years ago, and she said there was a presentation about low carb and how I think somebody had remitted their diabetes, and there's a room full of doctors, and she commented that not one doctor stood up and said, tell us how you did this, because what we learn at medical school sticks in our minds, and we've focused on that, and it's hard to learn something different. We learn about the latest drug because we're constantly having to prescribe drugs, or people are asking about drugs, and you can't get away from the new drugs. You have to learn about them even if you don't want to use them. So you can't have to do that. But in terms of reversing disease, making people healthier, there's no incentive and there's no interest, generally speaking. However, I don't want to sound totally negative. And just recently, I made contact with somebody in another part of the North Island who I learned was doing low carb, and I phoned her up and had a chat with her. And there are people around the place around the country who are doing it. So, people. Not all doctors are the same, and not all GPs are the same. So there are those that are interested and want to do something different. And lifestyle medicine, which is what this is touching on, is also growing as well. I think you asked about the authorities. Did you as well, about whether or not I've been approached? Yeah, not yet, but I'm expecting something at some point. A friend of mine, she's a dietitian, a well-respected dietitian in Auckland and well-known in the low-carb sphere, recently had a PhD student make a complaint about her for a video that she did. It went into a household in poor part of Auckland, and was advising them on dietary advice on the lines of low carb. And so she was reported to the Dietitians Board in New Zealand and made to account for her actions, which, you know, is just horrible. So yeah, no, one eye on, one eye looking over my shoulder. I don't want to go down that experience, but I cannot not do what I believe to be the right thing. And I don't think I'm doing anything wrong. And I know I'm not, you know, when there's enough evidence out there.
Dr. Marcus, a general myth about protein, that protein are bad for kidneys. Just before this session, if you remember, we were discussing about my case of membranous nephropathy. I use that as an example to inspire people. If I could, find remission of my third stage almost of membranous nephropathy, I think most people would do well to trust protein. What are your views on protein intake? How much should people take? And is it true that as you age, the protein consumption should go down? Because the popular belief that the body is not able to process protein as you age. Is that true? Talk a bit about that.
I think I have a background in general medicine prior to general practice, and renal medicine was an interest of mine. And we're always told, and I think it is true generally speaking, if you're having impaired kidney function, then you should not be having excessive protein, because that can make the kidney function worse. And that is a function, I think, of the protein filtering through the kidney, well, going through the kidneys, as well as perhaps raising the blood level of creatinine, the protein waste product. So I would be very cautious. And I did look after somebody who had he had diabetes and kidney impairment, severe kidney impairment, and he was able to go low carb, and we monitored his creatinine very closely, and he did all right with that. So I think it's a very individual thing. It has to be done cautiously and carefully. It's just the same as some of my kidney transplant patients are. You know, kidney function is normal, but you just don't want to jeopardize things, and you just got to be a bit careful. So in my mind, protein is something that you have to be careful with, and there's no one answer, I don't think. I was about to say to you before, when we were chatting before the meeting, you know, wow, that's pretty amazing. You know, someone who's got membranous nephropathy to then go and have a whole lot of meat. It's very, very interesting, and it'd be interesting to see what any low carb renal physicians would think about that, or renal physicians in general, because it's contrary, I believe, to what we would expect. And I imagine if you had membranous nephropathy, you would have elevated creatinine as well with that. So yeah, it's just counterintuitive from a general medical point of view, but fascinating at the same time. I think when it comes to protein, you can only eat so much protein in a meal anyway. So as people get older, they get less active, they eat less, their muscles do get smaller, sarcopenia as it called it, I think. And I think you want to eat a healthy amount of protein, healthy amount of fat, minimize the carbohydrates. So it's really about, I think, doing that first and foremost. And I haven't got any exact guidelines on protein intake in elderly people, but I just think fat and protein are the way to go with some carbs. And I would expect with physical activity, the muscles to maintain their strength and coordination and bulk. I mean, it will fall off to some degree, certainly, but you keep on top of it with a healthy diet, then I would imagine that you should be okay.
Do tell us about some of your interesting cases that you put on remission, especially if that is of an Indian or even locals, if if that can inspire our people.
Right. Just trying to think. I don't have any Indian. I only got a couple of Indian people doing the low carb diet, and then, as I say, they're not stats good at it, but that's maybe where a health coach will come in, and that's what my next step really. I have a lady, she's about 70, and over the last 2 or 3 years she was able to lose 32 kilograms in weight. She's diabetic. She was on 70 units of insulin. She stopped the insulin totally just by changing her diet and losing weight, and she was able to get her HbA1c, which is the measure of sugar coating red blood cells, how we assess diabetes control, to what we call the pre-diabetic range, and just above the baseline of that. So in other words, she was almost remitting her diabetes completely, not on any other medication for her diabetes, and just diet. So yeah, 32 kilos, 70 units of insulin, fantastic, really, really pleasing.
Mhm.
So that was her. I've got I haven't got any graphs I can show you, but I've got a couple of young men. One was overweight, developed type 2 diabetes, and then reversed that just by changing his diet. I've got, this is really interesting, I've got a young man who's got type 1 diabetes,
Mhm.
and he's just controlling his diet with low carb or keto, essentially. It has to be keto. And he's on insulin, but his insulin is reduced by about 30%. And he's just really looking at just having baseline insulin. And on my Facebook group just the other day, there was a mother reporting her daughter who developed type 1 diabetes. I'm not sure how old she was, but she developed type 1 diabetes. The doctors wanted her on insulin, obviously, and they wanted to give her 50 grams of carbohydrates with each meal and give her short-acting insulin to cover that. So in other words, counterintuitive to diabetes, you shouldn't give sugar to people with diabetes. You don't give a heroin addict heroin, do you? What happened then was that she came off the carbs, and the insulin is minimal now, and essentially flatline her blood sugars, so there's no spikes. David Dykman, he's a young man in America who has type 1 diabetes. He's got a YouTube videos and I think Facebook group, and he's done the same. He's an athlete. He's just taking minimal insulin just to keep himself alive, because everyone with type 1 diabetes needs some insulin, but he's not taking any extra, and he's just having a fantastic life. And this is doable. And going back to that 70-year-old lady I was telling you about, I mean, that was saving the country over $5,000 a year, New Zealand dollars a year, just by her stopping insulin. So I've got, excuse me, a young woman with polycystic ovarian syndrome who, once she's lost 10 kilos, her periods came back and she's planning pregnancy. I've got a man who reversed his non-alcoholic fatty liver disease, proven on ultrasound, lost 10, 15 kilos, and his wife has followed with losing weight as well. Every time she comes in, thank you so much. So I mean, it's all a positive feedback experience for me as well as patients. And, taking medication away is just great.
Mhm.
So, there's lots of stories there.
Yeah, very glad to hear that. Dr. Marcus, tell us about the child obesity epidemic that New Zealand is facing, and as a country, or even as a doctor who is practicing LCHF, is there anything specifically that you're doing to kind of safeguard this generation and from obesity? Because as I see, 1 in every 3 kid is obese. So what can be done?
Gosh, all you can do in terms of what I do is, if you encounter someone like that, is talk to the parents and try and encourage the parents to reduce carbohydrates. That is tricky, because quite often kids are controlled with carbohydrates, if you know what I mean. They sort of, the easiest thing to do is to give them some fries or some chicken nuggets or something to sort of settle them. And for lots of people who are busy and stressed, it's the easiest way to go.
Yeah, I was saying, sorry to cut you off there. The general belief is that if you're not giving children all of these things, you're maybe depriving them of the joy of growing up and stuff like that. So a lot of emotions attached to, processed and junk food, at least in India. And I think it's a general sentiment across the globe. If you are not giving children these things, you are, maybe taken to be depriving them of.
Yeah, I totally agree with what you're saying, but it's all about how you bring up kids. Kids can grow up on carrots and cheese and maybe they'll cracker. They'd be happy with that if that's all they know. But if they're constantly given sugar, then they want more sugar because that's tasty and that instant sort of feedback through various hormones, dopamine, etc. So I think it's very easy to go down that route of immediate gratification. But it also comes down to parent education and using other ways of introducing kids to different foods that are better for them. So no, they're not being deprived. They might feel deprived if you're not going to give them another sweetie because of what they've just done. But you can educate kids and retrain them to do stuff that's healthy. I guess it's a bit like the parallel of when I grew up. When I was growing up, my grandparents smoked and everyone smoked around me, so you kind of grew into that whole idea that smoking was good. So when I was a teenager, I smoked when I was for some years later. But then generations now are growing up knowing that smoking's bad, and no one's smoking essentially. So it's about educating populations. It's about again, behavior change, both in the parents as well as the kids. The parents have to walk the walk and talk the talk with the kids. You can't just have the kids do one thing, the parents do another. But you can move kids away from the foods that are unhealthy. But the parents need those tools to do that, and that's where health coaches and doctors come in.
So how is it, Dr. Marcus, that you're preparing to build this army of health coaches? I mean, what exactly is it that you're doing?
Well, it's not me. It's just an idea. It's just it's a phrase that I have. Now, I'm associated with Auckland University of Technology, and up there they're basically into the low carb area, and they train health coaches in a very proper way, in my opinion, with a whole lot of background about low carb, etc. So I'm very much an advocate for health coaches in this regard, and it's just recently struck me that we do need this army of health coaches. So although I have no role in the implementation of that, I'm very supportive of that and very keen to get that going. And we can do that on a local level at this point in time. But with AUT, I'm actually part of a research or a study where we're actually going to try and implement health coaches into local practices and then eventually spread that nationwide to see, and then measure the effect of that in terms of diabetes. So yeah, it's got to have. We're going to have to change behaviour. If the government's not going to do it, then we got to do it. And the government's never going to do it. I mean, just recently there was an election here in New Zealand. You had three major parties, and each representative on the panel said that they were not going to entertain the idea of sugary drinks taxation, despite the fact it's worked in numerous countries in Europe and other continents, because they wanted to make sure it was effective. Well, the effect has been proven already, but that's what we're up against. Massive inertia and probably a bit of financial lobbying going on as well.
Also, how do you see the metabolic health scenario of New Zealand by 2030, Dr. Marcus? I know you're making a lot of effort individually on your level, but do you see more people like you coming to the fore and doing things? As you said, the metabolic health coaches are now, being prepared. How do you see the health scenario of New Zealand, say in 2030 or by 2030 onwards?
Oh, it's in dire straits. It's just hopeless. It's just horrible. It's going nowhere. We've got staggering rates of obesity in all ethnicities. No one's doing anything about monitoring weight or obesity in the country. It's not even a health parameter that's nationally sort of measured. It's just happening, and of course we deal with the diabetes when it happens, and the high blood pressure and all that, and the complications of diabetes. So there's really no move to make a difference. Now, there are a number of health practitioners across the country, and I belong to a Zoom group. We get together once a month. There's 48 of us, and we discuss relevant issues. So there are people, both doctors, nurses, and health coaches and nutritionists who are working towards this, and I'm picking up new names every other week. So there are more people out there than we know. And we're building this sort of, I guess, workforce to try and improve things on an individual level. And we have Pacific Islander Maori who have obesity rates which are just incredible. I mean, this has all happened really since colonization occurred. And you can see that in other indigenous peoples in Australia and Aborigines, in the Canadian Inuit. You were asking, I think, about initiatives that we have as well. I mean, the initiative is really to get the word out there via my Facebook group. It's articles that I've published on what I've done with my patients. It's about asking the question, were Maori once low carb? Let's focus on obesity in New Zealand. These are articles that have been published, and they're just showing this drive to try and bring the subject to the fore. I mean, I've written to newspapers and national radio, but no response, not surprising. So I remain on the crusade, along with other like-minded people, health professionals and researchers, and hopefully we can make some change. But it's got to be the people or politicians that make that change, I think.
Yeah, you talked about Maoris, Dr. Marcus. I have some data with me, the ethnic group. Do they also have type 2 diabetes? And I recently read that the Maoris are 1.8 times more likely to have diabetes than non-Maoris,
Oh, for
and are
sure.
more likely to experience comorbidities and lower glycemic control. Why is that? And what's happening there?
Well, as a rule, excuse me, Maori are relatively poor. Therefore, the foods they eat are not necessarily best for their health. They have significant rates of obesity. And of course, with that comes insulin resistance and then diabetes, type 2 diabetes. Of course, once you get type 2 diabetes, then you're at risk of heart disease, stroke, kidney failure, peripheral neuropathy, visual problems. And, you know, you hit that diabetes mark and it's all downhill from there. And then there's compliance with medication. Then there's poverty, you know, so you're eating the wrong foods because you can't afford the right foods. It's just a nightmare. And of course, Maori don't live as long as Europeans either. And partly it's due to the fact they get the obesity-related diseases. So, no, it's not good. And I'm also on a crusade to try and make some changes in that area as well, when I can find the right people to do that with, because at the moment it's just tragic.
And what are your views? I mean, I wanted to ask this very significant question. People who are even on LCHF diets, I've often seen them gravitate towards cereals, thinking it's healthy, the cornflakes and stuff like that. What would you tell those people who are trying to be on LCHF but still haven't gotten off the cereals and oatmeal and stuff like that?
Well, that's where follow-up is important, you know. So, you know, if someone's on an LCHF diet or low carbohydrate diet, then just as you would follow them up for prescriptions for medication, you follow them up to see that they're on the right diet still. So it's just about regular review. It's about asking what they're eating, and it's about education. And again, you know, someone may have cereal each day, but they may have reduced the amount of bread, potatoes, pasta, and rice overall, so maybe they can have cereal. It's really about what you're trying to achieve. If it's a healthy way of eating, reduce the carbs. If it's about weight loss, then you need to reduce the carbs significantly, plus or minus keto. If you want to reverse disease, remit disease, you probably go to keto as well, or very low carb. But it's education, and it's about the appropriate level for what you're trying to achieve. So again, it's about regular review, not just saying, yeah, go away and do that. You've got to follow people up and have regular appointments and see that they're on track, because, you know, it's a learning process. It's not just a case of here's a handout, go do it. It takes time to learn this, and it takes time to do it, and it also needs encouragement. So yeah, it's about seeing people.
Dr. Marcus, also explain to our viewers a bit about how it all starts with insulin resistance, because a lot of people do understand obesity and individual metabolic health markers. They don't understand how is insulin resistance the root or the cause of where it all starts.
I don't think anyone really knows how insulin resistance actually kicks off. What we know is that people become insulin resistant. So you're exposed to carbohydrates over the years and high dose. I mean, we're talking, you know, all the starchy foods that we normally would eat. And as a result, for some reason, the body doesn't handle that. The insulin that's produced in response to the glucose that ends up in the blood becomes less effective over time. So the levels rise. And as the levels rise, they get to a point where they can no longer cope with the glucose load that people are taking at a standard carbohydrate diet, such that the blood sugar starts to rise, because normally insulin puts sugar into cells. So the blood sugar starts to rise, and you get your pre-diabetes and then diabetes. Now, I think it's silly to talk about pre-diabetes. I think it's all diabetes essentially, or call it something else. But hyperglycemia, raised blood sugar, because it's a spectrum, and you still get damage to blood vessels even with pre-diabetes. So yeah, you're basically looking at insulin becoming less efficient, and so what you see is a rising level of insulin and lesser effect. That's your insulin resistance, and therefore the blood sugar rises. Blood sugar's a toxin to blood vessels when it's at a high level, which does damage to blood vessels in the brain and the heart potentially. So it's chronic carb exposure. And it's interesting because, as I mentioned before, I've got overweight Indian people with diabetes type 2 and slim, skinny people with type 2. So it's not just about the weight. Weight is a big contributor. And more people who are overweight will have pre-diabetes and diabetes. But people who are slim, skinny, can still have diabetes because they've become insulin resistant. So maybe another speaker will know more specifics about insulin resistance and what kicks it off. But at the end of the day, the problem is, I think, carb exposure over a long time that then causes the problem.
And a lot of people are also of the belief that pre-diabetic is a stage where it's not that critical, it's not that dangerous, it's not an emergency situation. What would you have to tell those people?
I think that once someone becomes pre-diabetic, that's the time to jump in and tell them that, you know, here is an issue. You are insulin resistant. This will progress if you keep eating carbohydrates. And we know we're told diabetes is a progressive disease, but it is if you carry on eating lots of carbohydrates. If you stop eating them, then it doesn't progress and it reverses or remits. So that's the time, the critical time to actually get in and tell people there's an issue. And that's, I think, where we have the biggest bang for buck when it comes to saving health systems from the ravages of diabetes. Get in there, stop the pre-diabetes advancing or reverse it, and then you don't get the other complications. Whereas once you get to the point of diabetes, well, you already probably have done some damage up to that point, but automatically you've got a higher risk of various conditions such as heart disease, kidney disease, and stroke. So you need to focus early and get the message in early and do something about it early.
Yeah. Dr. Marcus, what would you be your message to India, message to New Zealand, especially in the context of India doing this first Metabolic Health Conference? What would you tell Indians here in your country and, you know, the general people?
Yeah, well, I've visited India a long time ago, but I've visited India, and so I have an appreciation, I think, of what you're trying to do for the nation's health. I think the Indian people need to listen to people like Shashi and you and Anup. I think it's great because you're embracing a healthier way of eating and improving or reversing obesity and chronic diseases relating to insulin resistance. And you deserve full credit for what you're doing in this battle against big food and big pharma, both of which complement and sustain each other. Healthcare is becoming unaffordable. People are living longer with more disease, more expensive treatments. You can reduce the misery that goes with these morbidities and reduce premature death. In India, you have the need, you have the manpower, you have the know-how, you have the technology. So I'd say go India.
Yeah, thank you. And I would like to call in Anup and Shashi as well to have the last word with Dr. Marcus. Can I have them on the screen, please? Yeah, I think Shashi and Anup both are here. Anup and Shashi, would you like to have a word, put in a word?
I'm very curious to know about the situation of the pharmaceutical medication. What meds are used more in New Zealand? What I've been reading is the market size in 2023 is expected to be $689 million US, and it is projected to grow to $839 million by 2028. Very curious to know what are these medication. I'll give you a brief background. In India, the number one pharma medication is insulin. It is from Novo Nordisk. So it's a mixed insulin. Like in your country also, what I see is primarily when it comes to diabetes medication, we have Sanofi, we have Lilly, we have Novo Nordisk as primary. So in India, though the number of type 1 diabetics are less, we see that in the top 10 brands, three are insulins. That means it is the glycemic control is very bad in India, that it advocates pushing a lot of insulin in people. Other than the latest drug, all latest drugs are available. SGLT2 inhibitor, DPP4, everything is available. So how is it in your country?
Oh, there's a drive to use insulin. I mean, it's interesting. You know, some years ago, I must confess, I gave a talk for Sanofi because I was very much on board with the use of Lantus, glargine insulin, because, you know, at that stage I was pre-LCHF, and what I was told was that, look, you can control insulin very easily with once a day Lantus, and, you know, it's magic because it doesn't cause hypos. It's just so easy to use. So I jumped on that because it seemed logical. And I gave a talk about my success with my patients. But, you know, now I don't do that. It's now about trying to encourage people to stop eating carbs and get the HbA1c, the numbers down. And I very, very rarely, I can't think of the last time I used insulin as in a new diabetic or someone who's poorly controlled. I use oral medication if they can't manage the low carb. But low carb will always be my first focus. So yeah, Lantus, there's a big drive both in type 2, obviously, in type 2, type 1 obviously, but in type 2 to use insulin earlier than later. And it's crept in, and the drug companies are very good at that. One thing I don't do any longer, or I haven't done actually for years, is if I see drug reps in my practice, I refuse to. I just don't do it. Yeah, it would be insulin, but of course you've got these newer drugs coming out now, the Jardiance and the Galvamet, and it's the cardiologist prescribing them because of this and that, and it's just come rushing in from all areas. These new drugs, I can't even remember their classification, GLP 1, 2, 3, or whatever it is. It's mind numbing. You should start with basics first and then gradually add on if you can't cope. So yeah, I can't tell you exactly which of the drugs, but we are behind typically in New Zealand with implementing things like, well, certainly the latest drugs, latest here have been out for 10 years in other countries. So yeah, in that regard, it's a bit crazy. Can I just make a quick comment about diabetes in New Zealand, and that, the Ministry of Health has not latched on to what Australia, Canada, the United States and the UK have said about low carb. We still think low carb is bad here. The Ministry of Health slags it off as unhealthy, as non-sustainable and non-effective. But these other authorities who, I think have a fair bit of experience and knowledge, they actually are giving it a tick now as an adjunct to managing diabetes. Just wanted to add that. Sorry.
I think, see, it is still surprising that when in 2019 itself, American Diabetes Association has already endorsed the use of low carbohydrate or very low carbohydrate diet in their MNT. But I think that MNT section is something which is not read properly. And I think people go for those drugs algorithm, which drug to start and which drug to end up with. Usually, of course, that is insulin. But I think if MNT is read, then people will know that. And this is the biggest authority in the world. And they've been having continuously from 2019. I think now it is accepted worldwide.
Also,
yeah, I think it should be accepted worldwide to that it is an option.
And the American Heart Association has no limit on the amount of saturated fat these days either.
Even they mentioned that low carbohydrate diet is very effective in glycemic control and in reducing triglycerides. Very categorically.
Oh yeah. Definitely.
And we have Diabetes Canada going one step ahead. Even they recommend low CHO and very low CHO diet for Diabetes Canada, for type 1 also, in addition to type 2.
Oh yeah.
So we have everything. Obesity Medicine Association recommend the use of low carbohydrate or actually ketogenic diet as one of the options for weight loss. I mean, it is there. It is just that we do not know that these options are available.
But they take time to implement with people.
Anup, anything you want to say?
Yeah, Dr. Marcus, I think you said, handling Indian population is a bit tricky because of the carbohydrate rich or grain centric diet. So, we are entirely focusing on Indian population, and so far we have been very, very successful in, dealing with them. So in future, I'm looking forward to possibility of collaborating to handle Indians in New Zealand primarily.
Yeah, please,
So
that would be great. Yeah, absolutely.
And I think step one is Anup is going to give you full access to D-Life in Forum, where you can access more than 1,000 Indian dishes, Indian low carb dishes. They will love it.
Fantastic. Yeah. Oh, thank you so much. I mean, I love cooking Indian as well.
And the striking feature of that is that those are not rehashed recipes. They have been all posted by members who have gone through whatever protocols we set or whatever we told them to do, and they achieved success. So they're all real world recipes and not rehashed ones. And 50%
trying it myself.
Yeah, and 50% or plus are vegetarian low carb.
Oh, even better. Wow.
Because the biggest challenge is in implementing the vegetarian low carb program. It is the biggest challenge, especially for Indians. So we Indians are dairy loving people. So we add dairy proteins to that, which makes it very easy.
Good. Yeah. I mean, most of my Indian patients are meat eaters, but I know that, a fair number of Indians, especially in the South, are vegetarian.
Fine. Thanks. I think we are coming to end of the session.
Thank you, Dr. Mark. So, yeah.
Yeah,
Thank
Well,
you.
thank you all.
Doctor.
Really appreciate the opportunity, and yeah, love to collaborate and talk to you again. And all the best with your conference. It's fantastic.
Thank you,
you
Dr.
too.
Marcus. Thank you for coming
Thank you.
over. Thank you for speaking to us.
You're
And
welcome.
Personally,
You're welcome.
I want to thank you personally that I found you in Diet Doctor. I was so happy to find the only doctor in New Zealand who appeared in Google search for low carb. Thank you very much.
Thank you.
You're welcome.
We can
Thank you
have
all.
so we can have the next session. Dr. Peter, Yogesh Dikshit, and Anup Singh can be here.
You're muted. Yogesh, you are muted.
Okay.
Yeah.
Cool. So good morning and good afternoon to our viewers in India and abroad, and a very warm welcome to our esteemed guest, Dr. Peter Buckner. Dr. Buckner is a medical doctor, and he has had two passions during this medical career. His first passion was sports medicine. Dr. Buckner is a world-renowned specialist sports and exercise medicine physician and researcher as well. He has been a team doctor to Australian national swimming, hockey, athletics, soccer, and cricket teams, as well as Liverpool Football Club in the English Premier League. He was Australian team physician at the Atlanta Olympics and team manager at the Sydney Olympics. However, Dr. Buckner's second passion is around nutrition. Why? He believes we have epidemics of obesity and chronic diseases such as type 2 diabetes owing to consumption of wrong foods. And to tackle this, Dr. Buckner has founded two public health initiatives in Australia. The first being Defeat Diabetes, and the other one is Sugar by Half. He has also authored the best-selling book, A Fat Lot of Good. Personally, I'm a big fan of your lectures, sir, at Low Carb Down Under, and those are quite intense and humorous as well. So across his illustrious career spanning across 5 decades, he garnered a number of titles, citations, and roles at the highest level. Now, let me take the honor to quickly introduce Anup Singh here. He can be regarded as the pioneer of low carb movement in India and is also the founder of D-Life, which is an e-learning and community platform for low carb. So, Anup Singh, do you want to add anything on that?
Yeah. First of all, good morning, good afternoon, everyone. And basically, I'm a type 1, type 2 diabetic since 2011. And I've been living low carb since then, and pill-free life and non-diabetic numbers. The platform is basically now the largest and the only platform for Indians anywhere. And we started as a community, and now we are into providing certification courses with the primary aim of building an army of low carb coaches. So welcome, doctor.
Thank you. Thank you for having me. Thank you for inviting me. It's a pleasure to. I've loved my visits to India in the past, and I'm very fond of the Indian country and the Indian people. So it's a pleasure to be here.
Amazing. And thanks again for accepting the invite and providing your valuable time over here, Dr. Buckner. So our discussion today will be broadly based on 2 topics. One is about the low carb in sports, and the next one is about your recent mission to improve Australian population's metabolic health through our initiatives, typically Defeat Diabetes. So it will be broad-based on these 2 topics. So let's start with the sports nutrition and your career across 4+ decades with sports, right? So and then you have worked with the teams, sports teams, national, international, Olympic level teams at the highest levels. So are there any significant changes that you have seen in athletes and typically to do with their nutrition over the last 4+ decades?
Yes, well, I really grew up in the carbohydrate era. It was carbs, and
Yeah.
but every athlete was told that you've got to carbs are the best fuels, carbohydrates are the best fuels. We need to fill up our muscle glycogen. And we had pasta parties the night before the marathon, and lots of sugary drinks, Gatorade and Powerade and so on, and gels while we were running marathons. And it was really it was all about carbohydrates. And there's no doubt that carbohydrates are unofficial fuel. An efficient fuel. There's no doubt about that. But my concern, really, with that whole generation is that we've had a generation of athletes who've had incredibly high levels of carbohydrate intake, mainly in simple sugary sort of carbohydrates, and I'm really concerned about the long-term effect of that. I think many of them would have developed insulin resistance and go on to type 2 diabetes and all the complications with that. So I think we really needed to rethink our whole way of fueling the athlete. And I guess in the last sort of decade or so, we've become aware, initially through the works of Jeff Volek and Steve Finney, and more recently through people like Tim Noakes, that there is an alternative fuel to carbohydrates, and that's fat. And we've sort of lived through the whole era of demonizing fat and the low fat high carbohydrate world, and so it's taken a real effort for people to get their head around the fact that maybe fat is okay, and fat can be a very efficient fuel for the athlete. Now my one rider is that probably at a very elite level, at very high intensity level, then carbohydrates are still required, for most people. But for the vast majority of people, they can fulfill their exercise needs on a low carbohydrate, high fat diet, because fat, as I said, is a very efficient fuel. It also has a number of other advantages. Probably the first one from the athlete's point of view is that you don't have to keep eating, or keep drinking. You see, someone doing an Ironman or a marathon, having to constantly be drinking and eating gels and eating bananas and things to fuel themselves. Whereas if you're running off fat, you don't need to take on any extra fuel at all. And I've had people do Ironman triathlons and just on water. And so that's a big advantage. The second one is the recovery, and that you just seem to recover a whole lot better when you're running off fat than you are off carbs. Carbohydrates, and especially the simple sugars, are quite inflammatory and cause a lot of sort of muscle soreness and muscle damage. And we've noticed that people recover so much better and are able to resume training after a hard race much quicker when they fuel themselves with fat, and that's certainly a case. And also injury-wise, I've had people who have sort of arthritis or tendonitis, might have Achilles tendonitis. They seem to do much better on reducing the amount of sugar in their diet, because, as I said, sugar is inflammatory, and they do better on a low-fat diet. So there are a number of advantages to having fat as your main fuel rather than carbohydrates. Now, there is a lot of individual variation, as I said. I've had people, at high level of professional sport be totally ketogenic, but I've had others who've been largely sort of ketogenic during the week, maybe, and then on match day they feel as though they need an extra sort of a little top up, or a cyclist who feels, no, I just need to get up those hills or to sprint, I just feel as though I need an extra gear and I need some carbohydrates. So the world of sports nutrition is gradually changing from this obsession with carbohydrates into more individualized, personalized nutrition, and depending on your training load and on basic, maybe low to medium level training days, people will just use fats as their fuel, and then maybe on high intensity training days or competition days, they'll top up with some carbohydrates. So it's an evolving area. There are still a lot of dietitians and experts who think that carbs are the only fuel for people, but I think it's now shown quite clearly that fat is a very efficient alternative fuel for the athlete with lots of side effects and other advantages.
Sure. Thanks. And that was a very powerful insight into sports and how essentially we should be looking at carbs and fats. So I think my one-line takeaway for the viewers over here is like you absolutely don't need carbs on most of the days. I think on championship days or maybe elite kind of performances, you might require, or you can do some mix and match just in case if required. I mean, at the highest levels, but most of the times you don't need carbs to load yourself with carbs, let's say, for your any kind of an endurance or any other sporting event as such. So that's an amazing. I think you mentioned about injuries, so I was about to be coming to that. So are you seeing, let's say, any negative or positive impact, let's say, on a sports performance when it comes to, let's say, embracing low carb as a diet or maybe ketogenic as a diet for athletes? I mean, is it getting better, or are there any issues that you're seeing?
No, I think it definitely is an advantage. And I've seen a lot of people with chronic injury problems do a whole lot better with when they drop their carbs that are causing the inflammation. And I think that's a really important breakthrough. That we're currently doing a study at my university looking at the effect of what we call an anti-inflammatory diet on knee osteoarthritis, for instance.
Yeah.
And the initial results are very encouraging, that people are having less pain, better function, and hopefully those results will be out in the next year or so. But it certainly is a weapon that we didn't realize existed in the sports medicine world. We tend to sort of use a lot of medications and anti-inflammatory drugs and things, and yet there's just as effective, I think, is the dietary approach by reducing the inflammatory the foods that cause inflammation, and they're basically the highly processed foods. So things like foods that contain sugar, but also foods that contain vegetable oils are quite inflammatory. So the ultra processed foods that unfortunately are sort of taking over in both of our countries, I think, as a sort of staple diet, they are quite inflammatory, and we need to get back to eating the way that our previous generations ate real food, rather than this very processed food, which is quite inflammatory in nature.
Absolutely. And coming back to our topic of discussion about injuries, and being an ardent cricket fan, and I know, I mean, you worked at the highest level when it comes to cricket, but there is a famous, I think, incidents that I can recall with a great Australian cricketer, Usman Khwaja, and he came across the knee injury, and I think there is an episode happened after that, and he became probably the number one batsman after that, after the kind of, let's say, a rehab that he went through. Can you throw some light on that, because that's an interesting one for most of the viewers who are here?
Yeah, well, it certainly changed the way I think about things. So this was 10 years ago now, and we're actually in your country, in India, touring India with the Australian cricket team. And Usman Khawaja at that stage had a lot of injury problems. In particular, he had a knee injury, and the source of the knee injury was unclear, and no one could really work out what the problem was with his knee. And he'd had a lot of tests. He'd had MRI scans, and he had arthroscopy, and they couldn't really work out what was going on. And he didn't play cricket for at least a year. And so then he'd seen a doctor in Sydney, and who diagnosed him with a condition called seronegative arthritis, which is basically like a rheumatoid arthritis, but not exactly rheumatoid. It's similar to rheumatoid, and placed him on some drugs, and some quite powerful drugs, some cortisone and so on, and that helped him a little bit. And then put him on a very powerful drug, which is a tumor necrosis factor inhibitor, if you want the science. But it's a very very expensive drug. It costs about 10,000 Australian dollars a year for this drug. And when I met him, he was injecting himself with this drug once a fortnight. And he said it could have controlled his knee pain reasonably well. He was back in the Australian squad. He wasn't in the actual team, but he was in the squad on tour. but he couldn't train fully, and I think the coaches thought he was a bit, a bit lazy, but he was restricted in what he could do. And he said at about 10 days after his previous injection, into that sort of fortnight, his knee would start to ache, and he'd know, it's time for my next injection. So he approached me on that tour, and he said he was interested in losing a little bit of weight, and which is an interesting thing, because it amazes me how so many elite athletes who basically spend their whole time training are actually a little bit overweight, and that always sort of mystified me. I now understand it, I guess, because of their diet. But anyway, so I just lost a whole lot of weight, which everyone had sort of noticed, and so on when I started my low carb journey. And he said, "Look, I'd like to try what you did." And I said, "Sure." And I said, let's do that. And he basically went on a low carb diet, stopped eating all bread and rice and pasta and so on, and just ate a very real food sort of a diet. And the good thing about working with these people is that they're very disciplined, and he was very disciplined about what he did, and we started to lose a little bit of weight. And about 3 weeks later, he came up to me and he said to me, "Doc, I forgot to have my injection last week." And I said, "Well, what do you mean?" He said, "Well, I haven't had any knee pain, and I forgot to have my injection. Should I have it today?" And so I pretended that that's exactly what I expected. He had no idea, of course. And I said, "Look, why don't you wait and see what happens?" Anyway, to cut a long story short, he didn't have to have any further injections. He managed to. He had no knee pain. He managed to increase his training. He got back into the Australian team. 12 months later, he was in the top 10 batsmen in the world, and he's still playing now. It's now more than 10 years since then, and he's still at the top of his. I think he has the highest average as an opening batsman of any athlete, any cricketer in history. So that really opened my eyes for the first time, I guess. And we're all learning all the time as clinicians, and that really opened my eyes to the effect that nutrition could have on inflammation. And Usman still he's still low carb, and he's still passionate about it. And we see each other occasionally, and we all have a laugh about that time. And he's very grateful. And he's now got a family, and they're all eating in a very healthy way. So it's a great story, but in particular, it was just a really important learning phase for me. I mean, I'd had two sort of big moments, really. I mean, one was my own experience. And then secondly, this one that opened my eyes to the effect that, and so I've been encouraging most of my athletes now to reduce their intake of junk food and processed foods, and try and make them get them eating more real food, lower carb food, and many of them have really really done well with that.
Amazing. And what entices me is the fact that he's already in his late 30s. I mean, Usman Khwaja is in his late 30s, and he's been playing after that particular incident, that particular injury, which was almost threatening to his career, it seems. I mean, that's what I've read in the press and things like that. Yeah. So that's an amazing story, success story. So taking this thread forward, Dr. Bruckner, I mean, I would like to understand, while there are so many of these, I mean, these success stories which we get to hear, but are you seeing or have you experienced any pushback from, let's say, athletes or sports management teams, anything on those lines? Like, I mean, a consistent thread that we are discussing across different sessions is, let's say, in terms of your own country, are you facing any kind of challenges, right? I mean, with respect to, let's say, from governments or any other organizations or things like that. But here, I think I want to put it in a little different perspective. So do you see any pushback happening from, let's say, athletes themselves, that I don't want to, they're scared, or they're probably not willing to be getting into low carb or things like that, or maybe the management team, those kinds of things?
Yeah, the athletes themselves are usually pretty quite open to the idea. I mean, they're always looking for ways of improving performance and reducing injury. That's the two things that they really want. And many of them have come to understand that that's a potential way of doing both. But there are certainly plenty of athletes who are very firmly wedded to the carbohydrate model, and that's fine if it works for them. That's fine. I think the major impediment really is the dietitians. The sports dietitians have all grown up, being educated and with the carbohydrate obsession, and so they're quite a challenge. I know with the cricket team we had a dietitian, and she and I didn't really totally agree on things, and the diet was her responsibility. But after a while, the players started coming to me and asking me about the diet and so on, because they'd seen the success that other people had and so on. So yes, there has been a lot of pushback. There has been some sort of official pushback. I think you're speaking to Dr. Gary Fettke today, and he'll no doubt tell you his story. And but I think we've gone past that. Fortunately, I think there's now much greater acceptance of this as a really realistic alternative to the traditional dietary model, and there's lots more interest, particularly among young people and particularly among young doctors. We find a lot of young doctors are actually practicing this way of eating themselves, and are much more positive about it than maybe the previous generation of clinicians who all grew up. Look, I quite understand why it's difficult for doctors and dietitians to sort of change their whole do a 180-degree turn, if you like, in the way they the advice they give. I mean, if you've been saying one thing all your career, and all of a sudden, some crazy people come along and say, we think you might be wrong, and so on. I can understand their resistance to that, and I can see that. But I think what we need is just more and more evidence, more and more scientific evidence, of which there's starting to be an increasing amount, which is why we're doing some of this research we're doing into arthritis and other events. I'd love to do a study on tendinitis next. That's next on the agenda, and see how we can improve that. So yes, there has been pushback, certainly, but less and less so all the time.
Yeah.
And some of the official bodies, some of the medical bodies. There's the main diabetes organisation in Australia is called Diabetes Australia, and they are very interested in what we're doing, and looking at coming on board with us as well. So things are changing, certainly, and interestingly, I think it's been driven by the public, by patients. I think patients have been educating their doctors, which sounds like a crazy thing to happen, but I think patients are coming into their doctor and having gone onto a low carb program and improving their diabetes or their weight loss or whatever, and the doctors are having to take note, and some of them try and pretend it didn't really happen, but after a while you have to admit that there's something going on here, and I think they've played a really important role in educating my profession.
So that's really encouraging to know the things are changing for good. And I think different perspectives I've got. One interesting is about the patient-doctor relationship and how doctors are probably becoming learned, right? I mean, for whatever reasons. I mean, not discounting what they have been doing or what they do, but that's a very different perspective. Thanks for sharing that. And we are really looking forward towards your study and research on tendons, right? I mean, tendinitis, because I think Achilles tendon is one of the worst kind of injuries that any athlete or maybe runner come across. So that's an amazing thing.
What people don't realize is that the doctors don't know much about nutrition. I mean, everyone assumes doctors know everything about everything, and they really, I mean, I did not have a single lecture on nutrition in my 6 years of medical school. Now, that was a long time ago, but last century, but it hasn't changed much.
Yeah.
And so, in a way, I sort of understand that doctors are reluctant, because you tend to stay in your comfort zone, and the comfort zone for medical practitioners is medications and surgery, and so that's what we recommend. I mean, we're not well educated on exercise and nutrition and these areas, so we tend to sort of steer away from them and focus on the things that we know, and that's one of the challenges, that we have to educate our medical students and our doctors much better in the importance of nutrition and the role that nutrition and exercise can play in the management, particularly of chronic disease.
Yeah, and that's, I think, very much a healing-focused approach that should work. I mean, that's the way. India, right? I mean, when it comes to sports. So what are your views? I mean, let's say we are almost there. I mean, in terms of the most populous country. And the performance that we have at the World Championships and Olympics and other levels, sporting events, is not at par as compared to, let's say, the population. What comes to your mind in terms of improving this particular situation? What can be done, just in case?
Well, there's no one simple solution.
No,
I'm sure if there was, then someone would have tried it already. I mean,
anything
look,
to do
there's
with
a lot.
nutrition? Anything to do with
Yeah.
nutrition?
Look, I think it plays a role, certainly. I think I think obesity and overweight is a massive problem in virtually every country now. We've gone from concerns about being underweight to in a generation we've gone from being more concerned about overweight, and so I think that is a real problem, particularly in children. I think the obesity rates and the rates of overweight in children are skyrocketing, and that obviously impacts on their exercise and their sport and so on. So I think we really need to address the dietary issues, particularly in children. They tend to have very poor diets these days. A lot of junk food, a lot of fast food, a lot of highly processed food. Yes. And I think that can affect a whole generation of children, and they're that makes it much more difficult for them to become elite athletes. And so I think definitely nutrition is a significant factor. I'm not suggesting it's the main factor, but there's a lot of factors that need to go into sporting success. And unfortunately, these days a lot of it is money. That government's putting money into elite sporting programs and so on, and that's what countries like Australia did in the early 2000s, or leading up to the Sydney Olympics, put a lot of money into these programs, and Great Britain followed suit and took over from Australia really as one of the top nations behind the really big countries. So and that required a lot of funding, and again, that's a matter of priorities, and I'm not going to get into that issue of whether it's more important to spend money on schools and hospitals or winning gold medals. I mean, that's a difficult one, but I think the important thing is not so much winning gold medals, although that does inspire a generation of younger people. But I think the main thing is to improving the health of the nation, and I think diet and exercise are the two key factors in that. We need to have our younger children, our children and adolescents, eating well and exercising regularly, and then as a result, if there's opportunities there, if there's programs there, then the elite talent will come forward and be successful. But unless we get the basics right, then it's going to be very difficult, I think, for to be successful.
Right, and it would be, I mean, a lot more interesting to discuss on sports, but let's move on to your own journey, right? I mean, in terms of what made you embrace low carb in first place, and which happened probably around 11 years back. But if you can just share some stories around
Sure.
that.
Yeah, that's right. Well, I was 60 years old, which was the age that my father had developed type 2 diabetes, and so I was very aware of the potential for getting type 2 diabetes. I was living in Liverpool, England, working with the football club there, and if you'd asked me at the time, how was my health, I'd have said, I'm okay. The reality was that I was metabolically quite unwell. I was overweight, borderline obese, and like many sort of middle-aged Australians, I'd probably put on half a kilogram a year for 30 years, and just gradually got thicker around the waist, and my children are sort of poking me in the stomach and saying, come on, Dad, it's time to lose some weight, and I would shrug my shoulders and say, well, look, I'm on a low-fat diet, it's recommended, and I exercise, and it's not my fault. And as well as that, I'd had a fatty liver on my blood tests for the previous 10 years. And to be honest, at the time, I didn't really understand what a fatty liver was. And I figured I was on a low-fat diet, so I was probably doing the right thing. And like most doctors, I ignored my own health warnings. And I had a high triglyceride levels and high insulin levels and so on. So I clearly was metabolically unwell. And in retrospect, I was obviously pre-diabetic. I mean, but I didn't realize it at the time. I thought I was fine. And it was my colleague Tim Noakes who got me onto it. Tim and I are old friends. We've known each other for a long time, both in the sports medicine, sports science world. We would Tim and I would often be the only two sort of non-Americans at some big North American conference, and we'd catch up in a corner and talk about cricket and rugby rather than baseball and American football and so on. Yeah. So we're all friends, and I'd also admired Tim's intellect enormously. I mean, he'd challenged a couple of the tenets of sports science over the years and been proven right. And so when he came out, I think it was early 2012, and said, no, we've got all this diet thing wrong. It's not fat that's the problem, it's carbohydrate, and talked about the way he'd reversed his own type 2 diabetes. My initial response was, "Oh, come on, Tim! You've really lost the plot this time. That couldn't possibly be right. The whole world couldn't have got this wrong for the last 50 years." But because it was Tim Noakes, I guess I thought, no, look, I should look into this. And I bought a book by an American journalist called Gary Taubes called "Good Calories, Bad Calories," and I guess realistically, this was the book that changed my life. And I read, started reading this book, and I got more and more into it. And because not only did the book talk about the relative merits of fats and carbohydrates and so on, and present a very good argument for that, it talked about the politics of how the sort of the low fat movement had won out over the low sugar movement back in the 70s. Now, which I'd always assumed was on the basis of good science and evidence, and turns out to be money and politics, and we should have guessed, really. And this book just blew me away. I distinctly remember sitting on the edge of my bed at night, after reading some of it, thinking, no, this couldn't be right. We couldn't have got something as basic as the whole Western world had actually been on this low-fat diet for 50 years. And here's this guy saying, it's wrong. I mean, I found it quite disturbing, actually. So I finished this book, and I thought, no, look, I need to know more about this. So I dived into every book and journal article and magazine article and everything I could get my hands on for the next few months. And I guess I'm a little bit OCD, but anyway, I really dived into it. And the more I read, the more I thought, no, I think he's right. I think we really have got it wrong. So then I decided, well, it was time. I'm a scientist, or a pseudoscientist, and I decided it was time to do a little experiment. But I also knew that an experiment with an n equals 1 is a waste of time, except when the one is you. And so I decided it was time for my own n equals 1 experiment into low carb. So I decided that I would do a 3-month trial of adopting a low carb diet. So on day 1 of the 3 months, I got my bloods taken, and I showed all the things that I'd mentioned, the fatty liver and the high triglycerides and so on. And I weighed myself, and I embarked on a low carb diet for 3 months, and stopped eating, all the foods that I'd been eating a lot of, rice and pasta and cereal and bread, potatoes and all processed food or sugary foods. And I went back to eating probably the way that my grandparents would have eaten, just real food, sort of meat and fish and green vegetables and eggs and dairy and all the things that we've been told were bad for us. And it felt quite strange, actually, because when you've been told things are bad for you for a long time, and all of a sudden you're trying that, you sort of felt quite strange. But the only fruit I ate was berries. I ate some nuts and seeds, and my 2 little indulgences were a little square of dark chocolate, in the evening, and maybe the occasional glass of red wine. But I really I was pretty strict on that for 3 months, and then things started to happen pretty quickly. Initially, I started to lose weight pretty much straight away. But the first thing that happened was that I stopped being hungry. So instead of sort of having my cereal for breakfast in the morning, and then getting to 10:30 in the morning, thinking, gosh, is it lunchtime soon? I would have my eggs and bacon and avocado or something for breakfast, and then not eat again all day. And I went from eating 3 meals and 3 snacks a day to eating 2 meals a day, and I basically stick to that to this day. And then I started to lose weight. Every week I'd get on the scales and I'd lose weight. Initially I thought, oh, that's just initial luck, if you like, but it just kept happening. But also, I just felt much more alert. I had more energy. My exercise improved. My sleep improved. Everything just seemed to work a whole lot better. And so at the end of the 3 months, I'd lost 13 kilograms in 13 weeks, and felt great. And I did my bloods again, and my fatty liver that I'd had for 10 years had completely disappeared. My liver function tests were back to normal. My triglycerides were normal. My insulin was down to normal. And basically, I'd resolved all my metabolic health issues in the space of 3 months. I mean, it may have been less. I only did my blood tests after 3 months. So, and this just blew me away. I mean, I just couldn't believe that you could have such an impact by changing what you ate. And I guess many of us have, many of your audience, I'm sure, have been on a similar journey. And you've got one or two choices when that happens. You can either say, well, I'm okay, I'll look after myself, and that's it, or you could you could spread the word, and I decided to do that. I didn't really have much choice, because everyone would come up to me and say, my gosh, what have you done? You look you've lost so much weight and you look so much healthier, and so on. So I started continued reading a lot about it, started talking about it, then started writing about it. Then we started this campaign called Sugar by Half in Australia, with the aim of reducing the amount of added sugar by a half. The average Australian probably has nearly 20 teaspoons of added sugar a day, and we wanted to get that down, at least by a half, and down to recommended levels, and so on. And that program's been going for a few years now. We've got a good schools program. We've got lots of lessons that we've designed for school teachers to promote the low sugar movement in schools, and that's been rolled out to a lot of schools in Australia. And then I was approached to write a book, and I sort of by Penguin, one of the big publishers, and my initial response was, the last thing the world needs is another diet book. But they convinced me that there were very few by Australians, or by Australian doctors in particular, and so I wrote a book called Fat Not a Good, which has been a great big seller. It was on the bestseller list for a number of weeks, and it's really done well. And I've had a lot of great feedback from people who tell me that their lives have changed as a result of that book. But then the elephant in the room really has always been type 2 diabetes. And, it's such a common condition. Nobody talks about it. It's not, it should be, right up there in the top of everyone's concerns. But it seems this hidden epidemic. And I've sort of was wondering why. And I think the reason is because people don't die of type 2 diabetes. They die of all the complications, as we know. Type 2 diabetes is a major cause of blindness, a major cause of kidney disease, of amputations, of heart disease, of Alzheimer's, and all these things. But it's not the type 2 diabetes that kills you usually. And yet there was evidence starting to come out from overseas that type 2 diabetes isn't necessarily a chronic progressive disease, as we're all taught in medical school, and you're on medication for life, and you're just going to inevitably get these complications. That you can actually put diabetes into remission. And there are a couple of programs, one in the UK, diabetes.co.uk, and one in the US, the Verta program, that have shown that using technology and using an app can be very effective in putting type 2 diabetes into remission, or certainly improving diabetes control. So initially we thought, well, that'd be, I kept waiting for someone to do something, and nothing was happening. So I thought, oh, I might have to do something myself. And initially we spoke to the UK people about licensing their program, but that didn't work out. So we decided to take the plunge ourselves, and that was during COVID lockdown period. So it was a good project to do that. And I got together with a colleague of mine, Dr. Paul Mason in Sydney, and a dietitian, Nicole Moore. And we designed a program which we called Defeat Diabetes, which we initially released as an app, and now is both an app and a web-based program. And we basically put together sort of 13 lessons, if you like, consisting of videos and articles about everything you need to know about what is type 2 diabetes and what effect diet has on it, and very practical advice about going low carb and so on. And as well as those videos and articles, we have lots of recipes, hundreds of recipes. We have meal plans. We have cooking videos. We have a very large Facebook group of people, subscribers who are very active and always putting up new ideas or questions or recipes and so on. So it's still, going slowly. We've had 10,000 people subscribe to the program. The results have been astonishing. I mean, very similar to those overseas, but basically, 50% of people who go on the program, more than 50%, reduce their HbA1c levels, their diabetes markers to the non-diabetic level, and the rest of all reduce it remarkably. And everyone who's been on insulin has got off their insulin, and people reduce their and look, it's just confirming the results from other programs through David Unwin's group in the UK and others, that it is possible to put type 2 diabetes into remission. And that's something that it's just not even talked about in the medical profession, and it's very exciting. I think it's really it's so exciting the great thing is that it gives people with type 2 diabetes hope, because at the moment you have a diagnosis of type 2 diabetes and there's no hope. You've been on medication for life. You're going to develop these complications. Whereas now, there's hope both for the patient with type 2 diabetes, but also with the clinician and with the doctor, because it's pretty depressing. And type 2 diabetes is arguably the most common disease that the GPs see in their practice. And there's really not been anything you can do for these people. And now all of a sudden there's something that you can do that will really help these people. So it's giving hope to both the patient and the doctor that they can do something. So we're really excited. We have another research project going at the moment, looking at a group of 100 people with type 2 diabetes through their general practitioners, enrolling through their GPs, who then put them onto the Defeat Diabetes program and then monitor them every 3 months with blood tests and various tests and so on. And we've got the early results from that after 3 and 6 months, and it's very similar. That more than half are putting their diabetes into non-diabetic levels, which is very exciting. So I think it's exciting times ahead in the world of type 2 diabetes.
And as we have already segued into the Defeat Diabetes initiative, I would probably hand it over to Anup. He possibly would have a question about Defeat Diabetes. I mean, we are anyways looking at, let's say, a long-term collaboration, if that can happen across different entities, who are working in this particular space of low carb. So Anup, you have anything to say or ask?
Yeah, actually, first part was pretty interesting, and it covered mostly the sports nutrition part. And I was going to come to this Defeat Diabetes initiative of Dr. Bruckner, because for us, the non-sporting segment is the primary, area of focus, where the Defeat Diabetes program like yours, we have in India, what we have launched 9 years back is the dlife.in. So as a, founder of that platform, my interest was what impact actually it is making in the general non-sporting Australian population. That is question number one, and I'll follow up after this.
That's right. Yeah, look, I agree with you. I mean, I think the sporting thing is very interesting, but it's the impact on the general population that is far more important. Sport is great. It's great fun, and it keeps a lot of us entertained and so on. But the real concern is the metabolic health of this generation, and we are so unhealthy. I mean, metabolic disease is everywhere and seems to be increasing very steadily throughout Western countries, certainly. I read a statistic recently that only sort of 12% of Americans were metabolically healthy. To have one of the sort of
Yes.
factors that have metabolic syndrome, and that's a really scary thought. So, I think programs like Defeat Diabetes and your own program are just play a really important role because we need to get to the average person, to the public, and it needs to be accessible and it needs to be not expensive. Because we know that there is a sort of a socioeconomic bias to metabolic disease. That it tends to affect lower socioeconomic areas more than the higher, maybe who can afford to have better nutrition, better food, and so on. So, these are the challenges that we have, in that we have to give people access to programs such as the two that we've put together, and promote it. And so we've certainly faced challenges with Defeat Diabetes, trying to get publicity, I guess. It's challenging. There's social media. It's become more challenging to publicize things on social media over the last couple of years due to the restrictions and so on. So we've got a little bit of general media publicity, when we launch and when we put our books out and so on. You can get and whenever that happens, we get a spike in subscriptions. It's all, but the rest of the time it's just word of mouth. What we're finding now is that more and more doctors are advising their patients to go onto a program like this. So, a patient comes in to see a doctor. As I mentioned before, the doctor's not that well versed in nutrition. They also don't have a lot of time to talk to patients. So they're finding it very valuable to just recommend a program like ours, and then just monitor the patients over time, and the patients can get their nutrition information, if you like, from programs such as ours. So it's certainly challenging. We've been going 2 years now. I had hoped that we would have more subscriptions that we have, but we have a relationship now with Diabetes Australia, who are keen to promote our program, because they believe in it as well, and so we're optimistic that over the next couple of years we'll get a lot more people. Interestingly, also, you might be curious to know that we actually have a parliamentary inquiry into diabetes in Australia. And a number of us have made submissions into that inquiry, and next month I'm appearing before the inquiry, and there's a number of doctors on that. We have a number of doctors who are parliamentarians, and we have a number of doctors on those, and so we think that might be a really important initiative for government, because there are certainly things that government can do to make life easier for people with type 2 diabetes, both in prevention and in management.
Yeah. So as you said, Defeat Diabetes is around 2 years old, right?
Yep.
Yeah. So can you walk us through the average improvement that you see in the primarily diabetes numbers, or any associated numbers with diabetes?
Yeah. So our we've done two types of evidence, really. We've done a survey of our members, and then we've also done this research project that's now well underway, and we have 3-month data and 6-month data. But basically, somewhere between 50 and 60% of people who are on the program go from having an HbA1c of greater than 6.5, which is the diagnosis of type 2 diabetes, to under 6.5. So that and that doesn't happen with any other sort of way of treating diabetes. So greater than 50% put their diabetes into remission. But that's not to say that the other 40% don't have any improvement. So you might have someone whose HbA1c is 10 and they go down to 7. Well, they're not strictly speaking in remission, but you'd imagine that they're a whole lot better off because they're they've got better glycemic control. And then maybe in the next 3 months they'll get down into below 6.5. So we also measure waist measurement, waist girth. That's all come down. The average weight loss in 3 months is about 5 kilograms, and over the 12 months it's about 7 to 8 kilograms. So it's a pretty dramatic effect for most people. Now there are some that don't respond. We have some in our cohort of 100 that haven't responded for various reasons. One had surgery and didn't stick to the diet, and there are a few who find it difficult to stick to the diet. I mean that's an interesting topic because a lot of the skeptics, a lot of doctors out there say, "Oh, you can never stick to this diet. It's too hard. It's too difficult. It's too hard." And my argument is always that the only people who say that are people who haven't tried the diet.
Right.
Yeah.
Because once you've been on this diet, you feel so good and you see the effects on your health. But that's very motivating. And people, if you haven't done it, you don't sort of understand that, I don't think. And that's why I think people are so skeptical and say, you can't, ketogenic diet, it's too difficult. I don't know about your experience, but I've not found it difficult. And every time you sort of slip up a little bit, you don't feel so good, so you get reminded that you should go back on it. So I think it is possible, and we're showing this from our research that more than 90% of people stick to the diet, and more than half of them put their diabetes into remission. So it's very rewarding.
Yeah. As you said, the naysayers are those who haven't tried the diet. That's point number one. And second point is, once you see the numbers or the improvements, you cannot unsee it. So as far as sticking to diet is concerned, it's very easy once you see the numbers. Now, taking this question forward, how easy do you find dealing with Indian population switching to low carb per se?
Yeah, well, it's certainly an additional challenge. We, as you know, we have a large Indian subcontinent population in Australia, and particularly in Melbourne, where I live. We have, and it probably presents an extra challenge because your traditional diets are very heavily carbohydrate based, so we have had a number of Indian, Asian, South Asian population on the program, and they've done very well. But it presents an additional problem because obviously there are cultural issues here, and then we need to be clever about it. And I don't think anyone's suggesting that you never have to have rice again. But I think a lot of the metabolism of Indian people is well attuned to complex carbohydrates and so on. So maybe it's not as difficult as it is for the Europeans. But certainly some of the results we've had have been very dramatic. Because they're certainly in Australia, there's quite a large problem with obesity in the Indian population, and we've had some very very positive results with that. But it does present an additional challenge, particularly when large families are living together, and maybe grandparents are living and doing the cooking and so on. That could be challenging for generations. But the results have been very impressive.
Great. And just a quick time check. We have 7 minutes left into this session. Anup, you have any other questions? Otherwise,
yeah, that's it. Primarily, the main concern is these diets are not safe.
Yeah.
Within quotes, they call it not safe. So just a short note from you on that.
Yes, that's a good question. Yeah.
Just to add to that, sorry about that, Anup and Dr. Bruckner. But sure. Just to add to that is basically how sustainable low carb diets are. Yeah, safe and sustainable.
Yeah, look, I think there's a lot of concerns, and yeah, you're exactly right. I mean, people say it's not safe. I've had doctors tell patients that you'll drop dead of a heart attack if you go on that diet. Because of this obsession with cholesterol, and I think that's been one of the real problems in medicine in the last 50 years. This over obsession with cholesterol, particularly LDL cholesterol. Most people, when they go on a low carb ketogenic diet, their triglycerides improve dramatically. Their HDL usually improves, and their LDL sometimes it varies. Sometimes improves, sometimes stays the same, and occasionally gets worse. But unfortunately, there's way too much emphasis on LDL cholesterol. It's interesting, isn't it, that people are obsessed with LDL cholesterol, and there happens to be a drug for that, whereas people ignore triglycerides because there's no drug. But in fact, triglycerides are probably just as dangerous for one's health as LDL. But what we find with this diet and the effect on LDL, it's not as simple as people think. LDL is not just one molecule, and it's the particular subfractions of LDL that we need to look at. And almost invariably, the LDL increase is due to the large, fluffy molecules that are not atherogenic. And not the sort of the small, dense particles that are. And so, if you're at all concerned, you can always check those particles and see what. But I think it's unfortunate that people have this obsession with cholesterol levels, and cholesterol is actually a vitally important structure. Without cholesterol, your brain doesn't function. And I think we've gone way too far into obsessing about cholesterol. And we also know that the major risk factors for heart disease is diabetes, and pre-diabetes. It's not high cholesterol. If you compare the risk factors, high blood sugars is way ahead of cholesterol. And so we've been focusing on the wrong thing for the last 50 years. And, I think we really need to change our focus to sugar and processed foods rather than worrying about cholesterol, because, we've known for 50 years that the cholesterol in food has no effect on your blood cholesterol. Yet, we've all been on these low cholesterol diets. We haven't been allowed to eat eggs for 50 years. I mean, what a tragedy. It's been terrible. So, I think I feel very comfortable that this diet is safe. And in fact, it's the opposite. It's the healthiest diet you can have.
Right. And just one quick thing, because I think we have been discussing about low carb. For our viewers, can you give some quick guidance in terms of percentage of carbs, proteins, and fats, basically to improve metabolic health or maybe achieve metabolic health? Anything that comes to your mind? Yeah.
Well, I think it's just a simple matter of focusing on foods that are high in protein in particular. I don't think generally we don't eat enough protein, and then avoiding. I think the real devil is this ultra processed food. I mean, it's and you can argue you shouldn't even call it food. It's sort of some chemical concoction that's dressed up to look like food. That really is not, and has so many different ingredients and colorings and emulsifiers and all sorts of things to make it look better, taste better, last longer, but actually doesn't improve the nutrition. And so any food that has 20 ingredients in it, as so many of these foods, you look at the food label and there's this long list of things. I mean, that's not food. That's a chemical concoction. And I think the trick is just going back to eating real food. There's a wonderful expression called JERF, JERF, just eat real food. And if you stick to that, I mean, you can talk about carbs and talk about everything like that, but if the real thing is avoiding the processed food and all the things that cause inflammation, because we know that inflammation is chronic inflammation is the key to developing chronic disease. And if we can tackle that with diet, then we can really do a good job.
And apart from the ultra processed foods, how about grains? Probably the last question. We have 2 minutes left here.
Yeah,
but
Yogesh,
how about grains? Your views on grains and beans? Sorry, Anup.
We'll get Shashi in during the last minute.
Oh yes. Right. So anything, because India is like Shashi says, we are a country of granitarians, right? I mean, we eat grains mostly. So
yes,
what are your views on that?
Yeah, I think we need to reduce our reliance on grains, certainly. So many people are affected by gluten and other factors in grains.
Amazing. So thanks a lot, Dr. Bruckner, for your time this morning. I know it's quite early in the morning, and I'll hand it over to Shashi. Thanks a lot again.
Thank you.
Dr. Peter, welcome. Thank you again for accepting this invite. And
my pleasure.
You are in Paris now, joined at 8:30 a.m. We are so happy that though you're not in Australia, you have joined this session right from Paris. And congratulations for being a grandfather now.
Well, thank you. Yes, I'm actually in Paris with my new granddaughter, so it's a very exciting time for us. So, but thank you very much for the invitation. Congratulations on what you're doing. This is a wonderful initiative, and I look forward to maybe coming on again at some for your future conferences. Thank you for having me.
We'll be so happy to invite you again.
Thank you. Thanks a lot. And we'll now get into the next session, which is with Dr. Gary Fettke.
And Pramila Mundra.
Yeah. Thank you.
All right. That's it.
Hello, everybody, and a warm welcome to the first ever Low Carb Conference in India. I'm Pramila Mundra from Bangalore, a low carb nutritionist, hosting Dr. Gary Fettke from Australia today. Welcome, Dr. Gary. It's a great pleasure to have you here.
Great pleasure to be part of this for everyone.
Thank you. Thank you for taking out time and joining us. So most of us here know about you and your work through social media handles and Twitter. But for the benefit of our viewers, I would like to introduce you briefly.
I'm humbled that people know me outside of my own household, really. I'm an orthopedic surgeon in Tasmania, which is an island off the coast of southern coast of Australia. And I suppose my claim to fame is that I've gotten into trouble with the system for recommending low carb for my patients and the wider community. That took several years out of my life. And as a result of that, ultimately, I was cleared of all problems. Low carb's been proven to be safe and effective. It's now part of our national diabetes strategy. And essentially, I've been practicing myself low carb for probably the best part of 13, 14 years, been advising it for my patients for that period of time. And it's just incredibly effective. So I've essentially looked after diabetic foot complications for the last 25 years. And this has been the most powerful option and intervention to save people's feet, their legs, and by other means, their other organs. So what a powerful tool. And I ended up being targeted by the food industry and the pharmaceutical industry for advocating it. But as it's turned out, after 4.5 years of investigation and essentially trials, that all ended for me in 2018. So I've been apologised to, exonerated, and that's been part of our ongoing pathway of continuing to encourage others and supporting those groups, those individuals that actually want to make a big difference for their patients. So all healthcare professionals. So myself and my wife have been actively supporting groups such as yourselves.
Yes. Thank you, Doctor. I would like to add a couple of things about you more. You're also the co-founder of Nutrition for Life, Diabetes and Healthcare, which assists individuals and also the broader community on their journey towards better health. Dr. Gary is also the chairperson for Infection Control Committee. He's
I used to be the chairperson of Infection Control. So as a result, I've had a fair amount of influence in that path in the past, but a lot of information, particularly around immunity and health now. It's all part of the same process.
Okay, wonderful. Dr. Gary has also authored the book Inversion, One Man's Answer for World Peace and Global Health. In his book, he has discussed a pressing need to respect our fragile planet and also has put down his unique approach to problem solving. In recent years, Dr. Gary has focused on the role of diet in the development of diabetes, obesity, and inflammation. So, Doctor, we would like to now know more about how did you end up knowing about low carb and what made you pursue it?
I think there's my professional story and there's my own personal story. So a lot of people who enter this low carb space actually have their personal story. So I was, by definition, I was what was called the fat kid at school. Now I'd just be called mildly overweight, but this is 50 years ago. So my mother had me on diets as a child, a teenager. I exercised, and as a teenager, I became quite good at a variety of sports. And luckily, I was at that stage clearly outrunning a bad diet. I had my own health issues in my 30s with a tumor at the base of my brain. At that time, arguably, I was pre-diabetic. I was 20 kilos heavier than where I am now, so 45 pounds. I had hypertension, and I thought I was pretty healthy, but I thought at that point in time I needed to start improving my health. So I ate the food pyramid diet, find out that didn't actually help anything. And I then, in the process of that tumor and the management of that, I came across the awareness that those people who were on metformin, which is a first-line drug for diabetes, there was a lot of work coming out of South America suggesting that those people with end-stage cancer did better if they were on metformin. And we're going back 15 years now. The theory is at that time, oh, well, if you reduce the sugar in the bloodstream with metformin, it may in fact help prognosis. And I'm just a simple orthopedic surgeon. I thought, well, actually, why take a drug? Why not just actually reduce your sugar? That's a pretty basic thing. Don't eat it and you don't need the drug. Mm. And around the same time, I remember coming up to Christmas, the end of the year, I cut my leg on a log. And someone gave me a book called Sweet Poison by David Gillespie, because they knew I was talking about sugar. And David was talking about the perils of sugar. So I decided to give it a go. So literally sitting on my backside over the summer, not exercising and just cutting out sugar, I lost 8 kilograms. So nearly 20 pounds, literally by doing nothing apart from that. And I went, hang on. The scientist part of me said, hang on, this is interesting. So I started looking at the metabolism of sugar and particularly fructose initially. So that was only described in 2011, the definitive biochemistry of it. So that's not in most people's textbooks. It's still actually to come into the textbooks what the metabolism of fructose is. So that was my start. I started looking at fructose. I then started recognizing the role of seed oils. And then in 2014, I understood that, came across from Richard Johnson's work, the role of glucose being converted to fructose, a thing called the polyol pathway. This is all in my talks, but in diagrams with lots of pictures so people can understand them. So it was in that year that I'm proud that I sort of came up with the model of inflammation based on nutrition, which is that the combination of fructose or sugar, refined carbohydrates and polyunsaturated seed oils is highly inflammatory. Now, it was purely a model, a hypothesis to be tested, but those people who decided to take that out of the system actually improved their health and well-being, not just myself, but others around me and then the wider community. Now, what that actually means is that's called low carb healthy fat, that's called keto, that's called carnivore, and it's extreme. So essentially it's a diet which is low in sugar, low in refined carbohydrates, low in seed oils. And as it turns out, the more, 10 years further of research down the track, that's actually got a lot of standing now as being the anti-inflammatory diet. So I can still remember that it's a 4-way email, on an Easter weekend where I was going on, what do people think about this? I think we've actually got a model of inflammation here. And inflammation sits under all modern disease. Doesn't matter if it's obesity or diabetes or cancer or inflammatory joint disease or inflammatory bowel disease or mental health issues or skin conditions. Inflammation is the underlying cause of virtually everything we've got in true pandemic proportions now. So if nutrition is the model of inflammation, and we can put those three together in a perfect storm, then the answer is actually pretty simple. It's not about more drugs. It's actually take the three of them out of the system, which is end up called low carb. And I had no idea when I described that how much trouble I'd get into for purely coming up with a hypothesis.
Yeah.
And for then recommending it to people. And it wasn't very long before I was targeted by Coca-Cola, I was targeted by the cereal industry, targeted ultimately by the pharmaceutical industry, because it's a very powerful tool of which nobody makes any money.
Agree. No profits there.
No profits at all.
Yeah. So, Doctor, I would like to ask you, you've been stressing on inflammation and how most of the contributing factors lead to it. But for a common man, how do they detect or how do they get to know what would be some of the symptoms and markers to identify inflammation?
I think the first thing is, how do you feel? And if you actually, most people now are living in a chronic state of low-grade inflammation, and they don't know that the new norm is for the majority of people to be metabolically unwell. I've looked at the data for India, and I mean, you guys are in the same strife as the rest of the world, if not a greater one. You're developing the Western problems of poor metabolic health, but that's on top of a third of the population, by what I'm reading, is being malnourished, undernourished, high rates of iron deficiency. And so India seems to be at a crossroads where you've already got a problem of malnourishment and undernourishment. Now there's an adoption of Western lifestyle and diet with the major introduction of seed oils and refined carbohydrate. And I actually see, from my understanding and speaking with a lot of people from India, both directly and who are living here in Australia, everyone's inflamed. So how do people know when they're inflamed? Well, they don't know until they actually do something about it and they feel better. So that's one funny way of saying, how do you know? Well, the thing is, you don't know, because if you're inflamed, most people around you are inflamed. US data says 93% of the population are inflamed. They've got poor metabolic health. The simple markers is waist circumference. So if your waist circumference is elevated, then that's a good sign that you've got early inflammation and you've got insulin resistance. And that's cheap. That doesn't cost anything. There are a whole series of blood tests you can start doing to look at that further. But again, that's not, I try and keep it simple. If your waist circumference is up, if you're feeling tired, lethargic, stressed, you're not sleeping well, and your weight's gone up, and you're not fitting into the pants or the trousers or the dress that you wore 5 or 10 years ago, then you're probably inflamed. And so that's the simplest measure, and that is affecting at least, elevated weight here, at least here in Australia and most Western societies. You've just got to look at people are not nearly as slim. Body mass index isn't a good indicator. Because if we look at BMI as a marker of obesity, well, that varies from population to population. So we sort of talk about BMI more than 25 is overweight. BMI more than 30 is obese. Well, that figure is actually about lower in, I don't know the Indian figures, but I certainly know the Japanese and the Chinese figures. BMI of 25 is actually 27, is obese. Whereas a US African-American, a BMI of 33, 35 is obese. So BMI is not a good measure. But if you personally develop a greater waist circumference, and that little pot belly that's sticking out there, rather than dropping down from your chest, then you probably develop. That's visceral fat. It's coming. It's there. You've got inflammation.
Thank you, doctor. I think it's insightful for the people because, a lot of us don't do regular tests. In India, I know, unless there is something which is signaling really harsh. People are not used to doing regular testing. And most of the times when the testing is done, sometimes it's a bit late. So this has been a wonderful input.
Oh, we can do blood tests, inflammatory markers, liver function tests, which will look at all that. But there's nothing cheaper or more effective
Correct.
than a waist circumference.
Yeah. Now, I would like to ask you a very, very talked about or often asked question when we talk about dietary changes to people, not only in India, but probably across the globe. A lot of people consider fruits as a very healthy addition to their diet. What would be your views on it?
Well, there's a talk of mine called "Is fruit good or bad for you?" And and I go into the simple biochemistry of it, but the long and the short, it is nowhere near as good for you as it's advertised, either in nature or in food guidelines. And the original sin in Christianity was when Eve plucked the apple from the tree. And I use this simple argument. Even God at that point said the original sin is don't eat the fruit. Now, I recognize that sort of, I use that as a theological argument. But sugar, fruit in nature is meant to be eaten at the time of plenty. And we're just animals. I keep coming back to that. We're just animals. Our biochemistry is the same as an animal. We run on the Krebs cycle, which is how we convert fuel, whether or not it's carbohydrate, proteins, or fats, into ATP, which is adenosine triphosphate. It's the energy of our cells. So we use exactly the same metabolic pathway as all animals. Now, fructose in the animal kingdom, sugar is meant to be eaten when the fruit is plenty, and it's there to be eaten just before we go into winter hibernation. So the end of summer, autumn, when fruit ripens, it's meant for us to gorge upon it. And so when we do, we actually, people will eat, I'll use an animal, a possum or a bird, or we'll strip a fruit tree bare just before we want to eat it. And it's a feeding frenzy. And the fructose actually stimulates our hunger, makes us eat it, drives behavior, no different for us as humans, whether or not you're taking it as fruit or if you're actually taking it as cake, drives behavior, and then it ends up making us fat for winter hibernation. So that's sort of okay if we were to eat fruit only at that point in time of the year. But we're eating fruit all year round.
Yeah.
And with huge amounts of transport miles on it. It's not seasonal. And as a result, we've got that fruit, which is now produced to have higher amounts of sugar in it, lower amounts of fiber, which improves its shelf life and transportability. But effectively, it is literally just sugar. So when you look at it as fructose, fructose has all sorts of pathways. It drives behavior, drives hunger, drives obesity, drives insulin resistance, which a lot of the speakers will be talking about, drives non-alcoholic fatty liver disease. It ultimately ends up as the triglycerides that I heard Peter Brookman talking about just beforehand. The triglycerides are the ones which can become oxidized by the seed oils. Ultimately, that's where the inflammation pathway is. So if you reduce your fructose intake by stopping eating refined sugar and limiting yourself to only eating small amounts of seasonally available fruit, then you're going to turn the whole pathway around. We are not meant to be eating fruit all year round.
Totally agree. Do you recommend any specific fruits which would be good if a fruit lover, has to pick up and be selective about the fruit consumption?
No. There you are.
Okay.
So, I mean, if I'm being a purist, there's another talk of mine is carbohydrate the poison? Where I come down with the argument that 4 grams of carbohydrate is the poison. And it does. It has a negative impact on the body. Fructose, unless you're trying to get fat for winter hibernation, has a negative impact on the body. So, and the trouble is, when you start eating fruit, you'll have a frenzy of wanting to eat more fruit. To be fair, I will occasionally have some blueberries.
Okay.
Less now than I did a year or two ago. And I'd have 3 or 4 blueberries in a nut granola with cream, because I quite like the taste of it. But do I need it? No. There's no single biochemical pathway in the body for us to eat fructose or glucose. And so therefore, if we're trying to look as purists to find out how much we should eat, then I'm going to say, actually, there's no biochemical requirement for us. So if animals survive without fruit,
Yes.
we can survive without fruit. We can survive
Exactly.
without carbohydrate, but we can't survive without essential proteins, essential fats, micronutrients, and vitamins. But we don't need any carbohydrate. And it's the fact that 50% of the diet now, we're having it as an unnecessary fuel source, which is driving our behavior and our obesity and our metabolic syndrome.
Thank you, doctor, for saying this, because it's very difficult for a lot of people to accept that fruits are unhealthy, because the major argument we get is they are full of vitamins, minerals, and fiber. So why not? But I think you've explained it very well.
I go into it in that talk, is fruit good or bad for you? And essentially, they are, I mean, as I say, they're over-advertised in nature. Nature wants us to eat them. A piece of fruit gets bright, shiny, so we're attracted as animals to eat it. But the fruit wants us to eat it so we can propagate its seed. But as I talk about, the fruit hasn't worked out that we propagate its seed into a toilet bowl now, so it doesn't actually do what it's meant to do. And that whole situation is, if you start looking at vegetables and you start looking at, which is a whole other topic, but if you look at meat and animal-based product, it smashes, it beats fruit gram for micronutrients, vitamins, minerals. It just smashes it. And so when you go back to the history of it, it was in the 1990s that there was a meeting on the west coast of the US between the American Cancer Association and 40 well-meaning food industries. They actually just made up this number of 5 a day. It's literally just made up 5 a day, fruit and veg. There is no science whatsoever behind it. It's a huge marketing ploy. And I make the argument, we don't need it, and they're infinitely better sources of food, but we're animals, so we quite like bright, shiny, sweet stuff.
Yeah.
But we don't need it. And not in the amounts we're eating.
Thank you for saying that, doctor. Now, I would also like to touch upon one more aspect. Just like fruits, vegetable oils are very widely used in India and across the world. And it is the most cheapest and most widely found cooking medium in the world. And the name vegetable oils probably makes it sound healthy. So how dangerous or how healthy are these oils? And would you explain to our viewers that if they are dangerous, why so?
Well, first of all, try and find me an oil that comes out of a vegetable.
Right.
Well, they don't exist. So it's literally just highly processed, highly manufactured oils. They come from seeds. Some oils can come from fruits, but most of the fact they come from seeds, which go through a major processing of. I encourage everyone who's got access to the internet to go and see how margarine is made or how vegetable oils are made. And it doesn't take very long before you see it's a highly industrialized process. It's so far away from animal-based fats. The long and the short of it is vegetable oils, seed oils, are liquid at room temperature. Butter, ghee, the animal-based fats tend to be solid at room temperature. So the only difference between a fat and an oil is what its state is at room temperature. So the fats are solid at room temperature, oils are liquid at room temperature. Now, they have this capacity based on the structure of how much saturated fat they have in them and how much polyunsaturated fat. So if something is saturated is solid at room temperature, then it's no good as an oil, no good as in a plant. So plants and seeds need highly flexible oils that can go up and down the plant.
Right.
And so that comes as having more polyunsaturated oil. So it has more double bonds. Double bonds equal flexibility. So a plant in the cold, if it drops down to 0 degrees, or 32 degrees Fahrenheit, if it drops down in temperature, then imagine that oil within the plant becomes solid, the plant will die.
Right.
Where in humans, we sit at 37 degrees Celsius, so we can actually have oils or fats in our body which are liquefied or more mobile, so we don't freeze up. So if our body temperature was 0 degrees, then we would be solid and we'd die. But we're not, we're at 37 degrees. Plants need to have oil in them which is flexible and doesn't freeze or doesn't get solid at low temperature. It does that by having lots of flexibility. That flexibility comes from the double bonds. The important thing about a double bond versus a saturated fat which has no double bonds is that each point of flexibility is a point of weakness which can become oxidized. Now, the simplest thing to understanding of oxidation is a bit like happens to a piece of steel when oxygen combines with that and it starts rusting. So points of oxidation become points of inflammation. So if you have seed oils in your body, if you eat vegetable oil, it's then mimicked, it's what then absorbed into the tissues. So linoleic acid, which is an omega-6 polyunsaturated oil, considered one of the inflammatory ones, we was sort of sitting at maybe 0.5% of our bodies 150, 200 years ago. And since the 1950s, we've seen a steady rise in that when you start actually measuring the omega-6 linoleic acid, which only comes in as part of your diet. So that figure now is up to around about 25 to 30% of the fat in our bodies is now omega-6. It's then highly full of these polyunsaturated double bonds, which can be oxidized. So 100 years ago, 1% of our body fat, and this is what sits in our body, it sits in our cell membranes, and it sits in the embryos from what our children, our babies, grow from. 1% of our body used to be polyunsaturated oil. Now it's up to nearly a third. So it's a bit like building a house out of kindling. You've got a choice of building it out of bricks, which are saturated fats, or you've got a choice of building it out of kindling. And so we're setting our children up, our new unborn babies, our newborn babies, our children, right through adult, with all of this oxidizable material. And I think that's, we can get, we've been eating fruit for forever, seasonally available. We've been eating more carbohydrate in the way of refined grains for the last couple of 100 years since the Industrial Revolution. Not nearly as much as we're having now, but nonetheless, we've been having. The kicker has been the polyunsaturated seed oils that have been not only coming into our lifestyle and our eating habits, and as you say, it's the major oils being produced around the world because they're cheap and they're transportable.
Yes.
They don't need refrigeration. But we've also now got this whole, true, as I say, pandemic of inflammation. And I think the kicker is clearly the seed oils. And I think that's the third rung of that perfect storm of fructose, refined carbohydrate, and the vegetable oils or the seed oils. And again, my talks on inflammation go into that in a more diagrammatic picture so people can see what I'm talking about in pictures, trying not to make them too complicated. And the half-life of a seed oil is about 4 years.
Wow.
So it's going to take a long time for it to get out of your system. And I've got numerous stories of people who actually have gone low carb, they've gotten rid of the seed oils, the vegetable oils. They keep feeling better, but about 4 years down the track, they really feel better. And it just happens to coincide with the half-life of these vegetable oils. I slipped back and said it vegetable oil. It's not a seed, it's a soy oil. Or industrial seed oils.
True. A great insight into this, doctor, because I think they are so widely used and it is very difficult for people to get off it and to convince them to move to saturated fats, which are the much healthier options.
Traditionally, you've got ghee there. I mean, it's what an unbelievably great product.
Right.
It's a natural animal-based fat, which is going to be a rich source of not just essential fats, but of essential vitamins as well. And seed oils have got nothing going for them. They've got no nutrition. They've only got inflammation. They used to be used, the seed oils used to be used as engine lubricants.
Wow. That sounds already so horrific. And to make people understand that it's not meant for their body is so difficult because of the mainstream data that saturated fats actually cause heart disease. So it's a lot of unlearning.
Of which, again, it's a massive problem, because if I'm right, if all the speakers here are right, it just means that the health professionals of the world for the last 40 or 50 years have gotten it wrong and have to say sorry. That's it. And most doctors, and they're going to be no different in India, hate saying sorry, I got that wrong. But the moment I did, I felt infinitely better. I said, actually, I've gotten this wrong. I tell people, I used to be the cake judge at the hospital. So I wouldn't take children's plasters off unless they brought me a chocolate cake. And I was the cake judge at the hospital. I got it wrong. I'm sorry. I apologize now for decades of giving the wrong, pushing this horrible product. So, I got it wrong. And the moment you actually admit that, you can move forward. And so you've got children, I've got children. It's a basic thing of parenting that you say to your children, actually, you've made a mistake, you've got it wrong, admit that you made a mistake, and we can all move on.
True.
Yet the medical profession doesn't.
Yeah. I wish there are more and more of us who realize this and, do it publicly and move on, as you said, because that would be for the betterment of the coming generation too.
It's a complete no-brainer. But once you realize, once you see all this, you can't unsee it. And I came up with that term some years ago. Just literally, once you see the benefits for yourself and the patients in your community, you cannot do anything but keep going forward.
Yes. So, doctor, in your practice, as per you, what do you think about the causes of osteoarthritis? Because you're closely related to, doing orthopedic surgeries. And do you feel any connection between dysregulated blood sugar, metabolic syndrome, or even insulin resistance? Do you find any connection between this and the orthopedic surgeries you do, or their whole physiology?
I'll just say yes. Is the simple answer. I just again, a lot of this stuff I describe there's a talk called Carbohydrate, the Dose is the Poison. I've also written part of the chapter on musculoskeletal health in the new textbook called Ketogenic that the Noakes Foundation has put out. Okay. It's again fascinating that the end products of osteoarthritis, the things which cause inflammation in joints and in tendons, are the end products of carbohydrate metabolism. They're not the end products of protein metabolism. They're not the end products of fat metabolism. They're not a vitamin deficiency. They're not a micronutrient deficiency. We find the end products of glucose metabolism. And so therefore, the more deranged your glucose metabolism is, whether or not you've got pre-diabetes or diabetes, which is well controlled or poorly controlled, elevated blood glucose, again, under the effects of inflammation, we end up with these things called advanced glycation end products. And you also end up with what I call the Maillard reaction. Some of your listeners or viewers will have heard of me talk about this. The Maillard reaction is a cooking term. When a bread or any meal goes brown, and what happens when that Maillard reaction occurs is under the effect of heat, the glucose in the food combines with the protein in the food, and it goes brown. It's caramelization. Yeah. And the same thing happens with diabetes. excuse me, every time your blood glucose goes up, it then combines with the protein, glycation of protein, and excuse me, I can't keep talking forever.
Yeah, please.
The, so essentially, every time your blood glucose goes up, just like a piece of bread that you put in the toaster or a piece of anything that goes brown, you're effectively toasting your brain, your kidneys, your eyes, but you're also toasting your joints. You're toasting the cartilage in the joints, you're toasting your tendons. So as it turns out, that's the primary cause of inflammation in joints. And the effect of insulin only compounds it. So there were some papers out of China in 2020 which confirmed the role of insulin in osteoarthritis of the knee. When the level of insulin went up, the osteoarthritis got worse. When you brought the level of insulin down, the osteoarthritis got better. That's it in a nutshell. But effectively, that means that if you can reduce your insulin load upon a joint, which means either taking drugs or, in fact, just not eating as much carbohydrate, the inflammation within the joints gets better. At a practical side, I have got hundreds and hundreds of personal patients who have decided to drop their carbohydrate intake. So they move from a high carbohydrate, high insulin environment to a low carbohydrate, low insulin environment, and their pain gets better, even in advanced osteoarthritis of the knee. In the shoulder in particular, I've got a colleague who's retired. He only did shoulder surgery, and he gets all of his patients. He retired because he couldn't convince himself he needed to keep operating. He got all of his patients with degenerative shoulder troubles. He'd book them for surgery in 8 weeks. He'd get them to go low carb. And virtually all of them cancelled their surgery. But their problem didn't go away. They've still got arthritis in a joint. They've still got a cuff tear. They've still got problems. But their inflammation and their pain and their symptoms improved to the point of them not requiring an operation. I personally think we over-operate in orthopedics. I'm not saying that there's still not a role for joint replacements, but I think we're doing far too much, particularly in Australia, far too much knee replacement surgery. And if people were to lose weight, drop their carbohydrate, drop their insulin load, then a lot of them will avoid that surgery or they'll delay it for a long period of time. And that's been my experience for a long period of time now.
So would you say that if we are careful with our food choices and lifestyle early on, these knee surgeries could be avoided?
Absolutely. I mean, it's still traumatic issues when people injure their joints, but from the long-term low-grade inflammation that we're giving people with our diet, again, carbohydrates, more inflammation related to the seed oils, then it's clearly a cause of joint problem. I work with some rheumatologists who are now on board with this, and they put people on what they call their anti-inflammatory diet, their low inflammation diet, which is exactly the same. It's low carb, healthy fat, it's keto. They call it the anti-inflammation diet. So, and they say, they actually put people on this diet before they start them on drugs.
Okay.
And it's just, so it's the same process. So whether or not we're looking at orthopedics from a joint problem, inflammatory joint disease, or right across the spectrum of disorders, which are going to be discussed this weekend, inflammation, reduce the inflammation. You can either do it with drugs or you can do it with lifestyle, and particularly diet, or you can do it with both. But we can't ignore diet anymore, not with the information we currently have.
What about post-surgery, doctor? After surgery, how do you find the change in diet as impacting the healing process?
Well, hospital food on the whole is lousy. So it's pretty hard to get good food for your patients. And I've been quite critical of hospital food because I don't think it has enough protein in it. I don't think it has enough nutritional value. And I think it's high in sugar and carbohydrate because it's cheap for hospitals to produce. I don't think that's healthy for healing. But if I look at my patients who are actually doing low carb, they come into hospital with their own food supply. You know, they might have some dried meats, they might have their nuts, they might have their cheeses. They avoid the sugar and carbohydrate. And I've spoken to other surgeons about this same concept. The majority, and again, this is anecdotal, seem to have less pain. They seem to recover better. It's very hard to quantify that. And maybe it's because they've got they've taken on a more positive attitude to their life and their lifestyle. But on the whole, now there's some biochemistry to back that up. When you actually look at neutrophil activity, which is one of the white cells, that neutrophil activity, and this is old literature, neutrophils are the cell produced as a result of inflammation or trauma or post-surgery. Neutrophil activity is reduced by 50% or so with 50 grams of carbohydrate. So not a lot of carbohydrate, and people are having 250 grams a day. So a small amount of carbohydrates enough to reduce your healing potential. By the same token, if you fast after surgery for 72 hours, which no one does because everyone's hungry after surgery, but when it's been tested, neutrophil activity goes up and up and up. So there's an argument that the state of ketosis enhances neutrophil activity, enhances healing. And look, there's more and more stuff coming out at a laboratory level about this. Anecdotally, it seems to make a big difference.
Right.
And the biochemistry, I think, is coming. We do remember the research that supports all of what we're talking about it hasn't been done, or much of it, because there's no money in it. It doesn't support any food industry. It doesn't support a pharmaceutical industry. But it's coming. It's coming. So, small labs, smaller papers, smaller publications, but it's starting to come. And that book, I keep coming back to it, Ketogenics, is probably the biggest repository of all that information in one book at this point in time. Because the amount of research you had to add, every sentence I put there, I had to justify with a current peer-reviewed research article.
Right. Doctor, we also know that you've actively been promoting low-carb, high-fat, healthy lifestyle, and because of which you've been caught up with the Australian health authorities. They were behind you, and it came to a point where you were trying to be silenced and taken off your right to practice. But then we read that you fought back along with your wife, Belinda, and finally won it over. Could you talk about the journey? How did you go through it? What are the challenges you faced with the government, and how did you deal with it?
I think the journey is easier for others now. I think at that point in time, we were all still learning about the benefits of low carb. We knew about it. I use the term low carb healthy fat. I've never really liked the term low carb high fat. People sort of get hung up on, it's so much in high fat. And I'm a great believer, cut your sugar and carbohydrates down as much as possible. Have protein for requirements, and then have healthy fats for satiety. And so therefore, a lot of times people talk about 80% fat. I don't eat 80% fat. I think I use the term low carb healthy fat. That means lots of things to different people, but I think it's a more literally palatable term. Yeah. So the science was evolving in that time frame that I was, getting targeted. But we've got all the internal emails of the cereal industry here well, not all of them, but we have enough of them to say that the concepts that we were talking about are affecting profits, and therefore these people are to be targeted. And I was the only Australian doctor on that list. We didn't find that out for a long period of time, but one of the good things about being a surgeon is surgeons often, when they know they're right, they're right. So that's a certain amount of arrogance that comes with being a surgeon. And I knew that I was right. I knew that this was based on clinical experience. It was based on basic biochemistry. the Krebs cycle is the beginning of all the physiology textbooks that everyone studies. It's not in the fine print. And I knew I was right. So the more trouble I was getting into with the system, there had to be something else going on. And that's where Belinda's work came in to find out all the vested interests which are shaping dietary guidelines around the world. And particularly here in Australia, which was at a personal level. And so her work was instrumental in partly getting me off. So I ended up being reported 3 occasions to the medical board. One of them was because I inappropriately reversed someone's diabetes on national television.
Wow.
And we're trying to work out whether or not it was inappropriate because we reversed his diabetes, or whether or not it was done on national TV and lots of people found out about it. And you can't make this stuff up, but that's what happened. Anyway, so, you know, that was 4.5, 5 years of significant personal stress, family stress. Every Christmas when the family were together, the children who were all adults, we'd sit them down and say, how are you going? Mum and Dad are okay. How are you going? Because my name was getting slandered in the press, both locally and nationally. There was a lot of social media pressure upon us because people believed he must be dangerous. Well, it wasn't dangerous. We were making people better. Ultimately, through a lot of work, a lot of social media pressure. So I thank everyone around the world who actually put pressure on the Australian regulator here, helped me get off. And ultimately, as it was all overturned, I received an apology from the medical board when they realised that I'd been actually targeted by the food industry for actually talking about science, talking about biochemistry, and talking about preventative health, and talking about making people better. And it's so absurd. But as it's turned out, here in Australia, you know, this is now mainstream. You can go, there are cookbooks that you can buy in the shops. So you can buy cookbooks. In Australia, we have now low carb beer. So if you're waiting for the guidelines to change, because they're still influenced by these vested interests, if you're waiting for the government to recommend it, already in Australia, the population are accepting it. I can go to a restaurant and ask for a low carb meal. And they'll understand. I don't ask for a low carb meal. I say, I'll have some meat, and I won't have any bread, and I won't have any rice, and I might have some seasonal vegetables. But, you know, and you're not looked upon strangely now. So the public, and this is where it's a grassroots revolution, if you're waiting for the government and the bureaucracies to change, it's not going to happen. You as an individual, you as a family can make that decision of what you're going to eat or not eat today. And then in a week or two, you can work out how you feel. And then you can work out how your waist circumference is coming down. And that's the power of this. People start feeling better very quickly. People with type 2 diabetes in particular get control of their diabetes almost immediately, with an improvement in blood glucose, an improvement in how they feel, and a massive reduction in medication. It's such a powerful tool. So what motivated us and kept us going? The people supported us.
So initially, when it started, initially when the movement against you started, like, were you still feeling that you're isolated, or the people were there behind you?
Well, first of all, I thought it was a joke. So you know, I honestly thought the regulators not taking this seriously. But they did. They just got it snowballed and just got bigger and bigger. But my patients and my social media community, and we're talking about the medical fraternity around the world, was, you know, very small, but everyone supported me. And, you know, I essentially, you know, sometimes you know you're right. And you just keep doing it because I wasn't going to be slandered. I was only helping my patients. People were getting better. It was based on good science. And it was very clear that this was a personal vendetta against me at whatever level, but we didn't know that too much at the beginning. We worked that out over time. So sometimes you just got to do the right thing for your patients, and you've got to do the right thing for the system. So, and having the family support, because that's the first thing, having my wife's support, having the family support, having my immediate medical community support. Not all the doctors in Tasmania, again, most of them thought I was crazy talking about sugar. But now this has become mainstream. And so a lot of the work I now do is supporting other doctors, not only here in Australia, but internationally. I'm helping one of your colleagues against the medical board, in a close nation to India. Again, this is, we just need to keep supporting each other. And so knowing that I had that support allows me to then give that support on an ongoing basis. So it's called paying it forward. It's
very, very inspiring, doctor. In fact, we need more and more people like you. But what are the dietary guidelines changes you have observed in your country in the last decade with your efforts, or in general, has anything evolved in the dietary guidelines?
Nothing. I was just saying, it's simply nothing. We've got the same dietary guidelines effectively that we had 15, 20 years ago. We've got the same vested interests that are shaping those dietary guidelines. Despite representation to government, the dietary guidelines persist. We've got a current review of the dietary guidelines, but we're going to get the same message because the people that are making the decisions on those boards, their research and their careers have been funded by the food industry directly or indirectly. And if they were to admit that they got it wrong, again, it's challenging for the guidelines to change. The good thing about guidelines, dietary guidelines, and I think they're very similar around the world, are they for healthy people? Dietary guidelines at a national level are for healthy people. Now, if 93% of the population are metabolically unwell, that means the dietary guidelines are not relevant. They're only relevant for 7% of the population. So where we have made progress here in Australia is part of the National Diabetes Strategy, 18 months ago was introduced, and low carb is part of the National Diabetes Strategy. So when you understand that a third of the population have effectively got diabetes, another third have got pre-diabetes, and it's no different, I suspect, in India. Therefore, 2/3 of the population having low carb as part of the National Diabetes Strategy is very powerful. So it's there to actually say this is a method, an option of putting people into remission without drugs and without surgery, because that's how we've got it in there. So the thing says people can go into remission with drugs or surgery or low carb. Really important that we can say, okay, low carb's there. That's the only one that doesn't cost anything. The only one thing that doesn't have any side effects. So and I think that's a huge step in dietary guidelines change, but it's not a dietary guideline for the whole population. It's a dietary guideline for diabetes. But that's the first step. That's the low-hanging fruit, for want of a better term. And it can only grow because of the benefits we're seeing. But it just means that certain hierarchies, those people in what we call eminence-based medicine, have to admit they got it wrong, or they have to move on. They have to retire and wait for the next generation to come through.
I feel the situation in India is very similar. We have a diabetic and obesity epidemic going on here. So what would be your input to the people of India? How do you think we can overcome this?
Start educating. This is part of this conference. It is literally to mentor each other and start telling those stories. And if your role, if someone is doing low carb and they're feeling a benefit of it, then I think I encourage people to go to their healthcare professional, either by themselves or with their family member who may have diabetes or some other health problem, and respectfully approach the problem. And I sort of say, let's say you go along with your mother to the doctor, and your mother's got type 2 diabetes, or she's got a liver problem, or non-alcoholic fatty liver disease, or some respiratory problem, and say to the doctor, I personally have seen the benefits of low carbohydrate. How do you think that would go with my mother? That's a respectful way of raising the topic. And I've said here in Australia and internationally, if doctors have not heard about low carb, particularly in the management of diabetes, and they are not recommending the benefits of it, I think they're now negligent. I think there's enough information, and there's enough information flowing around about low carb in the management of diabetes. If your doctor doesn't recommend it or isn't willing to form a position on it, then they're dangerous. They may talk about, oh, fats are bad for you or cholesterol is bad. My favorite question, and I encourage everyone to get educated on this, is to, when a doctor says, oh, it's bad for your cholesterol, then I dare you to ask your doctor, what is cholesterol? Because my experience is 99.9% of doctors cannot answer that question.
That's right.
And when you realize cholesterol is a major structural component of every cell membrane in the body, it's the precursor to major hormones, including vitamin D, the sex hormones. It's there for the formation of the bile acids. It's there for the formation of vitamin D. And the vast majority of doctors will not actually know that. They say, oh, your cholesterol's up. Oh, if you eat too much fat, your cholesterol's going to go up. Well, I don't give a stuff if your cholesterol goes up, because it's actually, we've got lots of papers now which say the higher your cholesterol, the better your longevity, the less likely you are to get cancer, dementia, diabetes. It's an ongoing argument, but I used to be a bit more respectful. Now I'm just saying, no, if you're not recommending low carb for your patients with diabetes, then you're negligent. And they're harsh words, but I think it's time to start calling it.
Yeah, I think we need to wake up to the reality. And as you said, if we have a cheap and a very viable option, which can be, why not, to get off the drugs and to make the quality of life better. So I think it's high time that we do that. So Doctor, we're almost reaching the end of our session, another 5 minutes. Before we end, I would like to ask you, would you like to share any interesting case about your patients? Anything which you feel where your patient would have recovered powerfully with the help of the dietary changes? Is there any specific case you would like to share?
I think I'll just come back one step. Look, improving, some people say it costs a bit to change your diet and lifestyle. You've got a choice of spending the money on your diet and your lifestyle now, or spending it in doctors' waiting rooms and operations in the future. Do I have a single story? No, I've got 1,000 stories. And all I can say is that those people who have adopted this change improve their health, their well-being. They've taken in control of their life again, and they become empowered in their health outcome. That's it. And when you see people take back control after eating badly, getting poor medical advice and specifically poor nutritional advice for decades, they are empowered and they just improve. And I think that's it. Low carb, LCHF, keto has restored the joy of medicine when you see patients getting better. Because doctor is to teach. Doctor is not to care for, doctor cure, it's to teach. And if you can teach your patients about this, then you're a true doctor.
Totally agree. Doctor, it was such a pleasure having you here. Now I would like to invite Shashikant Iyengar to thank you.
Hi, Shashi.
Yeah, hi, hello, doctor. I'll also request Himanshu to get in Anup Singh.
Hi, Anup.
So Dr. Gary, thank you very much for accepting the invitation and coming and speaking on very, very important topic of vegetable oil and fructose. And I still recall that you were my first podcast host 3 years back.
Yes.
And the phone memory remains even today. And I think India will learn a lot from you in this occasion. And I cannot thank you enough.
I think we've touched on a few things here. That's the beautiful thing about YouTube. The talks that I go, others, there's so much information out there now. I'm very proud to be part of your Indian journey. And I'm proud to be part of this low carb community, but we're all on each other's pathways, and this is a huge effort. And I think I congratulate you for getting this off and running, and as I did a few years ago. But you know, obviously come ahead in an enormous way.
Thank you, Anup. Anup, we cannot hear you. We cannot hear you.
Don't take your shirt off.
Yeah. You know, it gives us immense pleasure to let the viewers know that Dr. Gary Fetke was the first from Australia to review our platform. And that was around 5 years back. Time has flown. And Doctor, you'd be happy to know that we have come a long way from that then. And we launched, you know, certification courses in 2020, and that's doing pretty well. In fact, we have got one enrollment from Australia itself, and she'll be hosting another Australian doctor down the line. So this is I wanted to share with you.
Oh, look, I've been watching your progress, and I've actually been recommending to the Indian community here. They say, what resources? They say, well, actually, there's this group over in India. You know, so what you're doing is powerful, but not just in your own backyard, but also internationally. So, you know, you've got to be congratulated for that.
Thank you. Thank you.
Thank you. Thank you.
I would like to invite Dr. Diljan Mansoor for the next session, along with Shashikant Iyengar and Anup Singh. Thank you.
All right. Thank you.
Take an era also.
Hello.
Yeah, Hira. Fine. Dr. Diljan, welcome.
Thank you. Thank you, Sasi.
So there are three of us to support you.
Thank you. Thank you so much.
I think for the viewers, Diljan has a very unique story. So we'll briefly tell you about Dr. Diljan. Me and Ira will briefly introduce. So we all have heard about, or we all have not heard about, the harassment faced by many doctors across the globe. So we have Professor Tim Noakes from South Africa. Dr. Gary Fetke was just our guest from Australia. Dr. Sean Baker from USA. Dr. Annika Dahlquist from Sweden, and Dr. Bordua Roy from Canada, and Dr. Antti Akila from Finland. They all have faced a solid pushback from the local establishment because they have practiced low carb or they have spoken against sugar. So we have one such case in Asia also. For the first time, Dr. Diljan Mansoor is from Nepal, and he's facing a solid pushback in his local town, in his local country. And we from D-Life, since we are from this continent, we are the leaders in low carb, and we want to support Dr. Diljan to the maximum extent possible. And we have taken up this task, and we have allocated a special session even in this, so that the world comes to know about the predicament of Diljan and the solid, excellent work he has been doing. I hand over the talk now to Ira.
Hello, welcome Dr. Diljan Mansoor from Nepal, India's first Metabolic Health Conference, low carb across the globe. Welcome Shashi, welcome Anup. Here's a brief introduction of Dr. Diljan. Dr. Diljan is an MBBS and has completed his MD in internal medicine from China. He's worked as a medical officer for more than 5 years and also as a resident doctor for 2 to 3 years now in his own clinic, and has his own clinic, Food Diabetes Hard Clinic and Research Center in Kathmandu, Nepal. He's the youngest and the only internal medicine physician who advocates low carb diet to his patients. Recently, he was hounded by the local authorities for practicing low carb, and they made him close his clinic. After much struggle and fight back, he's allowed to reopen his clinic, but with some restrictions. So I welcome Dr. Diljan Mansoor. I am Ira Sahai, your host. I'm a metabolic health coach based out of Mumbai. And I welcome Shashi, Anup, and Dr. Diljan in this great conversation. Welcome.
So a word from Anup first.
Yeah, Dr. Diljan, you know, we are meeting for the first time formally here. Now, as you know, we are the only platform in India or the subcontinent, I would say, and the only award-winning platform for low carb. And we've had not many success stories. I mean, to quote a number, I would say collective, it is around 3,000 plus. Now, that's not a small feat because Indian subcontinent primarily is grain-based. And to, work with clients or work with patients on low carb for such a granitarian region, it's not an easy task. Yet, we have made it possible, and welcome to the show.
Thank you.
Yeah.
So first up, I think I'll begin by asking Dr. Dilshan about his background in brief, and tell us a bit about your medical studies and how did you come into low carb?
All right. Thank you, Yura. Thank you for having me here. It's such a pleasure to have you. Back in 2015, I was working as a medical officer after completion of my MBBS. So I was working as a medical officer in a lot of hospitals. And in 2015, actually, my dad was a diabetic and he was a hypertensive. I used to see a lot of tsunami of diabetes in my country, and it's increasing every day. And that time it was my own dad. My dad was hypertensive and he was on hypertensive medication. He was on diabetic medication. He was on hyperuricemia medication. So, and he was a diabetic for a long time back, like 10 or 20 years ago. But in 2015, when I started to understand things, what happening with my dad, and that time it was a bit concerning. Initially, my dad was on oral hypoglycemic agents. So my dad, we couldn't control his hyperglycemia. His blood sugar was raising every day. And despite of being a medical doctor, I used to do everything by the rule, that what I've taught in the med school, what I have learned in the med school. And if it is hyperglycemic, I need to switch from one class of group to another class of group. And so despite of doing everything, despite of doing every little thing that I'm supposed to do as the doctors and my seniors, my dad diabetes was getting worse and worse. And there was a condition, I had to switch my dad onto insulin therapy. And on being insulin therapy, my dad was like experiencing hypoglycemia and the hyperglycemia. He was sometimes being unconscious because the insulin was too high for him and his diet was not controlled. So I was very skeptical that time why I'm not being able to treat my dad. And gradually my dad developed AKI, the acute kidney injury. So we started my dad on dialysis. There was time he was on dialysis. We were doing all this medication, supporting medication, plus he was having on dialysis. So it takes like an year, and there was an earthquake in my country in that same year. And 2 months after earthquake, my dad, he was in hospital. So we need to do a dialysis. So initially we had a temporary dialysis before we had a fistula. We started doing dialysis of my dad, inserting a catheter in the jugular, and we started doing a temporary dialysis. So we also were planning to go for a permanent dialysis. So we created a fistula. It takes 2 to 3 months to grow. Meanwhile, my dad had a complication, and then my dad died. And once my dad died, I was shocked, and I was first time in my life I was so hopeless, because I did everything to save my dad. I tried oral hypoglycemic agent. I put my dad onto SGLT2 that was supposed to be safe for a kidney patient. Then I put my dad into ACE inhibitors, ARB inhibitors, and then we started doing dialysis of my dad. But I could not save my dad. The only question is on my mind, I killed my dad. Everything is because of me. I was so helpless. I could not even, if I could not help my own dad, like what I'm supposed to do. And I blame myself for everything that happened to my dad, because being a doctor, I could not even save my dad. He was pretty young. And then I was not in good mind, and I was started to look something beyond it. Like, what is happening to my dad? Why did he have to wind up into diabetic nephropathy? Why he had to why I could not control his diabetic despite of all the medications? And then I started digging into this low carb community. And that time I was a medical officer, just an MBBS doctor. So then I joined my residency in 2017. I joined residency after 2 years. I could not even work for 2 years, and I was so traumatized, and like I could not even process everything that happens to my dad. I did every little thing that I was learning in the med school. I did everything that I was supposed to do as a practitioner, as a medical doctor. Then I started my residency, and during my residency, I was in Fujian Medical University. It's like in the cardiac department, as being an internal medicine resident. And I used to see the tsunami of diabetic. And every time I see a patient with diabetic, it reminds me of my dad. I used to think that guy is going to wind up just like my dad. He's going to have a diabetic nephropathy after a few years, then he will be on dialysis, or at the end of the day, he will run transplant. And I could not sleep for like months and years, thinking all the time, there should be something that I should do. And then I started digging into low carb community, and the first person I came to know was Dr. Jason Fong. So I started digging more and more, and then I finished my residency. I was so much prepared. Once I'm going back to my country, I'm going to start I'm going to start low carb for my metabolically ill patients. So I started treating them with low carb food, and the response was so immense and so beautiful. I used to see my patient, they're thriving on low carb diet. Their hyperglycemia has been controlled from 4 to 5 oral medication. I used to taper their medication to 1 or 2 medication. From 60 to 100 units of insulin, I used to put my patient on 10 units of insulin, and it's working so good. And that is the beauty of being an internal medicine doctor, because I have idea about the medicine, which medicine is safe for my patient, which medicine is safe for his kidney. And within the years, I treated more than 6,000 patients, and here I am.
Excellent. So I believe that this situation would be similar in Nepal as in India. Like we have been rattling out this figure earlier also, 101 million diabetes. 136 million with pre-diabetes. The issue I probably feel is very, very similar there. So what is it you see in the general population, not in your practice, but in the general population? What all metabolic issues you see?
Let me tell you, sir, this is a very good question you asked me. Let me put you in the data, because these people do understand the data. In my country at the moment, the diabetic is like 1.1 million people are diabetic. I'm not talking about pre-diabetic. Forget about pre-diabetic. Almost 1 to 1.1 million people in Nepal. We call 10 to 11 lakhs. I think same in India. In lakhs, we use lakhs. So 10 to out of 30 million people, 1.1 million people are diabetic. So I was not only confined with my country, I started digging more into Asia. Look at now India is the capital city of diabetic at the moment. As you said, there's 100 million people are diabetic in India. We're not talking about pre-diabetic. And let's look at data about cardiovascular disease. In my country, 1.1 to 1.2 million people are having heart disease, like cardiovascular disease. And almost, according to the data by NIH in 2019, there was almost 46,000 people died of heart disease, and disability adjustment life. More than 1 million people are having adjusted life because of cardiovascular disease. So when you're talking about this metabolically, and when talking about pressure, out of 4 people, 1 person is having hypertensive problems, and the worst part is that only 5% of them have a controlled hypertension. So what I'm seeing right now is there will be a time, even my country or your country will not be able to handle this metabolically ill people. Our system will not be able to handle the diabetic patient. As there's a very beautiful word said by Anup earlier, graintarian. And he's so correct about that part. We are not only grain lover, but we're grain worshiper. I prefer the word worship. We worship grain, everything. And even you remember when you're harvesting the grain, we worship. It's similar culture in your country and my country. So from a grain lover, we are a grain worshiper. And at the moment, I can see there's so creeping disappointment by treating them conventionally. We are failing as a physician to treat them. Like we are trying to control their hyperglycemia. We're trying to control their hyperinsulinemia by the medication. But what is the end results? What is the success rate for that? What are you doing here? So when talking about all the data, I'm so stuck and so sad to see such a huge amount of amount of diabetic patient in my country. Cardiovascular disease is rising, is skyrocketing. So when it comes about data, we are on the top of the roof, and we are seeing this, and I have seen a tsunami of people, and I am sure maybe after a few years, we can't even handle this.
Very, very important. It is this statement of yours is going to be etched in the mind, that we are grain worshippers.
Yeah.
This is truly big. Yeah, no.
Yeah. So, doctor, you told us about, what made you go into low carb or prefer low carb. Well, you mentioned Jason Fung and others. Now, as you know, as you said, we are grain worshippers. So, low carb is a very, very, I would say, flexible term. So, in your practice, what is the carbohydrate limit that you set for a patient that comes across to you?
Thank you, Anup. It's a very good question. I always tell my patient, and I treat them individually. I see on their body mass composition, their muscle mass. Like if you have more muscle, you can tolerate more carbohydrate. And that is the very, very simple thing you need to understand. Because your muscle, when you have too much muscle in your body compared to a very lean person, you're muscular, it means you have too much of glucose transport. Well, GULT4, that's the transporter which transport the glucose to your muscles. So if a person is very muscular, he can tolerate a lot of amount of glucose. He can store a lot of amount of glycogen. But the basic, let's talk about the rule. Your liver can only store 80 to 100 grams of glycogen. Your muscle can store up to 120 to 200 milligrams of glycogen. So when it comes about when you are a diabetic patient, you are on oral medication, you are insulin therapy, you are metabolically very healthy, you have visceral obesity, at that time of point, you need to stop eating carbohydrates. It's not only about carbohydrates, you need to stop all those extra grains, carbohydrates, pulses that is converting into the glucose, even about the fruits. Because first we need to control your metabolic health. Once your metabolic health is considered, you are in a good shape, you are according to your height and weight, you are in your normal BMI, that time we can consider, I put my patient up to 100 to 120 grams of carbs. But a lot of people are mistaken with the carbs, mistaken with the glucose. What they think, rice is the only thing that's converted into glucose. They won't care about the potatoes that they're having or the sweet potatoes they are having. The only thing they consider, when talking about sugar, they consider about table sugar, the table sugar, oh, Doc, they come to my clinic, you should stop these sugars. And they will tell, Doc, it's been years, I'm not having sugar. Then I ask them, what do you have today for lunch? I have chapati, and then I have a bread. Oh, and whole bread, that's what they talk, like they have been manipulated with the word. Oh, do you know what? One slice of bread, 5 tablespoon of sugar in your bread? No, Doc, no, it's just a whole bread. So I talk about, first you need to know what condition you are, what type of patient you are, if you are diabetic, if you're hyperinsulinemia, if you have insulin resistance, and your HbA1c, all blood parameters are way higher than it's supposed to be in normal range. At that time, I want my patient to go below 100 grams of carbohydrates. As you said, in a country like Nepal and India, people, if you tell them to stop carbohydrate, it's like a crime. You're fighting with the culture. If you tell them don't eat rice, if I'm not going to eat rice and pulse like dal bhat, then what I'm going to eat? Look, their whole scenario is created with this dal bhat. And that is creating a big problem. I said, you can have dal bhat, but before you take a dal bhat, first you need to eat the glucose inside your body. You have too much of fats, you have a visceral obesity, you have a big stomach, you have a belly, and the other source of energy that we call another source we call ketones body. So first, let me fix your metabolic health. When your metabolic health is fixed, I will let you to eat carbs. You can have legumes, low carb legumes, and low carb legumes. Even the 100 grams of legumes have 14 grams of carbohydrate. You're taking carbohydrates. Low carbohydrate diet does not mean no carbohydrate diet. There's such a misconception with the people. When talking about low carb diet, they will think no carb diet. Oh, I'm going to die. My brain is going to die, because they have no idea what is called hepatogluconeogenesis. They have no idea everything that you eat in the form of carbohydrate that is converted into glucose in your body. You have another source of energy. But first, I need to tell them about the basic concept, how much glucose you need, how much glucose your liver can store, and the excess of all glucose is converted into fat. That is called de novo lipogenesis. So you need to control this part, and gradually, once they are very convinced on, I am telling them this is not a rocket science. You don't need something to bring from another planet. You can locally available things are available for you. We can fix it out. We can talk against your budgets. We can fix you out once your HbA1c is below 5.6, once your blood pressure is under control, and then we'll keep on adding a little bit of carbs. And even adding a carbs, we are not going to add any refined and processed carb. We'll go for the carbs that is good for you. So that's the answer to the Anup. I'm telling them every time when we talk about low carb, they're thinking only the meat. Oh, if I'm not going to eat carb, what I'm going to eat? You can eat lots of green leafy vegetables, dark leafy vegetables, lots of green things you can eat, and even slowly and gradually, I can put you on a little bit of pulse, and we can consider with the paneer and the tofu. Don't worry, if you're not into meat, fish, or eggs, gradually we can change you. But first, we need to fix your disease.
Okay, Dr. Darjan, how many patients have you treated on low carb? Being a conventional doctor, how many patients have you treated on low carb, and who are they usually? I mean, what kind of metabolic disorders do they come to you with?
Thank you. Most of the patients that I see, I treat two types of patient. One is you can see them and you can tell them, oh, he's metabolically unhealthy patient. They have visceral obesity, they have big bellies, they are diabetic, hypertensive, hypertriglyceridemia, and the obesity. That is the one type of person that is, you can, by looking at them, you can tell them before doing any blood test. And another is, especially in Asia, I'm problem with this person. They are very lean, they're very thin, but they're having diabetic. So sometimes if you heard the word tofu, thin outside and fat inside, and these people are lean, especially you go for Asian continent, they're very small hands and legs, but they have very big belly, you know, like they've got a protruded belly that time. So I'm seeing two type of person. One is very lean and an underweight person with diabetic patient, and other is morbidly obese patient. The two type of patient I have seen, and I have seen more than 6,000 of this metabolically ill patient. And once I put my patient onto low carb diet and try to taper their medication, adjust their medication, because you need to do with a very, very genuine person, a doctor who supports you, and with a doctor who knows about your medications. When I have to take off my patient off the medication, I need to understand what type of medication first I need to take them off. The first medication I take off is diuretics, because after starting low carb diet, my patient started to see there's a very, very lower blood pressure there. And once they started going hypertensive, you need to understand what kind of medication you need to taper. So the first part is like, you need a doctor who can tell you, who can talk to you, and who have a basic idea about your medication. Even I have a patient who are renal patients and they're metabolically ill patient. The renal medication that is safe for a diabetic patient in SGLT2 groups, and other is ARB or ACE inhibitors. So it's not about taking them off medication directly. It's like looking on their blood reports with their values, how it's working, and what is the percentage of tapering. Like, how did you taper the medication? We talk to them and how good they are feeling. And at the moment, I'm in my clinic, so I have a very special chart, especially for my metabolic patient. So I'm very keen with my patient. I want to know every details about my patient, what they're eating, what type of food they're eating, what the medication, and even I give this vital chart to all of my patients to monitor their fasting blood, their postprandial. Even sometimes some of my patients are like dawn phenomenon patients. Their morning blood glucose is very high. So sometimes I ask them to wake up at 3 a.m. in the morning and check your blood glucose. That time you might be in hypoglycemic. And once you're hypoglycemic, your liver starts to make a lot of glucose. That is called hepatic gluconeogenesis. So these two type of patient, the first thing, I need to know everything about my patient when treating them. And by doing this and putting them on low carb, the most beautiful things I see when I put my obese patient on low carb diet, the first thing, their skin started to change. They started to glow. They started to thrive. when they came in my clinic, they have so much of skin tags, you can see how hyperinsulinemia, your skin has been changed. And once I put them on low carb diet, I started to see, the first thing I noticed, their skin started to become so beautiful. And then gradually start tapering their medications. First, I am very, very concerned with the patient medications and their side effects and how does it work on my patient. So, and once I put them on low carb diet, the first thing I see, they started losing a lot of weight. Once they started losing a lot of weight, blood pressure is controlled, their hyperglycemia is controlled, and gradually after 3 months, 4 months, 5 months, 6 months, I could be able to take off the medications. And even after 6 months of off medication, they're in regular follow-up with me so I can check the blood glucose again.
Very interesting. We'll come back to that. See, like you were mentioning, what is the amount of patients you have had success with? I think you had mentioned a huge number of patients. We are very, very keen to know that how many patients and what all are the activities which you have done there.
Thank you. So out of 6,000 plus patients, most of them are metabolically ill patients, and some of them are 10% are like hypothyroid patient, autoimmune disease condition patient. And recently I have prepared 52 cases of drug-free remissions. So I'm going to publish that paper. I had a talk with Dr. David Unwin, and he teaches me last time. So I'm going to publish the paper. I'm preparing to publish that paper into New York, into NMJ, in the nutrition. So technically talking about like 90% of patients are metabolically ill. They are either diabetic or they're hypertensive or they're obese or they have hypertriglyceridemia. And the other people that I see in my clinics are morbidly obese, having problems with their spinal cord problems, their problem with their movement, they're not being able to move properly. And even out of those 90%, a lot of people have already developed diabetic nephropathy. They have started to have their microalbuminuria, and some of them develops macroproteinuria, or we call macroalbuminuria. So basically 99% my patients are metabolically ill patients, and 90% are diabetic patients, 10% are maybe hyperthyroidisms, or they're morbidly obese patient, or they're orthopedic patient who cannot even walk. Or I have a lot of patients, if I'll tell some of the stories, I have a patient who lost 65 kg in 1 year, and now he's playing football. So when he came to my clinic, he was in a wheelchair, and he could not even, he barely could walk, and he was 145 kg. I took a permission because I want to mention his name. To even find this morning, he was talking to me. His name is Prakash Karel. So he was 145 kg, and now he lost like 65 kg, and he's playing football, and he barely could move. He barely could walk, and now he went to trekking, and he make a video on top of Gosaikunda. There is a place where he went for hiking, and he make a video, a gratitude video, that I was not even being able to walk around my house. Now I am trekking on the feet of 4,000. He went to the trek. So when I talk about my morbidly obese patient, most of them had problems with their knee pain, the joint pains, their lower back pain. They could not even move, and their movements is very limited. But once they started to shed up all unnecessary weights and the fats, they started getting very healthier. When I talk about my hypothyroid patient, most of my patients are obese patients. See, it's so interesting correlations. See, if I talk about them. So most of my patients, those are hypothyroid patients, and they're morbidly obese patients. Their BMI is above 35, 36, 37. Once they started losing weight, there's such a good like improvement in their blood parameters. The THS from 10 started getting like 6, 5, 4, and start tapering their medication. And initially they were on 50 mcg of levothyroxine, so I put them on 25 mcg, then I put on 12.5 mcg, and the report started getting better. So technically these are 5 patients I was talking about. One is metabolically ill patient, the 4 I always have metabolic syndrome patients, and other is orthopedic patient. I've seen lots and lots of orthopedic patients. The movement is restricted due to their overweight, and they have joints pain, knee pains, and a lot. Even I see a lot of people with rheumatic disease patient. They have so much of inflammations in their body. So I always talk about them. Let's try this. Let's try this first. Let's get off all the extra weight. and then let's try to decrease your inflammation in your body, and then we'll talk about whether it work or not. First, you need to lose 20 kg of weight, and you have too much of inflammation in your body. I check all the metabolic panels in my lab, and once I explain them about what is called ESR, what is called CRP, how much inflammation your body has, what is called insulin resistance, your fasting insulin is high, you are metabolically unhealthy. First, let's fix your metabolic things. Once I fix your metabolic things, and then we'll talk about your pain. And once they started fixing their metabolic health, they started overall improvements. Their movement start to get better. If you just remember, a lot of diabetic patients have a Freudian soldier. Eventually, they have their movement. There's a restricted movement in their soldier. So once their hyperglycemia is controlled, their blood pressure is controlled, their hyperinsulinemia is controlled, they start, doc, look, I can move my hand. And that is the most beautiful part when they come to the clinic. Oh, you can move your hand now. And so these are the patients I'm seeing.
Great. Anup?
Yeah, Dr. Diljan, besides, attending patients in your clinic, are you doing anything to educate the general population in Nepal? If yes, what is it?
Yes, I'm doing it. As you know, I used to do in my clinic, so I've been restricted to do that. I cannot do.
We'll come to that, subsequently.
Yeah, like I cannot do mass counseling, so I'm doing individual counseling at the moment. The best part is I have my own YouTube channel, and especially it's in Nepali language because I want to make that videos for my patient. So I have my Facebook page where people who are following me, or the people who are interested in the low carb community, they follows me, and especially technically to educate the people, I have making a lot of YouTube videos for my patient. And I have some certain interviews in my country that has been viewed in millions and millions for my people.
Then earlier to this, like you were doing a lot of in-clinic activities also.
Yeah, so true. I used to have a mass counseling of 30 to 40 people at a time to teach them what is low carb diet. And so before I teach them low carb things, I used to teach them what is insulin resistance, what is hyperinsulinemia, what is diabetes, and what is metabolic syndrome. I used to teach them for 2 hours about metabolic syndrome. So they are very easy to understand what I was trying to tell them, because once you teach them how to fish, they can easily fish. But if I provide them the fish, they might use that fish for 2 or 3 weeks. But again, they have no idea how to fish this. So for that part, now I'm making the YouTube videos for my patient.
Doc, I think that is superb. See, generally, we find that we have very less time inside a doctor's clinic. Just
So
like
true.
get prescription. You are spending 2 hours on explaining the very basic concept. I think it is just out of the world that a mainstream doctor who is an MD, internal medicine, could actually take time out and explain to a group of people on what is the basics. And spending the 2 hours is very, very valuable. It's very rarely we have seen such doctors, really. I recall one pediatrician in Mumbai long back who used to do that compulsorily. Yeah, Ira.
Yeah. Dr. Mansoor, can you tell us what really happened, in the last 2 years? Talking about how the authorities, they objected to you practicing low carb. So give us a brief about that.
Let me tell you. Here's the story, Era. The main point is that being an internal medicine physician, or the mainstream conventional people, they think being a physician, it's inappropriate to preach or advocate about nutrition. That's the first point. Second point, low carb is unscientific. The fact is that there's hundreds and thousands of data are coming up every day, and it has been practiced around the world. When we talk about this low carb is scientific or unscientific, there are hundreds of papers are published. Even Dr. David Unwin published a paper, Type 2 Drug-Free Remission, and it's with such a tremendous results. So even we talk about low carb, it was in 1863, William Benting, in the letter of corpulence you first published about what is the health benefits of being on low carb diet. Even in 700 BC, the Greek Olympian used to have a low carb and high fat and protein diet to preserve their endurance, their athletic endurance. So that in a country like Nepal and India, or in the Southeast Asia or the Asia, where everybody is a grain lover, and when you suddenly come out of nowhere and young doctors saying that, oh, look, if you're going to fix your diet, you're going to fix your diabetes. So it's like, you know, you understand what I'm trying to tell. Oh, this is something wrong. We have been eating rice for centuries, and how could someone come and say you can't eat it? So that kind of mass hysteria has been created in the country, a fabricated story. Once you are on low carb diet, you wind up being in a kidney patient. Your kidney is going to, you will destroy your kidney. You will wind up being into a kidney patient. So such kind of, and this, you know, the media, how they have been controlled with these things, and so started defaming you and deframing you, saying low carb diet is inappropriate. As a physician, to prescribe low carb diet is unsustainable. You cannot sustain it, and it is and at the end of the day, you will double the risk of your cardiovascular disease, and you wind up being a kidney patient. But as you know, there's no any published paper that says that there is a direct relation between the low carb diet or the heart disease or the kidney disease. So this has been happened throughout the country since these 2 years, and I have to face all this alone, telling people, no, low carb diet is not going to kill you. It's going to treat you. Your diabetes will be controlled. But you know, being alone is sometimes so hard to tell the people and explain to people, but still the fight is going on.
So now I think it's very interesting you told that in 1797, John Rollo, the notes of diabetes cases, we know that he has treated diabetics with meat and fat diet. It is so old, and even as recently, it is endorsed by even American Diabetes Association in 2019. 2018, it's the joint consensus between ADA and ESD. They declared that low carb diet can be an option. And from 2019, it is there in their MNT. I think, I don't know how many of them open really the MNT section. People will generally see the drug algorithm, and that is what it is followed. And this is 200 years of low carb diet, 200 years. And still people think that it is something out of the world. People think it is a fad and everything. So the interesting point now is, after this protracted battle, you have done so much. You have, I think, single-handedly fought against the authorities. You have permission to open the clinic. So is there any restriction, or what are the restrictions you have right now?
I told you before, the first restriction is I should not do a mass counseling in my clinic.
Okay.
So I should not talk or preach or advocate people in a group. So they allow me to practice, but as an individual counseling, if people are ready to have a consultation with me, you can do one-on-one consultation. So, you know, like when I'm talking about metabolic syndrome, teaching 100 people at a time and teaching 1 people at a time is the same thing. So the only thing is that I'm happy as long as I'm being able to practice, as long as I'm able to, at least I'm going to make difference in someone's life. If today I'm going to make one life, like difference in one life, tomorrow it'll be the 2 and the 3rd and the 4th and the 5th, you know. So that is the restriction. I should not do a group counseling, and I should talk about individual counseling. So these are the sort of restrictions that I have been following, but that's the restrictions in the clinic. But I can do on my YouTube, so I can tell my people what's happening to them. So see, when he talks about the restriction, that is not a big problem. The problem is that our people, the people in India and the Nepal, they're not being able to understand the glorifications of this low carb diet to their metabolic syndrome. When it comes to metabolic syndrome, we are not only working on their obesity, we are working on their insulin level. We're talking about their obesity, their diabetes, their hypertension, and even on their obesity part. So even it's an individual counseling, my main focus is to teach them, to make them understand to how low carb is so beneficial for you. And there's not a rocket science. You can do it for a few months, you can see the changes, and it's your decision or the patient decision that what they want to do, how long they want to do. And as for my patients, see, I'm a physician, I'm ready to give you pill all the time. It's up to you. Come on, like, there's nothing, you have nothing to lose. But once this has been portrayed with the kidney disease, I want to tell you through today's interview or to our conference, to the people of India and Nepal especially, don't fear the protein. Don't fear protein. Say I'm telling you the story. You're worried about your kidney disease. Just do me a favor and Google what is the most common cause of kidney disease in the world. You'll get your answer. The first thing you pop up is a diabetic. So if diabetes is the first cause or the secondary, primary cause could be anything for a kidney disease. You could have a tumor in your kidney. You could have a renal artery stenosis. You could have a kidney stone that leads to your kidney failure, or you might wind up in nephrectomy. So there are so many other things systemically that you can have a kidney disease. So, but we're not dying of systemic kidney disease. We're dying of the secondary cause of kidney disease. So once you Google what is the most common cause of kidney disease, secondary cause of kidney disease in the world, the first answer is your hypertension. So we are trying to control your hypertension. We are trying to cure your hyperglycemia. So here is the catch to the people of Nepal and India. They need to understand it takes 5 to 10 years from pre-diabetic to diabetic. And from diabetic, it takes 5 to 10 years to develop microalbuminuria. Albumin is a protein that we see in the urine. So once you start microalbuminuria, it means your kidney is losing some protein. Your kidney is not being able to filter the protein. So one need to understand it's not the protein that is causing a problem to your kidney. For example, you have a strawberry in your sieve and you're washing the strawberry in a basin, and suddenly you see some strawberry in the basin. So you can't blame the basin. Oh, there's something wrong with the basin. Or you cannot tell, oh, there's something wrong with the strawberry. It's the sieve, that a hole inside the sieve, and that's how you see the strawberry in your sink. Same thing happened with the kidney disease. Once you had a kidney disease, it's not the protein that causes kidney disease. Your protein is not being filtered by the kidney. There is a hole in the kidney. So in the first hand, what causes hole in your kidney? Diabetic nephropathy. So prolonged diabetic for 10 to 20 years, your uncontrolled hyperglycemia for 10 to 20 years, that leads to a condition called microalbuminuria. And this is the first stage, like we started developing diabetic nephropathy. And from diabetic nephropathy to wind up into other condition we called macro, that's macroalbuminuria, or simply proteinuria. That is another 10 years condition. And these are two. From microalbuminuria to the macroalbuminuria proteinuria, you start seeing the problems in your kidney now. So in the first hand, what is the main problem for a kidney to progress into a kidney disease? Is uncontrolled blood pressure, uncontrolled hyperglycemia, uncontrolled insulin. So we are trying to fix your kidney here. We are trying to slow the progressions of your kidney disease, and low carb diet is undoubtedly the best thing for you. So when we talk about protein, if you have a kidney disease, and so once you start you stop eating your protein, you're not prioritizing your protein, what happened? There's a condition called protein malnutrition. Your body have 2 liters of albumin. You start swelling, your body, your cells, everything start to swell, and the condition become worse and worse. So it's not the protein. There's certain condition where we restrict the protein. For example, you have a heart failure and you are into end-stage end-stage renal disease. That is the only condition, and that is also believed 20 years ago. People saying that if you take a low protein diet, it might help because urea is the metabolic outproduct, and that might lead to a little bit of problems for a kidney to filter all those urea, and that a lot of people might wind up into the uremic encephalopathy. So that is the only condition where sometimes we ask our patient to limit your protein intake. That's why you need to talk with the doctor. It's not the protein that is creating your problems. There are a lot of conditions that are creating your kidney to wind up into a renal disease. So I always tell them, don't fear the protein. You talk to the person. First, prioritize your protein, like what kind of disease you have and what kind of. If you have a diabetic nephropathy, the first hand you have to control your hyperglycemia. You need to control your blood pressure. So I always tell them, don't fear the protein. Just figure it out. What is the secondary cause for your kidney disease?
Very interesting, and you have shown it very nicely that the microalbuminuria starts maybe after 5 years, then progressing into proteinuria. And I think that's what we say, that there is a window period of maybe 15 years or 10 or 15 years before the complication starts. And the crux of this point is today we see diabetes setting in at a very early stage. At the age of 25, 30, 35, that means by the time they reach 50s, which is still a productive age, they face complication. Unlike the earlier time when we used to get diabetes at 55 or 60, we still had a window period of 10, 15 years. 70, 75 is okay when people were considering old age. But now into productive age, people are getting in complication. I think, and very nicely you explained it really. That 5, 10, 15 years period. Very nice. Anup.
Yeah, doctor, you mentioned about, basically scaremongering was the route adopted by the opponents of your protocol. Now, to add to that, as a personal case, when I started talking low carb diet, discussing with the doctor, I was told within 10 years, you'll die of multiple organ failure. Now, it is 13th year, I'm still alive. Now, extending that, world tells us, or the mainstream experts, they tell us that meat, ghee, butter, everything is dangerous. So what's your opinion on this?
My opinions on saturated fat, or what is your
Saturated fat, ghee, butter, coconut oil.
Let me this is such a beautiful things. Even let's talk about India, in South India. What they do, it's not about today or today. It's like hundreds of years and years ago. People are on coconut, they have been eating coconuts. And ghee is not a new thing to the people of Asia. We worship cow. And the most beautiful part from a cow is the ghee, the grass-fed ghee. Let's talk about saturated fat. Our ancestor, or we, is not started eating ghee just last night or like the 2 days ago. We have been consuming this for years and years and years. Look at our civilization. Even before there was the seed oils, we used to light during the Durga Puja. We used the light with the ghee. If you can correlate with me, there was no such things, oils. And that time people used to do with the ghee, with the grass-fed ghee. Now, when talking about saturated fat, a lot of people are scared that saturated fat does good at heart disease, or it's double the risk of your heart disease. But there's not a single paper published that says saturated fat has a direct causation with the cardiovascular disease. There's only one study done, and people have been followed that study by Insulin, and that was not only 7 countries, that was a 21 country studies. And how the data has been manipulated, how the data has been scattered, data has been shown in a linear graph. If you go to the study, you can find out there's no direct correlation. Let's talk about the saturated fat. Saturated fats are the healthy fats. We're not talking about you're having a meat with a bun of bread. See, and you cannot blame the meat that's inside or between the bun. You cannot take the problem with saturated fat to the people that are understanding. They're taking these things with lots of other dietary bad habits. You're having a tablespoon of ghee and having a vodka in the night. You're having 1 cup of meat, and then you're having all the locals' liquor. You know what happening in our country? I'm telling you, with the socioeconomic country, they will take 2 pieces of meat and then have 2 bottles of beers and alcohols. And then you blame the meat for what the sugar did. You're blaming the meat, a saturated fat, for what the food you had. So in country like mine and yours, when something good happens, we have a sweet. Like, if you see carefully how those sweets has been prepared, and you will take just a little amount of ghee, but so much of wrong dietary choices with this. You're taking this meat with alcohol, with the beer and lots of junk food, and that's been real and cooked in a polyunsaturated fatty acids. And the meat which has been cooked in the polyunsaturated fatty acids, if you know, all the seed oils, they have a very low boiling point. And if you have a low boiling point, it means they are very vulnerable to perioxidation. Once they're very easy for perioxidation, you can see they can easily break, and they can create free radicals in your body. And the free radicals can damage your tissues and your cells. It's just like that same thing happening with the cholesterol. Cholesterol is the basic for every individuals, every human beings. Our cells are made up of cholesterol. If you study a little bit do your homework, every human cells in the body is made of cholesterols. If there's a cholesterols on your skin, once you're exposed to the UV rays, that cholesterol is converted into cholecalciferol, that's vitamin D3, converted into vitamin. If you see your sex hormones like estrogens and progesterones or testosterone, they all are made from cholesterols. Even cells are made up of phospholipids, bilayer phospholipid. That means there's 2 layers of cholesterols in your cells. Even you see for a neonate, a baby born, that is also having a lot of cholesterol from your mother milks. So if you see carefully, even for your bile salts, you need cholesterol to make a bile salts. Even you need cholesterol for all those steroid hormones in your body to regulate function, to function properly. Even for vitamin D, you need cholesterol to function. And the most important part is that your body, your liver makes 800 to 200 milligram per deciliter of cholesterol every day. Your body makes almost 2,000 milligram per deciliter of cholesterol every day. So once you start eating little cholesterol, your body starts making more cholesterols every day because you have to survive. Your cells need cholesterol. And the most interesting part, your myelin sheath in your brain, that is also covered by the cholesterols. See? So once you started lowering your cholesterol level, your body started making too much of cholesterols. So cholesterols is the main function of cholesterol is to repair your things. So once you have inflammation in your body, in your blood vessels or in your arteries, cholesterol is the first thing that reaches to your artery to heal it, to fix it. So it's just like blaming an ambulance for, like, there was an accident in the road and the first person to arrive at the site might be a policeman or the ambulance. So you're going to tell, oh, the ambulance is the person who causes the road accident. So same thing happening with the cholesterol. Cholesterol is the most important nutrients in your body. You need it, even your body, to proper function in your cholesterol. So the things that you need to understand, you cannot take saturated fat with the carbohydrates. You cannot take saturated fat with the alcohol. For example, you cannot take like all those sugary drinks and with your meat. You cannot have a tablespoon of ghee with all those fizzy drinks, because that is called perioxidation. So you should be very careful with the perioxidation. It's not the meat, it's what the meat is cooked with. Let me tell you a common scenario in our country. We cook the meat into a seed oils, and then we have that meat with lots of dessert. And once we come to a festival, we have to drink a lot of fizzy drinks. We have to have alcohols. We have the soda. So what I'm telling is that we are taking the saturated fat with the wrong food, with the wrong choices. And at the end of the day, we are blaming saturated fat.
A very nice point here. What you told is, how do we cook meat? It is in a lot of seed oil. And how do we take with lot of refined grains?
So true.
Lot of rotis. The more meat you have, the more roti we need. 8-10 rotis. And biryani, one small piece of meat and then tons of rice. So there's an issue.
And that is not the only one problem, Sashi. Let me add you the more problems here. It's not only the oil they're cooked in, it's what they're taking with. Yeah. And now imagine about the spices we're using in our country. Nobody is taking coriander in the way it was. We're taking lots of refined and processed, like we have to add a lot of ketchups. Even we are putting a lot of ketchups on the ketchup and the sugary drinks, and we have to genetically modified spices, and they are using all like all this Ajinomoto, like all this packet things, which has been packed with a lot of processed food. And even the new fashion, they are like cooking chickens or cooking chicken wings with the Coca-Cola. You know what they're doing? They have been demonizing the fat for something they're doing so wrong. You cannot do that. Like even once you cook any kind of sugar, it converts into Maillard reaction, and Maillard reaction is very toxic for you. And people started cooking sugars and saturated fat together, and with a lot of all of those like those sauces and those ketchup and those vinegars are full with the liquids and high fructose corn syrup. Can you imagine that? And even now they put in honey on it. Imagine that.
So, Ira, you can take up a couple of questions here.
Yeah, one of the questions is, I think, from Anjali, Dr. Dilja. How do you manage low carb on a veg diet? What do you do as a practice?
What diet?
Veg.
Low carb on a vegetarian diet. And if you could give some practical tips, and how do you do?
Thank you. I have more than thousands of patients that are vegetarian. Sometimes it's very hard for me, for my vegan patients. But for my vegetarian patient, I especially in a country like yours and ours, we have to be very careful with our patient. when my vegetarian patient comes to my clinic, the first thing I talk to them, listen, I'm a doctor. I will respect your decision, but you have to respect mine as a medical point of view. If you are vitamin B12 deficient, you have to take supplementation or IV or oral supplementation. It depends on your values. If you are vitamin D3 deficient, if you have a deficiency in iron's profile, I'm gonna check everything and then we'll talk. So especially for my vegetarian patient, I keep them on veg diet. For example, the most of the time I ask them to take all the green leafy vegetables, dark leafy vegetables, and I ask them to take the grains and legumes. And especially for the legumes, I want them to go for sprouts. When they're sprouted overnight, like we can decrease their glycemic index. So I ask them the 4 or 5 things I ask them. The first thing is like go for all the vegetables except the starchy vegetables. I don't want my patient, because they're diabetic and they're vegetarian, so that already I'm not being able to provide them as much of nutrients and the protein that they need from vegetarian diet. So I try to balance them, and I try to talk to them. The first point is that I want them to go for all the green leafy vegetables as much as dark leafy vegetables. Just avoid the starchy vegetables. Just go for locally available vegetables in your location, in your region. And I always talk about region and season. You have to just eat the things that is locally available in your place. And second part is I go for legumes. And once it comes about legumes, it's a tricky part. Sometimes legumes should be so harmful for my patient in case of controlling their hyperglycemia. So I ask them to my patient compulsory, they has to sprout. They has to make it a sprout. They should soak in the water for overnight. Sometimes I ask them to go for 6 days or 7 days, so you can have very good amounts, very low amounts of glycemic index in your foods. And third part is I go for them. They're like paneer, tofu, mushrooms, and the other part is sometimes I ask them to take some seasonal fruits in the country that very low glycemic index. But at the end of the day, I try to tell them if egg is possible, let's take it. Or if egg is not possible, I ask them to focus more on mushrooms and then more on the paneer and the tofu and the sprouts one and the lots of green leafy vegetables. And sometimes I ask them to take some coconut flours and almond flours so they can change their taste. Sometimes they're bored, because they're very limited for them, especially for vegetarian. So I ask them they can make some pancake with the almond flour and the coconut flour. In India, in South India, I think there are a lot of coconut recipes. That's very rare here. But I try to teach them, my patients, so you can take some coconut flours and almond flours, and you can make some pancake. And then at the end of the day, I ask them to take lots of green leafy vegetables and make a lot of soups.
I think we just have 5 minutes, less than 5 minutes. Dr. Anvin is also waiting. One last question which Anjali has asked. How is it that trekking guides which she has seen are surviving on dal bath and very less protein meat? How? Is it genetic or how?
This is very interesting question, Sashi. Look, part is that this is the half of the story. When talking about the trekking guide, they're not trekking 24/7. Because I have been personally involved in this trekking part. My friends are like trekking guide. What they do, there's always a time, like 3 days in a week, 4 days in a week. And most of the trekking guide, they carry lots of dry meat. If you see very carefully, most of my friends, they used to carry lots of dry meats. They carry lots of cheese, and especially in Nepal, the yak cheese, And that the saturated fats or the fat has 9 calories per gram, whereas the carbs have only 4 grams. So when I'm talking about the trekking part, the first part is like when talking about the professional trekking guides, they are very, very lean and healthy and muscular, and they are taking the protein part on different parts. For example, they're using lots of hard-boiled eggs, and before they're trekking, and they always carry such kind of food, dry meats and dry fish. And when it comes about their carbohydrate intake, as I told you, they're very fit, they're very lean, they're very muscular, so they can tolerate lots of carbohydrates. They can, as I told you, the more muscles you have, the more glucose you have, GLUT4, GLUT channel you have, and you can store lots of glycogen in your muscles and in your liver. So what happening for trekking people, as I remember, most of them are taking lots of dry meats, dry fish, dry eggs, and when they're physically very active, they can tolerate a little amounts of carbohydrate. So at the end of the day, they're not trekking 7 days in a week, that they're trekking for 3 or 4 days. And as you know, when they are trekking, the most of them they are fasting. They're indirectly fasting. And when they're fasting, their growth hormones are very high. And the growth hormones will help you to protect your muscles.
I think that's very, and probably as you say, though they may have a little more carbohydrate, it does get expended because of the high intense of activity which they are doing. And I think we cannot really mix this up with the average sedentary person. The average sedentary person, if he goes on and having excess carbohydrate in this form, they are sure to be in some or the other issue. So I think this is what the basic difference which I understand is from what you say, with the kind of exercise there and with the kind of dry foods which they carry, which they may be having occasionally, coupled with the fasting and everything, is really good. So Dr. Diljan, what is the message you want to give to India and to your own countrymen Nepal in this platform, both?
Thank you, Sasi. The first thing, in India, you call medicine as dabai, right? Dabai.
Yeah, dabai.
So the literal meaning is dabai, suppress. It is just suppressing your symptoms. When we call dabai, it means it's just going to suppress your symptoms. So I'm telling to my people, to the people of India, you need to take dabai when you actually need it. But don't throw the pills for a dietary disease, your lifestyle disease. The first thing is that you have to figure it out. How did you get it in the first place? If it is a dietary disease, just like you're having hypertension, diabetes, obesity, so this is your dietary disease. So you need to fix it with the diet, by fixing your diet. And the second part, to telling to my people and your people, don't fear protein. You need a lot of protein. You need a lot of protein. Having one egg is not enough. You're having only 5 grams of protein. First, you need to have a basic ideas. How much protein do you need? What is your daily activities? How physically active you are? These things is very important. Talk to your person, talk to your diet coach, talk to your low-carb nutritionist, talk to your physician. How much protein do I really need, doctor? I'm barely having any protein. So stop worrying about the protein. You need protein to build muscle. You need protein to slow the progressions of aging. You need protein for a lot of functions in your body. And you need to prioritize your protein. And when it comes about grain, we are not telling you don't eat grain, but don't worship it, the grain. You're a grainitarian. Even legumes have lots of carbohydrates. The vegetables you're eating is having lots of carbohydrate. The fruits you are taking is having lots of carbohydrates, having lots of fructose. So first you need to know what is your basic need, what kind of disease you are, and how physically active you are. Stop worrying. Stop worrying and stop fearing a lot of things. Once you are very cool and calm and fix your 5 things in your life, you start seeing a very good result. First, fix your nutrition. Fix your protein in your diet. Prioritize your sleep. Have to 7 to 8 hours of good sound sleep. On top of everything, talk to a doctor to add magnesium glycinate or threonate for a better sleep. Once you have a very good sleep, you can fix a lot of problems in your body. First, your nutrition. Second, sleep. Go and walk in the sun, bask in the sun, have 1 to 2 hours of walk in the sun. We are naturally blessed with such a beautiful, amazing sun. Go outside. Get sunlight in your eyes to fix your circadian rhythm so you can have a good sleep. Don't be scared. Don't every time put on long clothes and covering your face outside the sun. Sun is there to help you.
Thank you. Thank you for all the points, Doc. I think we are very happy to support you. And we have seen a very passionate doctor in Dr. Diljan. And we will have more sessions with you. And we really love talking to you. So thank you very much, Dr. Diljan, for appearing in this session. And for the next session, I welcome Dr. Anvin and Ira will be here. And me and Anup can be out now. Thank you, Dr. Diljan. Thank you very much.
Thank you, everyone.
Good afternoon and namaste from Goa, India. I have a very special guest with me today, Dr. David Unwin. Before that, before I introduce him, my name is Ira Sahai. I am a metabolic health coach. Welcome, Dr. David Unwin. And let me introduce him to the people, which is very unlikely. Most of our viewers already know you, but for the benefit of those who may need an introduction, Dr. David Unwin is a general physician, an RCGP clinical expert in diabetes who works for the National Health Services in England and who's changing the scenario of diabetes in the UK from managing diabetes as a chronic deteriorating condition to finding remission. He managed to save huge money for the NHS than the other GPs in the UK. His work has been so impactful and profound that he was awarded the prestigious NHS Innovator of the Year award and was named one of the top 10 most influential GPs in the UK. Dr. Unwin came up with the 4-gram standard teaspoon of table sugar as an equivalence to convey the amount of glucose in foods like bread or rice. 800 foods were measured in terms of how much sugar they actually were. The pictures on the internet that we see and you see often saying that 150 grams of boiled rice is how much sugar, or say 10 spoons of sugar, as Dr. Unwin, is his own work, and which is kind of redefining foods into how much sugar or how many spoons of sugar they ultimately turn into. The sugar infographics was first published in the Journal of Insulin Resistance, and since then it's been published in 18 languages, if I'm not wrong, 18 languages, and downloaded millions of times after that. That also explains why diabetics not having sugar don't really see remission. It's because of the high carb meals that they're eating. By the way, it took just one patient of Dr. Unwin to change course, to make him change course and also change the way he treated diabetes. Let's begin this very interesting session with Dr. David Unwin. Dr. Unwin, please tell us about the patient of yours who changed things for you, and a very warm welcome to you in this session.
Thank you so much. It's a great privilege to be chatting to you all today. I particularly enjoyed what we just heard from Dr. Mansoor. What a cheerful, lively young doctor. I'm really looking forward to seeing what he achieves in the future. Anyway, back to me. I'm chatting to you all from the British Lake District.
Okay.
It's very wet and rainy outside. I wish I was in the sunshine with you all.
Yeah.
Just to answer your question, for the first 25 years of my work as a doctor, I saw the human condition really as one of gradual deterioration, so that I expected my patients to deteriorate over time and for me to progressively add more medication to compensate for that deterioration. And so until the age of 55 years, until I was 55 years old, I had never once seen drug-free remission of type 2 diabetes, and nor did I expect to see it. I didn't think that was natural. And then one single patient in 2012 changed my life forever and the life of a great many of my patients. This lady had been a patient of mine for over 10 years, and I'd been treating her diabetes with the usual drug that we use here, metformin. I knew that she wasn't taking her metformin, and so I wrote to her asking her to come and see me with the anticipation that I was going to tell her off for not taking her drugs and to tell her that she was at risk. However, I was in for a great surprise because she was going to tell me off. She came in, looked so different than I'd seen her before, because she'd lost 3 stone in weight. She looked actually fabulous. And she was very cross. She said, Dr. Unwin, when you do my blood tests, you will find that my blood sugars are completely normal. And yet I haven't been taking your drugs. She said, I wonder if you're actually medically qualified, because in 10 years, you never once told me that rice was sugar, that bread was sugar and potato was sugar, all of which cause my diabetes to deteriorate. And since I've gone on a low carb diet, my blood sugars are normal. And the other point was, she said, the medication you gave me had a side effect of diarrhea, which was very embarrassing. And I was too embarrassed to tell you. So I was forced to take a drug for 10 years that caused diarrhea and didn't give me good health. And now I've gone online to discover that thousands and thousands of people are using the low carb diet, and it's working. But meanwhile, doctors like you are ridiculing the efforts of people who are getting good results. And I expect you're going to ridicule me. And that case changed my life, because I realized immediately that I'd missed something very, very important. And such a basic point about starchy carbohydrates turning into sugar. This is schoolboy biology. And I was so ashamed to admit that I had never once thought about bread being sugar. And that's how my journey began, by being curious and fascinated by this one case. And I should now update and say, since that time, I have seen drug-free remission of type 2 diabetes 133 times. This thing that I thought I would never see, I've seen it 133 times, and we're seeing it more and more often.
That's incredible. Dr. Anand, I usually see you, and I've seen you in a lot of videos making statements like, and that's very pertinent to me, and I want to know why. In one of the YouTube podcasts, if I'm not wrong, you said being a doctor is a depressing feeling. Why do you say that, and in what context? Please tell us what makes you say or give such statements, because this is very intriguing to me.
Yeah, this encapsulates I've been practicing doctor for 37 years now. When you're a young doctor, you're full of hope, and you want to make a difference in the world. That's why most of us became a doctor. And then, as I just described, for the first 25 years, my experience of being a doctor was depressing, because I saw the people around me. We have 9,500 patients in my practice, and I saw the people around me deteriorate in terms of their general health, significantly deteriorate, despite every year I was prescribing more and more drugs. And I didn't really see many people whose health improved. Now, we should say that drugs, of course, are very important for infectious disease and many things. But my general experience of medicine was a depressing one, because the health of my population, the people I care about, was deteriorating. And if you care about your patients, this is really depressing. On top of which, if my basic aim was to make a difference in my community, it felt as if I was failing, because I couldn't see any good results around me. Of course, that was until 2012, when that patient came in. And since then, I've seen astonishing improvements in so many measures of health. But that's to explain why I had previously found medicine to be depressing. And I think that experience is shared by many other doctors around the world. And certainly in the UK, we find that beyond the age of 55, most doctors are trying to retire. They're finding the experience of medicine to be so negative that they're giving up on medicine. So I am now the oldest. I'm 65. I'm the oldest practicing doctor in at least a 50 to 100 mile radius. So many doctors are despairing over the experience of medicine. And yet now I love what I do. It's fun. I go to work with a song in my heart.
Yeah, I think it's a very humbling and beautiful feeling, because your entire statement of why you found medicine to be so depressing, and now the numbers that you get out of the lab work and the positive impact that you're making, Dr. Unwin, I think that puts a song in your heart, if I'm not wrong.
It does.
Yeah.
It does.
So tell us, Dr. Unwin, I have so many things to ask you, but just briefly, why do you think, for the benefits of those who are new to low carb, how does it or why does it help people find remission, say for a diabetic or a hypertension patient, besides getting the weight issues in control?
Oh, I think it's time to talk about sugar. It's time to talk about sugar. So if we begin with type 2 diabetes, remember the hormone insulin is there to protect you and all of us from a high blood sugar. High blood sugar is damaging. In fact, we know that within 6 hours, a high blood sugar damages the sensitive lining of your arteries within 6 hours. It's called a glycocalyx. A high blood sugar also binds irreversibly to many proteins, causing damage. And for this reason, we're cleverly designed to be protected from a high blood sugar by the hormone insulin. Insulin takes sugar from the bloodstream and pushes it inside cells where it can do less damage. That's the vital work of insulin. So if you continue to eat more bread than you need to run around, or rice, or potato, or biscuits, that sugar has to go somewhere. And insulin, day after day, year after year, is pushing that excess sugar inside cells. And in many cells, the sugar becomes fat. In particular, in the liver, the sugar becomes fat, and the fat actually is called triglyceride, which itself is a very important marker of cardiovascular risk. So that if you continue to eat all these carbohydrate foods, the fat in your liver goes up and up. We now have a situation where 38% of the whole of the world have non-alcoholic fatty liver disease. 38% of everybody you know, all your friends and relatives, will have non-alcoholic fatty liver disease. The liver is full of fat. A fatty liver interferes with the good work that insulin is trying to do, and you become gradually insulin resistant. My friend, Professor Roy Taylor from Newcastle University, talks about the long silent scream from the liver. This is the 10 years during which your liver is quietly filling with fat. And at that time, your blood sugar may be normal, but actually the triglyceride levels are high and we're increasing cardiovascular risk. At the end of that time, insulin resistance comes in and you're no longer able to manage your blood sugar, which starts to go up because insulin is no longer working, and you are not anymore protected from high blood sugars. And so, if that is the case and you have type 2 diabetes, surely it's basic logic to avoid foods that put up your blood sugar, because you are immediately increasing cardiovascular risk. We know that what kills people with diabetes, the commonest thing is cardiovascular disease. But we also know that a high blood sugar is linked to cancer, directly linked to 8 different cancers. All of this explains why central obesity, having a big tummy, the other place the fat builds up. So having a big tummy is closely linked to 8 types of cancer and type 2 diabetes itself. And I've discovered that actually measuring somebody's waist can be as helpful as doing a lot of expensive drugs. But just back to the basic advice, which is surely it makes sense to eat nutrient-dense foods that do not put up your blood sugar. I believe it's probably as simple as that. And that's not a difficult message. And my patients who are 92 or 12 and everything in between can very easily understand in a 10-minute appointment, which is all I have, the dangers of putting up their blood sugar. And this, I think, is what I hope the people of India can begin to understand, the dangers of a high blood sugar and the logical approach whereby you are looking for what puts up your blood sugar.
Dr. Why do you think the dietary guidelines given by the associations are not working anymore? The guidelines are telling you, and these are the authorities that are supposed to tell you what to do. And on the other hand, you see a rise in the metabolic epidemics across the world. Why is it not working? And what is wrong with it?
What an excellent point. And it reminds me of my own position when I was 55. So I was so annoyed with people with obesity and diabetes because I gave them excellent advice and patient after patient failed. And what's interesting, at that point, I blamed my patients. How annoying they were for not taking my advice.
And that's so arrogant.
Yes, it was arrogant, wasn't it? But I had missed something, Ira. I had missed the fact that the common denominator for all these terrible results was me. It was my advice. And yet for 25 years, I didn't spot that. Very hard, I think, for the authorities to take responsibility for the disaster that we see around us. So in my own practice, as a young man, we had 57 people with type 2 diabetes in 1986. 57. And in the same population now, I have 630. This is a 10-fold increase in the prevalence of diabetes in a static population. This is a catastrophe. I am signing death certificates on a regular basis because of this. This means, this is replicated across the world. It means skin ulcers. It means amputations. It means a great deal of suffering, a huge amount of suffering. And I think we really need to be, or take some responsibility for this, because the guidelines, in my opinion, have been a disaster and that they are not working. We've put our faith too much into modern drugs. And modern drugs do help get rid of the excess sugar. So that's what you have to do. But maybe it's not as good as just not eating the sugar in the first place. If we think about the modern SGLT2 inhibitor drugs, they help you urinate out sugar. Cardiovascular risk and help with weight loss and diabetic control. But they bring with them some rather worrying side effects. And would it not be more logical just not to eat that sugar in the first place?
Correct.
And you could save a great deal of money, and you may be more effective, because the ability of your kidneys to urinate out sugar is limited to about 100 grams of glucose a day. So if you're eating more than that in terms of glucose, then you've still got a problem. I think it's very hard for healthcare professionals, me, to admit that what I have been doing is not working, and that we need to think again. And I think that's why what we actually have around the world is a grassroots revolution of inquisitive, intelligent people on social media experimenting with other approaches. And that's exactly what is happening in India now, a revolution.
Very interesting. Dr. Anvin, I want to talk about the sugar infographic towards the end, because I really want to discuss that in detail. I would ask you smaller questions first regarding the myths surrounding low carb diet or a keto diet, as many people still believe it's dangerous, or a carnivore diet, it's dangerous. I want you to briefly touch upon that. Also, is a low carb possible on a vegetarian diet in the Indian context? Because that does mean that you would not be having a lot of times even eggs. So tell us about all that.
Okay, so the first thing is, let's talk about cardiovascular risk. So of course, if you're going to, so there are 3 macronutrients. You've got carbohydrate, you've got protein, and you've got fats. So if you reduce carbohydrate, you're very likely going to increase something else. And in my early days, I was concerned about, if you increase fats, are you going to worsen cardiovascular outcomes?
Correct.
And that's why from the very beginning, I kept most careful data on the baseline and then follow-up of the fasting lipid profiles of all my patients. And we've published this in the British Medical Journal Nutrition on 2 occasions. The most recent paper was published this January. I wrote the paper with Professor Roy Taylor. And what's interesting is we demonstrated that every single measure of cardiovascular risk improved in my patients who were low carb. Every single measure. So that is cholesterol, cholesterol HDL ratio, HDL cholesterol, triglyceride, systolic and diastolic blood pressure. Everything improved. And in fact, there's an enormous meta-analysis from Liverpool University, which showed exactly the same. Many studies around the world have shown improved cardiovascular risk on a low-carb diet. Now, the second thing is, you might be going to increase your protein intake. Dr. Mansour talked about that. And there was previously the view that increasing protein would damage renal function. So again, I got together with a professor of nephrology, Professor Wong, and we looked at all the data over 10 years in my patients and published that as well. And if you Google renal function, Unwin and Wong, you will find my open access paper, which again showed astonishing improvements in renal function for my patients on a low carb diet. And it also reviewed the evidence for dietary protein and damage to renal function, most of which turned out to be dogma or poor quality studies based on animals only, not humans. So I'd say have a look at that. So I have shown in my own work that cardiovascular risk and renal function can both improve on a low carb diet, and that my patients see dramatic, statistically relevant improvements in everything I'm able to measure, work that's been replicated by many other clinicians. So I'm not concerned. I was concerned, and in the early days, I faced a great deal of prejudice, as Dr. Mansour has, where I was shouted at in public and ridiculed. The answer to that, I'd say to all the clinicians, is collect data, because data is power. And it's very difficult for people to ridicule you if you have quality data. And then if you publish it, it's a lot of bother, but it's really worth it because it makes you safer. And now we come to a number of questions, Ira. The next one, I think, was the vegetarian question. I thought Dr. Mansour answered that very well, and his knowledge of Asian diets is better than mine. I actually used the DLife India website because on it are such delicious recipes to solve this exact problem. But speaking generally, I'm emphasizing perhaps the idea of using gram flour instead of wheat flour. So gram flour has about a quarter of the sugar of wheat flour and more protein. I'm also emphasizing the use of ghee. And in fact, my wife, ghee is quite expensive, but my wife makes it every week herself. And homemade ghee is better than what we buy. I'm emphasizing the role of green leafy vegetables. I'm emphasizing that people think about protein, just as Dr. Mansour was saying. And I have plenty of patients who are vegetarian who manage this quite well. And some of them are, of course, in the UK, a great many people have come from Asia. So I do have patients from India. And what's interesting is my Indian patients suffer with diabetes at a lower weight than Caucasian patients would. And so actually increased vigilance is necessary for Asian patients, particularly if they're starting to get a big tummy. That is the first thing. And it's beginning to happen when people are younger and younger, particularly Asians. And so there we are. Those are my broad things, but I would go to DLife India and such delicious recipes there.
Thank you. Dr. Arvind, what are your views on statements or beliefs that say meat is bad and saturated fats are bad for heart conditions or even in diabetes, or eggs are bad, especially with yolk? So these are the common dietary myths. Yeah.
Well, they are, aren't they? The first thing is it's been generally and internationally accepted since I think about 2016 that dietary cholesterol has no influence on blood cholesterol. And this is why the subject of eggs has been so confusing, where I remember telling patients you could have eggs maybe 2 a week as a treat. And yet, when my patients gave up eggs and cheese and butter, and they said, right, Dr. Amin, I've given up all the foods I enjoy for you. I can't wait to hear how my blood results are. And time after time, my heart was breaking because the blood results were no better. And this is because there is no link between dietary cholesterol and serum cholesterol. This is because cholesterol is necessary for life. It forms most of your brain and also an important part of cell membranes. And so, if you don't eat enough cholesterol, your liver can manufacture cholesterol. And so this is the reason that there is no link between dietary cholesterol and serum cholesterol. And it's caused a great deal of damage and a great deal of confusion. So the subject really is homeostasis. Natural processes have checks and balances, so that if you eat too much cholesterol, your body will use it as fuel or get rid of it. If you don't eat enough cholesterol, your body will manufacture more. And again, in the early days, I knew my patients were eating more meat, more full-fat dairy, and yet all the markers of cardiovascular risk improved. And in fact, I haven't referred a single patient to a vascular surgeon in 10 years. That is astonishing. I haven't seen a single diabetic foot ulcer since we began. And I have come to think that meat, I have not seen quality evidence that meat is in any way damaging. Now, processed meat may be, particularly when it's consumed with bread and chips and other things. But red meat I have not seen. I don't think we've got time, but if any of the listeners want to go into this in more detail, the point is to do with the evidence from epidemiology. Epidemiology is most of the studies that have linked meat with poor outcomes. But epidemiology cannot ever tell us about causation, only associations. So it's a bit like rich people drive Mercedes motor cars. So there's an association between rich people and Mercedes motor cars. Rich people also live longer. But that doesn't mean that buying a Mercedes motor car means you're going to live longer. There's an association between owning a Mercedes and living longer, but no causation. And epidemiology, nutritional epidemiology, is the root of a great deal of confusion. And I have never seen an RCT which has convinced me that meat is dangerous, nor have I seen a single case of somebody who eats a lot of meat causing diabetes. So I have patients who are on the carnivore diet. They only eat meat. And without exception, their diabetic control has improved. So I personally am not convinced about the link between meat and poor health or diabetes, because I haven't seen it, and I have thousands of patients. So that's I think my answer to that.
On an LCHF diet, Dr. Anwen, we often see A1C going down. At the same time, the LDL going up. And I've had people worried about this. Could you explain the concept and how they should be people should be looking at it?
Yes, right. That's an excellent question. Let's talk about risk. So having poorly controlled diabetes shortens your life by at least a third. And you will die of cardiovascular disease or cancer. So in terms of risk, poorly controlled diabetes is huge, very, very powerful. In terms of risk, an isolated raised LDL makes very little difference. It's a small risk factor, but it's only one risk factor of many, and a weak one at that. So when we're looking at patients, we can't just look at one risk factor. We should look at blood pressure, triglyceride, HDL, LDL, smoking, weight, and most importantly of all, blood sugar. So most of my patients will improve blood pressure, triglyceride, HDL, weight, and blood sugar. And some of them might increase their LDL a little, but if it's only one risk factor in 10, and a weak risk factor at that, we have to look at the balance of all the risk factors. That's what doctors are for, is to look at the overall risk factors for the patient in front of you. And in general, what I'm seeing is a spectacular improvement in cardiovascular risk but also improvement in the risk of cancer, because we know that diabetes brings with it the risk of 8 different cancers. And so to concentrate on one small risk factor is to forget about the complexity of human beings.
Dr. Anvin, tell us about your low carb studies publication of it.
Oh, well, of course, I'm showing off now.
Yeah,
I'm
please.
showing off. So this is because, so in the early days, because of the fact that I received hate mail and because I was shouted at in public, I learned that I needed to collect data. And in fact, that people were making reasonable questions. So I collected baseline data and latest follow-up data. The results were so astonishing, I wondered if it could be true, because the results were so amazing. And I emailed 20 famous professors to say, am I a fraud? What should I do with these results? And I was very lucky. Just one professor emailed me back, and that's Professor Roy Taylor from Newcastle University, arguably one of the most famous professors in diabetes in the world. And he said, your work is valid and very important. And he got the first paper published for me, I think in about 2015. Since then, I have learned a great deal about publishing because it's important. And again, I'd say to the low carb doctors in Asia, this is so important to publish your work, audit what you do and publish, because this is how we can convince the world. My evidence for how important it is, and part of showing off, is that my latest paper, the one in BMJ Nutrition, is the most popular paper that journal has ever published.
Wow.
So that is really incredible and astonishing that the work of Mr. Nobody from Nowhere, a GP from the north of England, should be the basis of the most popular paper they have ever published. This is based on a thing called the altmetric score, which is how often the paper is read. The international low carb community is very powerful and very large. And they can drive altmetric scores because people are reading my paper. The thing is, write a paper in a way that perhaps educated but non-professional people can understand. And then the altmetrics go up. And then what will happen, I get 5 to 10 invitations per day to write more papers. So we've gone from, in the beginning, I had great difficulty getting my papers published, great difficulty. But now editors are writing to me 5 or 10 a day saying, please, can I have your next paper? And that is just shows the power of the international low carb community. The more we gather together, the more powerful we are. We've got shared goals all over the world. I have friends doing good work. And each of us is very committed and very energetic because we're doing this not to get rich, but because we can. And for that reason, we count. I think each one of us counts for about 10 ordinary people because we put so much energy into trying to improve the world. Ira, I've just remembered I didn't answer one of your questions, which I should, shouldn't I? The teaspoon of sugar equivalents never got answered.
I was coming to that.
Were you?
I wanted to spend some time on that because that's so significant. I never knew that came from you, Dr. Anvin. As any internet user, I was going to that for reference so many times. And yet when I started researching on you and, getting to know more about you, I discovered it was you who put it out there for us so simply that actually it made, at least for me, so simple to understand that this is not rice, not just rice, but this is actually sugar that's turning into my body. So, coming to the sugar infographics, How did you think about it? It is path-breaking work. It has changed the lives of so many people around. How did you come up with this idea?
Here, you're very, very kind. And how did it happen? Right. So after that lady who said to me, Dr. Unwin, you really need to understand that starchy food turns into sugar, I became interested in the glycemic index, which is the basis of the low GI diet. And I became interested from that in the glycemic load. And for a year, I tried to convince other doctors and my patients about the benefit of understanding the glycemic load. Because you see, different carbohydrates vary in how sugary they are.
Correct.
And I didn't really realize that. And this is very important information if you have type 2 diabetes, because, say, the sugar in cornflakes is much worse than the sugar in a mango, for instance. So this matters. And so I found I was explaining the glycemic load to a great many people, but in a 10-minute appointment, which is all I have, explaining the glycemic load takes time. And I realized, well, in fact, let's be honest, it was one of my patients who said, David, I know this is important, but actually it's complicated and you are confusing doctors and confusing the patients. Please stop it because you're causing confusion. Why don't you go away and come up with something that our patients can understand? And I realized that the points of confusion were two. Number one, the glycemic load gives you an idea of how much glucose there is in rice or potatoes or so on. And my patients don't cook with glucose, so I was confusing them by talking about glucose.
Correct.
Number two, in the UK, we have the imperial system of weights, so we don't weigh in grams. So to my patients, 25 grams means nothing. They have no idea what that means. And so I determined to think of, could I think of a way of explaining the relative glycemic loads of different portions of food in a way that my patients could understand. And I came up with the idea of 4-gram teaspoons of sugar. So a 4-gram teaspoon of sugar has actually a glycemic load, and you can divide that into the glycemic load of other portions of food. And from that calculation, you will get a teaspoon of sugar equivalent. And that is how I can tell you that 150 grams of boiled rice is equivalent in terms of what it will do to your blood sugar of 10 4-gram teaspoons of sugar. Or a banana is about 6 teaspoons of sugar. A small slice of bread is 3 teaspoons of sugar. I knew that people would not take me seriously with this, so I went to Dr. Jeffrey Livesey, who was one of the original experts on the glycemic load. And together we did the mathematics on 800 foods, and we published this in the Journal of Insulin Resistance. This was, I think, in about 2016. And then since then, there are now 8 different infographics translated into 18 languages, and they have been downloaded millions and millions of times. The important thing is there's no copyright on them, so I'm hoping you will all steal my work. You won't have to pay for it. You will not have to pay for it. And this is the way that any of the listeners can get it. If you Google in capitals PHC and then Unwin and sugar, PHC, Unwin and sugar, you will come to a UK charity that I helped set up where the infographics are in 18 languages and free for you all. If you require a different language and one of you is clever enough to translate, then please contact me and I would be, maybe we'll get to more than 18 languages. There you go. That's the teaspoon of sugar equivalent. Such you were so kind about it. Thank you.
It is so amazing, Dr. Anwin. It completely changed my perspective of understanding foods in terms of sugar. And amazing. I think it's helped so many millions of people already. It's amazing work. What are your views, Dr. Anwin, on when people say grains are okay for diabetics or fruits are okay for diabetics?
Ah, right. Well, of course, we come back there to the glycemic load very neatly. So if we just go back to what I said at the beginning, which was that it is a high blood sugar that does damage if you have diabetes, and therefore avoiding a high blood sugar is the logical first step. You then become interested in what foods put up your blood sugar. And this is where we come to the glycemic load. So if we're thinking of fruits, raspberries or strawberries will put up your blood sugar far less than mangoes and bananas. This is to do with photosynthesis. So the longer photosynthesis is where plants combine carbon and turn it into sugar. So that's the energy from the sun combining carbon to form sugar. So the longer that plants sit in warm sunshine to produce fruit, the sugarier that fruit becomes. And so raspberries are less sugary than a ripe mango or a banana. Unfortunately, most tropical fruit is very sugary. And so that is where, if we're thinking of fruit and veg, we shouldn't lump it all together. It varies a great deal in terms of how sugary it is. And in general, green leafy veg is so much better and puts your blood sugar up very little. And so there are infographics that look at green veg, infographics that look at different fruits to help people understand the glycemic consequences of their dietary choices.
Thank you. Before we have, I think, 10 minutes left, and I would be calling Shashi and Anup in a bit. But Dr. Anwin, tell me if this all begins with insulin resistance. And why are doctors not talking about insulin resistance at all?
Gosh, what's an interesting question. Why are doctors not talking about insulin resistance?
Absolutely.
I think this is most interesting. Most doctors think of themselves as scientists. I have begun to suspect that many of us are not scientists, that we're not really thinking about the true causes of illness. And certainly I lacked curiosity about the true cause of diabetes, because my paradigm was one of what tests would I do and what drugs would I give you. And so that for me in 2012, I had very little interest in insulin resistance. I'd never even heard of it because it didn't form part of my decision-making process. And it's only later that I've been really curious to swim upstream of the diseases of modern man that I find that insulin resistance is utterly central and key to so many illnesses. But if my paradigm was purely what drug shall I give you, then insulin resistance isn't very interesting. And I worry that many of us are not scientific enough in our thinking and not curious enough about where is this epidemic coming from? It cannot be genetic, can it? If I've got a 9 or 10-fold increase in diabetes in my own practice, this cannot be a genetic change. It's something environmental. And that same environmental thing I see in every continent of the world that I travel to. I see this epidemic. And it's environmental, and I believe it's what we're eating. And I think an understanding of insulin resistance is key to helping humanity with this pandemic. of diabetes and all of the other things that insulin resistance leads to.
I think you just mentioned a while back about translating the sugar infographics into any of the languages if anybody wanted to do that.
Yes.
So I think we would want to do that in Hindi as well, and as many languages, Indian languages as possible at D-Life. And I'm sure Shashi and Anup would agree to that. I would take them
Great.
on the screen right now. Can we have Shashi and Anup on the screen, please? Yes, there they are.
So,
good morning, Dr. Anvin. Good morning.
Yeah, Anup, you can speak.
Yeah, good morning, Dr. Anvin. You know, it takes great, I think it was 5 years back, you were the first person to, write a review about the platform. And you still remember how delicious the recipes are. And you were very kind enough to mention that in a live conference. Now, as Ira said, we would love to translate that infographic into as many languages as possible relevant to India. And since last 5 years, since you reviewed the platform, we've come a long way. Now we are offering, certification courses. So whenever you have time, you can always go through it and see wherever we are lacking, we would be, very willing to take the suggestions and improve on it.
Well, thank you. Thank you so much for that. Yes, I do remember 5 years ago. And what happened was I went on the website because people approach me on a daily basis with ideas. What impressed me was the actual quality of the recipes and that they were really tasty, which at the end of the day, I don't want people to suffer. I want them to enjoy nutrient-dense food that doesn't put up your blood sugar. And you have addressed exactly that. On the teaspoon of sugar equivalent thing, what I would say is have a look. So Google PHC, unwin and sugar. Have a look at the languages that are there. And from your point of view, from the point of view of India, have a look at which languages would be useful to your clients. And I'm sure you have the expertise to translate them. So I would be delighted to cooperate with that. It's not a problem at all.
Yes, sure, we'll do that.
Great.
We'll take a lead in this and we'll get it converted into a few popular languages or as many possible. And Dr. Anvin, I wanted to really thank you from the bottom of my heart for accepting to come for this event. I still recall 3 years back when we had a podcast with you. I recall telling you that one day we are going to do this first ever event of India. And then that time you told that you are very keen and please tell me as soon as you arrange this program. And let me tell you, the moment I sent a mail, you were the first doctor to immediately respond. Not only did you say yes, but you fixed up the timing also.
Yeah, you're so welcome. Could you tell me what is the thing that you are most proud of in your organization? I'm interested to know. What do you think is the best marker of your progress in Asia?
Shashi, I think you can take this up.
No, what exactly? I couldn't understand.
I'm interested to know what achievement from your point of view for D-Life India, what is your best achievement that you are most proud of?
I think it is the launching of the diploma in low carb nutrition course, because earlier we were just a community helping, but now Anup is churning out an army of low carb nutrition coaches, and this is going to help. And that's what Anup told you. He will give you a unique ID. Please log in. Please review the course also. I think you will be delighted. I can assure you that you will be as delighted as you had been seeing those low carb dishes also. You will be delighted with the course. I can 100% guarantee you.
And just to add to that,
please.
Dr. Anvin, yes, thank you. Just to add to that, I think Anup could tell you a bit about how it is the only award-winning low carb platform in India at the moment.
Oh, yes.
We are the biggest and the largest and the fastest growing, with so many countries now, willing to come over and get the diploma admissions. So I think that, and of course, your reviews and your validation define our credibility.
Yeah, I mean, we were featured in many, I would say, media houses, but the most prestigious one was the Outlook Group, where, they awarded Icons of India Award. So that's a big thing, big achievement. And once we started, started the diploma course, and we see the enrollments going up. Now it's, I think, 6 countries. The enrollments are from 6 countries, though we were targeting only India. So with a battery of army of low carb professionals, it might sound a small number, but yes, we can easily boast of 3,000 plus combined cases of success stories. And if you talk of extreme cases, we have seen A1C coming down from 15.7 to 5.7. So that's the extreme. Plus fatty liver grade 1.5, I think it's gone. Multiple cases of fatty liver, and not to forget your host, Ira Sahai. She has reversed membranous nephropathy on a carnivore diet. Doctors had given up hope, but she's still here hosting you.
The thing is, it works. And this is why this approach is growing inexorably and internationally. Because if you see something that works and changes your life, it doesn't matter what other people tell you, you know it works. You've seen it work, and you can't unsee it. And I think that underpins our steady growth, because as an approach, it works like nothing else. And then your relatives look at you and they do the same, and then your friends do, and thus it spreads. And so we have a situation now in my own practice where if you will go low carb for me in Southport, you have a 50% chance of achieving drug-free remission. 50% chance of drug-free remission. And we now have, if you took the entire practice, 20% of the entire diabetic NHS register are now in remission of their diabetes. And we're saving about £70,000 sterling per year on the diabetes drug budget. So it works. And gradually, in this way, in the UK, I'm convincing hundreds of other doctors to do the same. And then we're replicating, and this is a form of evidence where real world evidence where it gets replicated and then it works. And I'm sure that is what is happening for D-Life India, that it works. And then, your relatives look at you and think, well, you look maybe I should do the same. The struggle is always to overcome that first idea that I couldn't live without rice or I couldn't live without bread. But my other interest is in the psychology of this. And when we give hope, that makes a difference. And if you give people hope of living longer and enjoying life, then they can give up rice. That's the important thing.
Thank you. Thank you, Dr. Anvin. I think, again, I wanted to thank you for really coming in this session and sharing your knowledge. You are the master of diabetes remission, and you have so much work ahead of you still, I think. And we look forward for your further contributions to not only UK, but globally, because you're a global hero when it comes to diabetes remission. Thank you.
Just one line from me to Dr. Anvin. I think he's been very humble. Very humble. We should all learn from him. He came to my Twitter timeline. He himself replied to him. I think that's very rare. And that's such an encouragement for a new metabolic health coach like me. I mean, we look up to you, to your humility. And I would still call you a Doyen. You are a Doyen. You will be a Doyen.
Bless you. So my final word is just, I'm hoping that one of you will beat me. So I have 133 cases of remission. Internationally, somebody go out there and beat me, because that would give me great joy. Great joy.
Yes.
Thank you. There's the race. Thank you so much. That was a great pleasure. a lot of work for us to do. There are enough. My final point is about there are enough patients to go round. We don't need to fight about any of this. It doesn't need, there are so many people suffering. There are enough patients to go round, and we should try and cooperate really around the world. I'm going to go now because I think the next speaker is waiting and it's rude to take up more time. Goodbye, and thank you all so much.
Thank you.
Thank you so much. Good afternoon and welcome to another great session of India's first Metabolic Health Conference, Low Carb Across the Globe, from the lovely city of Goa, India. We have today with us Dr. Kishle. He's a doctor from Patna, India, a hypercarnivore metabolic Dr. K, as he likes to call himself. He's a big proponent of carbohydrate as an addictive substance that is causing more problems than any other addictions in today's times. Let's talk to him about his work in what he calls hypercarnivorous protocol for metabolic diseases remission. Give us a brief background of yourself, Dr. Kishle. Before that, I'm Ira Sahai. I'm a metabolic health coach based out of Mumbai. I'll be hosting you along with my colleague, Devana.
Thank you. Thank you, Ira. Thank you a lot. And thanks for introduction. And thanks to all members of D-Life team who have made this possible. It wouldn't have been possible without you guys. And you guys are doing just amazing. So I would like to give a special thanks to Shashi sir, who has given me the opportunity to speak in the first virtual Low Carb International Conference 2023. So I am really appreciative of what you guys are doing. You guys have united all the low carb medical doctors together and making this low carb movement even more stronger. And you all have taken this movement to a next level only. So let me just take you through my background, academic background first. So I did my MBBS and then prepared for PG entrance. And I got qualified. I got seat in DNB General Medicine. I worked there for 3 years as a DNB trainee in general medicine. So as I started understanding nutrition science and medical nutrition therapy, I kept on losing interest in prescribing pills to any of my patients. So we have this perception that nutrition can only be served as preventative medicine and not curative medicine. So that's why we have this. So that means when you develop any chronic lifestyle disease, now you can't do much with nutrition. So that's why there is not much emphasis given to the impact of food on our health outcome. But millions and millions of anecdotes absolutely and unequivocally establish that food and nutrition is both preventative and curative. And that's why I stand with this truth. And now I am completely into this lifestyle medicine, where I am doing mostly online medical consultation, helping patients with chronic metabolic disease of all kinds, like be it your neurological, cardiovascular, gastrointestinal, even CKD patients, skin-related issues, and other autoimmune diseases with this hypercarnivore dietary protocol, and getting them off piles and piles of prescription medication. So basically, I am using this social media platform to educate unsuspecting general public and mistrained, miseducated doctors and dietitians through my own YouTube channel, Instagram, Reels, Facebook, LinkedIn, and X, formerly known as Twitter. So now coming to my hypercarnivore protocol. So basically first, let's know about what hypercarnivore is. So hypercarnivore is a term used to describe diet that consists of more than 70% meat and remaining 30% non-meat items like eggs, dairy, fruits, vegetables, seeds, or any other plant-based materials. So, but my hypercarnivore protocol doesn't include any cereals and grains, as they are full of anti-nutrients, lectins, oxalates, and other plant-based gut-destroying toxins. So my protocol at large mainly consists of meat and eggs up to around 95%, and remaining 5% I allow most people to have fruits and vegetables occasionally. And even my diet looks pretty much same, like 90 to 95% revolves around 92 means eggs and meat only. So I do enjoy sometimes fruits and vegetables, but not much. So this is the story of mine in short.
Thanks, Kishlay. Is there anything in particular that prompted you to come into low carb? Any incident or something? Tell us about it.
Yeah, actually, my journey into this low carb space started since December 2015. In December 2015, after I completed my MBBS degree with internship and then came back to my hometown. So then I first noticed significant impact of dietary carbs on my dad's blood sugar level, because back then my dad was diabetic. So it's been 13 years now, but he's no more a diabetic. So as he was already a diabetic in 2010, and back then in 2015, somehow I realized that my physique is not up to the mark. Despite doing hours and hours of doing heavy weightlifting on the gym floor almost daily, I gained significant body fat mass over my 5 years of my MBBS career. So I kind of realized that something must be going wrong with my diet part only. I was striving for an aesthetic physique at that point of time. And it was 2016 when I took out my first year MBBS textbook of physiology Guyton. And I started reading and understanding about fat gain, fat loss under the section of carbohydrate and fat metabolism. And there it was clearly mentioned about the role of insulin in fat storage and how it inhibits fat loss and all that stuff. So since then, I started cutting back on carbs from my diet, and eventually I ended up in this keto thing after 1 year of commencing this low carb journey. So I lost 10 to 12 kgs over 12 months period. And although I didn't have any medical issue as such, but still I wanted to improve my own health actually in general, because apart from obesity, being overweight, I didn't have any other issue. So I continued exploring this keto science and discovered various low carb keto carnivore stalwarts like Dr. Sean Baker, Dr. Ken Berry, Professor Tim Noakes, Dr. Paul Mason, and Professor Ben Bickman, and even Professor Bart K, and so many are there. So this is the thing actually.
Would you want to take the next question?
Yeah, so I just want to ask, like, being a doctor, what do you do differently from other doctors in the field, especially when it comes to metabolic illnesses like diabetes?
Yeah, we medical doctors are actually taught to intervene medical conditions either by prescribing pills or doing surgeries. What we haven't been taught about is how to de-prescribe or lower the burden of medications with which patients have been chronically poisoned over the years. So this is happening because we doctors get no training in nutrition. And training in nutrition, I mean to say, is training that teaches you about low carb keto carnivore diet, not what regular or conventional dietitians get to know about in their indoctrination courses. So any nutritional training that fails to emphasize the importance of animal-based foods and huge on promoting complex carbs, so-called complex carbs that don't even exist, and fibers and other plant-based vegan ideologies is nothing but a fraudulent academic practice. And by practicing this low-carb keto carnivore dietary approach, I happen to be a metabolic doctor in this pharma-driven healthcare system. And this is the only difference that has made me different from most of the doctors, if not every doctor. And this one difference has made you guys believe that I should speak on low carb science fearlessly using this global platform. And moreover, this difference has made me lose most of my doctor friends, but at the same time, gain the trust of many honest healthcare providers like you guys who are actually ready to take a strong stance against academically bastardized science and propaganda. And the difference is not just with regards to diabetes or obesity management, but every chronic disease that has been labeled as chronic, progressive, irreversible, and incurable. So basically, I am using this nutrition as a medical therapy and using this keto carnivore diet actually that helps people getting off medication. Nothing else I am doing.
So, as a doctor, you've been told that diabetes is a chronic disease, it is a progressive disease, and it gets worse with time. So, and that you should be avoiding calories, red meat, fat, and all of that, eggs, which you don't agree with, which you don't seem to agree with. Can you tell us about this a bit, and can you reverse diabetes by ignoring the dietary guidelines given by the famous Diabetes Association and the various associations around the globe? Pretty
Sure.
much similar. Yeah.
Sure. Ira, first of all, we don't eat calories, we eat food. So the energy we are getting from food are actually should not be expressed in the form of calories, because calories should be used only in terms of heat energy, nothing else.
Yes.
But we so commonly oftenly use this energy as calories. This is not the appropriate way to express our energy which we are getting from our food. So we are taking just food, we are not eating or having calories from food. So this is the one more myth actually, so which people don't know much about. So let's understand diabetes first. So diabetes is basically a state of elevated blood sugar, which we see in 4 different scenarios, like in fasted state, 2 hours postprandial state, random, and by estimating HbA1c values. And if your fasting blood sugar goes above 125 milligram per deciliter, postprandial above 200 milligram per deciliter, random blood sugar above 200, if associated with symptoms of hyperglycemia like polyuria, polyphagia, polydipsia, and HbA1c of more than equal to 6.5%. So if you satisfy any of these criteria, you are diagnosed as diabetic. And this is what we have been taught. So, but there is much more to this. And it's not just about these criteria, rather it's about the individual's glycemic response to carbs intake. So let me explain you with an example. If an apple of same size, I mean same amount, is given to 2 different individuals at the same or different times, they will have different glycemic response to that same apple of same size. And if that same apple is given to one individual at 2 separate occasions, even then the glycemic response will vary. It will be different. So what I'm trying to say is there is an intra and inter-individual variation to the carbs containing food. It doesn't matter whether that food is of high glycemic or low glycemic value. So this glycemic index scale values are not constant or fixed for any particular amount, for any particular food item. So it's actually variable for same person at 2 different occasions and different persons also at same or different occasions, with the amount of food or content of carbs being constant. So glycemic index is totally inappropriate, unscientific tool to look for while managing someone's blood sugar effectively. So thus we can say that there is no such thing as low glycemic, high glycemic foods, no good carbs or bad carbs, and no simple or complex carbs. All carbs that get converted into glucose are basically the same metabolically. So now we can define diabetes in a much better way. Diabetes is not just about elevated blood sugar in fasted PP at 2 hours or random, but it is also elevation of blood sugar beyond normal physiological range after carbs ingestion, with multiple spikes over the course of the day, as people do not really have one meal a day practicing this balanced diet. So it's not practically feasible also, as they cannot make their nutrition complete if they take carbs, fats, protein, fiber all together. So, and one more interesting thing about diabetes is you can suffer diabetic complications without actually being diabetic criteria wise, because you do get constant spikes of blood sugar level on this particular high carbohydrate diet. And I have seen patients coming to ICU with heart attacks, having HbA1c within normal physiological range, within normal limits, below 5.7 or below 5.5 even. And many people do have autonomic neuropathy, where they do have gastrointestinal symptoms like GERD, constipation, diarrhea. And constipation and diarrhea are basically due to gastroparesis. That is nothing but microvascular complication of diabetes. Tingling, numbness in hands and feet. These are microvascular complications, and this is due to peripheral neuropathy, and they have normal HbA1c. But still, doctors don't realize actually that these are the microvascular complications of diabetes, even though they are normal lab-wise.
So before Dev asks the next question, let me reiterate, are you saying that the guidelines of the Diabetes Association and many such associations are not working anymore?
Absolutely. That is rubbish nonsense.
Okay. Dev, please go ahead.
So, how much carb restriction do you recommend for your patients? You already mentioned that you for 95% on animal-based food, but how much carb, if you were to quantify it, how many grams, that sort of stuff?
Yeah, actually, I don't have any magic number for carbs, Dave, to be frankly speaking, because as I follow hypercarnivore protocol, so I don't necessarily restrict carbs directly for any of my patients. Rather, I ask them to reduce plant-based food items from their diet, so including some fruits, most of the fruits, and some vegetables, and incorporate more and more of animal-based food items such as eggs, meat, and even dairy to some extent. And in doing so, it turns out to be ultra low carbohydrate diet plan. So I don't believe in any magic number of carbs that you can have or you can get in your diet without getting serious ill effects of it. So carbs in any amount above 0 is too much for our body to deal with it. Or another way of saying, if you are having carbs on carnivore diet, because you are getting some amount of carbs even on carnivore diet, because even eggs and meat have some amount of carbohydrate. So the amount of carbohydrate you are getting from eggs and meat is the exact amount you need for your body for optimal health. So this is what I have to say about this amount of carbs. But in general, I would say above 50 gram is too much. Below 50 gram is fine.
So given you are a hyper carnivore, Dr. Kishle, what happens to people who come to you and want to go vegetarian or stick to a vegetarian diet?
Yeah, basically, people need to realize that chronic lifestyle disease is not just a state of chronic inflammation, but it is also coupled with inadequate nourishment. And inadequate nourishment means sometimes it's malnutrition. We can say it malnutrition also, because on plant-based diet, plant predominant diet, you don't really access to nutrients contained in plant-based food items. They are less bioavailable. Plus, being in an inflamed state, your body doesn't extract nutrients from those plant-based foods, although they are less bioavailable also. And so many various biological process and enzymes activation that gets affected, severely affected, because you need some minerals which act as a cofactor for various enzymes that is happening in our body for biochemical processes. So these ways actually you are going to make your conditions even worse. So this is the thing. The patient must realize that they have to incorporate, they have to have animal-based foods in order to reverse their medical condition. If not, they are ready, if they are not ready to make it for their lifetime actually. So at least for reversal of disease, you need to take it for 3 months or 6 months period, whatever it is. So when you start carnivore or hypercarnivore style of eating, you are not just nourishing your body with nutrient dense food, but also alleviating the chronic inflammation issue that underpins almost every modern lifestyle disease. So no way actually you can replicate the same results as carnivore doing vegetarianism or veganism.
I think Dave can take the next question.
So the first question all of us hear when we mention about a low carb or a high protein is the cholesterol, and another one is about your kidneys. So as a carnivore, when you talk about the carnivore diet, especially, it might be a bigger issue. So how do you tackle, do you think these are concerns, the cholesterol and the kidneys? And have you dealt with any, in your practice, have you dealt with anyone with kidney issues using your diet?
Sure. Yeah, actually, chronic kidney disease is a state wherein patients do have reduced glomerular filtration rate. And that actually gives rise to elevated serum creatinine and urea. So this chronic kidney disease is almost invariably associated with hyperinsulinemia, insulin resistance, and blood sugar dysregulation. And all these things are in the setting of chronic systemic inflammation. So when you remove carbs from your diet, you are not just lowering your insulin level, but also you are avoiding mixing of carbs and fats together. That is the most dangerous combination to have in your diet. And because mixing of both carbs and fats by taking standard balanced diet is what lead people up to the state of chronic inflammation. And this actually inflammation is well explained by Randall cycle. This Randall cycle is also known as glucose fatty acid cycle, where glucose and fatty acids actually compete with each other to be getting inside the cell in order to get oxidized for energy. So this way, basically, if you are taking this way, actually you are elevating the situation of hyperinsulinemia by avoiding carbs in your diet. And this way you are allowing kidneys to filter more, thereby GFR increases, glomerular filtration rate, and serum creatinine urea levels go down in a matter of weeks, I would say. Because I have experienced this with two of my patients who had this CKD problem. One of them is 48 years old male diabetic kidney disease patient who has reversed his kidney disease within 45 days, and serum creatinine came down from 1.5 milligram to 1 milligram per deciliter. And this patient is from the same city, Jamshedpur, same hospital where I did my DNB general medicine course, but my professors are not aware of it, unfortunately.
Amazing.
So,
yeah.
Other one is 45 something years female post renal transplant CKD patient who also experienced the same benefit. Her serum creatinine returned to normal range within 2 months. Earlier it was 1.8, now it's 1 milligram per deciliter, and it's been 3 years now. She still has 1 milligram per deciliter, and till now she has gotten both her steroid and immunosuppressant tacrolimus dose reduced by more than 2/3 under my supervision, and doing absolutely fine with no problem whatsoever. So most important thing is one of the most important thing to note here is she never ever consulted her nephrologist after I came into this picture. But she continues to get her RFT done every 3 to 6 months. And this is the story of my own batchmate, Dr. Jaya Sharma's elder sister. Dr. Jaya Sharma is a gynecologist, and she is also a medical doctor and my colleague. So this is not something I'm telling fairy tale story. So this is the real story actually.
What about cholesterol?
Yeah.
Like that's another concern with this diet, right? Like when we mention about the meat-based diet, one of the first things that pops up is cholesterol. So what is your view on that? Is that a concern at all?
Exactly. The cholesterol thing is one of the most common dogma or hypothesis, I would say, that is going to last longer than any other nutritional dogma. So it's not gonna end anytime soon, but it will take multiple decades actually to get over this cholesterol mythology or ideology, whatever. So that is almost the same duration this idea has been around for. So I think it's been around for last 5 to 6 decades something. So now,
Please.
Now let's understand the fundamentals of cholesterol first. Cholesterol level in your blood or body is tightly controlled by the genes that encode proteins, that is lipoproteins, which we call, and that carry cholesterol throughout our body. So all doctors must have come across the gene allele ApoE2, ApoE3, ApoE4. So let's say if you have ApoE4, that means by genetic design, your body prefers to run predominantly on fat as a source of energy. And if you are mixing carbs and fats together, if you are having ApoE4 gene and you are taking carbohydrate in the copious amount, you create a metabolic mess by mixing carbs and fats together. Because ApoE4 gene dictates your liver to export more VLDL, lipoprotein, than someone having ApoE2 or ApoE3. So ApoE4 will give you slightly higher VLDL in your lipid panel and even serum triglycerides also. So that way you create a milieu where glucose and free fatty acids compete with each other at cellular and mitochondrial level for getting oxidized for energy. So this close competition 24/7 over the years lead you to the situation of chronic inflammation. And as I said earlier, it is well explained by Randall cycle, that is glucose fatty acid cycle. And what we have been taught is ApoE4 is a risk factor for Alzheimer's disease. But that is not so, because if a person having ApoE4 gene takes low carbohydrate enough that doesn't create chronic inflammation, so he will never ever develop Alzheimer's disease. So basically ApoE4 is not a risk factor for Alzheimer's, rather it's an associational factor. We medical doctors have been taught every associational factors as risk factors. So basically what I am trying to say is doctors have very poor basics, fundamentals of everything related to health and fitness. So higher the number you have attached with ApoE, higher your serum total cholesterol and other lipoproteins number would be, like VLDL, LDL, regardless of what your diet is, be it high carb, be it your high carb diet or high fat diet. What I mean by this higher level here is the values above standard normal reference range. That is how we consider any parameters to be high. But people don't realize that normal reference range value of cholesterol is that value range where 95% of average standard population values fall, who are on a standard balanced diet taking 60 to 70% carbs in their diet, not because 95% of the individuals are not taking 70% fat in their diet. So whatever reference range we have, it doesn't really give you the picture of what should be the optimal value of blood cholesterol for someone to be having for optimal metabolic health. So my understanding about cholesterol is very simple. The cholesterol number that you have is exactly what your body needs at that time, need not be intervened anytime by any drugs such as statins, PCSK9 inhibitors, or any other cholesterol lowering drugs. This is my opinion. This is not any medical advice. So let's say you have total cholesterol of 400 and LDL of 300 on high fat carnivore diet. That doesn't mean you have high cholesterol. In fact, you have normal or optimal blood cholesterol against the kind of diet you are already on. So definitely you might consider it elevated blood cholesterol if you compare it with normal reference range or to anyone having values within normal reference range following high carb diet. But the elevated cholesterol or LDL-C is not problematic to us in any way. That's why I always say the term hypercholesterolemia doesn't exist unless it's genetic disorder like familial hypercholesterolemia. So basically no one has high cholesterol. Either you have normal, or I would say optimal for you, the kind of diet you are on, or either low. So there is no such thing as high cholesterol. So we medical doctors have been taught every associational factor as a risk factor, that which I already mentioned earlier. So this is a thing, and many risk factor is a thing that has causal role in something. But as of now, we don't have any evidence that establishes that cholesterol has causal link with heart disease or any other chronic lifestyle disease.
And yet, as on carnivore, even as A1C starts coming down, I think people are more bothered about the LDL going up. One of the, this is a very common perception. Even doctors would tell you that, A1C to theek hai, but your cholesterol is high.
Yeah, actually, the thing is the target value for diabetics to have what we have according to guidelines by ADA. It's okay to be having 7 to 8 HbA1c in percentage, 7 to 8% HbA1c, but it's not okay to have LDL-C of above 100. This is so bizarre actually. So they are more focused on cholesterol rather than they should
lowering of the A1C.
Yeah, lowering of the blood glucose level. So having blood glucose over 24 hours around 180 is fine for them. So this is the scenario. So, and I want to say one more thing about this cholesterol lowering agent, especially statins, that statins do not really provide any benefit at all, in my humble opinion. So if anything, it destroys your metabolism at multiple levels. So whatever benefits some literatures purport to be getting from statins use actually are coming out of its anti-inflammatory effect, not because it lowers cholesterol synthesis by inhibiting HMG-CoA reductase enzyme. And lowering LDL-C levels statins actually inhibit this, means the benefits of statins, the anti-inflammatory action of statins is coming out of its action on toll-like receptor 4 signaling pathway. So basically it inhibits toll-like receptor 4 signaling pathway that actually mediates inflammation against various foreign bodies like virus, pathogens, other bacteria, viruses, and protozoans and other things. So this is the benefit, actually the minuscule benefit we get from statins use come out of its anti-inflammatory effect, and all the deadly metabolic side effects such as diabetes, dementia, myopathy, erectile dysfunction, tiredness, fatigue. And actually we do get these metabolic side effects by its very action of HMG-CoA reductase enzyme inhibition. So it's patients who have to make decision for themselves after analyzing risk benefit ratio of a statins use, whether they should take a statins or not, because my family members do always have cholesterol above normal reference range, including my parents. Mine though don't talk about my number, because my number was, I checked last in June, actually this June, it was total cholesterol was around 400 and LDL was 327. So which is totally fine to me. I don't fear cholesterol actually.
So basically, current paradigm of treating heart disease, diabetes is not being taken into account at all.
Yeah, exactly. So cholesterol has been the main focus for decades because we have beautiful medicine, dangerously beautiful.
Yeah.
Medicine statin we have. So that's why they are pushing this statins use.
I think Dave can take the next question.
What is the difference between a carnivore diet and a keto diet and a low carb diet? Like they are used interchangeably for the general population, but can you explain the differences between each of them?
Exactly. So basically there hasn't been any official definition of low carb diet as such, but everyone defines it as per their convenience, ideology, or opinion. So some say your carbs intake should be less than 30% of your total calorie intake. Some say less than 20%, some say less than 10%. Sorry. If you are doing diet having around 20 to 30% carbs of your daily caloric need, then it is not low carb diet per se, but low carb score diet. Because as it is vastly low in carbs compared to what we have in our standard balanced diet, that is up to 60 to 70%. That way it's low carb, that is in a relative manner, but in an absolute manner, it's not low carb. So that's not how we should define low carb. To my mind, carb intake should always be below 10% of your total calorie intake. Let's say if someone is getting 2000 kilocalories, so-called kilocalorie from diet, then 10% of 2000 kilocalorie would be 200 kilocalorie. And that will turn out to be 50 grams of carbs for 2000 kilocalorie diet. So 50 gram or below 50 gram is the amount that defines low carb for someone to be getting 2000 kilocalorie from food. So this is the actually way to define low carb. So if you are taking 3000 kilocalorie, your carbs, the threshold for your carbs intake, that bar will go upward. And coming to keto diet, the low carb diet is that low carb diet. Keto diet is that low carb diet that enables our body to produce ketones from fats into the bloodstream in a detectable amount during the period of not eating. So low carb diet in general doesn't necessarily put the body into the state of fat utilization where it produces ketones in a detectable manner. What we call it as ketosis, state of ketosis. So every keto diet is low carb diet, but all low carb diets are not keto diet. So this is the thing. So most of the people who are not metabolically sick or chronically inflamed can produce ketones on 50 grams of total carbs in their diet. Most of the people who are not metabolically sick can produce actually ketones on 50 grams of carbs. But whoever is chronically inflamed or insulin resistant don't even produce ketones even below 25 grams of total carbs in their diet, especially if they are not following carnivore style of diet. So plant-based diet, basically if you are even getting below 25 grams, you are not able to produce ketones or generate ketones on that amount of 25 grams of carbs.
So Kishle, Dr. Kishle, I think you are quite a regular gym goer, a great body. Also, I think I've seen a lot of your videos on social media as well, and you inspire a lot of people. But I see this general view about, you know, you cannot build muscles on keto, you cannot build muscles on this or that, and carbs is necessary for gym goers. So, what do you want to say to them?
I don't think so, because I have been able to maintain my body for last 8 years on keto carnivore kind of diet. So since last 3 years, I am doing this carnivore kind of diet. But before that, I was doing simple keto, means egg-based keto, I would say. So this is not actually true, because undoubtedly you can build muscles on keto diet. And idea of that losing muscle mass, you will lose your muscle mass, you will melt away on keto diet is completely false, because anyone can look at me and they can figure it out whether keto diet will melt you away or not. So I must say that on keto carnivore diet, you build your muscle even better than high carb diet in terms of lean muscle mass. Because the biggest advantage you have on keto diet while building muscle is that you don't even need to do dirty bulking and cutting phase and building phase, whatever professional bodybuilders do need to do actually during their prep phase. So you can build your muscle almost entirely on protein and fat diet without destroying your body composition during your prep phase, because they look like balloon during their prep phase. Just see them, just look at them during their prep phase. How do they look? So there is no need of adding any carbs in any amount to get insulin response in order to leverage the muscle protein synthesis.
I think Dev can take the next question.
Yeah. Why are high carb meals like the biscuits and poha and rice and all that? Like that's what is commonly recommended, even in hospitals in our country. So, what do you think is the negative side of such recommendations?
So,
And
and so, I would just add to that, Dr. Kishle, and we are talking about hospitals here, where diabetics get served 2 or 3 Marie biscuits, bread, and some juice, maybe sugar-free, or even diabetics generally would have what is that, diet Coke or diet soda or something, that sugar-free thing. So this entire myth and lie about carbs being okay for diabetics and stuff like that. Tell us a bit about why such food is being served in the hospital. Who's doing this?
So first of all, I would like to ask you guys, what do you expect them to give? Red meat, eggs, fish, what? The problem with people is that we are waiting for governments to change and doctors to change. And why do we expect them to change in the first place? They are not going to change. They are driven by profit, and they are highly influenced by lobbyists.
Yeah.
So we as individuals should take more responsibility for our own behavior, food choice that influence our health, rather than blaming doctors, dietitians who are indoctrinated puppets of criminal organizations like AHA, WHO and all. So carbs are very cheap, as we all know, and one of the macros which are ubiquitous and easily accessible to everyone. So hospital systems are meant to provide you medical care during the course of your illness. They are not there to improve someone's metabolic health in the general ward or ICU ward. So why wouldn't they give the things that enable patients to sustain poor health and landed them up like that actually? So the thing is, why would they do anything that shortens hospital stay? Business model doesn't work like that. So people don't come to see me, and this is the thing. So, and that's why most of the patients who come to see me, they are not like they trust me so much. I don't think so.
I was going to ask you the same question. I mean, you talked about a business model.
Yeah.
What business model are you talking about? If you keep yourself as an exception, my next question would have been to you, what is the acceptance level of people for you? Because you are giving advice that goes contrary to the conventional medical protocol. So tell us about this. I mean, why would people trust you? Do they mistrust you? What is the general opinion, and what is the business model that you're talking about? Do you have any such model?
Yeah, actually, the thing is, I'm not in a position where I can give some kind of trust to people because I don't have that much of qualification also. I don't have that much of degrees and all. So most of the time, people who come to see me, they're not coming out of trust in what I have to provide. So rather, it's the conventional medical system and doctors who failed them successfully and fantastically.
Yeah.
And now I am like last resort for them. So the thing is, whether you trust me or not, this is what you have to do in restoring your health back. And there is no other way around. So just look at me. Just look at me and look at yourself in the mirror. You will come to know why this doctor looks like this. So this is the thing.
So what is your what is the general love that you get from your own colleagues or your contemporaries, doctors? How do they look upon you?
Most of the doctors, actually, I don't make very good circle. Actually, I'm not that much of social guy also. So I don't have a lot of friends. So, but whatever I used to have, they are not my friends now, because the kind of post and kind of my behavior is my intimidating behavior, or whatever you may call it. The thing is, they are not my friends. I don't consider them at all, basically. And I don't want to actually make them like, you should be my friend forever, or so. I don't believe in all those things. I am here to serve people who are suffering from chronic metabolic disease. So I'm basically a servant, and you can use me for that. I'm doing my best to improve public health, because right now public health is in the toilet, I would say.
That's an amazing statement. I think you're making a difference out there. If I can just take the next question there. Why are you against the conventional protocol of doctors? And I think we still have about 17 minutes into the session. I would get Sashi in the last 5 minutes, maybe.
Sure.
But the last question from my side, and then probably Dave can ask. Why are you against the conventional protocol of doctors? And you didn't answer what business model we are talking about here.
So basically, these are not the protocols of doctors. So formulation of guidelines, protocols are established by so-called means fraudulent scientific committee that is actually sponsored by a big pharma agents, big pharma giants. So we are somehow beholden to this idea or thought that whatever these organizations have to say about anything is correct. So we have been indoctrinated like this only. So we are not someone who should question their opinions. We need to be sincere and obedient towards their protocols. Otherwise, you would be sacked for not doing so. So these guidelines kind of mandate us to do crime in a legal manner. So tell me, why shouldn't I stand against such protocols if unpracticing or ignoring them helped me, made me better in every aspect of health, helped my friends, my family, relatives, and all of them are getting off multiple pills and ultimately restoring their health. So that is why actually I am against this, and I'm continuously beating drum against all this nonsense. So it's my responsibility and duty as a doctor to influence more people to have good optimal health just with lifestyle intervention. And 90% diet, I would say, means I don't give much credit to exercise part in restoring health. Exercise part is basically to build your muscle. So diet is your foundation. So we need to fix this. And this corrupt system has brought us into the idea that diet, nutrition has nothing to do with your disease outcome. So these diseases are driven by your genetics. So only thing you can do for yourself is take pills, taking pills for lifetime. So that is how actually business model work, because agricultural industry, pharma industry are sponsoring those studies to happen. So that is all business model. And that's why they are promoting this low, cheap and low quality foods with low nutrient density.
And Dave, you can take the question.
As a doctor, do you risk anything? Like when you ask your patients to go on a low carb, high protein diet, how much of a risk are you taking, considering it's against what is there out in the conventional stuff? So how much of a risk are you taking?
Dave, I don't think there is any risk, but if there is any risk to anyone, then it's gonna be us who are advocating low carb diet and not patients. So it's a medical doctor working in this low carb space, risking his or her career as an academic person in any institution. So at the moment, you cannot use this as a treatment protocol, being a part of any academic institution. So with millions of success stories on low carb carnivore diet as anecdotes, actually has made one thing very clear, that it always works almost entirely for every chronic disease. And doctors who know about this are able to be getting their patients better with regards to disease outcome and health in general. So definitely it's not the patient who is risking anything, especially if they get started on this low carb nutrition plan under good medical supervision. So there is nothing going to be wrong with anyone's long-term health using this dietary approach, because this is our and most evolutionary consistent dietary style. So yeah.
Do you risk anything as a doctor? Like you said, mentioned you've lost a lot of friends and
yeah, exactly, because I can't, with this kind of attitude and behavior, I cannot work in any institution. So I'm not interested also. So this is the fortunate thing. And if anything, basically, if you are using this low carb keto carnivore approach, it will improve you. It will improve your health and keep getting better, and patients would be able to come out of most of their pills, if not all. So
how many people have you successfully now helped in remission, find remission or reversal for their metabolic syndromes?
Yeah, I don't have any number right now. I don't have that data, but exceptionally some patients, because I told you about 2 CKD patients and 1 ALS patient was there actually. Unfortunately, he is no more now, but he got her ALS. ALS is amyotrophic lateral sclerosis. It's a neurodegenerative medical condition where motor neurons get actually attacked by your immune system. So patients can't even move their limbs, upper limbs and lower limbs. So he was kind of paralyzed. So that patient actually was bedridden, but following this keto carnivore approach of diet, he started writing with pen, means after 1 month of diet, and he was able to go to bathroom also, which earlier he was not able to. So, and depression, I have treated one depression also, and she was my senior in my MBBS. During my MBBS time, she was doing PG in Ops Gynae, and I was doing internship at that time. So that ma'am actually messaged me that, Keshle, please help me with whatever advice you have regarding diet and all, because I really want to take advice from you. And she was on multiple pills regarding her depression issue. So she got off almost all pills for depression which she was taking before, and she lost 40 kgs on this kind of means keto carnivore diet, and currently she is doing fine.
Amazing. Dr. Kishla, how do you intend to make a difference in a city like Patna, where you're working right now, and against all medical protocols, conventional medical protocol that you're trained in? And people have a reason to believe doctors, and they're qualified. You are a doctor yourself. Why would they not take your conventional medical advice as against LCHF? So what are the challenges that you're facing in a city like that?
Yeah, the most common challenge is the kind of rituals or cultural practice we do as belonging to, means like we belong to some particular caste or some ethnicity or something. So we have some days where you are not supposed to have your eggs or meat, like Tuesday, Thursday, Saturday. So apart from these 3 days a week, you are getting Savan that lasts for a month in a year, and then Navratra comes, and then you have something Chhat, and then everything. So I say, patient, whether you come to me, so you simply follow my dietary protocol. irrespective of what months you are going through, and or else don't come to me, because you are taking this food as a medicine. And if you are not ready to accept that food is a medicine for you, at least for this 6 months period, then better you don't come to me. So this is the most common challenge actually, especially with Hindus, I would say, because other religion, I don't think, because they are ready to eat meat and all most part of the year. They don't have any such festivals where they are not supposed to eat meat and eggs. So this is the most, because that's why I love Muslim patients. I love treating Muslim patients.
Let's take one-liner questions from our audience, and I think we should keep it a one-liner answer as well before Shashi comes in.
Sure.
Somebody has asked, can I still drink my glass of wine on a low-carb diet?
You can do anything you want. You can smoke 1 or 2 cigarettes, definitely, but that is not good. But it's not that if you are taking alcohol with low carb diet, that will harm you, because you are taking it with low carb diet. It will harm you anyway, whether you will take high carb diet or low carb diet. But definitely, if you are already taking low carb diet, then it's good that you are taking at least alcohol. At least you change your diet at least. So in that aspect, actually, it's right, but it's not good to have alcohol or smoking or do smoking or anything.
One common misconception about grains is that when people want to quit wheat, they often tend to gravitate towards jowar or bajra or any of the millets. What do you want to tell them? I mean, is it?
Yeah, because right now, our current government is promoting whole grain, millets. So as I said earlier, because that complex carbs, simple carbs, these things don't exist actually. You are taking carbs, you have to look at the total amount of carbs in that particular food item. And if you are having 60 grams, 70 grams of carbs out of 100 gram of that particular food item, then it doesn't matter what your glycemic value of that food is. So this is nonsense, complete nonsense. This is another way to do propaganda. So people are getting confused. They are thinking that if I don't take wheat or rice, I will take bajra and jowar and anything, I will get my diabetes better, though nothing will happen.
Dr. Kishla, any incident with you where you have had to face some bias or probably a little bit of discrimination because you're a doctor and you go against all the medical protocols and you're quite vocal about it, even on social media? Anything in particular that you remember that you can just mention maybe very briefly?
I do get a lot of DMs on my Instagram.
Love mails, hate mails?
Hate mails mostly. So people don't love me that much. I don't think so. People love me so much because if you will do something different now against agenda or convention, I don't think majority will love you. Majority will hate you for that, because common people are like that only. So I don't need also that love from those common people.
But I'm talking about your own colleagues, the doctors that probably.
I don't talk to them actually, and they are on my WhatsApp and they know what I'm doing, but still they have some advices to give. Most of the time they give if they call me sometime, but I just listen to them and I do what I want to do. That's it. I doesn't consider them that I don't hold much importance to them actually.
I think on social media, you're making quite an impact, Dr. Kishler, because as far as I followed you, people are finding remission not only, by coming to you personally, but I think also by following your advice. And I see that quite a lot on your social media timelines. I think you're doing amazing, amazing work. You're changing lives, you're changing people, you're making things better up and, beyond your own profit and loss and everything else.
Yeah, actually,
so I think you've put the mission ahead of you.
Yeah, right now I don't have any conflict of interest, financial conflict of interest. I'm not selling any products. I'm not doing anything that will give me revenue except for the part that I am doing, what I am providing through my means service, like diet part. Apart from that, I don't have anything. I don't have other talent to make money, to make anything for my living. So
I think we need many more like you in every city of India, people who are making real changes on the ground and making a difference to people's life altogether.
definitely it will happen for sure.
Yeah. Dave, would you like to say anything? And in the meanwhile, can we get Shashi on the screen, please?
So I'd like to ask one more question. Like I think if one of our guys on Twitter asked, so like not everyone, like not every obese person has their blood markers totally off. Some of them, like blood markers wise, they're totally fine. So if you could answer that in a brief, it would be helpful.
Yeah, actually, I told you that is actually, that comes to your genetics, what kind of genes you have. If you have ApoE2, and then it means that you need high carbohydrate, means you are supposed to be on high carbohydrate diet because your genetics is like that. So having ApoE2, you are supposed to take, you are actually able to cope up with the side effects of carbohydrate that you are getting in your diet. But if you are ApoE4 and still you are consuming carbohydrate, that is deadly for you. So it depends on your, but it doesn't matter whether you have triglycerides of 110, 60 or 70, it will be dictated by your genes only. So even if it's not in the normal range, let's say, but my triglycerides also floats around 110, 120 something. I don't have that ratio also, that like triglycerides to HDL ratio, what we see in our lipid panel, to be, that is considered as healthy marker for your metabolic health. I don't have that ratio to fulfill that 2:1 ratio or below 2:1. But still, it doesn't matter. If you are not eating any carbohydrate, you don't have any inflammation in your body, it doesn't matter whether your triglycerides is 80, 90, 100, 110, because triglycerides are not causing you any harm directly. It's the whole metabolic milieu, that is the whole insulin resistance and chronic inflammation in the background, that is actually causing you the harm. So high triglycerides is actually the manifestation of something going wrong with your metabolism. It doesn't do any harm directly.
Okay, I think I'll have Shashi have the last word.
Yeah, I wanted to personally thank Dr. Gishle. We are so happy that we found you in social media, and you are a totally different doctor, and you have the nutritional approach to treat chronic disease, which India needs right now. So that's why I keep telling that we need a clone. We need to clone Dr. Gishle for every state, every district, and every village if possible, and we will defeat this metabolic disorder in India only if you have clones like you. And I'm so thankful that you could have
thank you sir. We will make one defeat diabetes India, like defeat diabetes Australia, which is by Dr. Peter Bruckner, sir.
And for that we have DLife for that. So
yeah, sure,
thank you.
Sure.
Thank you, Dr. Gishle. Thanks, Ira. Thanks, Devanand. So
so
I think
much, everybody. Thank you, Gishle, Dr. Gishle, for coming.
Sir. Thank you.
Thank you, Dev. Thank you, Shashi.
So yeah, so I welcome Dr. Tro, and I welcome the host, Mandar, to this session.
Hello, hi, Dr. Tro.
Hey, how are you? Nice to see you again.
Good to see you. Thank you so much for joining. This is Metabolic Health Conference, India's first and largest such conference. We are doing it over 3 days, and so many people are very excited to listen to you. So welcome to the conference, and I'm stoked to have you here. So a lot of us know you, we follow your work online, and but for the benefit of those who may not, let me take a minute and so, and just introduce you to the audience. So hey, right.
Sorry,
Hi,
go
everyone.
ahead.
So Dr. Tro, he's a board certified physician based on the East Coast in the US. He's an obesity medicine specialist, and he runs Dr. Tro's medical weight loss clinic and focuses a lot on reversal of obesity and type 2 diabetes. And his main way of operating is a lot of coaching, real-time biometric monitoring, educating his patients across the country. He, by the way, has a very inspiring story of his own, gaining his health back, and I'm going to be asking him about that. He has published very interesting research, including on food addiction, reversing diabetes, reducing triglycerides, using keto diet, intermittent fasting, and he passionately advocates, fundamental changes in nutrition and lifestyle, fighting food addiction, tracking key blood markers, and as some of you may know, those who have followed him online, he has a very, firebrand personality online. Dr. Tro, we love how you, don't mince your words and you put the truth out there. And, we are very excited to have you here in the session. Thank you so much for joining again.
Yeah, I'm excited. I've been following, Shashi for a bit, and it's just a pleasure. And to see you guys come together like this with so many people. And I looked at all the speakers and I listened to some of the lectures, and it's just so inspiring what you guys are all doing. And I'm just so honored. I really am. I'm really honored to be here.
Pleasure to have you. So, why don't we start with your own story, right? I think that could be a good starting point. Could you please sort of describe, what was the before and after?
Yeah. Well, I don't know how far you want to go back, but I knew I wanted to go into medicine when at the age of 12, I was the current weight I am now. So as a young kid, I was obese. I was, about 200 pounds, which is my current weight. And I remember going to the doctor's office, Dr. Adis. I remember him. I mean, he was a good family doctor, but I don't think he had the tools to deal with metabolic disease. He just cuts and bruises and colds and coughs. And I remember going there on my 13th birthday, which in the United States, where we go get your annual physical on your birthday as a kid. And my just to give you an idea, my mother has struggled with obesity. My father has struggled with obesity. My brothers are both struggling with obesity. So the whole family really struggled. And there I am at 13 years old, waiting for about an hour and a half to see the doctor. And then he puts me on a scale and tells me, "You're fat. You're going to be like your family." And I remember that was like my formative moment. I remember, that firebrand personality you mentioned, that was the minute it started. Because the first thing I thought was, this guy just sat me in his waiting room for 2 hours. They have little candies and lollipops on the counter, and then he's telling me to lose weight and basically shaming me. So I've wanted to, I wanted to become a doctor at a very young age. I was inspired to figure out, to be better than Dr. Adis. Not that he was bad. He wasn't a bad doctor, but I saw that he wasn't helping my family. I mean, we were all, some of my siblings have gotten to over 400 pounds. Anyway, fast forward, I went to med school. I went to medical residency. I trained in a Yale internal medicine program where I would become chief resident. And I got up to 350 pounds. So maybe Dr. Adis wasn't wrong. Turns out I had the MC4R and FTO genes, but, which are genes known to be associated with obesity. And my colleagues at Yale and elsewhere would say, Troy, you should count your calories. Troy, maybe you should have more whole grains. Troy, maybe you should eat multiple small meals. Troy. And I would do my best to be healthy. And nobody, including myself at that time, I didn't want to be 350 pounds. I haven't met one patient who wanted to be 350 pounds. And so, that was my primordial ooze. I was a 350-pound doctor. I was inspired at age 12. I have a family that suffered with obesity and diabetes, and I wanted to figure it out. And my wife, about 9 years ago, really sort of inspired me to she's like, you're the chief resident, you scored on the 90th percentile on your board exam. Why can't you figure this out? And then I turned to the medical literature like I would have if this was pneumonia, and if it was pneumonia, I would have looked at the antibiotics that are available for pneumonia, how to determine the etiology, or if maybe it's not bacterial, maybe it's viral, maybe it's fungal. I would have determined the etiology of that issue and then sought the best treatments with the least adverse events. So with that lens, I turned to the medical literature, and I read probably 3,000 original articles on obesity. I read 3 textbooks, including the great Dr. Eric Westman's textbook on obesity. And what I found was that the mainstream public health message for diet, eating whole grains, eating multiple meals, having more starchy vegetables, having vegetable oils, this is all a lie. It's not really based in good science. And all the interventional trials supported low carb. So that's where my journey started. I just wanted to be a good doctor for myself. And I found out that it wasn't exactly what we were told.
Wow.
And then I lost 150 pounds. And then the rest, the way you described it, I became a social media firebrand, mainly because I'm passionate. I've lived it. I've walked in 350-pound shoes. I know what it's like when you sit on that, plane to ask for a seatbelt extender, and the flight attendant says, get the hog strap, hogs, strap for the pig. I know what it's like not to be able to go on carnival rides, not to fit in aisles, not to go to concerts because you're not sure if you're going to be able to fit in that stadium seating. So I know what it's like, and I think that's what makes me a little bit different and makes me a little bit more passionate than most.
Amazing. I think people who are listening will start to see, or at least start to imagine the gravity of that situation. And I'm sure you probably heard before you got into the real depths of this science, you probably heard all kinds of advice, right? There is one particular one which sort of bugs me a little bit, is that a lot of times people are told that, hey, the advice wasn't incorrect. It's just that the people are sort of, they never follow it, or they are lazy or something, right? I mean, so what do you say to that?
Okay. What I say to that is, when I was 20 years old, I ran 38 miles straight. Okay. I love to run. I helped design the gym at my medical school. I literally, when they were building it out, they had a budget. I went to the dean. I said, give me the budget. Let me help you design it. I picked out all the equipment and I worked out at the gym there. I have tried every diet, and whether it's true that I can't adhere to it, right? Or whether the advice is wrong, to me, it doesn't matter. The results matter. And so if a medication cannot be adhered to, if metformin, for example, for diabetes causes severe diarrhea, a good doctor and a good medical system should be able to adapt, right? what would we do? Maybe we would try an extended release version. Maybe we would try another medication if it was needed. Maybe you don't even need it. You can go low carb, but the point is that a good medical institution should be able to look at an intervention and say, well, look, the adherence for this is very low because of the side effects. And if let's just say I was lazy, I don't know how I got through medical school and became a chief resident if I was lazy, right? I don't know how that could happen. But if it was, if I couldn't adhere to it, you have to meet the needs of the patient. We have to have other options very clear. If you can't, and the guidelines that we have in the United States by the USDA, the food pyramid, it should say, if you can't adhere to this, try low carb, right? So if it's me that's the problem, right, which is fine, you can have that opinion, that's your take, somebody's take, not yours, but as a good medical system, we need to provide an alternative, just like we do for any other intervention that patients can't adhere to. Right? If they can't adhere to medications due to side effects, we must adapt. We can't just keep saying, no, you have to take this. But doc, I had an allergic reaction. No, you got to keep taking it, right? You have to adhere to the medication I gave you. But doc, I'm having Stevens-Johnson syndrome. My throat is closing up, it would be crazy. So I think the reality of the guidelines is if patients can't adhere to it, right? If the whole world can adhere to it, we need to adapt. I mean, it's like the old saying, if one student fails, it's the student, right? If all the students fail, it's the teacher. So that's my thoughts on that statement.
Yeah, amazingly put. Thanks. So I know that you also attend, some of the conferences, meetings, and you are quite vocal about how the guidelines are being shaped. So since we are sort of on that topic, I just want to quickly get your, opinion on that as well. That how much of a change do you see, or what's the sort of the reaction that you get from your peers? And
yeah, so I do go to, I go to both metabolic conferences here in the States, but I also go to conventional medical conferences because, I feel like I should know medicine conventionally, and I should be at the top of my game in their way of thinking. And I should also be at the top of my game in my way of thinking. And this is why I've continued to put out research, continue to, lecture and in the metabolic space. So I think the problem with our colleagues right now is that they've come to the conclusion that, in the conventional space, that obesity is a genetic condition. Okay. And they look at that same thing that you said, Mandar, but they looked at poor adherence, and they say, people just can't do diets. They can't do diets. And this is a genetic condition. People can't do diets. We know the healthy diet. We've looked at the observational data. That's how they got to the guidelines. By the way, they do not. And I discussed this with panel members from the dietary guidelines. When they're looking at the data for the guidelines, they're only looking at observational data or interventional data that's not in a weight loss perspective. So every weight loss trial that's been in favor of low carb diets, a direct head-to-head or randomized control trial, it's not included in what their scope. And all the head-to-head studies showing that low carb, improves diabetes and can reverse diabetes, none of that is included in the scope of the guidelines. They're not even looking at that data, right? So they're relying mainly on interventional data for healthy people to gain weight, and they're looking at observational data. So the problem with this, and I don't know if it's too sort of advanced for the audience, but the problem with this is it's confounded. When you look at people who say eat meat, right? They're more likely to eat the bun and the cheese and the ketchup, right? And the soda that comes with that meat, right? So this sort of data is confounded, right? It's very confounded. It's not reliable, but that's what they use to make the guidelines. So the guidelines are a best guess, and they're very flawed, and they don't include interventional data. And like I said, as a doctor, we care about the person in front of us. And so when we're looking at data, we care, okay, where's the head-to-head study with one antibiotic versus the other one? What should I use, right? I want to know which one did better. Which drug should I use for cancer on my patient? Let's see what the head-to-head trial showed, one intervention versus the other intervention. And when you do that for low-carb diets, well, let's review. For hypertension, it's been studied head-to-head against DASH, and low-carb was superior. It's been studied in diabetes head-to-head against the Mediterranean diet, the healthy Mediterranean diet, and it was superior at reducing diabetes medications. It's been studied for obesity head-to-head against low-fat diets and calorie-counting diets, and it's been shown to be superior, okay, particularly at 3 months and 6 months. At 12 months, right? Let's go back to that initial question you said. Well, maybe people just can't adhere to the guidelines, and that's the problem. At 12 months, most people in a conventional setting will have difficulty adhering, right? And the way modern medicine looks at it and says, look, no diets work. At 12 months, everybody's the same, right? I think this is a key error in the thinking, right? It should be, what do we need to do to get them to adhere? In fact, I was just at this conference that you mentioned, right? And they're looking at huge data sets. They're actually doing some really interesting things with machine learning. And they found that if a family member, a doctor, and a friend all supported a diet intervention, guess what happened? They were more likely to stick to it and lose weight, right? So we should look at the best superior treatment when it comes to diet, which is low carb, without any hesitation, for hypertension, okay, for metabolic syndrome, for diabetes, for obesity. This is without question, head-to-head, low carb is superior. The next question shouldn't be, well, or the statement shouldn't be, well, nobody can adhere to the diet, so it doesn't matter. It should be, what do we have to do to make this something that's lifelong sustainable? And I think this is where our colleagues in the sort of the conventional world, going to Obesity Week, going to these, ASMBS conferences, where they need to shift their thinking, right? We need to think, how can we empower our patients? How can we help patients to sustain a diet? How can we make this something reachable for somebody in the Asian, sub-Asian context? How can we make it reachable for the guy living in Alabama? How can we make it reachable and attainable for every person? So I think the differences in the thinking come from the reliance of sort of these our colleagues in the traditional medical world on really faulty data. The Dietary Guidelines Committee is really relying on observational data, and the people listening to them, the 80% of doctors that just do what they're told and do what somebody else tells them to do, they just accept that. And then they say, well, people are just lazy and they can't do it, right? So it's a very tragic way of thinking, because people will suffer. I think what we have to do is flip the way they think, and we have to get them to say, nobody's lazy, nobody wants obesity, nobody wants diabetes. It can be reversed. Low carb is superior. And instead of saying, well, all diets fail in the end, we have to change their thinking to say, how can we empower our patients to continue doing this? How can we make it easier for them? And this is something that I've devoted the last 5-6 years of my life to figuring out.
So true, so true. So actually, I want to pick up on that thread, and then maybe have you please explain to us that, let's say a patient comes to you, right? And then how do you help them keep it sustainable, keep it going? I know you're a fan of, tracking various markers, but I would love if you could explain the approach.
Yeah, I think, so now in our clinic now, just to give people an idea, just because it's not like a typical medical clinic, I just want the listener to understand, we have 3 doctors, a physician assistant. We have 4 health coaches, 2 personal trainers. This is a big sort of team. And I'm very lucky. I have an amazing team. And so I just want to say thank you to my team if they watch this, because none of this is possible without them. But, let's go back to what a patient needs. A patient doesn't want to come to a doctor's office. They don't want to see you, right? They don't want to see, they're not going to fit in the chairs most doctors have in their waiting room. Okay. They've been shamed most of their life. They have serious medical issues. They are worried, is the table even going to be able to support their weight? Right. So they don't want to see you. Okay. They don't want to see you. And most likely, most patients, as I said, most patients realize their doctors don't know how to handle this. Right. So one, there's an avoidance to care. So when a patient actually signs up with our clinic, right, we're already delivering them information in the first minute. They get an app, they get a curriculum, they get a continuous glucose monitor shipped to their house. They don't have to even move from their home, right? They can get started within a second of wanting to establish care in my office. So this is called asynchronous education. Mm-hmm. And when they get the courage to make that change, right, you need to meet them where they are. They need to start now. They don't want to wait 2 months to see you. They don't want to wait 3 months to get into your office. They don't want to wait 1 hour, 2 hours like I did when I was a kid in the doctor's office. So we developed an app, and the app does a couple of things. It starts to get them involved virtually. So we have meetings like this every day of the week, okay, helping patients on various topics. Okay, if you're just starting, we have meetings for you. You meet once a week to understand the basic tenets of metabolic health and how to implement a diet safely. Okay, we have groups on fasting. We have a book club. We have lectures on advanced topics. We have in the month of November, we're going to have a free diabetes awareness lecture series. So anybody could download the app, Dr. Tro app, and attend our free 4-week lecture series. And what we're doing is we're creating that community. If you remember, I told you about that machine learning data that showed friend and family support makes it more successful. So we're creating a new family, a new friends for them. Okay, because they want to change their diet. That doesn't mean their kids are. Doesn't mean their husband or wife is. Right? They want to do something else. They want to change. It doesn't mean their school programs are going to change what they're serving. Doesn't mean the commercials are going to change. What their friends are eating are going to change. So we need to create social bonds, and we need to reach them with asynchronous education in the first minute that they're ready to change. So that was step 1, create an engaging, amazing app. Step 2 was remote monitoring. Mm-hmm. You need to start to think, how can we passively engage in this person's life? The scale should connect with your office. The CGM connects with you. The ketone meter from Keto Mojo connects directly to your office. And the absence of using these things, not using the app, not using these equipment, what does it mean? Somebody takes a CGM off, stops, stepping on a scale. That means something, right? So it means that, something's going on. Maybe there's stress. Maybe it's an important time to reach out to somebody. So not only are you monitoring the data that comes in, you also want to monitor the absence of data, right? So remote monitoring, 2, asynchronous education, creating community and support, remote monitoring. So that's like three things. And support and empowerment are so critical, right? These people, I'm lucky. I was a doctor. I have income. I have access to food and education. But some people don't have that. Education needs to be very simple. It needs to be fun. It needs to be and it needs to be amongst their peers, right? So we create small groups where people can sort of hear and see what other people are doing on their journey.
Mm-hmm.
A lot of what we do in human behavior is mirroring. We see what somebody's doing that's successful and we copy it. We learn from those strategies. So we've implemented small groups to facilitate this sort of behavior change. So between, these things, the asynchronous education, remote monitoring, empowerment, using small groups and multiple points of contact, the average patient in a 6-month time frame will interact with our office 500 times, whether it's an app, meeting, individual meeting with a doctor or health coach, trainer, whatever it is, right? Using the app, watching a module, doing a homework assignment that we give to them. And then, the advice has to be practical, right? So one of the things that we focused on is how do we help people in the systems they're in, right? How do we get people quick and easy meals at their home, at their work, at their, when they're on holiday, when they're on vacation, when they're traveling? What are you going to do? We start to empower them with easy things to do. We actually give people a McDonald's shopping list, right? Because look, the restaurants, we are creatures of habit. The average person coming to me has about 15 to 25 foods they regularly eat and crave, right? They eat them in 5 to 15 locations with 5 to 10 people. Okay. And, that's about 60 things a doctor needs to help a patient with, right? It's not a hard list of things to do. The average person has 15 cravings that you need to address. They have struggled eating in like 15 different locations when they're at work, when they're at, home late night by themselves, when they're, visiting a friend's house for holiday, right? And they have 5 to 10 people that they eat with. So it's not a hard task that we need to do, right? And we focus on that pragmatism. Hopefully you're unmuted and you can actually talk. So guys, if the session listeners, there he's unmuted.
Sorry about that. I had a bit of cough. So
yeah, I don't know, is that too much? But we're very thorough. We're a different practice. It's not like a medical clinic.
No, it's amazing to know. So I think, you have a very thoughtful step-by-step approach. And if I may ask, the adherence rate and, the overall retention rate for these guys to go hit their metabolic health goals must be amazing. I mean, do you have stats on that?
Yeah, so we have the best stats I have is so we get asked by large employers. Large employers come to us, companies say, Tro, help us with metabolic health. And they give us 500 people or 1,000 people. And they say, help us with these 1,000 people. And out of the 1,000 people that are interested in our program, we will probably take into our program because we assess readiness to change, right? So we're assessing readiness to change. We're assessing their medical needs. So we'll take in about 10%. Out of the 10% we take in, we have a very high adherence rate, 90+% adherence rate, right? And look, there's things that happen that people have to drop out. They leave their employer, they get another job somewhere, they promoted, they're fired, so once they come in the doors, the engagement rate and the adherence rate is high. But we also do a really good job of filtering out people who are not ready. We get thousands of people who just, they sign up their kid. They're like, I want my kid to lose weight. And then you pull the kid aside and say, hey, 15-year-old, would you rather be here or going and, partying and playing video games, And 99 out of 100 times they say, I don't want to be here. It's my parents. And sometimes I get the other way around. A kid signs up the parent. And, they're concerned about their parents' health. And then you get the parent here. You say, do you want to be here, or would you rather be playing bridge with your friends at the senior home? And they're like, oh, I'm only here because my son or daughter made me. So we do a very good job of assessing readiness to change and filtering people out of our program. Hey, maybe it's not the right for you. Maybe the guy, just handing out medications and saying, see you later, that guy would be better for you. We're expensive. We cost money to employers, we cost money to patients, and if you're not highly invested, the fit isn't good, right? Like if you want a quick fix, you can go on a medication and yeah, I don't think it's a quick fix. You'll find out very soon, just like we did with lap bands, so that has been my focus. My focus has been on making sure the person in front of me is ready to change and understanding what they need to, helping them understand what's required of them in our program. So we do a really good job of that.
So good to hear, that very detailed approach. And I think a lot more people need this sort of an approach, and it's definitely something to learn very deeply from you. I want to sort of, pick your brain on the whole food addiction thing, right? You have published on it. So for our viewers as well as myself. So one sort of angle I wanted to explore with you was, how do you look at, when people go on, say, low carb, and I know you have seen them change their food habits and, get away from their addiction. But do you sort of look at it as something is shifting in the brain, at a chemical level, maybe, or metabolic level? How do you look at it?
Yeah, so addiction, you have to look at in three. So let's get to that, right? So a patient comes to you, they're smart, they know better, they want to change, and they can't, and they don't, right? And they're doing an action despite self-detriment. They have diabetes. They know that a blood sugar of 350 milligrams per deciliter is going to hurt every artery in their body, right? So how do you describe somebody who knows better and can't make a change, right? And so describing food addiction has been challenging because unlike alcohol, for example, alcohol damages several cells in the body, right? Alcohol, we don't need it to survive. And yet we need food to survive. Every cell in our body needs protein, minerals, vitamins, right? And healthy fats. So we need food to survive, and yet there can be this disordered relationship. So it's important to understand that this is different. It's different than cocaine, it's different than alcohol, and it's different than, it's different than other things like gambling or pornography or video games that people can have addictions to. Okay, it's a little bit different, but it's similar in many ways. It is a chemical. There is a chemical, sugar. Sugar lights up the brain very similarly to other addictive substances. Fat potentiates that signal. So sugar and fat, that signal is even more strong, right? So there is a signal. Caffeine is also, has an independent signal. So caffeine and sugar are probably the most implicated. Salt can potentiate that signal as well, right? I'm sure you've seen, and if you haven't, there's pictures of these amazing goats going to death-defying heights to get salt from. So salt is a very captivating substance as well that can potentiate some that sort of addictive chemical property. So when you're looking at the data for addiction, you also look at, chemical dependence and withdrawal to see if that's there. And if you've ever taken a patient and put them on a low carb diet, you'll understand that every patient goes through withdrawal, right? Every single one. And you look at radiographic imaging, functional MRI studies. These can be helpful to define addiction. And then you look at other data, mouse model data, and sort of subjective data, right? So when it comes to food addiction, it's not an agreed upon term, but there are big groups that are trying to come together led by Jen Unwin and some others that are trying to define exactly what this is. Okay, but a quick and dirty way that you can figure this out is, is the patient smart enough? Do they otherwise show willpower in other areas of their life? Are they eating in a way despite self-detriment, self-harm? Right? And if these three things are there, you should at least be thinking about this concept of food addiction. And screening for it is quite easy. You can take the CAGE questionnaire for alcohol and then change it for food. Do you want to cut down on your food? Right? Because the CAGE questionnaire is a mnemonic, CAGE, for cutting, agitated or annoyed, guilty, and eye opener. And if these four are answered correctly, or not correctly, as yes, for alcohol, this is a high sensitivity for an alcohol abuse disorder. If you take that and modify it for food, do you want to cut down on unhealthy food? Yes, I do. My wife doesn't. She has no appetite. She has no issues. She eats one little, piece of chocolate and she's like, I'm good. I don't need any more. So some people don't want to cut down on their food habits because they have excellent habits and it's not a problem for them. Right? Do you get agitated when somebody tells you to cut down? When I was 350 pounds and I desperately wanted to lose weight, and my wife would say, my poor wife, she'd say, maybe you shouldn't eat that. Are you saying, oh my God, thank you, Rosette, you're amazing. All I wanted to do was put this pizza down, right? Or do you feel gratitude? Or instead, do you feel agitation, annoyed, stubborn, leave me alone, I know what I'm doing, don't tell me what to do, I'm just going to have this one, So that's the question, do you get agitated? And what this means is you have this goal. I want to lose weight, I want to eat healthier. And then when somebody reminds you of that goal, you don't get happy. You get annoyed. There's an emotional disconnect. Your emotional, visceral response to somebody helping you remove that substance is agitation and anger. Stubborn, opposition to defiant. Right? So this is a hallmark of sort of dependence. And then the next question in that questionnaire is guilty. Do you feel guilty? Do you feel shame? Right? Around your food use. I've certainly felt those. And, if I asked my wife, she'd say, no, I don't have any guilt or shame. I don't, I eat good. I'm fine, But for me, what does it mean? Why do I feel shame and guilt around food? It's because that emotional disconnect is, I have this strong desire to get healthier. That emotional disconnect is so pervasive and so common. I get angry, stubborn, leave me alone. Not now, later. I'll start again Monday. That now I have psychological distress. I'm feeling shame and guilt. So that emotional disconnect is so high from our mental goals. You have this central sort of frontal lobe mental goal of eating healthier, but your emotional disconnect is so great that now it's leading to psychological discomfort and psychological distress. That's shame and guilt. So cutting, agitated, guilt. And the last one for alcohol is the eye opener, when you feel so compelled to drink that you drink at an earlier and earlier time, or maybe you hide and sneak bottles, right? And the same can be true for food, but it's slightly different. It's, you don't eat in front of other people, then you lose control home alone. You avoid social situations, you don't eat in front of others, and then you binge later on. You hide and sneak wrappers. You eat, in secret because you don't want the judgment from others.
No.
And this last step is very critical to understand what is going on. So when an alcoholic drinks at an earlier and earlier time, and when they're hiding bottles, what are they doing? Right? The psychological and emotional and disconnect and the emotional distress is so strong, but they're so captivated to the substance, they're actually changing their behavior to accommodate the substance. Right? That's what's going on. They're sneaking and hiding bottles so that they can have less psychological distress and maintain the substance. So the substance use disorder is changing the behavior and maintaining that bad habit, that bad, it's keeping the alcohol there. And with food, it's the same thing. Why? when you're eating in secret, when you're hiding and sneaking the wrappers, when you don't eat in front of others and then eat a bunch by yourself. These are hallmarks of food addiction. If you have 4 of those, that's very likely that's a substance use disorder. If you have 3 of them, probable, and if it's 2, it's just harmful use. It's just like, sort of like, you probably shouldn't be doing it and it's negatively impacting you, but you may not have a substance use disorder. Now, this isn't a science. This is just the way I do it. It's not standardized. We're coming together to form these consensuses. So the listener should just take caution about food addiction, because it's not agreed upon, and we need it to survive, right? So now you have this patient and you do the screen and you're like, oh, you're addicted to food. Well, if they go and they can't just abstain like they could for alcohol, which makes it even harder, because you have to now help them live with their addiction, right? They have this relationship to food that looks like an addiction, feels like an addiction, and they have to learn to live with it. And, here's the worst part. If you go to a family gathering and you say, I'm addicted to alcohol, what happens? Everybody hides the alcohol. Maybe they don't even drink to support you. And they don't let you drink. But the minute you tell somebody I'm dieting, what do? They're like, oh, just have a little bit. I know those Indian sweets, right? I know there's no way you're leaving that house without trying one of those Indian sweets. I know it, right? And if you say no to the sweets that somebody made, right? How is that going to be taken? Right? I know it's not going to be good. Right? What happens if you tell your mom you're not going to have dessert?
Doesn't work, yeah.
What's that? Yeah. She will keep pushing it, I'm sure.
Right. So I wanted to sort of ask you, so I think you laid out the addictive behavior so well. I mean, I was thinking of people I know who a little bit do that. So I can totally see, how it pans out as a pattern. So what I wanted to also ask you was, what do you think low carb specifically does, which, helps them? Is that mainly the satiety, and, how do you look at that?
Yeah, that's an interesting topic. So there was a Volkow at the NIH who was probably a lead scientist on addiction. She recently did a study about 2 years ago looking at ketogenic diets for alcohol cravings, and it reduced alcohol cravings. Ketogenic diets improve mental health in various ways, seizures, migraines. So I suspect there's some central action to this, right? I suspect. The other side of it is, as you said, if you have a problem with food and you're full, it's a lot easier to say no. So if you feel sated and you feel full, you had proteins and fats, it's a lot easier to address those food cravings, right? Rather than going in hungry. So I think it's a combination of these things. I think there is likely a central mechanism to craving control on a ketogenic diet. And then on the flip side, I agree with you, the satiety, whether it's, meat, fish, chicken, eggs, these are very filling foods, calorie for calorie. If you, I tell my patients, how many slices of pizza can you eat? And they all say, maybe 2 or 3 slices of pizza. I'm in New York, so it's New York pizza is to die for. 2 slices of pizza, if you're looking under the calorie prism, that's 800 calories in New York. They're big slices. And I asked them, how many eggs can you eat? Can you imagine eating 10 or 11 eggs or 12 eggs? And they're like, there's no way, doc, I can't eat that much. Right? But it's the same amount of calories. So your point about satiety, I think, is really critical, because calorie for calorie, it is a very satiating way of eating. Particularly if you stick to whole foods and real foods. Now, I think there's likely other mechanisms. And Volkow's work, what we know about the centrally acting effects of a ketogenic diet, I think we don't have the data. I'm just theorizing here, but it's most likely also centrally mediated. I mean, how can it reduce alcohol cravings? So there must be some activity on the brain.
Amazing. So I want to sort of now go from micro to macro a little bit. Currently, how do you look at the overall scene of metabolic distress in the US? And maybe joining with that, do you see Indian patients in your practice, and what differences do you spot?
Oh yeah, I have a big sub-Asian and Asian population, a lot of Indian patients. I think some of the challenging parts, I have some that eat meat and some that don't. And I tell them, look, whatever you want to do, I support you. I've had a lot of people, they eat meat on their own. Like, I don't push it, and they all of a sudden they're embracing meat, particularly fish and chicken. So I think one of the barriers in that population is, there's a lot of meat phobia. Forget about the religion, like just outside of the religion, even, there's meat phobia. It's funny, I have a physician colleague, and he hadn't eaten meat. And I asked him what his grandparents ate, and he said fish and coconut, like that's just part of the India that his ancestors were from. Right. And eventually, his triglycerides were high. This physician colleague started to eat fish and coconut, and his triglycerides improved. But I think, you have to we have to figure out ways for people who decide they don't want meat. A lot of Greek yogurts, a lot of eggs, foods around, these stuff. Can we use cheese in creative ways to make different foods? How can we replace we have to replace bread, the flatbread. What do you guys call the flatbread,
roti,
right?
The roti, yeah.
Yeah. So we've come up with ways with almond flour to replace that flatbread, so that patients can, feel culturally, that something is not taken from them, and then from a metabolic perspective, I'm going to be honest, white people have it made. They can get a lot fatter.
Right.
They can get a lot fat. I was 350 pounds until I showed high triglycerides. So my sub-Asian patients, they can't even put on 10 pounds, 20 pounds, right? They will see visceral fat much earlier than a white person, right? And docs need to know this, that it is much more likely for an Asian sub-Asian person to experience metabolic disease at a lower weight, right? And they're much more likely to get metabolic syndrome and diabetes at a lower weight. So I think the challenge for the Asian sub-Asian population is that they need to be much thinner than to get that sort of metabolic health. And this is likely genetic. It would make you a very formidable, opponent, right? To be able to have lots of blood fat and blood sugar, right? You can go fast and run 25 miles, fight a warring tribe, and then come back and be totally fine. But in a world where food is everywhere, I think this is a challenge. I actually would say it is probably more difficult. It is more difficult for my patients who are Indian and Asian, sub-Asian. So I think that these are the things that I wish doctors would know, that you can't use the same metrics. Measure visceral fat. Measure visceral fat. And if you measure visceral fat and you look at the triglycerides and the blood sugar, right, their weight may need to be much less than white, Black, Hispanic people. And then overall, I mean, this is a disaster. This is a worldwide disaster. We're facing 90% of people with at least one component of metabolic syndrome. I mean, it's sad. It's so much suffering. There's 100,000 people losing limbs to diabetes. I mean, our kids, we have a pediatric obesity and diabetes epidemic in children. In children, they're talking about giving drugs and surgery to 6-year-olds, okay, for these issues. And I think that's a huge problem. And this, I think, is the easiest way to show the error in our colleagues' thinkings in the mainstream approach. That they're thinking it's okay to cut the stomach and inject a 6-year-old with medications that are poorly tested, particularly in that age group. I understand the problems of obesity are pervasive and metabolic disease are pervasive, but there is something wrong with us as medical providers that we've been unable to do better. And the ways that we have done better, cutting people's stomachs out or putting a lap band and giving them drugs, these are short-term solutions, and they have long-term complications. So if we can develop ways to empower patients not to need these things, we should. And we should not give up and just say, patients can't adhere. If patients can't adhere, if all the students can't adhere, it's the teacher, right? So I really wish that we can get our colleagues to look at metabolic health differently and empowerment differently.
Yeah, like the way you put it across, no holds barred. I wanted to sort of ask one quick question, because you have published on this topic as well, and you mentioned triglycerides just now. So sometimes people struggle with this idea that, hey, you're sort of telling me to eat low carb, so sort of my fats are higher now in the diet. How is it going to reduce my triglyceride, or how is it going to, help me lose fat? So how do you sort of explain this science to them?
Yeah, so the triglycerides is pretty interesting, right? So it's true, when you eat fat, your triglycerides go up. But what happens is as you eat, as you're void of carbohydrates, right, your fat oxidation goes higher and higher.
Mm-hmm.
And so what happens is your body becomes more efficient over about the period of 10 days at using fat for fuel. And you can quickly see that triglyceride level come down quickly, because many people have never had to really ramp up their fat oxidation, their fat burning capacity.
Mm.
I mean, who's fasted for 3 or 4 or 5 days? Who's eaten low carb consistently for 10 days? Very low carb. I mean, like 20 grams or under.
Mm.
Right? So most people's sort of machinery, it's got a bunch of dust on it. Their mitochondria has only gone one way. So you can rapidly see that. And what we've done here in our office, if we have doubters, the guys say, we have a lipid machine here. You can do your lipid every day if you want. I don't care. You can see it come down.
Mm-hmm.
Now, if it's dangerously high, so I don't know if you guys use the same metrics as us, but if a triglyceride level is in the thousands,
mm-hmm.
right, this may require, so if the blood fat is in the thousands and you're having excursions up another 1,000 due to like an LPL deficiency or some sort of genetic issue, right, which is possible, but although it's rare, you may want to do a low carb, low fat approach for the first 2 weeks,
mm-hmm.
until the fat oxidation increases. And then you can add fat and see what happens to their triglycerides. But even that approach is not necessary 90%. Like if it's under 1,000, I wouldn't care.
Mm.
I not that I wouldn't care. I would be much less, apprehensive. So yeah, what happens? It's true, if you eat fat, you can get a triglyceride excursion and triglyceride level goes up. But the ability of your body to use that rapidly outpaces any of these excursions. And we have fasting triglycerides of people that are undetectable, under 50, under 40. I mean, meaning like their body is very efficiently using fat for fuel. And so eating fat, causing fat, I mean, I think that's not hard. Most of the time, the patients coming to me, by the time they've used our app or seen a video or seen a lecture or watched, Ken Berry on YouTube or heard the Low Carb MD podcast or whatever it is, they already have done away with that. But if there's true naysayers, that's what the app is for. Like, here's the data. And in the app, we share the primary studies, so they don't have to trust us. And ultimately, I tell them, you shouldn't trust me. We're tracking everything, the lab work, the blood sugar, the weight. You're going to be the first one to tell me, look, it's not changing. Right. So I hold myself accountable. I am seeing, is my advice actually having an impact? And when it doesn't, sometimes we do reduce fat. Sometimes people can, do a lot of heavy whipping cream, cheese, and nuts. And, sometimes we have to course adjust. Right. And we may adjust some of these things, or they're snacking, or they're stress eating, or they're anxious eating, or they're sleep deprived and getting hungry. So we can course adjust. But ultimately, nobody should trust me. They should all verify me. And that's why we check labs very frequently and remotely monitor as much as we can. Nobody should trust me. I'm going to show you, because the difference between us and them should be, we're results driven. The guidelines have failed. The results are terrible. They think that their scientific method is correct. Their error is the results are terrible. Everybody's suffering. Everybody has disease. So we should go the other way around. We should be results driven. And this will help prevent the same mistakes that they made.
Absolutely loved it. Yeah, I think the accountability and proof is in the pudding, right? So you show them that it works. That's the best way. So we are almost near closing. So let me thank you once again. It was lovely chatting with you. And I'm sure folks have learned a lot of new angles of looking at low carb and their relationship with food. I also want to request Shashi and Anup to join just for a minute.
Guys, I'm huge fans of you online. I just want you to know, both of you, it's nice to finally meet. I know we're probably going to wrap it up in the next couple of minutes, but this is amazing what you guys have done. And I know it's not been easy for both of you guys.
Dr. Tro, personally, I want to thank you in this platform, because the moment I messaged, you readily agreed to come to this platform to speak today. And I think your story is very inspiring. We have seen, many of us know the kind of journey you had. And I think many of us in India also know, but most of them who are going to see this video may not be knowing about a journey. And I think that is very, very inspiring. The kind of weight loss journey and the kind of addiction subject is something which you come out very, very clearly. And I think we will need a lot of more sessions with you in coming times also. I want to thank you from the bottom of my heart.
Can I just say, I want to thank you guys because I know, particularly in India, this is not easy to do. And I know you guys have faced a lot of, unfortunately, unnecessary criticism, and I just am so honored to be here. I was telling Dr. Gadre here that I'm just honored. And it's honestly that population that I think needs this message the most. Certainly in I think we have to change the medical landscape there, and it's going to be challenging. I know you've been working on it for years.
Yeah, concluding message. Concluding message, doctor. I'm Anup here, and besides what Shashi has said, personally, I love you for one thing, that is being brutal. Because I also belong to same segment on Twitter. I'm very brutal. And I remember, one doctor from India, you had taken him on very brutally few years back. I won't name him, but thanks for that.
I'll name him. He misdiagnosed rhabdomyolysis. It was classic case of rhabdo. And he says this was due to protein or something. I don't know what he said. It was something so silly. And this guy has hundreds of thousands of followers. I forget what his name was, but I was like, I really think you missed that. Oh, he said it was shock liver. So when you have rhabdo, which is a muscle breakdown, just for the listener, which is a breakdown of muscle tissue, you can have elevated liver enzymes. And he's a GI doctor, I think. And he said this was due to shock liver. And I'm like, you're completely wrong. You know, he has myoglobin in the urine, hallmark of rhabdo, and he has elevated liver enzymes, which is beyond common to see in rhabdo. And he said it was shock liver, and I humbly pointed it out to him. I'm like, you got it all wrong, guy. And it did not go well. So I do not envy what you guys have to put up with if that's how most doctors are. You know, I think that's what you're talking about, but you know.
Thank you.
Yeah.
Thank you for coming.
Yeah, no problem. Thank you.
Namaste from India.
Namaste
Thank
from
you.
India.
Yeah, guys, thank you.
Thank you so much.
Hello, everyone. Welcome to the Global Metabolic Health Conference organized by D-Life. I'm your host, Priyanka Matanhelia, a PhD, and I also practice as a nutrition and lifestyle coach. I'm associated with D-Life, which was founded by Mr. Anup Singh. Today, D-Life is one of the largest and fastest growing community of low-carb nutrition coaches with expertise in reversing metabolic health diseases. I would also like to thank Mr. Shashikant Iyengar for being my mentor and guiding me through my low-carb journey and my approach as a nutrition consultant. Today, I have a very, very special guest with me, Dr. Mrudul Kumbhojkar. Dr. Mrudul is a licensed medical doctor. However, she branched out into low-carb nutrition coaching to help patients reverse metabolic diseases. She arrived at this decision after her personal journey of reversing her PCOS through low-carb diet. As a young doctor, she faced many challenges and hurdles to overcome family and social pressures to switch from traditional medical practice to being a nutrition consultant. From what I have learned about Dr. Mrudul in the past few days, I really admire her courage for leaving the safety and comforts of a traditional doctor practice and embark on an unconventional path as a metabolic health coach. I'm really delighted to talk to her and excited that today she will share her personal journey and stories of success with her patients. Hello, Dr. Mrudul. Welcome to the session.
Yes, hello, Priyanka. Thank you for this kind introduction. I'm so excited to talk with you and share my journey here. First of all, I thank D-Life for giving me this opportunity to speak in this mega conference, and it feels great to share my journey.
Okay, I will just share the screen for the just one. I'm not able to share the PPT.
You can open the PPT first, and then you can simply click on a share screen. The access has been given.
Acha, because it kept saying it's denied.
Yeah, access has been there. It's already there.
Okay. Let's see. No. Grant. 1 minute, sorry.
Any issue, ma'am?
Let's see. I think just a moment. Can you see my screen now?
No, ma'am, you have opened it in your laptop, but you have to you need to come on the Zoom platform and just click on the share screen.
Yeah.
Yeah.
Can you see
Now it is there. It's perfect.
Yeah.
Now we can just do the slides mode, ma'am.
Yes. Sorry. Thank you.
Perfect.
Yeah.
Thank you, ma'am.
Thank you. Okay, so Dr. Mridul, I'm really curious to know, how did you get started on this journey of low carb nutrition consulting?
Yes. So I took admission to MBBS in 2013, and it was the exciting phases of my life, a dream come true moment. I was following the footprints of my mother and was very excited to do my favorite graduation. So it started in 2013. The journey was, of course, a roller coaster ride. I was enjoying it, but until in my final year, I realized that I have gained a lot of weight and I was diagnosed with PCOS. So I had gained almost 15 kgs, and
Wow.
that was the point where my excitement of availing this noble graduation degree of MBBS suddenly came to a halt by knowing this diagnosis. I would like to add that it was PCOS. It's a condition called as polycystic ovarian syndrome, and it has a triad of symptoms like obesity, then excessive hair growth, and irregular menses. So I was facing this. There were irregular menses, and this got me into the dual stress because it was my final year of MBBS, and this unwelcomed disease.
Right.
So yeah.
Yeah, it must have been very, very difficult to manage this, being a medical student, the pressures of, studying medicine,
Yes,
and
absolutely.
living in hostel, right?
Right. I was
away from families. So yeah, so how did you then manage to complete your degree?
So in that final year of time, I diagnosed it. Then me and my mother, she is a pediatrician. We both went to endocrinologist, and finally, all with all the medications, lab investigations, I started doing the remedy. And the priority was, of course, completing MBBS. So I kept aside PCOS for some time, and I cleared my MBBS in 2008.
Right. Wow, that's really, really commendable. Congratulations. Yeah. Unlike, despite the pressures, because I know PCOS can be very, very debilitating, especially as a young woman, the kind of lethargy, the fatigue that you experience. And despite that, and not getting good food in the hostel, waking up late nights, it could be very, very challenging.
Yes,
So,
yes,
yeah.
it was. So now, as my exams were over, now the time has came that I need to reverse PCOS. So I started doing gym, and I hired a personal trainer also. Also, I met a dietitian and followed her nutritional plan. So this led me to a weight loss of 15 kgs, and I also reversed the hormones also. So that time I was into the remission phase, but I was doing everything in the holidays, which we get after the exam and before starting of the internship. And now, finally, I went back to college. My internship started, and that was the challenge began from there, because my food pattern got changed, and again in just 2 to 3 weeks I gained up again 4 kgs. So
oh my God.
yeah, because I was in the home and I was eating homemade food. So even gym was there and everything was there, but my nutrition, my homemade food was there. So weight loss karna easy hua. But जैसे internship चालू हुआ, the change was that food got changed. I was eating canteen food, and mess food was there. So I gained 4 kgs, and that alarmed me, and I got curious that if you want nutrition or food plays an important role.
Right. So I think that's a very good lesson for a lot of young people who think, canteen food is okay because it's like, Indian food, it's probably not processed. They think that way, but it's not true, right? It does affect our health. Even if you are younger and you have good metabolism, etc., it can affect your health. And despite gymming, because a lot of people think when they gym, they can eat whatever they want, right? But that is not true. Right? Gym has nothing to do with your weight loss as such, right? As you discovered, I'm sure you will talk a lot about it. Yeah. So what happened, like once you realized that nutrition is the main cause of your, disease coming back again and the weight coming back again, what did you do next?
So when I realized this, I started doing some research, and research was on YouTube. I started seeing some videos, and then I came across Dr. Rohini Patil. She's an MBBS doctor. So I related her with myself a lot, and she was doing nutrition practice. So I saw her videos, and I made some minor changes. Like, for example, she also used to tell me that to eat, she used to tell in her videos to eat eggs. So I started making these changes ki canteen mein jaake I used to eat eggs. Then the intake of tea was more because I was doing internship and late night shifts and all this stuff. The intake of tea was more. So I cut down consumption of tea. And I made these changes, and I saw differences that there was inch loss. So this gave me the curiosity that I want to learn nutrition and science. So that was my start.
Wow. So you were quite like, you actually, I think what fascinates me is that you did not find the answer in the traditional medical education that you got. You actually had to go and do your research online to learn about nutrition and how to manage your weight. I think that's another big lesson for a lot of young people today, that one has to manage weight, one has to go to right sources where you can get nutrition education. Okay, so what did you learn, about, how did you learn about low carb nutrition then?
So I talked with my parents regarding this, and then after all the research, my mother and me were searching for the authentic course because she wanted me to pursue a post graduation into nutrition, as after seeing my interest. So I took admission to Masters in Public Health Nutrition. That was my post graduation after MBBS. That was the first, and it was basically designed for doctors to treat malnourished children in the community. So I used to go into the field work. We used to design the midday meal programs, the nutrition program for the kids. So that was the structure of my post-graduation. But later, as I wanted to do, my interest was into the obesity or diabetes, which is the leading problem right now. So I started doing my research, and then I came across K11 nutrition program. And that was rather first my step into the world of fatty protein, and I came to know about low carb over there. So there I learned about endurance nutrition, athlete nutrition. But again, being a doctor, I wanted to treat my patients metabolic disorders on nutrition and lifestyle, as how I had done on myself. So still I was my research was still going on, and then finally I came across D-Life.
Okay, so in D-Life, what did you learn?
Yeah,
how did that change your perspective about nutrition per se, right? Yeah.
Yes, because in D-Life it was a thorough nutrition science, and it was basically from the starting from the human evolution till all the recent advances and new remedies were there. Everything based on the nutrition, like what is insulin resistant, what is the root cause, how to treat the root cause first. So yes, sir, D-Life mein mera clear hua, and I found out that now I'm confident enough to treat my patients.
Okay, so that must have been quite a revelation that, so what did your parents think about this whole, change in plan? Because you had this dream of becoming a doctor and suddenly you are changing courses, and your mother is a doctor too, and traditional doctor. So how did she react to this, whole business of doing nutrition courses, 2-3 nutrition courses? How did she react to it?
Yes, there were conflicts, there were arguments. Like it was whole 6 months. Like I'm telling them my side, and they were even telling me to at least give the entrance exam of MD. But I even denied that. But then after seeing the change in me, my reversal of my health, everything, my mom saw the passion towards this subject, and she helped me then. And she was with me in this whole journey.
And what about, low carb nutrition was actually very appealing to you? Like, what were the things that you were actually attracted by? Like, so you went through this whole medical education, you learned about various diseases to treat with pills, right? But in this, they are telling you to treat diseases with nutrition. So how did you, what really surprised you about it?
Main thing which I experienced is when I started doing low carb, that it kept me a long period. I had the satiation. Okay, so I don't used to feel hunger. जो पहले regime में मुझे every 2 hours, 3 hours, I used to feel hungry. So that I saw, because I used to eat in a calorie deficit manner. After this low carb, I came to know the importance of dietary fats, and then eating nutrient dense food, and how it kept you full for long. And this reduced my cravings, my every kind of hunger pangs. So yes, that was the difference I found out by taking knowledge of low carb.
Okay, so when you say fats, right, dietary fats, and most of us, I know young people especially, they don't like fats at all, right? I'm sure you have friends, and if you're taking fats, so what kind of fats you took, and what was the reaction of your friends or your parents, when you're eating so much fat?
The reaction was, of course, they were surprised to see that I'm eating gallops of ghee and cooking into butter. But then I just they were surprised initially, but then later, after seeing my results, seeing myself, seeing my health, my mother also accepted this. And yes, there is a scientific way behind it. They understand, and then they are in my journey. They are happy to see me working in this field.
Okay. And what about your friends, the doctor friends? Because, obviously you branched out, but they were still practicing. So how was their reaction? Were they, accepting of the fact that you are doing something different? How did they react to it? Did anyone try to adopt your this thing, or they were like very, no, this is not good?
Yeah, there were mixed of the emotions, that some were like, what are you doing this? We don't know the scope of the job, everything like that. But then also there were some friends who were like, okay, you have interest into this, and you can. My parents were with me, and that's all sufficient in changing the path.
Okay, so I guess family support is a very, very important factor, especially being in India, because our family, if they stand by us, then change can happen.
Yes.
Okay, so how did you start as a nutrition coach? Because till now you were doing your graduations and studies, and what was the first step you took?
Yes, so along with my master's and all the course which I was pursuing, side by side, I was doing awareness on low carb, because I found out that the public is not much aware about low carbs. So my weapons were social media. So I started creating awareness on Twitter, Instagram, and then eventually the social media awareness started creating buzz. And then, yes, I started getting clients through it.
Okay, so when you went on social media, what were the reaction of people who started following you or looking at your tweets? Were there a lot of questions about this new approach that you were talking about? What kind of questions would you get?
Yes, I have faced a lot of trolling for this, because you are telling something which is very unconventional according to the mainstreams. So eating fats, then fear of proteins is there in much in people. So I used to try my best by sharing the scientific reports, by sharing our D-Life podcast. So I was doing my minor contributions, but I had decided that I have to make this change jitna, as much as possible for me.
Right. So you stuck to your own, and I think being a part of D-Life community also probably helped you in
This helped
your
me a lot.
social media mission, because there's quite a budding community of nutrition experts on Twitter and Instagram these days, and especially D-Life members. So yeah, I think that is quite good. So let's talk about, I believe you were also invited then by the mainstream media to talk about it. How was that experience?
Yes, so this low carb buzz on the social media, by seeing the mainstreams, they approached me. The first podcast was of Bol Bhidu. It is a Marathi podcast, and later I was also invited in Pune University for a radio talk show. And now recently I shot for a podcast on Sakar. So Sakar is a very leading newspaper of Maharashtra. So these were the
So as a young doctor, it must make you feel very, very, how do you feel that, you are presenting this very, very new knowledge to the world, which is also very contradictory to the medical practice. So how does it make you feel, and how do your friends now react that now you are being invited by mainstream media to talk about it?
Yes, I just feel that, yes, my decision was right. Even now my parents are also proud of me, and
nice.
Yeah, matlab jo bhi decision liya, I was not I didn't thought of any of this will happen in future, but mujhe ye karna tha, itna hi target tha, and I did this, and it's going just well. So I'm feeling good about this.
Nice to know. So you also started your clinic?
Yes. So as the awareness on social media, and I was getting patients, so I even got some of the patients told that they want to meet me in person. So I gave a thought that I need to set up my own clinic. So I was doing job. So along with my job of medical officer, I set up my clinic in Kolhapur.
Okay, along with being a medical officer, right?
Yes.
Okay. So as a medical officer, what was your experience as a medical officer? Could you just talk a little bit about it, especially after getting this nutrition knowledge? What were your observations there, and how did you feel about it?
So medical officer is basically work based on MBBS and my post-graduation, which was public health nutrition. So we used to conduct various programs, the vaccination program, nutrition program, then all the Abhiyan, which is designed by the government. So we run into the community. So that is the main job of a medical officer. And with that, I also had the part of NCD, that is, of course, our non-communicable disease. So that is diabetes, everything. So yes, in even the community में भी बहुत वैसे लोग who are facing a lot of obesity है, then PCOS है, then there is diabetes. So there are a lot more of those people also जो कोई भी junk नहीं खा रहा है. They are, like we say that, BPL people, below poverty line, but still they have all of these metabolic syndromes. So but as such, I was not able to do the nutrition practice over there. But मैं थोड़ा just suggestions and just thoda de rahi thi ki what you have to stop, what you have to start. Okay, small changes what you have to make to stop the rice, to switch from chapati to bhakri, that is jawar. So small changes they used to make, and yes, that is a scenario. Even in community, there are a lot more of metabolic disease.
Right.
Yeah.
So that basically, made you think that, there is a lot of need for actually metabolic health reversal rather than just, so
yes,
you, So these are what are these pictures? Could you tell us
Yeah,
about these
these are
pictures?
some of the glimpses of my inauguration ceremony of my clinic. She is Dr. Geeta Pillai. She was the president of Medical Association of Kolhapur. And in this picture, my family, we are all sitting into my consulting room. So,
okay.
yeah.
So basically, through your mother, by convincing your mother, you also convinced other senior doctors in your community, in your town, that this is something to be, something to be practiced. And it seems like they are quite supportive of you.
Yes, they all loved my decision, and they all supported me. Yes.
Okay. So now could you talk about, a little bit about the personal challenges? Of course, your family has became supportive about low carb, but I believe you did face some challenges. So could you talk about the challenges that you faced on a low carb journey?
Yes, as I was doing well in my job and even my clinic, so I felt that let's get settled into the personal life also. So lately I got married in this year. I met this guy on matrimonial site only, but it was not directly through parents. So I met him, and I wanted to tell him my food pattern because he belonged from a vegetarian family.
Oh, okay.
Yes.
That
So
must
I
have
found
been
that it's very important to tell him. I told him everything, and he was very supportive. He just told that we can do on eggs and paneer. Just it was not allowed to cook meat in home. And
Right.
realizing that the guy is supportive, I went ahead.
Okay, so I guess this nutrition is now also impacting marital decisions for young people. But these are important decisions, right? Because
Right,
it impacts your whole life and, peace in the family. So how did you overcome these challenges?
Yeah, when I discussed with him, he gave me all the support. And if you want to eat non-veg, we can go outside and we can eat. And the question of low carb, you can do it on vegetarian also or over vegetarian. So I was eating eggs and paneer and veggies. So my concern was to do low carb. So wo ho gaya, vegetarian mein bhi ho gaya. And see, you can do it when you leave the grains or carbohydrates.
Okay, so it doesn't matter your culture, etc. If you want to do, because in India, as we've been discussing throughout this conference, there are a lot of people who are just vegetarians, and then they feel that, okay, how can we do low carb? So basically, you've experienced both sides, right?
Yes.
And you think that it can be done. It does not have to be very restrictive to just meat or eggs. It can be done by vegetarian people as well. Very good. Nice. So now could you just tell us a little bit about your nutrition consulting process? How do you go about, consulting?
Yeah, so I'll tell it. It's a 3-step approach. So understanding the patient is the first, that I take the thorough history, then transitioning to low carb, and then the last is measuring the outcomes. Into 3 consultings it happens. Yeah.
Okay.
Then the first consultation, where I take all the detailed history, all the medical issues or the symptoms the patient is going through. Then I give him the detailed list of all the blood work which I need that should be done. Then that is the first basic consultation. Then next, after the reports, I share the analysis of blood report and then discuss what will the program will be about. And I ask them if they want to enroll into it. And then third, last is they get ready for enrollment, and then I share the customized plan, and then the coaching begins to explain them what is low carb, what is high fat, everything so it's a coaching. Whole 3 months is the coaching.
Okay, so when you do, when you start explaining the importance of low carb and high fat, what kind of questions or surprises, or resistance you get from your patients who come to you?
The major which they get the fear is fear of fats and restricting carbohydrate. Fear of fat because it will rise cholesterol and फिर वो heart attack आएगा, and then these kind of fear they have. Then next is restricting carbohydrate. If we restrict lot of carbohydrate, then we will be low on immunity or will feel giddy, or skipping breakfast. अगर breakfast नहीं किया तो kuch matlab chakkar aayega. These kind of fear they had, and the major fear is fear of proteins. High protein. जब भी मैं बोलती थी तो they used to have a lot of fear that it will damage kidney and these kind of stuff they had. But in this coaching, I used to do their counseling. Counseling helped a lot. I shared them all the scientific evidence, then videos, podcast, and whatever query they had, I used to explain them in their simplifying in their language, in the complete layman language, and they were agreeing to it. Moreover, the social media awareness had created a trust, and so they were knowing ki kya rahega plan, and still they were enrolling into the program.
So I guess social media is also a very, very important aspect of, you know, this. Okay. So in the second step, you say like you just implement. So what are the challenges, or how's that journey, you know, progresses?
So after doing this all counselings and explaining them, they enroll into the coaching, and then it is a 3 months or 6 month journey, whatever they opt for according to their metabolic health issues. And daily update on WhatsApp of what they eat, daily food updates. I take it on WhatsApp. Also, there is weekly call from me, and any query if they're having, it is cleared as soon as possible on WhatsApp. If it's like a lot more than that, then I get on a Zoom call and I discuss with them everything. So everything is I do clear at that time itself.
And what about recipes, because I believe when people are doing low carb, it can get very monotonous also sometimes, and, challenging to eat the same food. So do you get such questions as well?
Yes, I have I give them my if the person is non-vegetarian, then non-vegetarian recipes, which I have experimented. So I give them that list. Also, if the person is vegetarian, then Sindhu ma'am's book I recommend to all of my, mostly I have recommended to all of my vegetarian clients, and they're happy with that kind of all the recipes. So whenever there is monotonous, I give them the YouTube videos also to try new recipes. So it works.
Nice. So Sindhu, I will just, for the benefit of our audience, I'll say Sindhu Vijay is a very, very, stalwart member of our D-Life community. And she's written a book of vegetarian recipe book for low carb, low carbers, people who follow low carb diet. Yeah. Okay. So measuring the outcomes, I think this is probably the most exciting phase of this low carb journey, because people see real results. So let's talk about that. What do you could you, if you could share a case study to explain the outcomes, it would be nice. Yeah.
Yes, so I'll tell about this patient. So he was a 30-year male, 185 centimeter heights, and he was very obese of 110 kgs. Like if we see according to the height, his weight should be 85 kgs, but then he was 30 kgs obese, and he came to me with the symptoms of acidity, indigestion, bloating, irregular bowel movements. There was disturbed sleep. He was facing lethargy, then drowsiness, tiredness. He used to get a lot of hunger pangs, cravings for sugary food. So mainly he was an IT engineer. And yeah. So
if you could tell us, like, what all kind of information did you take from him at the initial phase?
Yeah. So I got to know all his dietary habits. So he told me that I eat a lot of fast food because he stays in the, he lives bachelorette life. So ordering food from Zomato, then Swiggy. So I eat a lot of fast food. I have lots of sweet cravings. I get hunger pangs. So that was his habits. Also, lifestyle, he was having sedentary lifestyle. It was his work from home, so he used to sit and do the work. Then disturbed sleep, and that was his overall lifestyle. And so I gave him the blood work to do. That was fasting sugar, then fasting insulin, then lipid, and the KFT, kidney function. Yeah.
Okay. So could you explain why you wanted these tests to be done? Because it's not like he came for diabetes or anything. What is the significance of these tests? Yes.
When I came to know about his symptoms, I related it with that his weight also. So I need to know the root cause, as I know that the root cause will be obviously insulin resistance because of because of these kind of lethargy, then drowsiness, tiredness, fatigue. I came to know that I need to work on the root cause. So my pattern of the consulting is I tell them to do this kind of blood test, and after that blood work report, everything has been, the picture gets clear more.
So could you explain a little bit about insulin resistance? Because I think most people are not, because fasting blood sugar, of course, a lot of people are aware because it is directly seen as a symptom of diabetes. But fasting insulin, why is that important? And if you could explain the concept of insulin resistance, because a lot of people don't know about it.
Yes, it's the most ignored test, fasting insulin. Basically, insulin get resistant because it can't take up, the body cells can't take up more of your glucose. That condition is basically insulin resistance. And when that is the underlying cause, the many of the metabolic disorders like increase in visceral obesity, visceral fat, okay, so all the metabolic like PCOS, diabetes.
So visceral fat, you mean like the central obesity, the fact that people put weight on their waist and the hips, that is probably is so a lot of people can be tofu like thin outside and fat inside is what you're saying. Okay,
so even though you by physiologically, if you look at the person by the appearance, he will be like lean also, but if we check his blood reports and if we check the fasting insulin, then he can be insulin resistant.
Okay.
Yeah.
Okay.
So that test is very important.
Yeah. So do patients, ask you, why are you asking for these tests? Or they resistant to do these tests, or they agree to do these tests easily?
Yeah. Patients agree just to do every test which I tell them because before that, I explain them the plan. Yeah. So they get ready to do the test.
Okay. So there is no problem with that. Yeah. Okay. So what is the plan? What was his plan, if you can tell us?
So I kept him on ketogenic dietary regime because of the lifestyle he was following, that is ordering the food from outside. So I told him that you have to go off grains, you have to go off sugar, seed oils, and all the junk. And he has to increase the animal-based proteins like fish, chicken, mutton, eggs, and combine with all the veggies. So he used to bring the tiffin, but then later he's मतलब एक cook लगाई उसने, and then now he's cooking in his home. So this was the food, that is mutton and bone broth. So also I told him to do intermittent fasting. Once a week he used to do water fast, that is only to be on water, like water equals black coffee or green tea, like that.
Okay, so could you explain why ketogenic dietary regime was important for him? Like, why did you recommend ketogenic diet to him?
Because like after when I got his reports, he was severely insulin resistant. Also, his lipid profile was deranged completely. And it short, I was knowing what is the cause, that all what he was eating, the junk and whatever the abuse he has done to his body by consuming all the carbohydrate. So first and foremost, I told him that you have to cut off means junk to cut off here, but with that also you have to cut off grains and sugar.
Right.
So he got agreed on this.
Okay, that's very surprising that, a bachelor hired a cook and everything. So you must be very convincing to him.
Yes.
Okay. And what about fats? Was he resistant about fats at all, or okay with that change? Because that can be because a lot of young people like, oily or chips, etc. So how did you convince him to use healthy fats?
Yeah, basically, I told previously that every client was from Twitter. The source was Twitter.
Okay.
So they used to read my tweets and they were knowing already that कि क्या
Okay.
खाना रहेगा. So वो एक उसका
अच्छा.
mindset was ready, and he got angry immediately, and he just knowing, he was knowing what is ketogenic and what I want to do, but he wanted the coaching, wanted
Okay.
someone to monitor daily, and
Okay.
so he approached. Yeah.
Okay. And intermittent fasting, can you explain like what is the significance of intermittent fasting in his diet plan?
So fasting is basically, I believed, it's for autophagy mode. So you put your body on the autophagy, and that is what I explained to him, that the stage where your body cells start to phagy, like to eat your fat cells. So that was my intention of intermittent fasting, and it works because you don't get that insulin spikes every 2-3 hours. So yes.
Basically it works at a cellular level, you're saying.
Right.
Okay, nice. And he started also on exercise, strength training.
Yeah.
So how does that help in diet plan?
He was doing exercise, but he used to like 2-3 hours. He used to do the gym. So I told him that just do 1 hour strength training, and that is also for 4 days is enough. Don't give much importance to the exercise, because I believe in the ratio of 80:20. So 80% is the food and 20% is just exercise. So do that like that. So that was like, he was like agree to it, and now he's doing only 4 days, 1 hour exercise. That's it.
So actually correcting your food and nutrition, you don't have to sweat yourself so much in the gym. You can enjoy your life, and also you don't have to eat so many times a day. You can just eat, a few times a day, once or twice a day. And so you have a lot of time free to do other things. So
True.
I think it's quite a good plan. Okay, so how was his, outcome after 3 months?
Yes, now we will see. This is like the appearance. So he was 110 kgs. The date is like 31st July. So this was his picture, and now his weight is 86 kgs on 25th October. So this was the drastic 24 kgs of fat loss. And also he lost inches. That is, his waist was 42 inch. Now it's 38. And he also told me that the shirt size is now from XSL XL. It has come to XL. So he's very, very happy now. This was his outcome, appearance.
Okay, so after 3 months, in 3 months, he lost actually 24 kilograms of fat.
Yes.
That is quite commendable, quite commendable. He must, he's lost almost like a small child.
He didn't do any kind of cheating. Only 2 meals per day and 1 week of water fast, and that meals were obviously fats and proteins. That's it. This was his whole diet regime.
Okay, now let's look at his blood markers. So
So yes, so this was like fasting sugar was 101. Now recent lab reports it's 70, so it has come down. Now he was insulin resistant, as I told, that fasting insulin was 12, and HOMA-IR, it is a test for insulin resistant. So it was 3.7. Now it's 0.4.
3.7 is quite high, yeah?
Yes, it should be 2 or less than 2.
Okay.
Yeah, then lipid also, it was 164. Now it came to be lipid, means we in the lipid profile, we need to see only triglycerides and HDL. Triglycerides should be lower and HDL should be higher. So it was 164, now it's 64. And HDL is also at the rising level. It's 42 right now. It was 33. And now the ratio came out to be 1.5. It was 4.9 prior. Now it's 1.5.
And his uric acid also.
Yeah. Yes. So even this cleared. Yeah.
Yeah. Please go ahead.
So this cleared that myth ki if we eat a lot of proteins, it will raise the uric acid. So this also got cleared from this.
Right. And what about LDL? I think you wanted to, you've highlighted in red. So obviously you want to talk about a little bit about the LDL concept that everyone fears because it is raised, right?
Yeah, because see, this has a lot of scientific theory behind it. We should not fear LDL and total cholesterol. We should fear what is triglycerides, because that denotes tri, means 3 molecules of glucose attached to lipids. So that is the concerning factor we should read in the lab report rather than LDL. So LDL, it's though increasing, the person is my patient is absolutely fine, no issues of any kind of symptoms and nothing like that. So we should not fear LDL. It's just a carrying particle of cholesterol. So we need to see the triglycerides only.
Okay, nice. So was he very surprised? What was his reaction after seeing his blood reports?
Yes, he was very surprised, first of all. And he told me that, of course, he had that concern of cholesterol. But then again, I did his counseling. I explained him not to fear cholesterol. Cholesterol is essential. Cholesterol, like, for example, 80% of brain is made up of cholesterol. I explained him everything. And then he was cleared on this. So he got his symptoms, like his energy levels were improved. He didn't had any lethargy or fatigue. Then
okay,
yes, everything he told me that his digestion issue resolved. So he was very happy, and everything, the query or the jo bhi uske man mein tha regarding the cholesterol thing, it got cleared.
Okay, so I think he left a big review for you also.
Yeah.
But tell me one thing, because see, he was doing exercise and you asked him to cut his exercise to 4 days, and that to just strength training, and just limited him to do exercise. So what was his feeling after 3 months, that, because it was just all food, or like, did he realize that?
Yes, he realized now that food plays a very important role, because it's not just you have to go and sweat yourself into gym 2 to 3 hours, and then coming back from gym obviously you will be hungry. So it's of no point to eat a lot of carby food after the gym. So wo 2 ghante jo bhi kiya, it all goes in vain. So he realized that, and he now doesn't give much importance to exercise. Just goes for 1 hour. Also, he's practicing some kind of breathing techniques and everything which comes into the lifestyle change. So he saw this.
So basically now he has time to explore other hobbies rather than just sweating it out in the gym all day and not getting any benefit from it. Not that exercise is not good, but we can say that exercise also has to be done in a balanced manner with adequate nutrition, so that, your body can avail of that benefit, right? So tell me one thing, since, what I find very fascinating is that, you are a young person yourself on this low carb ketogenic journey and guiding young people, and your client was also very, very young, and you have a community of young people you live with. Your husband is one, he's also an IT software engineer. So what is your advice to young people in India who are, dealing with such, because of course there is a lot of awareness about exercise and eating right, but then there is also this rising level of junk food, etc., or eating sugary breakfasts. What is your advice to young people in India to, maintain their health?
Yes, I feel that first of all, you have to live at least junk. Okay. So like ordering the food from outside, going to restaurant, okay, these kind of things, if you stop, then you have achieved your like 50% at least. And then later start cooking yourself in your kitchen, in your home, because you are the only person who knows that what you are putting inside. Even there are a lot of places right now which you get a keto and low carb, but still we don't know that what's going into their kitchen. So I feel that try cooking seeklo. Everybody should learn cooking, and even male, female, whatever, and you have to cook for yourself, and that will be the baby steps towards the lifestyle change.
Okay, and what would you say, because your practice is based in Maharashtra and India, and a lot of regional foods. Actually, we have religion festivals every 15 days, right? Every 15 days there are festival, and festival foods are different, or people fast for religious purposes. So how do you see what are these challenges, cultural challenges, while implementing low carb in India, and what advice do you give to people to manage that?
Yeah, so there are many patients right now who follow everything. Like for example, we have सोमवार का fast रहता है, या फिर Saturday fast, everything like that. But I explained them कि if you're fasting, then what does fasting mean? That give rest to your gut. So भाई उस दिन मत खाओ. Or if you still want to eat, then what are the options? Like for example, I explained them making items or foodstuffs from paneer. Okay, from paneer is allowed during fast, or from nuts, something we can make out of coconut flour, almond laddus, like that. So also I give them recipes that if you want to do that fast and still want to eat something, then yes, you can follow all your religion pattern, everything, and it is feasible. The thing which you need is the willingness to change. That nahi, like for fasting I need the khichdi and everything. So if you are ready to make change, then you can absolutely do this.
Okay, thank you so much. This was very, very insightful. And I think Shashikant has already joined us. And I would also like to invite Mr. Anup Singh to join this conversation, because both of us are from D-Life, both Dr. Mrudul and myself. And I think, I would invite Shashi to, if he has any questions for Mrudul.
Well, I don't have any questions. I only have praises from Mrudul. So she has come from the mainstream into nutrition, into using food as the medicine rather than medicine as a food. And what you've done is really, really commendable and really good. And we need more people like you. We need more doctors like you in every state, in every district, in every village, is what I say. I told this to Dr. Kishle also, that we require doctors. So if you kind of doctors, if we have in all the state, all the villages, then we will be able to battle the rising metabolic disorders that we see in India. And it's a very bold and courageous step which you have taken to leave behind something and gain something else. I think it's really commendable. And you sharing this PPT and your success stories, your case studies were really good, and very good value addition by Priyanka also. And I think you will do well. And I think you have the blessings of the entire team with you.
Yes,
and I don't know if Anup is somewhere busy, engaged. So
okay, but
okay.
I will just add myself that I joined D-Life community just 3-4 months ago, and I've been following Mrudul's journey very closely. And through this for this podcast, I got to know her more closely, and I realized how much she has overcome. I mean, a PPT and sharing your story to public is certainly important, but when you know her, you realize how much she's dealing with, and it's really commendable. I'm very impressed, and I think she's a trailblazer when it comes to young doctors, and who will take on India and combat this, the tag of diabetes capital of the world, right? India being diabetes capital of the world. So I see doctors like Mridul really, taking that very seriously and combating this disease. Yes. Okay, Mr. Anup has joined us. So Anup.
So
yes.
congratulations, Mridula. Now, one thing I would like to specify is out of total 10 doctors enrolled for the course, you are the first from mainstream to successfully complete it, and now you are on a journey through your operations Change and Evolve.
Yeah.
All the best for that, and we are always around for any help that you need.
Thank you so much for having me here. Thank you.
Thank you,
Thank
Mrudul.
you.
It was really a pleasure to talk to you, and thank you for explaining everything so beautifully. I'm sure a lot of people have learned, from your journey and, your expertise. Thank you.
Thank you very much. Thank you. Thank you, Priyanka. Thank you, Mrudul. Thank you, Anup. So I'll invite the next guest here. It's
Yes.
Antonio Martinez with a very, very unique story. And he's going to come and describe his story, and hosted by Mehek. Thank you.
Are we on, Yoga Sandesh?
Yes, ma'am.
Hello and a very warm welcome to day 2 of the Metabolic Health Conference India, an event with a purpose to heal. They say that tough times don't last. It's the tough people that do. And tonight, I'm about to spotlight this tough human to you. A New York-based lawyer who wanted to be a doctor. He has been a heart attack survivor. He has stood against the conventional wisdom to put his diabetes to remission. And how, if you may ask? Well, let's have the spotlight tonight on Antonio Martinez. Welcome, Tony. Welcome to the show.
Well, thank you, Mahek. And I know it's good evening in India, and India is a country I look very much forward to visiting in the future. And it's an honor to be part of this community because we're a global community. I spend a lot of time traveling, and the problems that India is facing, the United States facing, South America, Latin America, I spend a lot of time there, in Europe. This is a global problem, a problem with diabetes. And my life is really a story about how we manage and deal with this condition. And it's been a journey, because it is a journey. I would say to anybody who's dealing with this as a patient, it is a journey. Think of it as a journey. You'll get to explore, you'll get to experience, and you'll get to learn and evolve, because it will, this crisis is a transformative experience for the patient, because you are forced to learn and try new things, and then when you find out what's working, you want to keep the momentum going in your favor. So I'll just stop and let you. I can go on and on.
That is so nice. It's it's so nice to hear it from people, especially the ones who have been through it. It's very easy to just read up things, but when you're actually talking to somebody human, there's so much of emotions involved, and there is so much to exchange and learn from the other person. And I really thank social media too for this, because that's one of the ways we've all connected, and we get to learn each other's journey and learn from each other.
Absolutely. This whole crisis, I look at this issue from another perspective, because one of my observations about these conferences is that doctors, the scientists get together, but there's not enough input from the patient side, because you need to hear from the patient experience to know why things work and why things didn't work. And then you also have to look at, in a broader context, the milieu or the environment that's permitting this. So as a lawyer, I'm thinking, what regulations, what laws, what policies are creating the situations or blocking the ease of solutions, making solutions more difficult. And I've always said that in these kinds of conferences, there should always be a component that looks at the policies and the laws that create the problems and could solve the problems. So that's the only way that we can actually make these things more significant or substantial for everybody. And you also want to attract scientists and innovators, because when you follow, for example, the ketogenic diet, you're struggling with, so, well, how do I continue if I can't eat bread? Well, what can I eat, or how can I take something that I was used to eating and create a ketogenic version of it? Like, I always look at recipes and go, okay, I would love to have this, but forget about it. I see these ingredients. So how can I substitute these ingredients with something that would fit in, and will it taste as good? Will it be fine? These are and you got to look at it as an adventure. It's fun. There's a lot of trial and error, and but you do it. And then, eventually you strike gold and you get there. So anyway, please.
So magical, literally. And I totally hear you, because I have been through the same journey last 5 years. The entire transition, from being on high carb, and then you switch to a little bit of low carb. And then, of course, then there's a lot of people telling you, oh, this is not going to work, and how long are you going to do it? So there's so much of mixed emotions, even when you're in that transition journey, that sometimes you also start doubting yourself. Am I doing it right or not? But then you just keep moving on. And like you said, one fine day, you're just going to strike gold.
Yeah. And you also, the experience is really profound. When you become fat adapted.
Yeah.
So like, I was traveling, I was at a conference in Las Vegas of nutrient supply manufacturers. In fact, they do this conference in India. I know the people at the company that they actually do this also in India. And so I went to a late night dinner party on Wednesday, ate quite a bit, but I had a steak and I had shrimp and then I just said yesterday, which was a travel day, I said, I absolutely had no hunger. And I said, I just fast. And then I woke up this morning, I went to the gym, do my little lifting routine. It's very important. If you're diabetic, what I want to tell you as a patient, something you have to kind of conceptualize, that you are managing an energy distribution problem in your body. And so you have to be aware of all the tools. Anyway, we can talk about that a little bit more, because going to the gym and weightlifting, strength conditioning is critically important. Think of it like your muscles are your kitchen sink, and muscles are the only things that really, besides the brain, that utilize glucose. So if your sink is deep and wide, then there's more room to manage the energy that's coming in. But anyway, but my point being is, I wasn't hungry. I mean, I woke up this morning, I went to the gym, I worked out, fasted. I just had my decaf espresso. Wow. That was it. So that's it. But that's when and later today I'll have a steak and, maybe have some broccoli or something with it. I have to go to the market to that. But these are you can do it, and I don't feel deprived, none of that. And that is the beauty of, one of the benefits of the ketogenic approach is you will become fat adapted, and you understand that your body can run off fat, and that your necessity for glucose is minimal. And even if you don't have, the body has that. The other thing, this experience, and I'm a spiritual person, it really leaves you in reverence for God, for our creator. Put this all together is magnificent. You go, wow. This is, this is how you can do it. But if you're just starting out, understand this is a journey that's going to take time. Think of yourself as like you're back in school, and enjoy the ride, and work with your teachers, because your doctors are your teachers. There will be friends or people that will have influence on you. I have the privilege of knowing Shashikant, who put to organize this with Anup and D-Life, and these are,
that
you
is
get
such a lovely cause to get everyone together.
You get to meet lots of really great people and organizations. We all have a common goal. We want life to be longer and more qualitative.
Absolutely.
And this is the way. So I'm rambling. So go ahead.
It does not even feel like I'm speaking to you the first time. I just feel like we've met before, we've spoken before, and there's so much to learn. But yeah, let me start.
I do believe in past lives, Mike.
That's wonderful. I'm sure we've met then, Tony. I hope we do meet in the future, but yeah.
No, well, definitely. And because I do believe that there's no reason why there shouldn't be a Low Carb India Live. You have one of the largest populations on planet Earth.
Absolutely.
And so
there are so many to hear.
I'd be delighted to work with the people who put this together, the business side of it. There's great opportunities for people here to offer services, products, and also give some guidance and support. Because this journey, it also can feel lonely, because when you get a diagnosis of diabetes, you're like, oh my God, what am I going to do? Or damn, I thought I could avoid it. And now I have it, like my parents or this relative or that relative. Don't let that get you down. Now, accept that reality. And like I said, you have to look at it. Like I said, my metaphor is the dragon.
Yeah.
So there's a dragon. So I've got to keep that dragon sleeping. And you can keep the dragon sleeping for a long time. There's no reason, if you have type 2 diabetes, why you can't still have normal blood sugars, why you can preserve your eyesight, you can preserve your kidney function, you can preserve your healing capacity, so you're not losing limbs and extremities. If you understand what's going on inside your body and know that food is at the source of either the benefit or the detriment, then you can make adjustments. And if you're struggling because there's an addictive component to this, then there are still things that you can do about it. And there's even medications that can do that. So
yeah, absolutely. I really think this is so important, this understanding of what accountability means. We are accountable for our own health to ourselves. We're constantly blaming everything around us, the surroundings, the people, the coaches. But what we need to understand is, when we've cleared our mental setup and when we have decided that we want health over illness for ourselves, and it's obviously going to transform to our family. So I really want to understand, at the beginning of this conversation, of course, we've had a pretty nice conversation already, but I want to understand from you, what happened? How did your journey begin? What happened? And what brings you here today, being a lawyer? What are the struggles you went through that has got you here? And I believe you're a heart attack survivor too.
Yes. Yeah. We'll talk. So I was diagnosed with type 2 diabetes in 2002. And I went off the track. I just thought, well, I'll take the medication and all that. And
sorry if I may just interrupt you here. I would like to know, how did you detect your type 2 diabetes? What was your eating pattern?
Okay,
before that, and what was your lifestyle like?
Okay, well, I was overweight, and I was also feeling kind of sluggish. I wasn't feeling right. And then the doctor did a blood test. And he was looking at me and he said, you have, I think you have diabetes. He said your blood sugar's at 200.
Oh, 200.
Yeah, 200. Yeah.
And you had never tested your blood sugars prior to that?
No, I had done years before that time, I had done a glucose tolerance test that was kind of like a borderline. There was a problem. That was when I did it with the late, great Dr. Robert Atkins.
All right.
Who I had the privilege to work with in the early 90s. We worked to get the laws changed to allow dietary supplements, botanicals, herbs. They were going to be taken off the market. And the FDA had an agenda to take them off the market and make them, or to put them into the pharmaceutical category, which would have made it tremendously expensive and just bad. People having less choices and less access to information. So yeah, I when I'd gone for my checkup there, and I wasn't feeling right, the doctor says, yeah, you probably have your blood sugar's 200. You probably have diabetes. We did another test and he could confirm it. And he goes, well, I got to put you on metformin and you got to change your diet and blah, blah. So I do that. And then
He did tell you to change your diet at that point. In spite
he did. He said, hey, but it wasn't, but it was the wrong guy. It was like go on a low fat, it was
the conventional wisdom.
The conventional diet that they give to diabetics, which is crazy.
And I see that in India too. When I look at the diet paper, it's amazing.
Yeah. When you think about it, if diabetes is a condition of carbohydrate intolerance, why would you have a diet that focuses on carbohydrates? And why have you demonized fat? And then, but that's the extension of the, I guess I want to use it. I'm looking for the best words. Well, the dogma that was created by Ansel Keys,
absolutely,
with that whole cholesterol theory, which is flawed. We know that is flawed. Anyway,
and there is no evidence to that anyway. So
yes, I mean, cholesterol is like
it's life.
Yeah, it's like no, but in the play, in the drama, in the movie of heart disease. It's like cholesterol is a supporting actor. It's not even the actor. It's a supporting actor with a tangential role, but not the primary, not even a catalytic role.
It's just found at the crime scene. And
exactly. It's at exactly. Anyway, so we do these tests. So I evolve. I go on to the next drug called Janimet, and I'm thinking, great, I'm still eating everything that I think I want and all that. And I'm thinking the medication is going to take care of it. And so, 10 years ago,
the high carb diet on your regular diet.
And pretty much, no, still eating. So for example, and this will be a shock to somebody, particularly in India, because this is a staple. I haven't eaten rice since 2014. Okay, no rice. I still will have occasionally, I will say, during maybe 2 or 3 times a year, I'll have, because I actually become a pretty good cook. Cuban black beans. So we'll have that. And now, thanks to innovation, there are products that you can use to substitute for noodles and rice. The shirataki, the konjac root, perfect. That's what I use if I wanted to have a pasta dish, or they even make konjac rice. I'm actually experimenting to make different forms, different recipes to see how that goes. But it has a consistency, or I love it. I had a good Spanish paella, in a long time. Now I tell my friends in Spain, now if you want to make me a paella, we got to do it either with cauliflower rice or this stuff. But you get innovative, you get creative. But yeah, so you give up those foods. So it's 2014, and I won't forget this. I'm in Puerto Rico on a legal meeting, client, and I remember here's the other thing too. I remember I'd eaten with some at a Taco Bell, just junk or garbage. And after I eat that, I'm not feeling I go to bed, I'm not quite feeling myself.
Happy about it.
I wake up in the morning, I'm still not feeling myself. I feel kind of like indigestion. And yeah, and I feel like right under right over here in the sternum, right there. It feels like there's like as if there was a pebble. And that was actually the blockage, the constriction there, the stopping of the blood flow that was causing that pain. So it's there, and I'm like, I just feel awful. I can't continue the meeting. I think I'm wondering, my stomach's not right, and so I take some like Pepto-Bismol. That kind of doesn't do anything. I'm not feeling right. All I can do is just lay down and stay. And my friends say, "Why don't you go to the emergency room?" I go, I'm going back to New York. I'm not going to stick around. I don't have any relatives here in San Juan. I call American Airlines. I said, when's the next flight back to New York? 5 o'clock, there's first flight out is at 5 a.m. or 6 a.m. I said, well, put me on it. They put me on it. And I remember I was like feeling, I'm like with luggage and all of this, and I'm like feeling really bad. And on the plane, I can't really eat anything. I'm just drinking later. I call a friend of mine and I tell him, I said, listen, I need a favor. I said, can you pick me up here at the airport? And you're taking me straight to the emergency room. Oh, well, we're going to, I go, no. I said, you're going to take me to this particular emergency room. This is what the Obamacare, the new health insurance program had started. And I had paid for the best, the platinum plan. I was like, something like, no, you're going to take me to this hospital. I want to make sure I'm covered. I just got instinct. So we get picks me up, takes me straight to the ER, and literally after they check my blood pressure and they do the vitals, they rush me into the ER, and they immediately apply heparin and nitroglycerin. And I still have, and I unopened from 2014, that I'll get to that nitroglycerin that was given to me, prescribed to me by my cardiologist, who said to me, oh, after this, if you have pains, you got to take the nitroglycerin. Well, I'm in the ER, they stabilize me, and the doctor says to me, the lady who's now my cardiologist, she says to me, God must really like you. I said, why? I said, because he says, you were nuts to get on a plane. He said, you should have gone to the ER immediately in San Juan. I said, if you had waited probably a few more hours, I said, you'd be dead. Whoa. He said, I've got to, so count your blessings. He said, well, I've got to send you to a different hospital because you need more aggressive treatment. I had to have stent placement. And I was transported by ambulance to a hospital called Montefiore in New York City. And there, they had me there, and they weren't, by the way, in my diabetic state, they weren't giving me any medication. And then they were feeding me the worst food that you could imagine. Why would you give to someone who has a poor glucose control and is, dealing with and heart attack?
Yeah.
Why would you give them this horrible food, this low fat skim milk, toast, potato, all these things? And I'm like, I call a friend, I said, please bring me something, real food, bring me nuts, salmon, so I can't eat this crap. And then they were monitoring me for like 24, 48 hours. And then they did the stent placement. And then they put me on, they released me, after they put the stent, they released me like 2 days. So I was a total in the hospital, I believe my recollection is about 3 or 4 days. And then when they release you, they just give you this laundry list of supplements, and they tell you all of this that you got to do, and drugs, not supplements. They give you a laundry list of pharmaceuticals, and there's no very little emotional support, because you experience really for the first time your encounter with mortality. You realize that you're not going to be here. I called when I was in the intensive care. I called my son, who was in college at the time, and he literally, he drove straight to the ER to see me. It's a traumatic experience. And then after it, when you get out, like, okay, what am I going to do? And why did this happen? And you start to evaluate, and you look at all of the medications, and one of the medications, and they tell you medications is, they put me on I'll never forget this, because there's a drug called metoprolol, which is fantastic beta blocker, but they don't tell the patient of one of the terrible side effects, which is you have, if you're a man, forget about having an intimate life. And then they don't warn you, and then all of a sudden you're with your loved one, your partner, your my girlfriend is at the time, and she was like, oh my God. And I'm like, doctor, why didn't you tell me these things? I said, do you actually think at this point in that I'm going to spend the rest of my life and not have a full life? So I said, all of these drugs, and then some of them made you feel not yourself. And I said, I got to get off all of this crap. And I said, well, I got to go back. I said, maybe Dr. Hawkins was right. So I rented and I bought a documentary called Serial Killers, like cereal, like the cereal cornflakes. And that was just brought everything back home to me. And I said, of course. And the premise of Serial Killers was that how could an Olympic athlete all of a sudden, later on in life, develop all these chronic conditions, diabetes, heart disease, and so forth. And then we understanding, you go, okay, it's always been about the insulin. It's about the hyperinsulinemia that creates the cascade of all of these diseases, which is a function of the hyperinsulinemia related to the insulin resistance. And so you've got to get back down to the root causes. And so one of the ways, you got to stop it. How do you stop it? How to bring insulin down? Stop eating carbs.
Absolutely.
Reduce your dramatic, and a ketogenic diet will do that. So that's how I got into it. And then I told my doctor, I'm going to do this. And he said to me, hey, that's good. That's a lot of fat. I don't know. He said, we're going to have to really monitor. You're going to try. I said, yeah, I'm going to do this. So that was the summer of 2014. And I come back from, it's the end of the summer, beginning of September, I do my first set of labs. And that's when he called me up after he did those labs. And he said, Tony, what have you been doing? I said, why, doc? He said, well, whatever you're doing, keep doing it. I said, your blood sugars, you have your A1C's normalized. Ooh. I go, really? He says, yeah. He says, I don't have to. He says, you don't have to take Janamet. He says, yeah, I want you to still take metformin, but I can take you off Janamet. You don't need to be on this. I said,
that is such an aha moment, right?
Yeah, that was an aha moment. And I always said, when I do my public speaking, I would say, yeah, the September 2014 was the moment in time when I stopped my contribution to the $25 million a year salary of the CEO of Merck. And not that, I think Pharma does great things, but I mean, the whole business model of diabetes pharma is not to deal with cures. It is to deal, to keep people on drugs for life. And at that time, it was like $600 a month to be on Janomet that I was on, and crazy. I think if my calculations, year to date, not being on Janomet, it's got to be well over $60,000 now to date. Mortgage. It's that I didn't have to spend. My health insurance company didn't have to give to Merck, and that money could be used for other things. So like when I'm beginning to save, as I came off all the medications, and I did the same thing with my cardiologist started taking me off everything. The money that I saved, I started to use to buy better food, higher quality meat, organic vegetables. Again, as in a ketogenic diet, if I were to have any fruit, it would be the strawberries, blueberries, blackberries, the berries, and maybe an occasional some kiwi fruit. But and in lemons and limes you use, of course, and then the other, the atypical, what you don't think of fruits, but are fruits are the eggplants and tomatoes, those things. That's so you just change what you do, and then when I went on the ketogenic diet, I did have an adjustment period. I did experience what's called the keto flu, keto rash, which when I went to the doctor to look at the rash, he was like, didn't know what to do. We did some checking on some of the research, and they found one course of doxycycline, and that was it. I was done. I never had the issue ever again. And it's always been about, from that point forward, following the program, and implementing other things. So with the heart attack, I looked at a very targeted supplement protocol, which has been working very well for me, because I'm going to be 60 years old in December. I'm not on any blood pressure medication. I'm not taking any cholesterol medication. I do follow a protocol that was put together or works off of some research that was done by a gentleman named Patrick Teut, T-H-E-U-T, and he used that protocol to basically stop coronary plaque progression by following basic principles with the diet and the targeted nutrition, and then you do the other really important thing which is the exercise, the strength training. You have to keep your body in a muscle building mode. It's almost like the program that goes off in your body is to lose muscle mass. And so you have to interrupt that. And so you got to get there at least, 3 times a week, go through all the different machines, work out to failure till your muscle failure, so you can't do it. And you do it slow. You're not trying to be like Arnold Schwarzenegger or Mr. You want to do it where when you walk out of the gym, what you feel in your arms or anything is kind of like this. You feel the blood flow, and you feel like there's there's an expansion, a tightness. So that's what you're looking for. And you want to work with a weight and at a speed where you can build up that kind of tension. And then when you feel that heat, you stop, you take a break, and you move on to the next, machine. And that's kind of how I do it. I really wish I had the time for a trainer so I could get more, more target, but that's my general approach.
Lovely. So you are currently even exercising, and I believe you're also still following the ketogenic carnivore diet. Am I right?
Yes. Oh, yeah. I know that I know that beef is not it's common in the Indian culture, but but tonight I will be eating
cow meat.
Excuse me?
We don't have access to cow meat. We're here with just goat and buffalo and lamb and chicken. So.
Yeah. I love lamb but I'm like, I'm gonna have a steak tonight, and that'll be the main focus. So it'll be like a fatty meat And then if I want to, if I feel like if I want to, I'll add like broccoli or one of the vegetables that are low carb, and there are low carb vegetables.
Absolutely. And you can always have them once in a while where you want to maybe just, make a change for your palate, or when you're sitting with friends and family, just for that little shift. But I think that doesn't really go for a longer period. You just have it occasionally and you're done with it, right?
Yes. Yeah. And then, what I also appreciate and I had to adapt to is, you really have to learn how to cook and take control of what you're eating, because if you're surrendering yourself to restaurants, you don't know what the hell they're giving you. You don't have control over the seed oil issue. And even if they tell you, oh, this doesn't have sugar or whatever, I remember being told, yeah, this is sugar-free, and I'm drinking this drink. I go, there's no way that this, and I go, man, what, if you're not using sugar, what are you using? Oh, the kitchen tells me they use this thing called agave. And I'm like, agave is like, this was like
you'd rather add sugar to it.
Yeah, it's like a duh, that's sugar. And I'm like,
that's
please.
true.
And then I would go and I'm like, because wearing a CGM, and I'm like, oh my,
it's spiked.
What the hell did I?
Exactly.
Yeah, what the hell did you just give me? So you develop the discipline to cook, so you can have control over the ingredients, and you can decrease the possibilities of screw ups like that when you're at a restaurant. Yeah, and when I go to restaurants, it's pretty easy because I'll just, I pretty much will go. I'll my appetizer will be some kind of meat or cheese or something like that, and then my main dish would be some kind of meat, and maybe a vegetable. And then when they come back to go offer you dessert, I'm like, no, I'm good. Cup of coffee maybe, but that's it.
Yeah. Yeah, this is one of the issues I have even seen with people and with clients, even with family. Whenever they go out, they're always so stuck. What are we going to eat? And I said, it's your choice. When they hand over the menu card to you, you make the choice. No one forced you to call for a pasta. No one forced you to call for a sugary beverage. There's always an open menu, but it's always what we wish to choose.
Correct.
Yeah. So tell me, what according to you is the must not haves in a diet? Usually we ask people that to include certain things in our diet to make our lifestyle more healthy. So what can I add? Everyone keeps asking me, what can I add to my diet? And I often tell them, well, let's look at it the other way. Let's look at what we can eliminate from your diet to make it better.
Well, I just follow. There's a really good advice. I was put together really by a gentleman named Vinny Tutorich, is another friend of mine. And Vinny is very smart, strong, is a very sharp guy. He just says like no sugar, no grains, no vegetable oils, no sweet fruits. And for diabetic, and no starches. And if you're type 2 diabetic, one of two things will happen if you follow that basic approach. You will go into dietary remission, or your A1C is definitely going to come down with that. Now, that sounds shocking at first.
Yeah.
But once you understand, or for example, when you become fat adapted, your appetite changes. So you're not like hungry all of the time. And when you eat, you stay fuller longer. Yeah. And the desire to have all these other things, they diminish. They may not all necessarily go away. For example, I will struggle with nuts. I like nuts, but nuts are very and addictive. Nuts can become like potato chips. You just can't stop. You want to keep. Yeah.
I totally agree, because 3 years back, when I started reading The Carnivore Code by Paul Saladino, I remember it was just a transition from keto into carnivore. And, it was so tough, Tony, when I was reading that book. Usually I would finish reading a book within a month. That's the longest I take. Now for the carnivore code, it took me almost 8.5 months to finish that book because there was so much of elimination. There was nuts to be eliminated. There was spinach to be eliminated. There was broccoli to be eliminated. And I'm wondering, what am I going to be left with on my plate?
Yeah. Well, my answer to that is you got to find what works for you.
Yeah.
So it's not like I look forward. It's not like I eat broccoli every day, but if I'm going to have a vegetable, or if I'm in a situation, yeah, that's probably one of my go-tos. Broccoli, one of the cruciferous vegetables will be the rule of thumb is if it's a vegetable that grows on a leaf or above the ground, it's probably going to be better. Anything below the ground, now you're in, you're in carb territory, and you shouldn't do it.
Yeah. And then there's also that addictive nature that then you keep going back to those same or similar kind of foods.
Right.
Because like you said, you're hungry all the time. Your blood sugars are fluctuating.
Yes. And you're also dealing with, and I've been fascinated about it because these new class of these GLP, GIP agonists, the drugs, Ozempic.
Yeah, I was just reading about Ozempic a few weeks ago. People kept
they are finding that not only is it helping people stop eating because they stop overeating, but they find that it helps with cravings in general. They are finding that it is helping to reduce cravings for alcohol or other kinds of behaviors, addictive behaviors. The problem is we don't have long-term data safety. There's one massive what I would say phase 4 drug experiment going on in the population, where we don't know yet. We've usually found that for every drug that does something miraculous, there's an underside, or there's some.
We have to wait.
There's nothing for free.
There's something behind it.
Some price there that's
got to be paid.
The patient's going to have to pay, not just with the wallet.
Yes.
But there's got to be some type of help because it's a manipulation of the balance of the system of, we look at your body as a system of signals.
Yeah.
And if you get the signal, then this happens. And if it doesn't get the signal, then that happens. And it's a whole breakdown of things, all because we're not eating properly. We're not eating in the manner that supports the proper signaling and functioning of the body.
Absolutely. And I would call this as even the term hormonal imbalance. Everyone that I hear today is talking of hormonal imbalance. And I tell them your hormones will be balanced when you eat the right quality of the food, not by suppressing it with medications or by, other forms. So yeah, it all bottles down to your nutrition, to your choices, right?
Yes. Yeah. Correct. It's always.
You were a vegetarian, I believe, for some time.
I tried vegetarianism in the 90s, and it was a bad experience for me. Because when I went to the doctor thinking that, and this is before my type 2 diabetes diagnosis, but it was when I got the warning of that glucose intolerance. What are you doing?
So you were vegetarian.
I'm doing all these fruits and vegetables and juicing and all that. I'm thinking and I go get my blood test, and the doctor says to me, "What the hell are you doing?" I said, "What are you eating? What are you?" I go, "Nothing. I'm doing fruits and vegetables."
Yeah, they're so healthy.
Doing juicing and all of that.
Yeah.
I go, "Well, because you got like 600 triglycerides. I said, I'm going to have to put you on a drug called Lopid if you don't stop." It's 600. Yeah.
And this is on a vegetarian diet.
Yes.
Unreal.
Well, it just goes to show you that it's not just because it's vegetarian, it doesn't mean
it's a lot of carbohydrates because
there's too much.
You have to make up for that loss of whatever you're not getting, the nutrients that you're not getting. You have to make it up.
Yes. Yeah, that's exactly. So yeah, and also to me, it wasn't as it wasn't the satiety. That is another thing.
The signaling is not
You should eat to the point where you feel full, not overeat, but that you feel full. And that wasn't working for me with a vegetarian diet.
And for how long was this?
I was doing the vegetarianism for probably about a year because I was kind of like experimenting at the time because I was like looking at different
juggling
ways because I was overweight. I was like, oh, let me go on a low fat, complex carbohydrate, all this, like, come on.
I know.
And then and then I remembered Dr. Atkins, who warned me. He said, no, Tony, you've got to, he says, you're borderline. Don't wind up like your my father had diabetes, and my mother was just diagnosed with diabetes. So it was almost a fait accompli.
Whoa, that is really sad. Genetically, that's one of the factors that people keep adding to their statements. Oh, it's genetic. Well, I said it's not genetic. It's your dietary pattern that's genetic. You've been eating the same way that your grandparents or your parents have been eating. So it's your eating pattern that's hereditary.
I use this example to help people understand genetics.
Yeah.
So just because you have the genetics, it doesn't mean that it's going to happen. Think of when you think of mold or mildew, it only happens in dark, damp places. If the room is dry and well lit, there will not be mold or mildew. It just doesn't happen there. So diabetes is like a switch. You should know that you have the switch. Don't turn it on. It's like the dragon. You've got the dragon, you wake up the dragon breathes fire and causes real problems. Don't wake up the dragon.
I'm going to remember that. Don't wake up the dragon. But tell me, Tony, I see a lot of meat eating states very high in diabetes. Their rates of diabetes are exemplarily very high in these states. And I really wonder, what is the problem when they're eating meat? Why is the rate of incidence of diabetes at a rise? There has to be some connection somewhere. If you can just help me with that.
Well, it's a very interesting observation that's coming from that research, but the research that begs some more deeper scientific inquiry. And it's like, what is the meat being eaten with? And let's remember something else. The hypothesis that I believe is, if meat is fat and protein, energy concentrated. Remember also the body, when you eat protein, the body will metabolize it into either waste or metabolize it into glucose, gluconeogenesis, if the body requires it from protein. So excess protein will get excreted, but before that happens, if it's needed for gluconeogenesis, it'll be used that way. And more metabolically efficient. It'll actually burn more energy to do that. But so when you think of it, that's a source of energy, one type of fuel, two types of fuel. And then you have this other fuel, this carbs, which it's like, think of wood kindle, just throw it on a fire and then boom, it like burns quickly, rapidly. But if you're overloaded here and you're overloaded here, what is diabetes? The diabetes is the inability to manage all of that energy, particularly this one, the glucose. So they're blaming meat for what this did. It's and then here's the other thing that they haven't been able to show me in studies where eating meat and water alone will cause diabetes. They haven't been able to show that. And it's a study that's been done. Here's the thing, the ignorance is profound. the Arctic explorer Stephenson did this study at Bellevue Hospital in the 20th century. He did 6 months, meat and water with patients. They all thrived. They had no problems because Stephenson was fascinated by the peoples that lived in the Arctic where there are no vegetables or fruits. They were only eating meat, whale, seal, fish, that kind of thing. And any foods they also were also eating a lot of fermented foods too. This is because when they had a very short season, they would ferment whatever berries or whatever. That's another. That was also something else that was very interesting. So that's the question that we should be asking when we say, well, why is there a high prevalence of diabetes with meat? Say, well, what else are they eating? And then separate
the two energies,
the two, and test and see what results you get. And I will say, if the science is consistent, I think Stephenson, he will be vindicated once more. And all of us who follow this primarily carnivore type diet, keto carnivore diet, we are vindicated by our own personal experience, because I don't care how many plant-based people come to me and tell me, oh, I go, dude, or hey, I have normal A1C. I'm like, I'm doing fine. I don't have here's the other classic thing that you see that's is if people who have insulin resistance, they have the pot belly.
Absolutely.
So my stomach's flat.
Yeah.
So, and so that's another warning sign that you have too much energy. And so you got to get the energy under control. So how do you do it? Stop this so that the body starts to use the stored fat, and all of this and then you will achieve a balance. And then and your balance is only possible by your ability to utilize and manufacture insulin.
Yeah. Would you recommend fasting? Because then again, when you do a ketogenic lifestyle and then you combine it with intermittent fasting, I think that just works like a miracle.
Well, yes, I do intermittent fasting. As I said, I was traveling and I just came off of I would say a 36-hour fast. And I'm fine. I mean, this morning I worked out, fasted, and then I just had an espresso with some cream, and that's it. And then this afternoon I'll have a nice sized piece of meat, and that's pretty much I should be fine going into the next day. If I want to have something else, I would, like I said, I'll heat up some broccoli and olive oil or butter or something like that.
Nice. What do you think needs to change in the healthcare policies around the globe? And the reason I ask the globe is because, of course, we are all fighting a common problem. So that includes India too.
Well, there has to be a reevaluation of the whole global food production and what's being sold to people.
Yes.
And on one level, there has to be a look on the pharma side of this as to we should be incentivizing people and companies to start. We need to go back to looking for cures. The whole economics is all screwed up because prevention and wellness is not as profitable as sickness and disease. And that's the contextual problem. And it's going to require policy changes to think about, how do we incentivize our society to focus on these things? Why are people getting rich off of death and disease and sickness and all of that, instead of the businesses and people who are actually keeping people healthy and living well and a quality of life? That's kind of a broad policy guide, but we have to look at things like guidelines. We have dietary guidelines here that actually have made the world obese and diabetic. And there needs to be accountability there. We have to stop. If something's not working, don't let it be human enough to say, doggone it, we were wrong. We need to change course. That's a biggest struggle I've seen in politics is I was wrong, I apologize, or we can't keep doing this because it's not working. There's always someone that no. You got to keep.
All about you. You did it wrong. You did not follow it.
Or God, heaven forbid that my whole reputation in life was staked. That and then all of a sudden I was wrong. I was proven. That's life. Sometimes that's the way things evolve. So, that's the contextual. Specific things like we're here in the United States. I'm really glad to have been part of the movement that moved to protect nutritional supplements and botanicals, herbs, and those kinds of things from being placed into the drug category, and was involved in getting the laws changed. And that that law does need some updating. Something. I was at this ingredient conference, and and I tell you, if you're going to buy supplements, if you're interested in a particular ingredient or botanical, look for the products that actually have the ingredients that have actually been patented and have some research. So, for example, Indians can relate to this Ayurvedic medicine. There's ashwagandha is a great botanical, it's excellent for anxiety. It's a calming, yes, it's a really great botanical. Well, they've done the research and they found that the substances that make ashwagandha effective, there's companies now that have isolated it, and I think of this, it was like a free plug for them. But if I'm going to buy an ashwagandha product, I want to make sure it has KSM 66, which is the patented, where the company is guaranteed that this ingredient will deliver and have the precise amounts of the effective components of the ashwagandha. So this is the approach that we have to look towards. And when it comes to food, it's about going to organics, avoiding the seed and vegetable oils. I would rather see them being used to burn in cars as biofuels than in our body.
Thank you for saying that.
Well, here's the thing. So how do we get industry to move away from food and into energy? Well, that's where that industry and energy industry should be getting together to go, okay, how do we scale the economy, make it feasible to start using this oil, to move our motor vehicles or, further, but to stop eating this. And how do we incentivize the right kinds of oils that actually will support the health? If you don't want to eat animal-based oils, you still have the avocado, you have the coconut, you have the olives. I mean, in Spain, one of my favorite things to do in Spain is I go to the olive oil part of the country there, and it just smells fresh of olive oil. I brought back like this giant 4-liter jug of Spanish olive oil because I knew it was pure, and I got it right there from the factory.
Absolutely. We're never testing our sources.
I'm sorry?
We're never testing our sources. Where are we sourcing our
Yes,
products
exactly.
from?
Exactly. So we have to look at, as a society, look at the laws that incentivize and reward the correct behaviors and de-incentivize the wrong ones. If it isn't profitable, then people are going to stop behaving in that less profitable way.
Yeah. Absolutely. Is there any policy or reform that you are planning to change in the near future?
Well, one thing I'd like to do here in the United States is legally, there is no legally reinforceable definition of the terms low carb or ketogenic. Right now, it is Wild West. The consumer, really, it's really buyer beware, caveat emptor.
Yes.
You have to do your research. You have to look at the ingredients. Just because something says it's keto friendly doesn't mean it is. Just because it says keto doesn't mean it is either. The people are using that term very liberally, not strictly applying criteria.
Yeah.
So there needs to be some regulation like that on the books so that ethical manufacturers can compete fairly and not have the unfair competition by the unscrupulous manufacturers who don't care and are just trying to make as much money as they can, trying to fool the consumer who doesn't know or understand what keto means. They just know, oh, keto, that means I'm going to lose weight. I'm going to burn fat. That's the sad reality of the marketplace. The consumer is, for most purposes, ignorant. And part of our job is to educate. These three, if you're in this business, three things I tell you. You inform, so you tell a person about the problem. You educate, what are the solutions or answers to this particular situation, and you entertain. Try to make the process fun or an experiential way that the person goes, okay, I get it. Or, yes, I remember that person told a very funny story, but now I understand what the point that they're trying to get across. So that's marketing 101.
Yeah, because there are a lot of products that are being marketed as with the term healthy, and this is again a misguidance for people, where you're taking on all these foods only because they are saying it's a keto product, but they never really look back at the ingredients and what those ingredients mean.
Or even the nutritional profile that, are the 20% of calories coming
in
from
from weight?
carbohydrate? Yeah.
So reading labels, I think, is another aspect we need to look into, to teach people and to educate them how to read labels so that they are not fooled on a daily basis.
That's the challenge, and that's a challenge that government literally has, and it's literally and legitimately has, because it has to put it out in language that people can understand. And the tragedy is that most people's comprehension level has not increased; it's decreased. And that really does not serve the society as a whole. It may serve interests that keep power in place, but that's not really the best interest long-term of the society.
And we have to keep looking to change that.
Yes.
Daily.
And it's events like this that we're doing here, and they're able to do this globally, makes it even more profound, because this is how transformation happens in a good way.
That's the reason when I started the conversation, I said the Metabolic Health Conference is an event with the purpose to heal. We're wanting to educate people to heal themselves, but of course, with the right learning, with the right coaches, we're trying to wash out the misinformation. We're trying to make them unlearn. So I think there's a lot of unlearning that's going to happen in this entire 3-day conference that we're doing.
Yes.
Thank you so much. Tony, I have one last question for you. I know I'm taking up a lot of your time, but you've been so kind enough to be with me here all throughout this hour. What is your message to my country, India?
Wow. In the brotherhood of humanity, India is one of man's roots, with a very deep tradition, a very spiritual tradition of the whole question of man always wanting to connect with God and through life. And you are a hope for the free world, because we are in a world now where of the forces of totalitarianism, autocracy, socialism. And I don't want to say that in a way that in a way that it is, these are forces that are seek to control, undermine, and go against basic human principles. So my message is, in the area with health, we need to work together. We need to empower each other to be creative. And we need to reward achievement, and we need to change the playing field back to give health and wellness a level playing field to compete and prevail over sickness and disease.
Lovely. Thank you so much, Tony. It was so wonderful. Like I said, it does not feel that I'm speaking to you the first time. Thank you. Let me call on Shashi sir, and I think he would like to say a few words before we head on to our next.
Thank you, Tony. Thank you very much for accepting this invitation. In fact, when we had podcast 2 years back, that time we told that we are going to have a conference, and I'm going to invite you here for this conference. So we are so glad that me and Anup, that we could keep a promise and get you in this first event.
Well, when you do this live, I look forward to being one of your speakers, and looking forward to visiting and spending time in your wonderful, magnificent country.
Thank you. Thank you. Anup.
Yeah, thank you, Tony. Thank you for joining this session. And, 2 years back or 3 years back, when we did this podcast with Shashi, you had said, do it once in India. So all I have to say is we have heard you.
Yeah, thank you. No, and bravo. And looking forward to the next evolution of this. Much success and blessings.
Thank you.
And thank you for giving me this opportunity to be with you.
Thank you. Namaste.
All right. And my contact information on Twitter is the @US AMBCUBA. And look forward to communicating with everybody through that channel. And now Twitter has the ability to call and video. So technology is going to actually bring us closer. It's going to bridge the divide. Have a beautiful evening over there. My day is starting. God bless you all. Take care.
God bless you, Tony. Thank you. Thank you, guys. Thank you so much. Please carry on the next session. Welcome, Cecilia.
So please get Cecil. Cecil, welcome to India virtually.
Thank you. Thank you. It's my honor.
So my co-organizer, Anup Singh.
Yeah, welcome to India, and thank you for joining.
Thank you.
So you know Anup Singh very well, but we will interact briefly in a moment. So you know all about me. So nothing to introduce myself. Anup, you can just briefly introduce yourself. Though Cecil knows you very well. Please briefly introduce yourself.
Yeah, I'm a diabetic, type 2 diabetic since February 2011, and almost completing 13 years in next 5 months. Pill-free and non-diabetic A1C. When I say non-diabetic, it is 5.6 max and 0 pills. Now, I founded dlife.in. You are very well aware. You have added that site on your website. So that was founded in 2014, 9 years of existence. And we have grown from, being just a community to now we are offering low carb certification courses with the intention of building an army of low carb coaches. That's in short.
So let me have the pleasure of introducing who Cecil is. Cecil Shade, she is the founder of metabolicmultiplier.org. Very interesting site on which we are going to discuss shortly. So Cecil and her husband has been keto since October 2017. They founded Metabolic Multiplier in 2018. Keto helped Cecil recover from a skiing-related traumatic brain injury, as well as to manage osteoarthritis condition. In the process, she drops 3 dress sizes and has lost 50 pounds. During this period, her husband put his diabetes and hypertension in remission. Very, very interesting, which we have seen in many cases. Also, she's of all medication he stopped all his medication, lost 12 inches off his waist and dropped 70 pounds. So Cecil first saw the first-hand impact of the treatment-resistant mental illness on our extended family. I think this is again a very emerging science which we are seeing of late. And this has the hope for potential effectiveness of metabolic psychiatry. Very, very interesting. And of late, we have seen a lot of discussion around metabolic psychiatry, and a lot of studies are also being carried out. So I think it is an apt moment that we are getting to discuss everything. So Cecil, please tell us about your background.
Great. Well, thank you very much for having me here. So this is my second time around in seeing the standard of care in medicine change. It is very possible, but it can take decades. My congenitally deaf son received cochlear implants 3.5 years earlier than the standard of care, which was 5 years at the time. With a lot of effort, we helped him to acquire normal speech and language, which was not even imaginable at the time. I said, don't even hope that he'll attend normal kindergarten. And he did. He's in college, works in with other people, hearing people wouldn't know if they didn't see his implants. So it took a great deal of effort, but we've now, the new standard of care is to implant kids by 1 year of age. So we've seen it happen. Now I'm also a mom of 3. My kids are aged 20 to 24. I have an MBA from Harvard, so I'm a little different than the average clinician practitioner here, and I bring a different skill set to bear. Professionally, I've worked in strategy consulting, marketing, digital marketing, and a great deal of nonprofit leadership. So that's my background.
Great. Anup?
Yeah, it's interesting to know, that you're married to an Indian and you take pride in calling yourself Indian Bahu, if I'm not mistaken. Now,
absolutely.
Yeah.
I get along famously with my in-laws. I'm the Chota Bahu, so I'm completely spoiled, which I love, as they do as well. My husband Raj was raised Jain. He attended Doon School, and then he emigrated to the USA for college. We've been married 26 years and together for 29. I've been to India over a dozen times. We go again for a trip Monday. And we've hosted family here from India often. So I'm pretty comfortable with both veg and non-veg contexts. And most of my in-laws are still Jain vegetarians. And for the birth of every child, one of my sisters has come and stayed with us for 2 months, helping and guiding us through early child rearing, for which I'm very grateful. So this is just a small token of my trying to give back for all they've done for me.
I think that is very interesting. See, you are the first person from the Western world to call us veg and non-veg. Otherwise, this concept is known to only us. In India, we call us as non-veg and non-veg, whereas others, they will say as meat eaters or something. Whereas here, non-veg means anyone who has eggs and upwards, eggs, meat, fish, chicken. So that's how. So you are very well thorough with India, and we will actually, during the course, we'll find out what are your interests and how you are helping India also. Many of us may not know this. So Cecil, please tell us what got you into this low carb world, what and how. You can be as detailed as possible in this.
Okay. Well, my husband, Raj Kumar, had tried to control his diabetes with the standard of care for 10 years. He had a high carb, low fat diet, intense exercise. He'd get up at 5 a.m. and, every day without miss, before going into the city or even with the gym in the city. He managed to lose weight, but his medications kept increasing insulin production to reduce the serum glucose. And as we expected, as this group would expect, his type 2 diabetes progressed for 10 years. And his doctor indicated that injected insulin was expected to be the next step and his standard of care. But Raj had watched his mom die very painfully of diabetes complications, and it was definitely a fate he wanted to avoid. And most of his family, or many in his family, also were suffering from diabetes, as is not uncommon in Indian households. He researched the space. He found the Two Keto Dudes podcast, which is still, a great source if you just want something to listen to. And he realized that he had to try the ketogenic lifestyle, low carb and high fat, the opposite of what we've been eating. I joined him in support, and our kids and all of our various guests have all loved the yummy home cooked meals. So that was pretty easy for us. Raj had normal serum glucose levels within 6 days. After 10 years, it reversed in 6 days. He eliminated his sulfonylurea and all 6 other prescription medications, including statins, metformin, and blood pressure medications. In 2.5 months, he had an A1C of 5.8 and a blood pressure of 110/70. Now, Chris Palmer had asked me, did you guys go slow, or did you guys kind of do the big bang? We are just kind of a big bang. We go all in on anything we do. And he had done the research and then, changed the pan. So we did very much big bang. And we were lucky that we did not have a lot of other symptoms. We knew about electrolytes and salt, but some people have more and need more help in transition. Now, I still had lingering traumatic brain injury symptoms and arthritic knee symptoms, and I needed to ice my knees literally daily. In addition to the weight loss benefit, I no longer ice my knees. The TBI symptoms finally abated, and I can hike again. So the change for me was absolutely dramatic. I thought we were going to have to sell our house with the stairs, and now it's no big deal. Overall, we both feel great with this lifestyle, and we intend to maintain it indefinitely. And, for us, it hasn't been a really hard transition, but we did it together. So I really encourage if it's in your family or without your family, we all need that support network.
Very interesting. Now, I'm very curious to know one thing, that what was his diet before and after?
Plenty. We were the classic American diet. We've always been big cooks. So we would literally get their banana boxes. We get 3 boxes of banana boxes of vegetables once a month. We would have about 1 week a month would be strict Indian non-veg or veg, because we'd go to visit my in-laws, and when my kids were little, they didn't want to have, it was unfamiliar food. They want familiar food. So we kind of, till those groceries were done, we would cook vegetarian, and then, he's a big meat fan, so we'd also have non-veg, but we wanted our kids to be very comfortable with both. But we were very, very, very low fat, and very, so we cooked, we had real food, but it was a lot of carbs.
I think so. That was how it is. Okay. I thought whether he was primarily a vegetarian earlier and then shifted to a little more protein from meats or eggs. Okay.
He was, he would, we'd buy the Costco beef, big loin wrap and cook it up and do steaks. And he was a very big meat eater. But when we'd have family here, we'd be veg for the 3 months. At least I would be. I'd put all the non-veg in one corner and label it. I think in my experience, Indians are way more tolerant than American vegan environmentalists or American vegetarians, because they're not, it's new for them. So, my family didn't make me do it, but I remember going in the garage once, and I see my son with this busted look of horror. And he was getting meat from the fridge. So I was like, no, sweetheart, it's okay. But, easily have been vegetarian 6 months without a problem. That's it during the time before. And you can be, you just need the right, you can even be vegan. You just need the right supplements if you're doing this lifestyle. If you're vegan, you do need to work with a practitioner for supplements.
So that means when your in-laws comes there, so that means you shift to a vegetarian diet and still manage the blood sugars.
Yeah.
And that
yeah.
way you have
So
covered a
you
good
need to do yeah, my husband actually looked at all of the recommended fasting for vegetarians in the Gen culture, and it's 60 days of fasting a year. And the whole idea of not eating after dark, obeying circadian rhythms, there's a tremendous amount in there that, and you're also avoiding some of the starchier things. His mom didn't have the potatoes and onions, so you really need to combine those. And one of my sister-in-laws lives in Toronto, and she's very much still vegetarian. Her husband's non-veg. They were in an A&W. And she was a patient of Dr. Fung's, and that's of the fasting, Jason Fung of the fasting method. And she was able, with low carb, to reverse her diabetes and get a lot of control. You also need to sleep and the other things as well, but you can absolutely do it either way. You will hear more of a metabolic psychiatrist in particular talking about nutritional ketosis because we have more literature there than anywhere else. And your average IRB, which is a review board that approved for a hospital that will approve studies, in America, they're terrified of, not eating for more than a day, whereas India still has those fasting cultures. So the fasting studies, there's less literature in terms of published studies, but there's a lot more history to it. So that's an advantage that the Indians have, that you have more of the, I only wear yellow on Tuesdays. It's a concept of fasting that you can bring to your vegetarian lifestyle that will help you stay in ketosis. But that's why they talk about nutritional ketosis, is because that's where the research is, not because it's really therapeutic ketosis overall.
It's very interesting with you is about the American culture and about the Indian vegetarian culture very well. And I think you have really adapted this situationally. Very nice.
Well, thank you. Thank you. I really saw there was a gap in the literature. I mean, what we do with Metabolic Multiplier is really, how can we give back? And I had the knowledge of both. So that's, if I see something that's missing, then I'll either write a post, or if there's a lot of good information in there. And that's where I found D-Life India. It's like, I reviewed your literature, you guys were nailing it. And, that's where I came up with the idea of doing a post of the best of low carb in India. And
so we'll come to
missing,
we'll come to Metabolic Multiplier later.
Hanji?
We will come to Metabolic Multiplier later.
Okay,
I want to save this discussion later on.
Hanji.
Anup.
Yeah, Cecil,
Great.
as we understand, roughly only 12% of Americans are metabolically healthy, if the numbers are right. So of the 88%, what kind of metabolic disorders do you see, if you can run us through the numbers?
I don't have the numbers, but what I felt was helpful is that we've organized the almost 5,000 studies regarding reduced carbohydrates worldwide. And if you look on my website, there's 3 metabolic portals help you out. So we put together a small team organizing research, and we organize conditions into 3 buckets, which is the metabolic disorders, neurological disorders, and a third set that seem to have a metabolic component. And this is the adjunct treatment for other treatments that are there. So that, and you'll see that at research.nutritionnetwork.com, or you'll see the 3 where I am. Now, on Nutrition Network, we curated basically there's 40 plus conditions that fit into these 3 buckets. And we organized all of the research around those. So you can see the metabolic, high level, and then we'll do like the top 20 studies or articles per each. And we've tried to organize them that if you don't have any familiarity, if you're a cancer doc and you have someone come to you with PCOS and you really don't know much about PCOS, you can then, where would you want to start? That's how we try to organize them. So that's one, the curated portal, We then have on Zotero the nearly 5,000 articles if you want to dive deep. And that's where it's very easy to do a lot of research because people were having to reinvent every time the research, pulling together literature. And then separately, there is almost 12,000 articles that are including the rationale behind non-veg, including animal products. So this would include vegetarians having dairy and ghee and those other things, because there's some important nutrients and vitamins that are hard to get without animal products. So then you can do your own research. You can send your own doctors there. And then there's a volunteer who works with Nutrition Network who keeps up the first two. And then Travis, her name is Sarah Rice. And then Travis Statham keeps up the last. So Metabolic Multiplier is, we don't charge for anything. And so therefore people are happy to volunteer because we're not making any money. We're just trying to give back.
So Cecil, I will jump to the question now. I will jump to the question. What is Metabolic Multiplier and who came up with this idea and what all you did? And I will, once after you speak, I am going to display Metabolic Multiplier in the screen.
Okay. So we explore the effect of lifestyle on metabolic health. A friend and I started, there was one other woman locally. She didn't have a local support network. So we started meeting for lunch. And then we were like, after once a month. And we did that for a while. And they were like, everyone else is working so hard. We've benefited so much personally. How can we give back? She's a nurse doing psychotherapy and has for 35 years. So we have completely complementary skill sets. And we started helping where we could. We helped Chris Palmer with his first site. We helped Society of Metabolic Health Practitioners, who you hear after this, and have worked with many others in the space, helping them with various things. And we have no outside funds, no financial conflicts, which encourages it to be volunteer powered. The other thing is I really wanted to know, what of this stuff is real? I'd heard circadian rhythms. That sounded like hooey to me. So in order to better understand for myself, we organized a bunch of low carb practitioners to vet around common interests, because that's what I'm good at. I'm an MBA, a manager, around common interests, and vetted the information that you see on the website, because you really don't want your health information from a Harvard MBA. You would like to have it from practitioners with expertise in the area. And then we really got to see where there is consensus and where there is not consensus. And we focus on those areas. So I've talked about, we curate and amplify existing information. For example, we have a post that lists the 20 plus directories of low carb practitioners. So help you find, it's still a lot of work, but help you find them. And then I've also recently started adding a directory of reliable information sources that are respected by low carb practitioners. So I'm not trying to redo what's already out there, but if you're new, you're like, okay, is Diet Doctor real or not? Is SMHP real or not? It's like, yes, these are respected, sources, as is Charlie Foundation. In addition, there is a big difference between the metabolic conditions, people supporting those, and the neurological conditions, which have come out of the epilepsy world. And for those folks, they worked for 100 years trying to get some credibility. And I think the standard of care is now you have to fail 4 medications before they'll put you on, suggest trying the keto diet, which seems to me like it's a low risk, low cost intervention. You at least want to try it earlier. So they have kind of stepped away from the therapeutic carb restriction world because they want to protect their hard-won credibility. And that's where the metabolic psychiatry world, you tend to need the high fat. For the metabolic conditions, you don't see the high fat necessarily. And Adele Height, who wrote the therapeutic carb restriction and was very involved with us before she passed, her dream was that for each condition, we'd come up with a version of what works best. Like for migraine, salt is and electrolytes are particularly important. Low carb or carnivore helps, but what are the things that matter? And we really try and tease that out.
Nice. Very nice. Anup.
Yeah. What made you, to have a section focused on India specifically?
Well, honestly, I did it. I knew the information. It was just natural because I'm pulling together all these other things, and you talk to clinicians, and they wouldn't know in America or Europe, South America, because I've had people all over the world involved in our team meetings, and they don't know what to do when there are South Asian patients. They don't know, and there's a ton of great resources. There's resources in Bengali and Hindi and, have been translated to these things. I think Dr. Unwin's sugar metrics are in 18 languages, but people don't know. So and they also don't know who's real within the low carb world and who's also throwing in magnets or something that's either emerging or doesn't have any has little basis with the other stuff. So that was why I started to put it together for my own family members and self. So that's where I did it. And there are sections for, Desi's, if you're in a Desi culture, you know certain things. Other people are trying to add Desi food, they're bored with whatever else they're eating. So I have sections like, hey, if you're American or British, it's talking about where do I get this? What do I do that? So I really tried to meet all of those. And frankly, if anyone has anything else you'd like to add, please let me know. I would be happy to. And I think that's where the directory also helps. You could just go ahead and put that listing in for yourself. And one of the other things that's emerging is that it appears that there are different ethnic genotypes. So while people are people and we suffer the same conditions, the biomarkers are quite different. So many Asians at a much lower weight will get diabetes. They talk about TOFI, thin on the outside, fat on the inside. So the biomarkers for a South Asian or someone who is African American are very, very different than those for other ethnic groups. So I also have a link to that literature as well that you could give to your doctor if you're not in India and you're part of the Desi diaspora. Then hey, check my insulin or check some other things as well.
So that means your metabolic multiplier in the India section. So this is specifically useful for not only people from India, but even people across the globe.
Hanji, because many in the UK, for example, they talk about curry being the national dish. And some of the authors most of the authors are Indian, but some of the people who put together great guides are not Indian. They just know the area really well. So I think that's helpful. And that's where D-Life India can also be helpful, or working with you is that, Shashi, is that, if I am in Indiana and I really don't have, a lot of support, that it can also be helpful. So I really tried to think of who within this community, what might they want to have, and have added whatever I've seen. And I update it a couple of times a year.
Okay, so that means you update it very frequently. So that's why. So it was updated till 2023 is what I see.
Hanji. Yeah. So I had done it a few years ago, but then I update as we see other things. And some people, one of the other issues in the community is that we're kind of all fighting for credibility, just like with cochlear implants. And some of the folks will have other interests. For example, one of my other interests are native plants in New Jersey, because I live in New Jersey. Well, the people who are interested in metabolic health may not want to hear about native plants in New Jersey because they live in Colorado or Delhi or somewhere else. So it's not that relevant to them. So I think that's one of the reasons in this space, people don't share each other's information, because they don't want to undermine their own credibility. If we've had a few cases where that person then, went into another more controversial area. And as a for individual people bringing their authentic selves to the space, that's great, but that's as they should. But I think it's now, as the space has grown up a little bit, it's time for organizations with a set mission statement to take over. So you've done that with your Metabolic Health India, with D-Life India. And that's why when I'm talking about metabolic health, I post more from my co-founder Nurse Christy and I post more from Metabolic Multiplier than we do our personal accounts, because we're speaking under this umbrella, and we're trying to be diet diplomats and very practical, very reasonable. Anyone who wants to come to space, my 85-year-old mother isn't necessarily going to give up her Greek yogurt for breakfast. Trying to get her to have the Greek yogurt for dessert after dinner, but she really wants it for breakfast. Okay. So, there are other things that she can do that will help, like time-restricted eating. You have to look at this basket, with Chris Palmer's book, it shows us that this basket of metabolic interventions are really helpful.
Very nice. So what I'll do is I will briefly display the website.
Great.
Yeah, I think it's live now. Everyone can see. Can everyone see?
It's visible, sir.
Visible, huh? So this is the Metabolic Multiplier site. While it has a lot of information, so this page is devoted to India. Something has changed. So this is devoted to India. The guide to best low carb Indian foods 2023 is updated till 2023. And this is what it contains. The leaders in South Asia, low carb cuisine, the practitioners or fee-based coaching program, the influencers, social media community, guides, recipes. While this has been made for the Indian diaspora, however, India can also benefit because it has a lot of information which is valuable for all of us in India. So that's how I see it. So these are some of the practitioners she has mentioned. So all those who are Indians, she has also mentioned. So they may be India, they may be abroad also. So like we all know Dr. Nadir Ali also, very, very famous. And some of the coaching programs like D-Life In. So you had mentioned D-Life In also with all the success stories. And this was a little surprise for us. One day I woke up last year and suddenly I find a mail, you telling that you have included me. So I'm here. So I'm here as the influencer of using social media for low carb. So I'm here. And me and Anup, so both of us are here, in fact. So we were so thrilled and surprised to see that, though we never had any contact, but then you picked us up from the social media. And we were really thrilled. Me and Anup were really thrilled that day.
My honor. You all have done a phenomenal job. And I knew nothing of you, because I think you'd perhaps focused on the domestic market. And you're doing a tremendous job. And for anyone with DAC patients, South Asian patients across the world, it's helpful.
And even the guides to reducing carbohydrates in Indian food, you have put in so many links, including, of course, the Headbanger's Kitchen, which is famous in India, and also Dr. Anwin's sugar infographic. So very interesting, Cecil. Today we had Dr. Anwin in our session. So he was mentioning that there has to be in more languages. So Anup has committed to him that we are going to translate many of his infographics into many Indian languages, and which we will do.
Fabulous. And that's another, one of the value adds we've had in the community is just connecting people. Because I guess I had not realized, but many clinicians are introverts. They're meeting with one or two people at a time. And I'm an extrovert and I'll call up anybody. And it's a lot easier to call up someone on someone's behalf. And, I've cold called Dr. Unwin, Sean Baker, all kinds of people, Jeff Volk, and who have been very, very kind.
So there are other things like you have made something like you have given the recipe for keto dosa also. I think that is something which everyone will love. And all all those websites in India who are going to speak something on keto, and also the genotypes specifically the Asian Indian genotype susceptibility to diabetes is also given very nicely. It has you're depicted the same. So ethnic Indian, Asian, the population who are little susceptible to diabetes, and you are given all the relevant journals also. So culture and reducing carbs. Yeah. So I think, Cecil, it requires one more updation. And
Sure.
that is, you will have to now add Metabolic Health Conference into this.
Absolutely. And I was going to ask permission to either use your graphics, your schedule
Please,
graphics and stuff.
I'll send you
Great.
I'll send you the original ones,
Yeah.
please.
Yeah. And in the directory, please, people, if you know of other, I will add folks from the conference. But if there are other people and things I have missed, I'm not trying to make money. I am trying to help folks. So please, submit them to the directory, or send me an email through the website.
We'll do that. And I'll just come to the home section, like you have just mentioned all about metabolic multiplier. So this is I think relevant to everyone, not specifically India. So all the health
absolutely.
practitioners.
And it's also very much what we have found that is our useful ways to discuss it with other people. And here, like the low carb, can low carb agree to disagree on these 12 topics? This is where Adele Height and Sarah Hallberg, before they passed, this is the list of things like, saturated fat versus seed oils, or grain fed versus not. It's like, it may be good, but the science isn't settled. And if what you can afford is what you can afford, then that's what you should have. And it's also, I think, so it kind of helps you to see what's the best, what's the worst. I did something different for the Black culture community. We went through ketosis versus ketoacidosis, is the going through some of those terms that they may be confused about. Metabolic health, there was not a good definition. So when we started out, so we put together, instead of doing a roundup post, we created one. First, we could only get people to say, well, it's absence of disease. Okay. And then after thinking about it for a while, Adele was like, I think I can make it in a positive way. So we have both of those. Lifestyle medicine, there's a place for prescriptions and supplements and procedures, but usually the order of magnitude largest effect is with lifestyle. So let's help people to start there, and talk to your clinician when you want those other things. But our website's pushing the lifestyle stuff, whereas people are not making money. We have best resources for clinicians, best resources if you're just starting out, like who's credible. And if you're starting with D-Life India, great. Anyone in our directory, you can just start there. You don't have to read all the others. How to build my ketogenic therapy team. We've worked with my extended family has schizophrenia, so growing up. So I'm sensitive to, hey, I don't want my kids, my kids are just coming into the age where this comes on. How can this help? I wanted to know that. So that's something I've dealt with on the website from early on. And this how to build my therapy team is like, okay, there is no metabolic psychiatrist in my rural or even small city. What do I do? Well, this is how you can bring that expertise together. I could bring an experienced keto clinician such as Shashi, working with my therapist and talking with Chris Palmer and the other metabolic psychiatrists like Georgie Eid and Shabani. All of them have been absolutely, Ignacio Carante, have been wonderfully helpful whenever we've asked for things. So
I think this is what,
and if you scroll down again, let me point out the one that has all the research. It says 3 metabolic portals, so it might be on the next page.
So which one should I click?
Directory? But if you search,
which one should I? Disorders or
no? If you search metabolic portals, it shows.
Where exactly is it?
Metabolic Health Portal. So that's where you can find all the research. So you don't have to organize everything. I guess that should be on the homepage. But that will help you figure that out. And then organizing how we think about metabolic health factors, that's really how we that's the organization structure that we put together.
And I think this is what we were talking about, segment-wise, diabetes or depression or schizo or Alzheimer's.
Yep.
So I'll just click on diabetes.
Hanji.
So this is, and very nice information about diabetes. Very nice. And especially the patient toolkits for pre-diabetes, type 2 diabetes. I think you are given really very, very nice information. I think many of us from India can actually use this.
Absolutely will work. And the one on the left, Eating for Metabolic Health is Easy. It's got a letter you can give your clinician. It's got very straightforward stuff to start with. It's got a downloadable overview, download a PDF version of the guide, something you can give your clinician. And it's written in a way that your clinician who doesn't know about this isn't going to be afraid of it. So it's really written with that audience in mind.
So I'll just click one more disorder, anything. Let us say Alzheimer's.
Okay.
Very interesting topic.
And, might keto therapies fight Alzheimer's? I think the argument's pretty strong that it helps. But the clinicians have taught me to be very careful with our language. So we try not to overstep, which is one of the reasons which has given us more credibility. So,
and you also described Mary Newport's experiment also.
Yep. And frankly, Mary Newport, the main intervention she did was 2 to 3 times a day. She gave her husband a tablespoon of coconut oil. And it has, as you know, very high and medium chain triglycerides. And if you look at the 2 leading dietitians doing treating epilepsy and going into the mental health conditions, they say that's where they start their patients, is they do, a couple tablespoons of MCT oil. Now, if you don't like coconut, you can pay a lot more money. The taste of coconut, and they'll pull the taste of coconut out of MCT oil. But that's where, India is at such an advantage because, you've probably grown up with coconut. You probably can think of things you like to have that have it in it. So that is a great place to start but you need to start long before you start having hardcore symptoms for Alzheimer's, because it seems to be the 10 to 20 years before when you have mild things. So that's a great intervention right there. Just 2 or 3 tablespoons of coconut oil. And I can tell if I can tell the difference, probably because of my TBI. But if I'm feeling a little off, I have a tablespoon of coconut oil, or a spoon. I don't measure it.
So in the intervention, you're given nutrition, lifestyle, sleep, stress, exercise. I think you're really covered it very holistically. I think there's going to be single information, health literacy, again, a lot of information, and of course the directory, of course, what we have seen. So I'll stop sharing this. So Cecil, what we will do is we will give you information about the conference so that you can put in, because there's going to be a regular affair now. We're going to have
fabulous
conference also. And
fabulous.
And probably once Dr. Anwin's infographics are ready, probably he will also inform you, and that can enter into the India section. So that will also be useful. And possibly we'll give you maybe some information about some doctors in India who are into this low carb keto, and you can include them because it's going to be a very big resource for Indians.
And that's also where it's helpful having, I've looked from afar and gone through their websites, but you've heard them speak, you've met them personally, so you know who's doing this. And then there are some who have, who are kind of adjacent to our space, who are pushing whatever they're selling. They're pushing their supplements, etc. Those are, so those are the folks I'm not including. So, I mean, you can still get a lot of benefit from them, but we know that the lifestyle first. So that would be very, very helpful.
And I think, let me specify very clearly to the audience, it is metabolicmultiplier.org. Very simple. Metabolicmultiplier.org is the website. Please visit this website to get very good information. Whatever doubts you have about, if you have doubt that whether it is ketogenic or whether it is ketones or ketoacidosis, a lot of confusion, everything, confusion will be cleared here. A lot of resources for Indians, which website you can go for recipes. Of course, it is there. DLife is already there. Plus, you can also update about the nutrition course which DLife is offering. I think that's a big resource because Anup Singh is building an army of low carb coaches in India, and that is going to battle this terrible metabolic disorders in India. So Anup just gives a few statistics about the course.
Course content, if you talk of content briefly, it's about 200,000 plus typed words that would run into around 600 pages of printed book. Now 800 odd references. And it's a 6-month course spread over around 240 lessons and topics. At the end of the course, there's a test sort of. And then, doing the course is fine, but since we have a community, now that community has got 8 years plus of curated data. Now, curated data means every thread there is a reference in itself for anybody doing the course. For example, we have dealt with diabetes, we have dealt with the hypertension cases, real world cases. So anybody doing the course can always see how in real world scenario, a coach is handling the case. So it's a mix of theory and practicals. And the popularity of the course, yes. So far, from 6 countries, we've got enrollments, and it'll go down the line. I'm sure it'll, spread further. And close to 100 now is the enrollment, and 30 have already completed the course. So they are practicing individual. So that is in brief.
So do create an ID and give it to Cecil so that she can also go through. Very interesting, and you'll appreciate the stuff which is there. So Cecil,
you've done a wonderful job, and so many things of the little things like I wanted doses. really missed my doses. So how do I do that? And people talking about how they do things like weeknight meals. It's not necessarily a whole recipe. I mean, one of the things I struggled with for a decade with Indian cooking is I measure everything. That's how I learned to cook. And I'd have an amazing meal and I'd ask my sister-in-law or my husband, like, what did you do? And they're like, I heat the oil and add the usual mix of Indian spices, and I'm lost. So it took me a decade to really kind of crack the code on that. But that kind of, being able to speak to you the way you cook is very, very helpful.
As far as recipes go, the community has got around 1,200 plus Indian recipes.
Amazing.
As posted by members after trying and testing. So it's all a ready-made resource. And in fact, today, Dr. Ranvin, in his session, he specially remembered the recipe section of dlife.in. So we'll give you access to both the course and the community. You can always review and, get back if there's any improvement required there.
And it dwarfs the other resources. So it's a phenomenal source.
Right. So in the end, we're coming to the end, Cecil. What do you feel about the terrible metabolic disease in India? You have been closely associated with India. What do you feel when you see in your relatives on the other side, on your husband's side? What is it that you see?
Yeah, I'm very, very hopeful. I mean, almost everyone has some form of something. So of the adults. So, but I'm also very, very hopeful. You have these religious traditions of fasting, both food and other things, intermittent fasting within the circadian rhythms and eating windows. And, if I talk to friends here, they're like, yeah, fasting is in every major religion's traditions, but fasting was back in Jesus, and he didn't really go 40 days and 40 nights. That's not possible. So I think that that's very helpful. I think another strength India has are these strong relationships, communities, and family bonds. Before World War II, my father grew up in an extended family in southern part of America, in Alabama. And he said it was really easy to find a family member to talk to. And we know from the metabolic psychiatry that social connection, purpose in life are very important. You still have those. I remember when I'm 9 months pregnant, walking past a do in the neighborhood with my sister-in-law, and she's like, okay, so if you went into labor now, could we just knock on that door and ask for help? I'm like, absolutely not. I would not, even if I'm 9 months pregnant in labor, I would not knock on a stranger's door. So India, you have so much stronger community bonds. You still have an emphasis on real food versus ultra processed foods. You know, you at least know someone in your family who still cooks. You know, I used to tell people, oh, you know, this is really like the health ways and food ways of your grandparents. And I now have to say great grandparents, because in America, it's like, no, my grandparents didn't have real food, but India, you're still closest to it. I think home cooking, it's much, much easier to control the added sugars. So that's where it gets a lot of people. And that's where wearing a continuous glucose monitor will show you, oh, you think that this is fine, but it's not. So home cooking is closer. And then you have a tradition in healthy saturated fats like ghee and coconut oil. So it's accessible. And I have seen several family members who have tried this with us, and they can't imagine not having a roti with every meal, but they're then able to. And I think you can absolutely do it with vegetarian as well. You can do veg or non-veg. It is easier if you don't include animal products, then you need supplements. So work with your practitioner, but you can do that as well. So I am very optimistic, but I'm also an optimistic person.
Fine. Very, very nice. Anup?
Yeah, thank you. Thank you for, accepting our invitation. And one thing before we sign off is I love the way you say Haji. That was pretty interesting.
Well, I lived in Germany and I'm fluent in German. I worked in privatization in Eastern Europe after the Berlin Wall came down. That dates me. And I knew that when I feel very close to someone, I would go to the informal you. And that has a lot of cultural significance. So like the executive secretary is like, oh, well, she's American, I'll just go to do with her. Do is the informal you. But then like I'm invited to her house on Sunday for brunch. So it has a lot of cultural significance. And I wanted to make certain that I never was disrespectful or use the informal with my father-in-law, who was the sweetest man in the world. So I would use Hanji with the little kids, and they just thought I was hilarious. But I just Hanji, I use the most formal language with everyone, and then I was golden. So
very nice, Cecil. Very, very happy to interact with you, and we are so happy to have such a fabulous portal, fabulous site where we can refer. And thank you for including me and D-Life in as one of the part of India low carb movement. So Cecil, what is your final message to India? Couple of 2, 3, 4 lines. Your message to Indians.
We've got this. It's not that hard. If you go back to what your grandparents or great grandparents, if you're young, ate, those traditional health ways and food ways are now backed with science. So I can speak more for Genism, but just, hey, I'm not eating after dark. They say 3 hours between your last meal and going to bed, you get into a deeper REM sleep, and you're more likely to prevent the those tangles that are associated with Alzheimer's. So there's a cultural excuse right there. How many times have I said been with someone who's like, oh, well, I don't eat Thursday night, or I don't eat, and I know it's difficult with the traffic in India, and it does have a very late night culture of socializing. But I think you have easier contextual conventions, social conventions that will help you do that. So I'm very, very bullish on what we can do as individuals. And it's going to take a decade or two. Luckily, I'll be followed by Doug Reynolds' Society of Metabolic Health Practitioners, and they're doing a tremendous amount to help speed those decades of transition. But I'm very bullish.
Thank you.
And it's very possible in India or as part of the diaspora.
Thank you. Thank you, Cecil, once again to accept this invitation. And we are so lucky to have an Indian Bahu coming and speaking to us of what she has done for India, sitting abroad and having a full website full of resources. Thank you very much. I'll see you again.
Hanji, I'm honored.
Namaste. Namaste.
Namaste.
So we can take in the next guest, Pam and Doug. They are already here. Good morning. You have to unmute them. Yeah. Doug and Pam, welcome.
Thank you, Shashi.
This is
awesome to be on here.
This screen is so nostalgic. And I'll show you why it's so nostalgic. We met 2 years back. Or is it 3 years? Anup, when was it? 2 years?
Yeah, 3 years, around 3 years.
3 years.
Yeah,
Time flies so fast. 2020?
Yeah.
Great, great. So what I will do is first, before I introduce both of you, I want to show something. I'll show a video.
Okay.
This is so interesting, and I so love, and I kept this video ready for the exact moment. Yeah, so this was in 2020. So all four of us again in the screen. So
that's great.
Low Carb USA meet D-Life in India. And Doug, you're wearing almost the same clothes, almost.
No, that's not. There's no sweatshirt.
I will play this video
I have it in the cupboard, but it's not cold enough for a sweatshirt.
So I'll play the video for a few seconds. We will hear what Anup says. Word again, final word. Anup.
Thank you, Doug, and thank you, Pam, for sparing roughly around 100 minutes now. It's big time, and hope to meet again. And as Shashi said, holding conferences is uncharted territory for us.
No, we will help you with pleasure. Don't worry about that.
Yeah, we would need all the help because that is something which we are not having any experience or any knowledge. So sure, we'll be looking at and hope we can do it jointly. That's not an issue.
So thank you. So I'm stopping the sharing here. So this is exactly what we told 3 years back, and again here we are here, and we have invited you for this India's first Low Carb conference called Metabolic Health Conference, and I'm so happy that finally we could organize.
Yeah, welcome, Doc.
Yeah, thank you very much.
So I will first introduce both of our distinguished guests, Doug Reynolds and Pam Devine. Doug is the founder and CEO of Low Carb USA. The original organization was founded in the beginning of 2016, and the initial intention was providing a platform through annual conferences for internationally renowned scientists and medical practitioners to present the ever-increasing body of evidence on the benefit of reducing carbohydrates in the diet and adding healthy fats. I think this was a very big initiative you have taken. It is just that we don't believe, but we have medical practitioners coming in and producing evidence, which is very good. Doug also felt that the education about the power of low carb ketogenic for individuals may not get the information from their medical team or from the mainstream nutrition advice for the practitioner who may be able to prescribe it. And he is also the president and founder of SMHP, Society of Metabolic Health Practitioner, which represents all the researchers and practitioners working to improve the metabolic health around the world through education, training, and support of evidence-based nutrition approach, including carbohydrate reduction as a valid therapeutic option and intervention. And I'm so happy to say that I am one of the accredited member. I am the first SMHP accredited Society of SMHP accredited Metabolic Health Practitioner in India. Me and Roshni Sanghani, Dr. Roshni Sanghani, we are the only two ones. We had a good discussion with Dr. Roshni. She kicked off the event on the first day. And Pam Devine is the co-founder of Low Carb USA and also the founding member and full-time volunteer of SMHP. Besides her role as operation manager for Low Carb USA, Pam has an unyielding advocate for the value of therapeutic carbohydrate reduction and the lifestyle to improve metabolic health. Through her work, she aims to educate individuals and especially health professionals about its science-backed benefits, which holds promise in improving metabolic health and offering benefits, and potential reversal and remission of a long list of medical conditions, which includes diabetes, pre-diabetes, fatty liver, cardiovascular disease, hypertension, even Alzheimer, epilepsy, and all the mental health disorder, which is an upcoming science as of now, and also PCOS. And her mission, clear and unwavering, is to amplify the importance of metabolic health to empower more professionals to be an informed advocate. She had recently earned her MHP accreditation from SMHP in all these endeavors. So I want to welcome both of you to this historic event, Doug and Pam.
Thanks, Shashi, man. It's awesome to be here.
Thank you. We're very honored to be here. And thanks to everybody who's joining in and listening and joining the discussion. It's an honor to be here.
So we'll just briefly know about both of you. Doug, please tell us about your background and what were you earlier and how you came into this low carb field.
So,
and you have a connection with it. You have a connection with India also.
I do. So back in the day, I was an electrical engineer, became a software engineer. Software engineering wasn't even a thing back when I was at university. And we were working on a satellite TV set-top box, new one that Bharti Airtel was introducing in India. And I spent about 18 months basically pretty much living in Bangalore, spent some time in Noida, Delhi, and then our factory was in Chennai, so I spent a bit of time there too. Yeah, and I think my story about how I got into this, I've told it on a lot of different podcasts and stuff like that. And Pam always says to me, like, you say the same thing every time. And I say to her, well, that's the story. If I said something different, I'd be making it up, right? But I understand it can also be, and her story and mine are really intertwined. So I feel like maybe this time I'd like her to actually tell the story from her perspective, because I don't even know if it's ever really been recorded. And now that's both our stories about how we got into it anyway.
Fine, and you speak, yeah.
Ah, that's funny. Okay. So yeah, our stories intertwined. Prior to learning about low carb, Doug and I were always trying to live a healthy lifestyle. So there were some transitions in our jobs, and but in the background, we were always promoting nutrition, sports nutrition specifically. Doug talks about his background in engineering, but he's a very big background in marathon running. And he often tells that story about how, it was always about carb loading. And so we would bring, volunteering at our local running club, bring what somebody fondly started teasing us about, sugar water, pink sugar water, because it was a carb loading based drink. It had a lot of electrolytes, but it also had a lot of sugar in it. And we all thought that's what you needed to run with. Doug had a history of over 100 marathons, training marathons for ultra marathons, and he always carb loaded. He does remember though getting to the starting line and struggling and thinking, I'm not fit enough, I don't feel well. But those 3 days before, it was pizza and pasta and potatoes and every big plate of carbohydrate that he could get his hands on, because the theory was that your body could suck it up like a sponge and then use it on the day. But he felt terrible. And so my story talking about nutrition, and healthy eating, I tried to help him with low fat, healthy carbohydrates. So brown rice instead of white rice, and brown whole wheat bread instead of white bread, and eating more vegetables. And I was introducing more fruits. And I was, a healthy breakfast for me, if you think about the beginning of 2015 and before, middle of 2015 and before, was I would make my own oatmeal, and I would put nuts and some dried fruit like raisins and dates, and I'd have a banana and a low-fat yogurt with some fruit. There was very little protein in my breakfast, but it was a lot of carb. And I was shocked to think about how many carbohydrates was in it, because then I went and I got a coffee and it had low-fat milk, but it probably had a lot of sugar. And I learned from my dad and somebody else to put chocolate in my coffee. So I had a dessert coffee, but it was low fat. And, we would go to work, and by 10 a.m. I was shaking. I was hungry. I had a headache. And I was telling Doug, I have to go over to the delicatessen and get eggs. I wanted like hard-boiled eggs. Thankfully, my body was smart enough to tell me, don't go and get more carbs and sugar. It was like, you're missing the protein and the fat that you never had 2-3 hours ago. So I was going and I was getting that. And then lunch was, let me try to eat salmon and a fresh vegetables from this restaurant that was nearby. And I would go for a walk on the way there and, try to be healthy. I was outside in the sun. That one lunch place, another place had salads with a little bit of protein and low fat. And then I'd walk there and I'd walk back. And we were more active than anybody that we worked with in our office. Everybody was much more overweight than we were, but we were still putting on weight, even though we were walking at lunch, running after work at least twice a week. We were meeting our running club on Saturday. We were doing marathon training runs. We were meeting with them for 5 hours and running on Saturday morning. Doug and I actually both did a martial arts training for 5 years. And during that time, we were leaving work early and driving to martial arts and doing that twice a week, sometimes 2 classes, so 90 minutes of martial arts while we were drinking our sugar drink, mind you. And then getting home and having, we did try to get a protein snack, but I'm sure there was quite a few carbs. And Doug got into this really bad habit of pulling out bags of candy, thinking we'd worked really hard. We worked really hard at martial arts and running. We could have more sugar and carbs, and piling chocolate candies in front of us and like divvying them out and giving me some. And I remember sitting on the couch thinking, okay, Doug, I've had enough sugar. I can feel my heart doing this. I was getting super hyperglycemic. I could feel it. I was like, okay, I had enough sugar. Like my heart's racing. It's nighttime and I'm probably supposed to be going to bed within 2 hours or an hour of this time. And I'm thinking, okay, no more sugar tonight. Tomorrow we would do the same thing again. And we didn't understand why we were slowly putting on weight. We thought we were active and we thought we were eating healthy. And I was starting to get very confused about what I was eating. So around mid-2015, somebody sent us an email that we've been working with in the nutrition field. We also did healthy corporate lifestyle expos where we talked to people about what they should do in nutrition. And we got an email that said glucose as a fuel or ketones as an alternate source of fuel. And we didn't know what that was. We were like, wait a second, what is this? And Doug really started going down the rabbit hole of what is a ketogenic diet and what is nutritional ketosis. He started reading Steve Phinney and Jeff Volek's work, which is a foundation of those 2 expert researchers. If anybody wants to go down that rabbit hole, fantastic. They have great books. The Art and Science of Low Carbohydrate Living and Art and Science of Low Carbohydrate for Performance. And we kind of went down the for performance rabbit hole, where Doug was really interested in how can I fuel my sport and how can I fuel my running. And as he was going along for about 2 weeks, I said, Doug, are you still reading about that ketogenic diet? And he said, yeah, that's fascinating. And I said, 2 weeks straight of reading about the ketogenic diet. But there was so much information even in 2015, but there's even more now. Shashi, I want to tell you something that actually sparked my interest even more was the movie, The Serial Killers, CEREAL, Serial Killers, the movie. Doug put that on, and that actually sparked my attention more than reading a scientific article or a book, because I saw Donald Collins doing an experiment of him starting a low-carb ketogenic diet, and where he was a little bit confused about where he was going to get his nutrition from, where was he going to get his fuel from, and then he did experiments of shopping and cooking, and how did he feel? And then he went and did sport. He was outside doing his little routine of push-ups and sit-ups and outside in a park and doing some running and talking about how he felt. And I started listening to this and I thought, this is really different, interesting. He's not eating grains. He's not eating rice. He's not eating pasta, but he still has energy to do his workout, and he's still figuring that out. So that caught my attention. And Doug says to me a few days, maybe a week or two later, okay, he says, Pam, I've got a list and we're going to the grocery store and I have a list of the things I want to get. And I looked at him first and I said, you're going to go to the grocery store with me and you have a list? He always fought with me about going to the grocery store. He says, oh, you go. I don't really feel like going, and just call me when you get here with the groceries and I'll help you bring them in. So what did we buy? Oh, go ahead.
Yeah. Okay, please go ahead.
So what did we buy at the grocery store? Meat, fish, eggs, bacon. I know you probably don't eat a lot of the different things in India, but that we were looking for. But if you're eating dairy, we were looking for full-fat yogurt. It was very hard to find in the low-fat yogurt refrigerator case. A little tiny bit of full-fat yogurt here down on the bottom of the shelf. Really hard to find, but we did find it. We bought leafy green vegetables. We bought broccoli and fatty meats and pork and all kinds of different things. And we brought it home and said, okay, we're going to do this. And Doug started losing weight really quickly. I, as a woman over 50, or getting to 50 at that time, found it a little harder, but I was getting more and more dedicated to try to figure this out because my pants weren't fitting. That Christmas before, I had asked my parents or my mom on my Christmas list, can I get some of those pants, the stretchy kind that don't have a waistband, because my pants don't fit me anymore and I'm really uncomfortable at work. And so I was dedicated. I was going to do what I had to do, even though it took me a little bit of time because I don't want to throw food away. I didn't want to waste the food that I had in the fridge. And I also needed to adjust my brain that I didn't need the cereals and the bananas and the beans and I didn't go to bread. That was probably easier to give up. Hummus was really hard for me. I really loved hummus and those kind of beans, but they turned to sugar, I learned. So as I learned more, then I was able to cut things out a little bit more. And then I finally started seeing results.
So you lost weight and you took interest into coming to this. So I hope there was no pre-existing medical condition like pre-diabetes or something.
I don't think so. The last test that I had before that was my A1C was 5.4. Now there were some months in between the time where I had that test and when I started the low carb diet and what I was putting on weight. So I had become, Doug and I are sure we had become insulin resistant. But one of the things that we're going to continue to talk about is that in the medical profession, and when we're getting our lab work, we're not testing for, it's not common to be testing what is your insulin levels getting to by this stage. Before, I mean, and 5.4 is already getting to pre-diabetes. We're trying to educate medical professionals. Let's start looking for A1Cs in the 4s, in the high 4s and low 5s. Let's start to think by the time we're getting to 5.4, we're getting a little too close to starting with pre-diabetes. And diabetes shouldn't wait until we get to 6s and 6.5s to say someone has diabetes and they need to do something, right?
No, and I don't think I ever got tested. So I'm convinced that I was pre-diabetic at the time when we started this. Kind of wish that I'd known about all these blood tests and stuff that I should have had a baseline bunch of tests done just to compare it to. But we didn't even know that was a thing we should be thinking about when we started. So yeah. So I mean that's sorry. Yeah, I mean that's how we got started on this. And then 5 months later, it was my birthday in January, and I was pounding my fist with Pam, saying like, "Hey, like, we need to." What we were doing in the business at the time involved putting on big conferences, and I was trying to say, how did I not know about this? Everything had come back to normal. My weight was back to what I was when I was running these ultra marathons in my 30s, and I just thought like, why didn't I know about this? And what can we do to help other people who don't know about this? And well, there were little conferences at the time about low carb, but nothing big. And I was saying to Pam, we need to put 1,000 people in the room. Like, this is ridiculous that people don't know about this. And so that's how we started planning the low carb conference. That was in January, and we ended up putting it on at the end of July that same year. We didn't have a website, we didn't have social media presence, we had nothing. And we found a bunch of speakers that were prepared to come and speak, and we put it on, and it was pretty amazing. I mean, Pam can like attest to this. Like, we had friends of ours that were helping us as volunteers that weren't even really keto at the time, and they had gone outside in the evening during the pre-registration that we had the night before to get something to eat, and they saw all these people running around in the street. And she said, or the both of them said, it was surreal. Like, these people were running around in the streets, like, so excited about the fact that this conference was on, and they were going to get a chance to meet all of these heroes of theirs and superstars that they had only ever seen on YouTube before. So yeah, I mean, and at the time we were only going to put on one conference. That was the idea. And then everybody was saying, so when is next year's one? And why don't you come to the East Coast? And we started planning. I stayed up through the night and started planning the one for the next year. And a few months later, 6 months later, in the January, we ended up putting one on in Florida, in West Palm Beach then at the time. And since then we've been doing like at least one in San Diego and one in Florida every year. We've done one in San Francisco, in Seattle. We've done a one-day one in Virginia. And we even took a few speakers over to Jakarta in Indonesia and helped a guy put on a conference there. And this one that's coming up in January is going to be our 20th event, which is that's a hell of a milestone. So we're quite excited about that. It's going to be pretty amazing.
How many conferences you have per year?
2
Well,
normally.
We've got to the stage where we try to resist it as much as possible to put on more than 2, because there was a time, was it 4 or 5 even in a 12-month period that we ended up putting on? It was hell. It was crazy, and we were totally overcommitted ourselves. Then saying that, we were literally on a call yesterday with a pharmacist who's based in Hawaii, and we're talking about possibly doing something like a women's metabolic health conference in Hawaii in March-ish 2025. So that will be a 3rd one that year that we do, but generally it's 2.
Very interesting. I think so. So you were the guys who started the first Low Carb conference in USA. So there was no one else.
No. There were other conferences on at the time. The Metabolic Health Summit was on.
Used to
in Florida.
be called Metabolic Therapy something. And Jeff Gerber.
Yeah, I mean, Low Carb Denver. I think they had one for the first time the year before. In fact, Jeff Gerber, who was the doctor who put that one on, was incredibly helpful with us to put our one on. He gave me a lot of help and insight and information into what we should even be thinking about and what we should be doing and what we needed to do to make this actually work. But they were small, and so when we ended up, we didn't put 1,000 people in the room. We put 350 people in the room. But that was still a lot bigger than any of the other little conferences that existed at the time. And Denver has superseded us. I think the biggest San Diego event we had before COVID was 650. I think they had about 800 or something at an event that they did in Denver the year before COVID happened. And they were going to put that many at least in the room again in 2020. And we actually were at that conference. And that was literally the weekend that the entire world shut down. So there was a lot of people didn't show up for that conference. And there's some of us that did show up and mentioned it on social media. There was a lot of flack that was being thrown around about, well, we shouldn't be traveling and we shouldn't have gone, and it actually got quite ugly. But I knew what Jeff was going through in terms of how much money he was going to end up losing, because he was still committed. There was no mandate that we weren't allowed to have a conference in the hotel at that stage yet. And so, we were going to, he had to do it. And I knew what the contracts looked like that he would have signed. And the room blocks that he had committed to, which he's on the hook for, the food and beverage minimums that he's on the hook for, that when those weren't met, he had to come up with that money. And it was huge bucks. And so we felt like the least we could do was actually show up to his event and show him some support, But yes, there were other conferences before ours, but I think I'd like to feel like we started to lead the way in terms of getting more people at these conferences, which was a kind of our aim. We wanted to get as many people, expose as many people as possible to this. And then the others all looked around and said, yeah, we could be doing more. And they've ended up getting some big numbers at their events as well, which is awesome.
It's nice that we could inspire others because others have inspired us. We also saw, we want to thank Rob Taylor at Low Carb Down Under, because he had done some original conferences. Tim Noakes had done a conference in South Africa, and we actually found those online as we were starting to get the idea of planning a conference. Doug had wanted to do a coaching program because he really wanted to reach the individual. And then we thought maybe we should think bigger. Like, these guys are doing conferences and we kind of have that experience. Bring the science, bring and provide a platform for people to talk about the research they're doing, to talk about the benefits and the outcomes of doing and changing, making lifestyle and dietary changes. And we really saw that the importance, Jeff helped us see the importance of having CMEs at the conferences and bringing more healthcare professionals, because the more times over that we heard from an individual that they couldn't find the help they needed because they were sick. They had a really bad car accident and they were injured and they couldn't get the proper help to help them with a brain injury, that we're now finding ketogenic diets very helpful with brain and head injury, the neurological symptoms, in injuries from stroke and cardiovascular disease and neurological disease that we're learning about. So it was very early on at that very first 2016 conference that we realized that we really needed to focus on the healthcare professional, reaching them and bringing them in to get the education and raise the awareness, because more doctors and physicians need nutritional information that they're not getting in medical school. And we need to continue. That's why we've made so much effort and commitment to make sure that we're reaching the medical professional, because currently there's a nutrition profession and then there's the physicians, and we kind of need to bring that together. Physicians and treating clinicians, like we have nurse practitioners and physician assistants here. That would be the part of the treating and the clinical doctor who needs nutritional information to bring to their patients, and make that more of an open process that happens more often and is more widely accepted.
And I think it's wonderful what you're doing is this conference, you're bringing the latest science and the evidence-based science. The medical doctors are coming and speaking on the therapeutic potential of low carb. I think it is wonderful, and all these conferences are actually changing the landscape. It is giving an option to people that there is something which is beyond the pill, and it can be adopted. No doubt pills will be useful. It has its own utility, but if someone wants a reduced number of tablets or want to get off anything, I think this is what you're providing. Yeah, Anup.
Yeah, Pam talked of, others inspiring for conferences. Now, 3 years back, we were inspired by both of you. And that's why, I talked of at least holding some sort of a conference here. So, though virtual, but we have made a beginning, and we hope to have, physical conferences also someday, for sure. Now, with that said,
that'd be amazing.
Yeah, I think we can help you with that. And
yeah, sure.
I think I mentioned to you, or Shashi, or both of you, that there's an organization called Health Quest that's just getting spun up now. They're trying to raise funding to actually do this, but they looking at creating this global, what they're calling a global ecosystem of doctors and health insurance and training and all sorts of stuff that that people can have access to. And one of the things they're bringing me on board for is to help them to improve the attendance at the current conferences that exist, and also to find gaps in the US and around the world of where it would be really good to have a physical conference. And India is definitely one of the top of the lists, from not even from us, but from them, saying, we want you to identify these places, but already you need to be looking at India. So they're already identifying the fact that something there, you've got such a huge population who so many are suffering that, it's really important that we try to reach more people by putting on, and because the thing is, if you put on a physical conference, then suddenly something's actually happening in India, and that becomes a thing that people hear about, and then the majority of them won't be able to actually come, but they will be able to join the live stream.
Yeah.
But they will have become aware of it in the first place because you're putting on this live conference, and that there's probably been, that's the kind of thing that we, as with Health Quest, we would help with, is to promote it and get it out to the media and make sure that people hear about it. And that's the way we spread the word, Like Pam's favorite quote from Prof. Noakes is, we're changing the world one meal at a time. And that's literally what we have to do, is go and scrape and slowly build up this thing organically. Because there's not going to be any help from the US dietary guidelines or any other kind of dietary guidelines that's going to encourage people to at least take a look at this. We have to physically go out and find the people, and involving India is a big part of that.
And we are ready for this, Doug. And in fact, let me tell you, me and Anup, we are hosting this from a state called Goa, from Taj Siddharthi, Goa, and we are enjoying all low carb keto menu.
Wow.
So we are ready for physical conference because we identified a joint where we can get our meals.
Where you can do it. That's brilliant. Yeah, no, I look forward to it. You know, you said in sometime in the future. I'm hoping in the near future. I think I would look forward to coming out and being a part of that.
Yeah,
Please,
sure.
yeah, we'll invite you. So now please tell us something about this SMHP. How did you come out with this idea? What it is and how significant it is for all of us?
Well, I think, again, I'm going to ask Pam to at least tell the beginning part of the story, because she had a conversation with Dr. Trokalajian at our Boca conference just before COVID in 2020 that I wasn't even aware of until a couple of months later. And that's really kind of where it started. So maybe Pam can talk about that.
Yeah, okay. Yeah, so Tro came in and I thought, you know, the first night it's pre-registration, it turns it a little bit of social hour. And he came in right away with, he wanted to talk about how much he thinks was needed, the work to put together a society to support the physicians and the clinicians who are working in the field. And we had a very long discussion where I actually wasn't ready for, but he was very adamant about the need for this society. As Tro can be. Very, and you know, he wanted to bring together a place that would support physicians who want to do this in their practice, bring together the evidence and the science and the research and the clinical protocols. 2019 in May, the clinical guidelines that the whole world of experts contributed to writing, and I've heard Adele Height's name mentioned earlier from Cecile. We all worked really closely with Adele, who had this mission to put this clinical guidelines together. I'll let Doug talk a little bit more about how he got the board of advisors together for that. Worldwide leaders that you've had, Dr. Unwin, we've talked about Prof. Noakes, you've had Gary Fekke on earlier today, who all contributed their expertise to this document, where the SMHP, the Society of Metabolic Health Practitioners, now has a home for the clinical guidelines of the application of therapeutic carbohydrate reduction as a valid intervention in practice, where it has the research, the history of nutrition recommendations. It has all the nuts and bolts of what is a ketogenic diet, what is a low carb diet, what is a moderate low carb diet, what can you expect to see, what can you expect to eat, what can a physician make sure he needs to focus on with medications. Do they need to be just deprescribed off of medications before making adjustments in their carbohydrate intake? They're going to need to make adjustments in the medication they're taking that isn't unnaturally or through pharmaceutical intervention lowering their their blood glucose. So they don't want to eat a low carb diet and then take a medication that's also lowering their blood glucose, because then they're going to have a problem with really low blood sugars, and we don't want them to get sick doing this. We want them to be able to take them, have the physician be able to take them off of the medication and then lower their blood sugar naturally through their diet. Same thing with high blood pressures. You don't want to have somebody's blood pressure coming down from the nutritional changes that they're making, because there's been probably a few people who talked about how high carbohydrate intake and high insulin as a result of makes people have high blood pressure. So once you change that, their blood pressure is coming down and they'll need to change their blood pressure medication. So many people are taking blood pressure medications. So they need to make sure that doctors are aware of how this needs to happen while they're doing that. So those are just things that we want to talk about through the SMHP. Doug, is there anything-
I mean, to go back to the story of how it came about was Pam had this big conversation with Tro, and nobody told me about it. And one of the things apparently
I tried
that he did say,
so did you talk to Tro yet?
one of the things that apparently he mentioned was like, we need to have this organization, and I think Doug would be a good person to do it.
That's true.
And I was unaware of that, but he obviously had this bee in his bonnet, and so in February-ish, a month or so later, I actually saw him. He put a Twitter post on, saying we need to have an organization that represents all the metabolic health practitioners. Well, he didn't actually use that term. That came along later, but basically practitioners that are using this intervention in their practice, they need support. And I wrote to him, and I wrote to him and I said, we're already starting to do that, or we had the idea that it was necessary. We had this concept of a professional membership in Low Carb USA, and we had by then published the clinical guidelines on the Low Carb USA website. And it got, a lot of people got to see it, but it wasn't the right place for it. We didn't have anywhere else to publish it. And then so I spoke with him, we went backwards and forwards, and eventually decided that we needed to have this organization. By then, COVID had come in and taken over the world. And I was sitting at home and I started to create this nonprofit organization, which was kind of working with the government and organizations to try and just get the licenses, and all of the stuff that needs to be done officially was even more difficult now, because those departments were originally shut down and then they opened up again with skeleton crews working from home and all of that kind of stuff. But somehow we managed to get the nonprofit established. I put a board of directors together with a lot of people that I think you're having on during this weekend. And in the December of 2020, we actually launched it. And we had no idea whether anybody else would think it was a good idea. And yet we launched it and suddenly people started signing up. It was incredible. And as Pam said, now we've migrated the clinical guidelines there. We've got a really cool provider search database now that people can search for type of physician, their name, what kind of specialties. They can put in a zip code or a country in the case of India or something, and try and find people that there. We don't have many, I don't believe, in India yet. It's something we need to work on. We got a whole ton of people in Malaysia and Indonesia, all based on that trip that we did with Gary Fedke and Georgia Eid and Garrick Westman, that we went to their conference there. And a whole ton of their doctors he's a bit like me. This Tio Presateo that organized this. He's an engineer, but he's helped his son with cerebral palsy to basically walk again by changing his diet. And so he goes around personally and he holds grand rounds at hospitals and places, and he now has hundreds of doctors following him and following this low carb practice. So he's done an amazing job, and a lot of those people have already signed up with the SMHP as providers, which people can do for nothing. Like, it's to put your information in there is free. Contact info, what you do, everything. In order to listen to the grand rounds that we do and to become accredited, which you mentioned earlier, you were the first Indian accredited SMHP member. But you know, we need to be able to get more of you guys on board. That's the whole thing. But what I think I was trying to say is we got so many people that joined as members. I was going to say you need to be a member in order to become accredited. You need to be a member in order to join the grand rounds and participate in the forums and everything. And we thought that would be a problem, and yet more and more people are signing up. I think Pam was the 70th person that eventually got accredited, and we've had a few more now that have come through since. And we were in Australia a few weeks ago at Low Carb Down Under, and we were in Denver at Low Carb Denver in March, and we had a table at both of those places, for the SMHP, and so many people came to the table, was saying like, we're so happy that we were able to find you guys, and I'm about to get accredited. I've got one more course to do before I can submit my application, and so we know that there are tons of people that are in the pipeline somewhere in that accreditation process. And I often say, I've tried so many businesses and so many projects and stuff like that through my life that I thought were brilliant ideas, worked really, really hard at implementing them, and nobody came. It turns out I was the only person who thought it was a good idea. And yet we still did this, but I was really nervous because this has happened to me so many times in my life that I'd done something and created something and put it out there, and nobody thought it was a good idea. And I was really nervous that this would be the same, but it's been pretty much the opposite. Anybody that hears about it sees immediately how beneficial this could be. We saw in Australia, that was one of the reasons that we went there, was to do a presentation there about the SMHP. And there was a lot of people at that conference that didn't know about that it even existed. And so many people came up to the table and said, I can't believe I didn't know about this. This is amazing. This is just what we need. And so, yeah, establishing that accreditation process, I think, was one of the best things that we did. But since then, I was telling Pam, she was asking what else we need to talk about, and I had also to make sure that she reminded me if I forgot to talk about it, and that's the journal. There was a journal of insulin resistance that existed that had very little going on. And we approached them and said, look, we'd like to take this over as the SMHP, make it the official SMHP journal, rename it and rebrand it to the Journal of Metabolic Health. And we literally announced the launch of that. I actually was finalizing it on the long haul flight over to Australia to go to that conference a few weeks ago. So the journal is launched now, and we really know tons of people that are looking at and trying to find out how they can submit case studies and papers that they, trials that they are doing. And we feel like that's going to be such a big thing in terms of adding the perception of legitimacy to the existence of this organization, to anybody who hasn't heard about it, wants to look, and they can see, wow, they've got this accreditation process, they've got a journal. This is a real medical society organization, and it's not just some fly-by-night group of hackers that have decided that they want to do something. So we're pretty proud of how it's evolved, and I even said when I ended my talk in Australia, was like, considering we've got our 20th conference coming up in January, and that this SMHP has evolved out of that and exists and is doing so well. That's pretty amazing for the two of us, thinking that we put on one conference in San Diego back in 2016. It's been incredible.
I think that's an incredible journey you have, and I am also so happy, and I'm very proud to display my SMHP accreditation. And that is why when we met last time, and we and Anup, we spoke to you that give some recognition to D-Life diploma course also. Plus, you can add some more courses, and you will have a lot of members from D-Life coming in as for the accreditation itself. So this itself is a potential member, and we need a lot of metabolic health practitioners in India. We need with the kind of metabolic disturbances, disorders we have. It is just like a huge mountain, and Anup is trying to somehow bridge it or win the mountain through an army of metabolic health practitioners here as coach currently, but we would like to have a tag of practitioners. I think we will look forward for this collaboration in the coming time. And regarding the SMHP, I think there are a lot of resources there. Download like the CGM, the insulin resistance part, the low carb, and even I think you had a TCR present. Of course, the information on TCR, and I've seen even you had put some information on Dr. Anwin's studies also, I think.
Not so much about his study, but it definitely the sugar table that he published that's been used around the world. But just to go back a second, Pam actually mentioned that we should probably do this. You mentioned that you are accredited and everything, and maybe we want to turn the tables on you a little bit and say, when you saw this, what was it that made you think this is something I need to do? And how, I know you say you display it everywhere and you talk about it a lot, but how valuable is this to what you're doing and to anybody else who might want to be doing this?
So your question is to me or Pam?
To you,
to me. Very good. See now, see that accreditation is the mark that we have gained the highest knowledge of this, and then we have support of an organization behind my back, a support of a organization which is involved in a lot of conferences, evidence-based science, and I think that it itself is a stamp of approval that this person has sufficient competency and knowledge, and this is how I see, and that is how it is. So that's why some of even our D-Life members have done not only D-Life course, they have even joined Nutrition Network course in the preparation for getting this SMHP accreditation. So I think, and this is the way forward. I think you guys have made something very big, and this stamp of approval is something which people will yearn for, and it is aspirational. Let me tell you, it has an aspirational value.
That's amazing. Yeah. So that's kind of what I wanted to hear you say, because that's what we were hoping it would mean to people, and the fact that so many people are working on it and have already achieved the status makes us realize that that what we were hoping for was actually coming true. And this was totally unscripted, right? So we just asked you out of the blue about that, and so the fact that you said exactly what we want to hear without scripting it is pretty amazing. And
you will find that logo in my Twitter DP, even in my LinkedIn.
Everywhere. That's cool.
So I'm very proud to display that, and the amount of respect I get even from international community is huge when they see that this is a guy who is having that accreditation from SMHP. It has huge value.
That's so amazing, and I want to talk about my appreciation for that, because partnering with the Nutrition Network for the courses and all the evidence-based information that's all been put together for you as a practitioner to learn, to have guidance from, to use as validation of, to say I have this education is really important. For you to display that very proudly means so much. And we hear often, and not that we're surprised, but it just validates the work that we're doing to put this all together, because doctors have written to us and said, this means more to me than the day I got my medical degree, because now I know I can make a difference, more of a difference than I was making. And it's like, wow. It gives you chills to think this is changing the face of their medical practice. It's changing because doctors are getting frustrated. They're not making the difference that they went into medical school to make. Their patients are becoming more metabolically sick. There are more patients, like Dr. Unwin talked about. He had a couple of patients with type 2 diabetes, and they were in their 80s 30 years ago. Now, every other patient has type 2 diabetes, and now he has a solution for them. But it took him over the years. He had to learn this, and it wasn't from his medical school. His patient, Doug tells a story that Dave came back and told him, he says, my patient was angry with me that I didn't have this information for her. She learned, the one first patient that taught him, she learned it from somewhere else, not from him. So we need to raise awareness and bring more information to more medical professionals so they can provide these tools and resources to the patients to help them and support them to make changes, and how they can not have type 2 diabetes that's chronic and progressive, that you're only going to get sicker, that you're only going to need more medication. It doesn't have to be that way. And also in a medical professional where we had a physician write to us a couple of years ago and say, I'm doing an expo and I want to use the logo. Can you send me the logos that I can make a poster? They're allowing me to make a presentation about metabolic health at my organization. And we were so proud. We're like, that's amazing. And then she linked us to her website, and it showed us that she was using her logo. She was showing her accreditation. She was listing all the things. What is metabolic health? What is metabolic disease? What are the things that we can go over with you and fix? Like we were just talking about high blood pressure, lowering blood sugars, type 2 diabetes, and a whole list of other things. But she was also able to tell us that accreditation, like you're saying, brought validity to her metabolic health practice. She was able to bring that to her organization and say, I have this training. I'm a metabolic health practitioner. I would like to open up a metabolic health clinic at our organization. And they allowed her to do that based on her education. It was a pilot program to start, where she did a part-time office. But as the couple of years that have gone by, she has more and more referrals from endocrinologists, from weight loss doctors, from the general practitioner who says, I have a patient who needs to lose weight, who wants to lose weight. And that with your help, I know they can do that. Cardiovascular doctors are sending their patients to her because they know that she has information about heart health and maybe limiting the possibility of having a stroke, and all their blood pressure, women's health, helping them with PCOS and infertility. All of these metabolic health problems that can be addressed by looking at insulin resistance, lowering blood sugar, lowering insulin, and her organization is understanding this, which is fantastic because we need more of that. It just reminded me, I wanted to tell you because I don't want to run out of time. I know you probably have some feedback to that, but it reminded me that Matt Hawkins, who's the head of our resources committee, who's been helping with those handouts, the insulin resistance handout is free and downloadable on the smhp.org website. Everybody can download insulin resistance. What is it? How can you help it? How can you reverse it and get more insulin sensitive? Just some basics. A physician can make a poster and put that on their wall. A dietitian can make a poster and put that on their wall. The therapeutic carbohydrate reduction one, the TCR one, you can just print it out as a handout. You can download it and send it in email as an e-document. posted on social media, any of these documents that we're talking about. The resource committee headed by the doctor of clinical pharmacy that we were talking about in Hawaii, head of our advocacy committee, has worked with the other MHPs that you know, Tia Reed and Karen Zabaka and the people in her committee to put together that insulin resistance one. We have a CGM. What is the benefits of a CGM? What is a CGM, first of all? What are the benefits? How do you use it? One for patients, one for practitioners. So some of them are variable for the patient and the practitioner. You can look, there's 2 different places that you can go on that resources tab. But on the practitioner one, Matt Hawkins, the head of the resources committee, has put together a video and a slide deck that people can use who may be a practitioner who want to go to their organization and say, I want to start a metabolic health clinic. This is why. It has statistics of metabolic dysfunction, how many people have insulin resistance, how many people are getting and will be forecasted to get diabetes in the future. And this is how we address it. And I want to do this in my location. So he's put together resources for a physician assistant, a nurse practitioner, a nurse to say, I want to do this in my practice, and this is how I want to, this can help them approach their employer or their organization.
And I also need to jump in here quickly because it was something that I forgot, is that the clinical guidelines that we migrated over to the SMHP has also been translated into like 11 other languages, 10 other languages. And Hindi is one of them. And we're actually working with Gapriya to get it in a couple of other major Indian languages as well. So yeah, any of your physicians or whatever that may be listening to this, or that you can even print this out and give it or send it electronically to people that may be interested. I think that's pretty cool.
I think they are very, very interesting development. And I think everyone should know that the kind of pioneering work you guys have done. And I think the achievement of floating this MHP was something, it's very big. And I think it's a game changer. Personally, I see that it's a game changer. Even you have changed the name of Low Carb USA Conference to now Symposium of Metabolic Health. So everything is diverging towards, it's going towards or unifying towards the metabolic health. And one part is like, as I say, that seeing me, many people are inspired now in India. They keep asking me, how do I do this? How do I get the certification? So that is, and my wish is that each of my colleague or friends in DLife, everyone should have this SMHP certification. That is my sincere desire for all of my colleagues, because I think that is going to be a game changer in helping the population. So I think Anup and you can work together and get some sort of recognition, so that by adding a few more courses to this, maybe from Nutrition Network, we can design something for India, so that my colleagues in DLife diploma courses can also get this accreditation. So I look forward for this. Anup, you want to say anything?
Yeah, that's all. That's all we are nearing about. We've got about 3 minutes left. So
yeah.
Before we close, what are the future plans? Besides, of course, collaboration, between us, what are the future plans?
I don't know, to just keep finding ways to get this out there. Yeah, like when we had the first conference, we didn't have any future plans, and it's just everything's just evolved. So we constantly, I think this Health Quest might be the next kind of phase of I think what that's going to be is going to have a lot of money behind it, which we've never had in this low carb community before, so that we can have the money to advertise about it and put it out there in the media that costs money. We're growing organically through social media and stuff, but to actually put a big money behind it will kind of have a step function effect in terms of the number of people that we manage to reach. Putting on conferences in places like India, and we're talking about Dubai or Abu Dhabi. I'll probably go back and do another one in Indonesia. All those things, I mean, just as ideas come to us, most of the time it makes me weak at the knees initially, and then you think about it a bit more and think, okay, we can do this. So yeah, just to find more ways to reach more people.
Thank you.
And
Yeah.
can I add to that? I'm sorry,
Yes,
Shashi.
yes.
So you know, we recently started doing something where we focus a little bit more on one topic and one day of our conference. We did food addiction 2 ones ago in Florida, and it was very well received to have that big focus. It got the people who are really interested to talk about food addiction. How if you don't talk about how addictive processed foods and carbohydrates and sugar are, you're never going to help a lot of people, because they're not going to be able to make that change. Besides talking about cultural aspects of like your culture has certain foods they eat, there's a lot of addictive foods that people have trouble giving up. So navigating that. Last year we did cancer, a focus on oncology in the SMH Symposium Metabolic Health San Diego. Next year in Florida, we're doing type 1 diabetes, very under talked about area where people who have children or family members or that have type 1 diabetes themselves have a lot of trouble getting the support to help them with that disease. Next year in San Diego, we're going to do mental health, and all the research that you talked about a little bit more earlier today about how mental health can be helped with dietary nutritional changes. And the type 1 diabetes one specifically, there's a lot of work being done behind the scenes in SMHP to do addendum specific clinical guidelines to talk about specifically type 1 diabetes, specifically type 2 diabetes, specifically oncology. So whenever we can get those committee members together who can work on these so we can publish them and get those published, that's a lot of work going that will also get published in the Journal of Metabolic Health. So thank you.
So thank you.
For your time.
A big vote of thanks to both of you for appearing for this. And also thank you for having me and Anup in a special podcast specifically for this conference, which you have floated. And we are so thankful. Rest of it, we'll take it in mail and we will get back. We look for solid collaboration. In case you're coming to India, then please have conference with us. We are here ready for you. Thank you. Namaste.
Thank you, Anup. Thank you, Shashi. Please let us know how we can help in
Yeah.
any way that
We'll take it in mail.
doing
Thank
going
you.
forward.
So we can get Dr. Swaranjit Bhasin and Harshil into the screen.
Hey, hi. Welcome, Dr. Bhasin. Thank you for joining us in this event, which is Metabolic Health Conference, where we have had 47 guests from 15 countries, and it's India's first of a kind event with such a wide variety of speakers. And we're glad that you could join us, and so that our people who are watching us or maybe will watch this recorded session will get a lot of insight. So without further ado, I'll just give a brief introduction about myself. So I'm Harshil Subarnakar. I am a metabolic health coach, and I'm founded something called as Nutrition Lab, where we do nutrition-based research and help people reverse diseases through nutrition and holistic approaches, which are not in the conventional field. So then we have with us right now is Dr. Swaranjit Bhasin. Dr. Bhasin is a prominent radiologist in California, United States, with over 15 years of experience. He was born in New Delhi and grew up in the Bay Area. His medical interests include cross-sectional imaging, especially CT and MRI in abdominal and musculoskeletal imaging. He's currently associated with Kaiser Permanente, which allows the flexibility for patient care, where physicians can provide the best possible treatment for the patients in the way the physicians want to. And the organization is also well known and respected in the community locally over there. And as I'm told that this community or the Kaiser Permanente group has about 10,000 doctors associated with them. So it's a very large base that Dr. Bhasin works with. Dr. Bhasin, especially being a radiologist, he also advocates in treating patients who are metabolically affected or otherwise. And he has developed this first principles thinking, which I think we'll hear from him. Before we start, I'll hand over to Dr. Bhasin for some few words, then we can start the session with him.
Thank you, Harshal. Great to be on this format, first of its kind in India. I really want to congratulate the Indian community for putting this together. I think it's very necessary in India and throughout the world. So I'm really honored to be part of this event. I just want to give a little background of myself, and so the audience knows a little bit. I'm not as famous as some of the speakers that have been on this. And I've actually learned and watched some of the speakers that you've had in day one and day two. So these group of individuals are amazing, and I think I was not aware of them before 2022. So this is where I've been practicing for about 15 years now. And something that always bothered me in the back of my head was, why are we seeing cancers in younger and younger patients? I myself, as a diagnostic radiologist, I see mammography. So we're diagnosing breast cancer. And as the years have gone on, I've seen cases of cancers in younger and younger patient in their 20s and 30s. So this is actually before we would even do screening mammography for them. And again, rectal cancer is another one where we see very young patients in 20s and 30s getting rectal cancer. Again, the screening will not catch these patients because they're not at the screening age. So that was my really, one of the things that really bothered me on the back of my head throughout. And why is this increasing? And this is where last year, 2022, I did a deep dive into just diet and nutrition and what can we do to really help patients. And this is where I found some of the speakers that have been on here that have been saying for a long time that low carb, this is the problem. We need to really vilify carbs, which is really getting to the root problem of insulin resistance. And this, I think I learned everything last year, 2022, what I should have learned in medical school. And for some reason, this is part of the problem is where we're not learning diet and nutrition in medical school to connect the dots, what the root cause is. And this is where, ever since last year, I've come up with, just something very, very simple message that I can really convey to my colleague, my staff member, any patients within 1 to 2 minutes. So I've considered myself that I'm going into more healthcare marketing from a radiologist standpoint, just to get that message across. And that's my forte this year. I've been just developing that and just getting the message across on how we can really reverse disease and prevent cancers. And non-alcoholic fatty liver disease is another one of those things where I'm just seeing more and more CT and ultrasounds. I see cases routinely. I'm a body imager myself, and almost half of the cases that I'm reading on CT and ultrasound, I'm seeing fatty liver disease. And sad to say, even kids as young as 10 years old have diagnosed with fatty liver disease. And this is where there is no pharma medication to treat non-alcoholic fatty liver disease. So we really need to give solutions to our patients on how we can tackle this. So this is my journey, but I'm really new to this movement of low carb, but I'm really passionate about it, and really honored to be invited to this speaker session.
Thank you, Dr. Bhasin. It's interesting to know about how interdisciplinary complements like medicine and, like you said, nutrition. If we combine that, I think it has got a lot of healing power, and I think we can look forward to maybe a very lesser proportion of disease in the world if we combine these interdisciplinary advantages. So let me start by asking you, given that you do radiology and you spoke about non-alcoholic fatty liver disease, which is basically having a fatty liver without consuming alcohol. So the non-alcoholic fatty liver disease in the world, along with other metabolic diseases that we see, are growing at an exponential rate. And if I had to quote a statistic, just for everybody's knowledge, in 2016, a study said that global prevalence of non-alcoholic fatty liver disease is in 25.2% of the world's population. So just imagine this. And, when we see cases, and maybe if, around, if, I'm sure that in anybody's sonography that you see, you'll at least see a grade 1 fatty liver in India. With given this background, what's your perspective on, non-alcoholic fatty liver disease, sir? And what's its progression? What are the causes which is causing such a global prevalence, and why is it rising at an exponential rate? If you can just throw some light on that.
Yeah, I think the root cause, again, we have to go to what is causing all this exponential increase. And if you look at it, the rise of sugars in our diet, high fructose corn syrup, which is metabolized in the liver similar to alcohol. We really need to understand that this is the problem, where we're eating, I'm going to quote just the American diet, 60 to 70% of the American diet is ultra-processed foods. And these things are filled with sugars, high fructose corn syrup, and vegetable and seed oils. That's one of the other problems in our diet. And this is really the cause of the rise. And I've seen numbers as high as 45% of the US adult population having non-alcoholic fatty liver disease. And we had, I had one of the guest speakers that came and speak to our physicians in Kaiser, Dr. Robert Lustig, very well known in the community. And he said, this is the silent epidemic. This is the epidemic that we really should be talking about. COVID was here and it's gone now, but this is the new epidemic that is really, really prevalent, and it's a silent problem that we don't see till later on. It brews inside, but as a radiologist, I see this now, and what I've started doing is, when I see this on my imaging, I might be the only radiologist in probably US and probably worldwide that I'm actually writing a prescription on the report on how patients can reverse this, because we really need to empower our patients. They can take charge. There's no medication that, the primary care doctor is going to write. There's no GI doctor that's going to write a prescription how to reverse this. So as a radiologist, I'm putting it into the report that this is what you're going to do. These 3 simple steps. You're going to go ahead and reverse this and empower the patients. And I think this is the magic pill. We're talking about we're always searching about what's a really good drug that can really have a lot of effects on different things. And I think the diet and the low carb that this session is about, that is the magic pill. And I've noticed that this cuts across all the things. It's not just GI that can get help with the low carb. It's the oncologist, because cancer, we all know, is also linked to insulin resistance. I can reach out to the neurologist. If you want dementia prevention, that's how you do it. You do it with your diet changes to try to reverse, again, the root cause. I've started calling out insulin resistance. I'm bringing it up in almost all the conversations, just to bring it up to the forefront, because this is the elephant in the room. We're actually not doing a good job calling it out. So I think we really need to bring it to the forefront, that this insulin resistance we need to tackle. And how can we do it simply? And that's my marketing message that I've started advocating.
Thanks for that. It's very insightful to hear directly from the horse's mouth, given that you see the scans firsthand, and interestingly, you as a radiologist, you'd be, I think, one of the only maybe in the world who would be giving a prescription. But to know from you, given that liver is the only organ which can regenerate itself, and it's like a fully functional factory which has like various processes. From your clinical experience, if you can just tell us as to what kind of lifestyle can damage it. Like, isn't it that, the extremes will only damage such an organ which has the ability to regenerate itself? And basis your years of experience in terms of the cases that you've seen, like you said that, kids also have it these days. So if you can touch upon that topic a little bit more in detail for the curious parents who are listening to us right now. And what is the things that you prescribe to your patients for especially non-alcoholic fatty liver disease?
Yeah, I think this is where it gets into my 3 simple step message. First step is to avoid seed vegetable oils. And these are really, really, and this is something that my son actually helped create after I did, a talk with the 3 simple steps. So I'm going to just show, if you can go to that first page. And then, I see patients that come in for mammography. They're getting called back. So we read the mammograms, and if we see anything abnormal on there, what we do is we do a callback where a patient comes back and we do some additional imaging. And majority of the time, it's usually nothing. So what I do is I actually pull out this little trifold and I show patients this. So what I do is, the bottom right of the screen, it shows the multiple different things. So I tell them what we're trying to do is we're trying to prevent cancer and dementia. And we're also trying to reverse all the other 6 things that are on there. And again, pointing out to the top left, I tell them, what is the root cause? The root cause is insulin resistance. So if you go to the second page real quick, and then I'm usually able to get through this, within about a minute or so, I'm able to tell them. So this is the quick little message. I'm hoping I can even get you all to really follow this. First is to avoid the seed and vegetable oils. These are made in the factory, really unhealthy. And I'm sure in India, there's, again, a lot of marketing, how to sell these things. There's a lot of commercials saying vegetable oils are healthy, but no, if you look at it, how they're made and processed, it really is terrible. And this is where we really need to, and this is one example I like to give to my patients is large fries at any fast food chain, the toxins are equal to 28 cigarettes. So this is what the toxicologists are telling us. Toxicologists have separate meetings, MDs have separate meetings. We're not listening to each other. So we really, really need to listen to what the message is from the toxicologists. And then we need to give healthier alternatives to our patients. And this is where the message is very unclear. Saturated fats is unhealthy, but this is where the data really shows all these simple fats are really okay to use. Butter, ghee. In India, you should be using ghee and coconut oil. Those are really big and healthy. Don't shy away from these 2 superfoods, I would say. And olive oil, on avocado oil, and I think beef tallow probably not utilized in India. But give the message what to avoid, what to use. Very simple. Second step, eat a diet low in processed carbs and sugar that uses healthy sources of fat. And this is where I've learned from all the speakers in this series. It really hits home. Low carb is important. If you look at it, I want my patients to have this image of blood insulin response to the different macronutrients. Carbohydrate, huge peak. Same thing with sugar and high fructose corn syrup. Protein is in the middle, and fat is a flat line. So this is where I think in healthcare, we really should be unvilifying healthy fats. Fats are okay. We really have to get out of that low fat, big food marketing message. So, and then, shopping the perimeter of the grocery store, you can really avoid the ultra processed foods. The stuff in the middle, I say 90 to 95% are addictive substances, not even real food. So this is where I think in healthcare, we're fighting a addiction model, and we have to call it out. We have to say, you having a sweet tooth, that's a problem. And then the last part, practice intermittent fasting. I think this is where Dr. Jason Fung, I would have to give him a lot of credit. I've learned a lot from him. I actually invited him out to come speak to our doctors, and he gave a message of demystifying intermittent fasting. And this is where this is a wonder drug that we really should be utilizing more. It doesn't cost us anything. Actually, it would save money for patients. And this is where the 6 small meals a day is very unhealthy and promotes insulin resistance. And most adults should be eating 2 good meals in an 8-hour window. And fasting really, really is powerful. And this is where, everyone knows about autophagy probably on this call, but, any listeners out there, 24 hours is approximately the time where autophagy kicks in, where your body goes around and cleans up your own damaged cells. And if you can go 36 hours fasting, that actually kicks in, it increases 300%. So this is where we really need to utilize this drug, and we should all be writing more prescriptions for this. And this is my little message. And again, this helps with non-alcoholic fatty liver disease. So this is where I would tell parents, if you're going to treat your kids to something, they've done a good task, you're going to take them out for fries and soda, that is actually very damaging for their health. So I would try to tell them, pick some alternative places, pick a local restaurant that cooks in better oils, where the food is coming from. So I think this is where we need to shop more local. And I think fast food is something that was exported out of the US, and it's just unhealthy anywhere. And we really have to call that out.
Yeah. I think that's put really powerfully. I think we should credit your son for making this, and it's a real powerful message. Just 3 simple steps: avoid processed seed vegetable oils, low carb and intermittent fasting. That's really powerful. In fact, Ben Bickman and Jason Fung were there in another conference, and they put it very nicely. And we've just got another research which says that we are biologically fit for going into ketosis. Basically, when you do low carb, your body takes in the fat, so you need to be in a fasting state for a longer period of time, and little time should be your feasting state, where you don't see any other form which goes always in a feeding state. So when you go in a fasting state, that promotes a lot of advantages, and that's how we are biologically built. And I think these 3 are very powerful messages, and for the audience who are listening to us. So
and I would tell you from personal experience, I was under the marketing thing that we should be eating 6 small meals. So before I learned all this stuff, I was actually doing the same thing. I was eating small meals, snacking throughout the day. But I think that has, again, you have to stop and think, who does it benefit when we're eating 6 small meals a day? The only one that it benefits is the big food companies, because they're selling more of their processed foods. And if you are not satiated with what you're eating in the ultra processed foods, you're going to need to snack in between. So once I realized that message, you can understand how to really break out of that. And now I just usually do a couple meals a day in an 8-hour window. And it is hard in the beginning, but you can easily get used to it.
Okay. And just another corollary, I just remember, another bioscientist, he just quoted recently saying that, a calorie in, calorie out concept, is a physics concept. But, when you apply pathophysiology, where you combine physics and biology, you need to understand the balance of hormones, which is when insulin kicks in. And hence, you need to understand how fasting, time restricted eating, low carb, and having more carbs, what kind of an expenditure, say. So calorie in, calorie out model might not work when you put it inside a body, like it's biology also. So one needs to understand biology before we put that model inside for us. So that's
Exactly.
Great. Yeah. So that's great insight, sir. So now, like you touched upon, non-alcoholic fatty liver disease, but then what we've seen is, that, this thing has changed. This is just an example that I wanted to show to you, that since the 1970s, the kind of liver mortality, so mortality because of liver diseases has like just shot up. So maybe would you want to pay some of your insight as to why would this have happened since 1970s? We understand that, processed foods, etc., has increased, but it's just at this point that we see as an increase.
Yeah, and if you look at this, if you had another chart with showing seed and vegetable oils, you would actually see a similar kind of trajectory going up to the right, and especially starting after the 1970s. And this is where I think you really have to understand the money. I think the fiat money and the incentives are really perverse, I think, in healthcare and nutrition. So during my learning in 2022 about nutrition, that's another thing that I was studying is our monetary system. And something happened in 1970 is, I think it was 1970 or 71, Nixon took us off the gold standard. So there is nothing backing the US dollar, and the fiat money can be printed, out of thin air. And this is where I usually recommend folks to, there's a great series on YouTube, Hidden Secrets of Money. Just watch that to learn what we use day to day. And that gives you insight into nutrition and what the big food incentives are in all of what we see in the store shelves, and why they're, the incentives are profits. And I think one of your speakers yesterday was saying that, yeah, the corporations and the government, they're not going to help us change this. We have to do the work on the ground. And the reason why we have to do the work on the ground is the public-private partnership. They're aligned with the profits. So that's not going to really help. But the conferences like this, doctors that are getting out there and getting the low-carb message out, this is the real way we can really make change. And I'm hoping to be a part of this. Make it very simple. That 3 simple step message, I tell all my patients, next time you go through the aisles of the supermarket, I want you to think about me. And be careful, put your guard up, I want you to think twice before you go in there. And I think they do really appreciate that. But yeah, this is where we really have to get to the root cause. The root cause of the health going bad is insulin resistance. And I think the root cause of the whole system, why we don't see change and why obesity and diabetes keeps going up, I would have to call out the fiat currency. So this is where I think Herschel has a little bit finance background, and I think Herschel would probably understand this more. But again, Hidden Secrets of Money, first 4 episodes, must watch for everyone.
Yeah, thank you. So that's the benefit of this we speak of interdisciplinary advantage of understanding and linking both fields together, like how the hidden kind of incentives for the companies to do, which is basically making money, causes all of this. That's an interesting insight, and how we can connect interdisciplinary knowledge. When we talk about non-alcoholic fatty liver disease, can you maybe explain from a doctor's perspective as to how the progression happens? At what stage is it irreversible, and what is the linkage between fatty liver disease and the other metabolic syndrome, of how it affects people? Maybe just a short summary for people to understand.
Yeah, and this is where, one of my colleagues, Dr. Singh, he's a GI doctor. He actually gave one of the talks in our group, and he described that, by the end of this decade, there's going to be more cirrhotics due to non-alcoholic fatty liver disease than from hepatitis. So all the different viral hepatitis, this is going to take over. So this is where, if we catch it early enough, we can easily reverse it with our diet changes. But if you leave it, some of them progress on to NASH. And then eventually, if you're not taking care of it, some of these fatty liver disease will progress on to cirrhosis. And this is where if we don't change the tide right now, we're looking at more cirrhosis from non-alcoholic fatty liver disease than all the other hepatitis. So this is the epidemic. Dr. Robert Lustig, we need to listen. A great doc. He has, I think, Sugar, the Bitter Truth. I watched that and it's like, wow, that medical lecture. It really shows what's going on. I think he gets into all the details of sugar and how it's metabolized. I can't really, as a radiologist, I'm not that good at getting into all the different steps. But this is where we really need to get all hands on deck. And if we're tackling non-alcoholic fatty liver disease, guess what? You're reversing all the other stuff too. You're getting the benefit. The side effect of treating non-alcoholic fatty liver disease is you're going to reverse type 2 diabetics, pre-diabetics. You're going to help with blood pressure, and you're going to prevent cancer and dementia. I think those are the biggest things that we worry about, right? Cancer. Yeah. We don't want cancer. And I think the metabolic background of cancer, that's catching up more and more. And I've seen a lot more prevalence to that. I'm glad that there's something that I can do. I can help my patients and members to do to prevent cancer in between now and their next screening. Not just say, oh, keep getting your screening. We're actually trying to stamp out cancer with this. Sorry, I got a little off track, but non-alcoholic fatty liver disease, I would say, yeah, the mechanisms and stuff, I don't know as much of the detail, but this is where we really need to reverse the tide.
So, sir, like we've been touching upon cancer, but then, when we've been reading and doing a little bit of research, newer studies now say that, you have decreased level of estrogen as a result of insulin resistance, which increases the risk of developing cancer in any organ which has high levels of estrogen receptors, which is including breast, endometrium, and ovaries, which is especially on the female side. So how have you been, like you've said, it is increased. So what has been your experience in terms of seeing these scans and, a lot of these patients getting this? And maybe if you can touch upon, how it has helped, in line with, as a treatment with conventional therapy, which is chemotherapy, how low carb will be able to work, given that, we understand that these cancer cells have a high amount of insulin receptors, given that it is bereft of the liver, basically. And if it doesn't have access to the liver, it cannot produce or energy from fat or protein sources. So it only can take glucose. So it has a high amount of insulin receptors, is what we understand. So if you can just touch upon this for our viewers.
Yeah, and I think this is where, if you look at CDC, a website, they have that there's 13 different cancers that are linked to 13 cancers that are linked to being overweight or obese. So I'm just going to give some of the numbers. In the US, 73% of adults in the US are overweight or obese. And then 35% of kids in the US are overweight or obese. And I think probably India is not too far behind. I think it's probably not as bad in India, but this is where we know that this is all linked to insulin resistance, and we really need to reverse that. So if you're a little bit overweight, the best way, again, you really need to reverse that insulin resistance. And I think we haven't offered the right kind of messaging on how patients should lose weight. We always keep saying, eat less and move more. We've always given that mantra, but that does not work because we're not getting to the root cause. Because obesity is a hormonal, not a caloric imbalance. Dr. Jason Fung, I've learned from the guru, this is where we really need to tackle the insulin resistance. And again, you're talking about the hormones. The hormones is what we need to get to. And this is why I've seen in my career that I'm seeing younger and younger patients coming in with diagnosed breast cancer. Young patient feeling a lump, we would think it would be something benign, all of a sudden we're seeing a big mass, and then we have to do a mammogram to see, and there's cancer. I see cancers in bilateral breast, which is quite unusual, where someone comes in and it gets diagnosed with cancers in bilateral breast, but that is happening more often. And again, it's all linked to this. Simple messages get to the root cause of insulin resistance, and you can do it very simply. And we got a lot of experts here to learn about low carbs. Really listen to them, because I think they're giving the right message. We're messaging that we really need to vilify the carbs and sugars, and then unvilify the healthy fats. We really need to get that messaging out. And again, the seed and vegetable oils, get rid of those things. The Indian diet should be using the good quality desi ghee and coconut oil. I'll advocate for that. If there's any brands out there that need a spokesperson for desi ghee or coconut oil in India, please reach out to me.
That's interesting, sir. So have you had, or maybe some cases of maybe reversal in these non-alcoholic fatty liver disease, and after the reversal, what has been the patient? What do patients think with you when you say this, and how happy are they when they come back when things look okay?
So I've started doing the prescription in my reports for about 6 months now, is what I've been writing, and I've reached out to my colleagues so far. Primary care doctors, the GI doctors, and the ED doctors. They're all really, really happy about it, because they usually, they don't have time to spend with the patient to sit down and do the diet and nutrition and stuff. And we can't send so many people out to educators. So just having that message there, I know the clinicians have been happy. I'm very sure I'm going to get results fairly soon. I haven't started hearing about any of the positive things yet, but hopefully soon I'll have some good results. But this is shown, it's proven to work. And I think a lot of practitioners out there, I think you guys have a lot of data where you're reversing non-alcoholic fatty liver disease, and it's very doable. And I know it works within 2 to 3 months. This can really be effective. I haven't seen personally. I haven't seen the thing, but I know it's working. But I will reach out to all my colleagues. And again, this is where radiologists are usually consultants for other physicians. So the main interaction with the patients is not as often. If someone's coming in for like a fluoroscopy study, then we have patient interaction, and then mammography is the other big one. And that one I usually utilize each moment I have with a patient. I really try to connect and make sure I'm talking about the diet with them. And they're really, again, very appreciative of someone taking out the time and letting them know the clear message, what they can. And again, they look at the pictures on my little trifold butter. They're like, "Are you sure, doctor?" But yeah, this is where I have studies showing, and Journal of American College of Cardiology says, saturated fats should not be feared. And that was from, I think, a 2020 state of the art review.
And it's quite the contrary, right, to what they've been saying. So saturated fats has been termed as a bad, and I guess what you've said on saturated fats, it goes with the practice that at least in the low carb world goes that saturated fat is in fact very healthy, and you see
and then I've seen, I was just getting back to your point about cancers also, and this is where I've seen a lot of momentum building and a lot of research going on, that ketogenic diet, how it can prevent cancer and augment traditional therapies. Someone that has been diagnosed with cancer, if they're on a ketogenic diet, it can really help them get through that and help with the treatment process as well. So this is where another one that I really need to help vilify in healthcare is the ketogenic diet. I think sometimes physicians just hear ketogenic diet, keto diet, and they're afraid of it because it sounds too extreme. But the data, I mean, overwhelmingly, every day I see something on social media or Twitter, one of these experts putting out a study that ketogenic diet has been shown to do this. So all the data is coming out, but we need to stay ahead of that and make sure we're getting the right messaging across to the patients that are following something like a ketogenic diet.
Yeah. Yeah, and it's interesting that new research also speaks of how ketogenic diets or maybe low carb especially helps in cancer treatments in along with conventional chemotherapy treatment, and it actually helps augment the results. And I think more research is going on, and hopefully we get to the conclusion that both in conjunction will help in terms of helping putting cancer in remission or reverse it. I think whatever you said, I hope it opens everyone's eyes towards the dangers of ultra processed food, seed oils, and we maybe gain back the fight against metabolic health, given how it has raced against time, and it's increasing like an epidemic. But on a closing note, can you share some pointers from your radiology practice to on our audience on although you've shared on metabolic health and uh, which diet, maybe exercise, and overall other things that you see, and how can one prevent getting there or reverse their metabolic health?
Yeah, again, this is where we really need to do healthcare marketing to really counter the message of the big food marketing, right? They have a huge budget. They have lab scientists that make the food really palatable, and then they have the marketing that come up with the packages. So that's why when you go in the aisles, you're seeing like very shiny packages of food. So we really need to do a better job healthcare marketing. And this is where again the 3 simple steps I'm just going to lay it out. Avoid the toxic seed and vegetable oils, low carbs and high healthy fats, and then intermittent fasting. And then I would also say if I had to add like a 4th step on there, that would be resistance training. I think resistance training is a must. Indian population, I think they're hitting the gym a little bit more. I think I heard one of the other speakers saying that Bollywood actors are more muscular, so hopefully that is getting across. But this is where 3 days a week I should be going to the gym, and this is where I've seen data shows that you just need to do each muscle group, you can just do 1 set. You don't need to stay there and do multiple sets. 1 set is just as effective as multiple sets. So you can go to the gym, get each one of the muscle groups moving, and you should be able to finish within 20 minutes. So all of us can do that. The muscle is, I think it's the more I see about this, that we really are lacking that. So resistance training is a must. And then maybe if wanted to get to a 5th one would be little cardio. HIIT is really, really powerful. So high intensity interval training. If you're going to do some cardio, get at least 10,000 steps a day. And then when you're going to do some interval training, I would say once or twice a week, you should do that.
Yeah, that's really interesting. And before we end, on the muscle piece, it's basically GLUT4. Basically, it's like a glucose transporter 4 in the muscles, and muscles being so greedy, when you work them out, they just soak in glucose without the insulin, because that's the biological benefit available to them, that they can translocate the transporter, and without insulin, the only thing which can take in glucose inside is muscles. And that's an interesting point. I think the 5 points are very true of what you said, and maybe Sashisha, you would want to take over.
No, see, first of all, I'm so happy that Dr. Saranjit could come here and share his knowledge, because we are very keen to see what is a radiologist perspective. And the reason is, like in India, the fatty liver seems to be very rampant, and I'm sure it is across the board, it is everywhere. But what we are also seeing nowadays is small children's having central obesity. Overall, we kids were always lean in India. Now we see overall obesity. And what is the incidence of fatty liver? What is our exposure in kids, in small children? Do you get opportunity to see some fatty liver in them? How is it?
Yeah, this is where, as my practice over the years, it's been getting worse. I actually never used to see fatty liver in kids before, but for the last 3 to 4 years, I'm seeing more and more fatty liver disease in kids. And yeah, I was telling Herschel earlier that I saw a kid as young as it was about 10 years old 2 months ago with fatty liver disease. And again, I'm speaking to the pediatricians, and they're seeing it. They're seeing their patients get diagnosed with this. And this is where if I was writing a prescription for a kid, I would put just the first 2 steps on there. I would not put the intermittent fasting. That is not healthy for kids to do. But this is where, again, I think this is, we have to create an environment for the kids where we don't have snacks available all the time. Kids can be healthy. Give them 3 good rounded meals in a day, but eliminate the snacks and don't take them out to the fast food for the fries and soda. I think that really is one of the root causes.
I think you will be interested to know that there was a study which was conducted in Mumbai. So we have Nair Hospital here, which is government hospital. They conducted a study in 2016, and this study was done on school children's of South Mumbai, southern part of Mumbai, South Mumbai, which is an affluent class. Now they found half the kids are having fatty liver. Some of them had even fibrosis. Can you imagine school-going children? And this is 2016. And this is officially published in some journal. I can send you over the link to the journal. Very interesting. You will be interested to know this as a radiologist. And this was 2016. This is 2023. We can imagine what is the extent of disease that would have spread due to this, the same thing which you say, the sugar and the vegetable oils. And that is what consists of all this junk food. And in South Mumbai, affluent class, frequently eating junk food is the norm. How would you react to such a study?
Yeah, this is really sad to see. This is where we think we're treating our kids to something positive. They're doing a good job in school. They scored well on an examination, and I think the parents are thinking they're doing a good job and taking them for a treat, but we don't really understand how bad these things are. And I would have to call out the fries at fast food again. I want everyone to have the picture. Large fries equals 28 cigarettes. So let's not inadvertently give our kids cigarettes. And then again, soda is processed in the liver just like alcohol. So if you're giving your kids like a 24-ounce soda, it's almost like that they're getting like 2 beers. So you're giving your kids 2 beers and a pack of cigarettes. That's not a treat. Let's not treat them that way. Let's give them some home-cooked meal with some desi ghee and coconut oil. And that's the way. Really, that's why, cooking at home really makes a big difference.
So it is not just fries, but ketchup, and then the huge can of Coke. And then we see this everywhere. See, in hotels also, if you go in the buffet corner, there is a kid corner. And in that kid corner, what do you find? All the sugary junks are there in the kids corner.
Right. And I think this is where the big food, again, this is where the money really gets into the advertisement, right? The advertisements showing all these sugary things, sugary products, and there's no warning label on them. So anything, this is what I tell my patients, anything advertised on TV, please do not grab, because that is the highest profit foods out there. And usually the most addictive is what is being advertised on TV. So we really need to, as health educators, we need to understand the root cause of why we're getting there if we really want to make a big difference. And I think the money is really important to also look at in this.
And did Harshil also touch upon, do you see incidents of fatty pancreas?
He hasn't touched it, but I do see that on imaging as well. Yeah, for the diabetics, yeah, we see fatty atrophy of the pancreas. And this is where in the US, we have almost 100 million pre-diabetics. And again, 8 in 10 of these pre-diabetics don't know they're pre-diabetic. And I heard some of the statistics for India too, that you're close to the similar pre-diabetics. We need to catch these patients. Why aren't we doing more of these fasting insulin levels? Why are we waiting for the sugars to rise after 5 to 10 years to catch these folks? Let's catch them early. And this is where, again, just to keep it simple for my messaging also, I recommend when I'm talking to colleagues, 3 simple steps to check on metabolic health. How do we check under the hood? The 3 simple steps, which I learned from, again, a lot of the experts in the field, because I'm a radiologist. I'm not really ordering any lab work, rarely, but I really dove deep. And then the 3 ones are triglyceride to HDL ratio. Very important. That's the one we really need to look at. That's excellent marker of metabolic health. Second one is the fasting insulin. It's not being ordered as much. We need to order a lot more of these, catch all those pre-diabetics early and start reversing. And then the third one is hemoglobin A1C, which everyone's aware of. But I think once that starts rising, that's a little too late. Let's catch these people early and reverse. Let's not focus on LDL, which we tend to. And I think, again, money's involved. There's a lot of money to be made. So we really need to wake up to that fact.
I think you always have a very, very simple point of view. You have 1, 2, 3. You only have the same thing. And it's very nice and simple. Vegetable oil, sugar, intermittent fasting. So your 3 bullet point is really excellent and simple for us to know. And regarding the fatty pancreas, I think Professor Roy Taylor also in his study, he has mentioned in this diabetes reversal or remission, the presence of fatty pancreas. And then for his protocol, whatever he has recommended, he has seen a reverse in this, and then better sugar control. And I think that remains one of the crux, probably which needs to be explored in future, whether through imaging we can also identify fatty pancreas, a possibility which can affect the insulin level itself. Yeah, Harshil.
And I think I see it so often, the fatty pancreas. Maybe I've started not paying attention, but maybe I will, given your advice, I'll pay attention and see if patients are losing weight and if it's the atrophy is reversing and stuff too. Yeah, that's a great thought. I'll keep an eye on it.
Yeah, and I think what you said is very important, right? TG by HDL, which is triglyceride to HDL ratio, and fasting insulin. It's a preventive checkup. Like you know that you're getting there, that your car is going to go there, and it acts as a sign for somebody that you're going to get metabolically affected. So why don't you stop right now, go away from the danger, reverse yourself? And I think that's very important, along with subtle signs like your skin tags, acanthosis nigricans, which is blackening around your neck. Those signs I think are very important. If they get prescribed very early, or people know that these tests can be done, and they know that they are going to go on the bad path or land up very badly, things are much easier. And of course, once your HbA1c is risen, you're already a diabetic. At that point in time, it's so difficult to reverse things, whereas when it's as a preventive thing, if you start just small steps right now, then you reach here at a much better situation than a curative test like HbA1c.
And then I would give the audience like triglyceride to HDL ratio. If someone in the audience listening is calculating it, you want to aim for less than 2.5, and then less than 1.5 is optimal. And again, how do you fix that ratio if your ratio is bad? You cut down the carbs, right? Low carb. This is what you do, low carb, and then you're going to increase your healthy fats, including saturated fats, because you want the HDL to come up. So this is where don't fear the healthy saturated fats, fear the carbs is the healthcare message.
I probably fear the
Can also
carbs
tell our
and-
audience on what's the level of fasting insulin that they should look at.
Fasting insulin, the numbers 2 to 6 is normal or less. Anything above that, you're starting to get a little bit insulin resistant. So time to start reversing that really. And this is where you don't want to be normal, you want to be optimal metabolic health. So this is where, you know, triglyceride to HDL ratio less than 1.5.
Yeah. That's very important, you know, coming from a doctor like you, you know, that, you know, given that the lab range is 2 to 24, above 6 is not optimal, is what people should know and, you know, pay attention to.
And ultimately, the very description of metabolic syndrome is the waistline, TG, HDL, blood pressure, blood sugar. Ultimately, everything boils down to insulin resistance. So this is what, if these 5 parameters are amiss, that means your insulin resistance. If your blood sugars are normal, that means we still have time to reverse it. I think that is a core fundamental